the delegates who are present physically over here and also the delegates who are attending online, we have a special YouTube link which has been activated, and we have almost 250 to 300 online delegates who have registered, and the registrations are still on. So I would like to especially welcome Dr. Dinesh Thakare sir to this conference. Next, I would request IMA President Dr. Sanjay Sid to please give a speech.
Good afternoon all. Respected IMA President Thakare sir and our IMA member from AKLUJ, Satish Joshi sir, Dr. Khartare sir and all respected friends. Today we have gathered here for our annual conference of EVECON, which has been hosted by AKLUJ IMA in this hotel, Fern Hotel. And theme of our conference is laser and robotics. So it will be very useful for us in day-to-day practice, which is useful in various fields as like surgery, gynec, ophthalm, also in IVF and robotic knee surgeries and all. So I request all our IMA members, respected seniors, friends, to have fun for this two-day scientific session and enjoy the get-together which we have been held by the IMA AKLUJ for this coming 2 days. Thank you all.
Good afternoon, all of you. Today we are here for the conference of IMA Maharashtra State Women's Doctors Win Generation Next 24. Today all of us will have academic feast as well as cultural feast, medical legal feast also, and with the tadka of Panchgani. So let's have a fun in Fern today and then have a very good fellowship, friendship, and good memories of the conference we will be able to cherish for lifelong. I wish all the best for this conference. AKLUJ President Dr. Sid sir, Secretary Dr. Rane sir, WW Chairman Dr. Revati madam, and my friend Dr. Santosh, who has organized all these conference along with the team. I am thankful to you on behalf of IMA Maharashtra, and I wish all of you a full to enjoyment. Just have a fun in fun. Thank you.
Thank you, sir. Yes, thank you, sir. Our organizing for this conference under the women's wing is Dr. Revati Rane, and also our organizing secretary Dr. Khartare sir has also been a pivotal person in helping us to arrange this conference. So we'll be starting with our first session. Sessions for the MOCs for the session are Dr. Nikhil Misal and Dr. Suraj Madik, and yes, I would request Dr. Revati Rane to please be on stage and say a few words about this conference. Then we'll be starting with the session.
Good afternoon, everyone. Thanks a lot for coming here all the way from Mumbai, Pune, Ahmednagar, and from all the areas from Amravati, and welcome you all. Very warm welcome to all of you. From IMA AKLUJ and from Women WDW, as a chairperson, as a chairman, I am welcoming you all. This theme is robotics and laser. We decided to go with that to be the generation next and to focus on the advances in the medical field. Very warm welcome to Dinesh Thakare sir, President IMAMS, This whole event wouldn't have been possible without the backbone of IMA AKLUJ, that is Santosh Khartare sir. Everyone in the IMA AKLUJ and the body, organizing body, has taken lot of efforts. So I request you all to please enjoy this event and let's the fun begin. Thank you.
Good afternoon, all the doctors and esteemed guests and conference participant. Welcome to EVECON 2024.
I'm Dr. Nikhil.
I'm Dr. Suraj.
We are starting our scientific sessions. I would like to call upon stage Dr. Pramod Kadam sir. And
He will be delivering 2 lectures, Robotic in GI Surgery and Lasers in Proctology. To chair this session, I would like to call upon Dr. Ravi Kale sir, Dr. Rohit Phade sir and Dr. Charudatta Shitole sir.
Dr. Ravi Kale sir is a senior anesthetist from AKLUJ. Dr. Rohit Phade sir is senior general and laparoscopic surgeon. And Dr. Charudatta Shitole sir is pediatrician from Pandharpur, from IMA Pandharpur.
Hello.
Hello. Hello. Happy birthday, Rohit sir. Today's chairperson, Dr. Rohit Phade sir, senior surgeon from AKLUJ.
Thank
Happy
you.
birthday. Please introduce the
So I am requesting Dr. Pramod Kadam sir to start his lecture. Before that, I am giving some short CV. He is a robotic and laparoscopic surgeon from Ruby Hall Clinic. He has performed his first robotic colostomy in 2028 in Pune. And he is experienced robotic and laser surgeon in inguinal hernia repair, umbilical hernia repair, and ovarian mass excision. Over to you, sir.
Inviting me today here, and it's a wonderful experience to be back home. It's frankly, it's my hometown, AKLUJ, and it feels like coming home. I'm really thankful to the organizing team for inviting me today. So I won't take much of your time, and let's discuss, as we are discussing 2 important topics today. Let's start with the robotic one. So as the slides are getting ready, let me share you some of my wonderful experiences in our OPD. So there was one fine day when I was sitting in my OPD at Ruby Hall Clinic, of course, and the patient came who was a post-discharge patient. We did a robotic gallbladder surgery, and the patient came after 7 days for follow-up. The best argument which the relatives did with me is, Doc, we have seen the bill of the patient and it's been written your charges of Dr. Pramod Kadam XYZ rupees. So if we have done the surgery by robotic way, so how come you have come into picture? Why not the money being given to robot rather than giving it to you? So that was the funniest comment that came across, and then the discussion started that it's not only the robot which does. Is the human, it's the surgeon who's sitting behind the console is the deciding factor. So it's like driving a car. Even if you have a Tesla, you definitely need some kind of human interference, definitely. So let's start with today's discussion, and we will be dealing with various aspects of robotic surgery as far as GI issues are concerned. So basically, robotic surgery is never a complete robot as of now in 2024. We have always a human-assisted robotic surgery. So more precise, the statement is better as a robot-assisted surgeries rather than having a autonomous robot surgeries. So here the surgeon decides and gives commands to robots to perform a particular step in the surgery. Robotic surgery per se, it means it is the computer-assisted surgery either by a telemanipulator or a computer control. This is the one robot which was invented 25 years back, and this is the first robot which was used to implant, to use the needle in case of a CT-guided brain biopsy. So this is the mother figure of today's robot. This is how the history evaluated. We had in 1985 the Puma one, then it went to Probot in 1998, then in 92 we had a RoboDoc, then advancing up till 2000 where the Da Vinci surgical system came up. Right now in India, most of the places we have this Da Vinci system, and it's really amazing and precisely controlled, three-dimensional, and literally altogether a different world. If you are a laparoscopic surgeon, you should definitely switch over and have an experience of robot, definitely. So let's go back quickly in the history. So it's basically a word arising from Czech word robota, and it was first developed it was first used by Čepek in the play of Rossum's Universal Robots in 1921. Basically in 1997, the Da Vinci system came into picture, and US FDA gave approval in 2000 for the use of robot in humans to Da Vinci system. So 1997, the first robotic cholecystectomy was done. In 98, the heart surgery was performed with robot-assisted efforts by Dr. Fedrich. In 2007, we had a robotic pancreatectomy, and in 2008, it was a minimal invasive surgery in the form with the help of robot for the liver resection. We have types of robot. Basically, industrial robots, then we have assist devices, and then the telemanipulators. Industrial robots, their characteristics are programmed so highly precise, and their actions are so repetitive that they can be used in orthopedic and neurosurgeries. While assist device, we have a control instrument located under guidance of a surgeon. Okay, and its example is SOF type of robot, and telemanipulators are the one which are commonly used. The example is Da Vinci system. We'll go one by one to each one of these so that you can have a better idea about it. So what are the types of robotic surgery systems? We have super visionary controlled robotic surgery system. Then we have a tele surgical system, and we have shared control robotic system. In tele surgical system, we have Da Vinci, the commonly used across the globe. Then we have Zeus robotic system and SOP. SOP and Zeus are not that commonly used nowadays. Supervisory controlled robotic surgical system, it follows a specific set of instructions. Surgeon should program the robot, and surgeon should map the body of the patient in 3 different ways. That is, first is planning, second is registration, and third is navigation. It is precise in nature, and it produces the trauma. Commonly used in hip and knee replacement surgeries, basically. Now, telesurgery system, we have called a remote surgery, is performed by a surgeon at the site away from the patient, and surgical tasks are directly performed by a robotic system controlled by the surgeon at the remote site. Now let's talk about this, the Da Vinci system. It is the one which is commonly available and being rapidly used. In Pune, I believe we at least have 4 to 5 institutes where we have this Da Vinci system as of now. And there are 3 to 4 more who are about to come in a year's time. So there was an era when there was a transition between open surgery to laparoscopic surgery in somewhere in the late 90s and early 2000s. So that was the time when there was always a debate and discussion, why do we need a laparoscopy if we have an open surgery which is time tested and proven. And that time also used to have similar discussions like what we have today. What is the use of a robot if we have a laparoscopy and the surgeons being so trained in laparoscopy? So we'll go to those points. in short time. So it's developed by Intuitive Surgical, that's the company in California, and it is designed and enable and enhance the invasive surgery. So first robot they came into picture in 2000, which got a clearance by US FDA. Then we had basically the use of it was to eliminating the tremors and scaling all motions to a selected degree, which is more than possible, more than the laparoscopy one. So we had a S version of it. It's like we have a mobiles who has developed over a period of time. It's like Android 1, Android 2, and so on and so forth. So does the Da Vinci system. The basic version was the S version, which was developed in 2006. Then the company came up with the SI system in 2009, and now the XI is in 2014. And at present, we have XI all over the cities, most of it. So it provides the most important point here as compared to laparoscopy is why one should go for robotic. That's the question being commonly asked, because of the 7 degrees of freedom to the instrument. In a human wrist, maximum degree of freedom we have moment is 60 degree for a human wrist. But for laparoscopy, again, it is more limited, not more than that. But for robotic, we have much higher degree of movement inside the body of the instruments, and that definitely helps in having a microanastomosis, dealing with the pelvic surgeries more commonly, where the laparoscopy becomes literally little difficult to reach. It basically commonly used in prostate surgeries nowadays, but GI surgeries is definitely coming up with a lot more indications nowadays. So it has 7 degrees of freedom of the instrument which we use. Then the surgeon directs the motion of robot, hence it makes the robot very expensive technology. Definitely it is more expensive, but initially being used at a limited centers, as soon as the use increases, definitely the cost will go down. The types of instrument used in surgical instructions are viewing and controlling console is 1, surgical arm unit is 2, and the optical tower is 3. So let's have a look at this. So the surgeon is sitting in the same room. Okay, he is at the surgeon console. This is his console. Then we have the robot arms with the robot itself, and this is the monitor system. This is how this together forms a robotic system. So in another figure, we can have an optical 3D tower, we call it. Here, the assistant, the nurses, staff, everyone can take a look at the procedure, what is happening on the screen. These are the robotic arms with the robot, which are put inside the patient's abdomen. And this is the surgeon console, where the surgeon sits, directs the function, whatever the arms has to do. The instruction comes from this surgeon console. Nothing has been independently done by the robot itself. So we have a stereo sound and audio video system here, where the surgeon, until unless surgeon put his head inside, the system doesn't work. That's such a phenomenal machine they have made, that even if in a best possible way, if the surgeon takes his head out of this system, there are infrared rays which doesn't let the robot function. So there are no chances that once the command is given from this center and the surgeon comes out of the chair and the function happens at the body. No, not possible. So that is kind of a safety measure which is given in this system, and it's really absolutely amazing. The surgery here you can see, in the next picture I can show you. Basically surgery is done by thumb and index finger. In laparoscopy, we almost use entire fingers of our right hand as well as left hand. But here, the precision is so much that we can only deal with index and thumb. That's all. With 2 fingers, you are sitting nicely, absolutely comfortable on your chair with your dimensions and according to your height. It's been adjusted in such a beautiful way that you don't need to do anything other than just sitting, relaxing. No need to strain your back. The surgeon is at ease, and no need of taking any painkiller post-surgery for the surgeon. So this is what we have, and let's go to some theoretical aspect of it. Basically, take a look at it here. This surgeon console, everything is adjusted with the help of these two fingers, right hand, left hand. Whatever movements happen here, the same movements are reflected on patient's body here with the help of the arm. Then if you look at it, we have a plus and minus pedals here that will help in zooming in and zooming out of the inside the abdomen. These are universal colors for our monopolars and bipolar cautery pedals. So everything, all the controls are here in the surgeon console. So what are the uses? Definitely in today's era, whatever we do in laparoscopically are all the indications where those surgeries can be performed by robotic. I'm the first surgeon in, I would say, rest of the Maharashtra, excluding Mumbai, who has done the first robotic gallbladder, first robotic umbilical hernia, and first ovarian mass robotic assisted, of course. So all those abdominal organs, more precise, I would say the pelvic organs, it's a big boon for moreover a gynecologist who are doing a laparoscopic practice and urologists who are doing prostate surgeries very often. So robot would be more beneficial in the pelvic surgeries as compared to supra-umbilical areas. We have definite other uses also other than GI surgeries. We have cardiac surgeries, we have gynec surgeries, and thoracic procedures also been done commonly with Da Vinci. This is another type of a robot where we have a Zeus robotic system. It is made up of ergonomic surgical console, and it has 3 tables mounted robotic arms, the voice control and touch screen interfaces with the monitors. It is user friendly to operate and use in endoscopic surgeries. It is another system like what we had in Da Vinci. Like it is called as ESOP robotic system. It is the first robotic system which is cleared by US FDA to operate on humans well before Da Vinci. So it provides surgeon with the intensive operating controls, and its endo-wrist movements are much easier. So again, the uses are various other than GI surgery. We have cardiac, we have general surgeries, we have gynec procedures, then pediatric surgeries, neuro, as well as orthopedic and radio surgeries. And urology is a very commonly used. Now, benefit of robotic surgery. Why one should go for robot and why not laparoscopic? So, if we have a blood loss of, let's consider 20-30 cc in a laparoscopy, the robot will give you hardly a 5 to maximum 10 cc of a loss. Reason is simple. The precision is such an excellent, 3D viewing is such an excellent, the micro details are such an excellent that you are least likely to be damaging any kind of a micro vessel. If in case of any operating field in the pelvis region, or even in case of a gallbladder surgery, even if you have a I would say aberrant duct in the gallbladder fossa, that also can be easily seen as compared to when if we compare to even a 3-dimensional laparoscopic system. So it is less blood loss, so less chances of any blood transfusion, less chances of infection, less complication, because the vision is literally amazing. One has to literally experience to understand these benefits. Less chances of procedure converting to open one, and shorter hospital stay. We are gradually thinking of sending the patient home on the same day, like admitting in the morning, doing surgery of, let's consider gallbladder or abdominal surgeries in the form of appendix or inguinal hernia in that case. We are planning to do it in the afternoon hours, observe the patient post-extubation for next 6 hours, and planning to send them home in the evening. That sooner or later we are coming. Maybe in a year or so, we will be in a position to discharge the patient on the same day. The only issue that occurs with the insurance, once we get the approval from the insurance companies to these procedures, we'll definitely go ahead. So, shorter hospital stay. So that is again important, so that in a country like India, where the patient load is so much so on the system, that we need beds for the more and more patients to be occupied in the hospital. Lower readmission rate, again because of precision, and less post-operative pain, less use of narcotics in the post-operative time, and quicker and faster recovery to return to normal activities. So there are few of studies which has been done for foregut surgeries, then There are what are the best indications for using robot? These are the procedures in which we require a small operating field. Then the procedures where we have a fine precision and dissection and safe intracorporeal sutures. In case of a bowel anastomosis intracorporeal, robot gives a much advantage over conventional laparoscope because of 7 degree of maneuvers which can happen in the intra-abdominal. So these are few studies which have been carried out in robotic gastrectomy, then GI luminal malignancies, then bariatric surgery. It's been really beneficial as compared to laparoscopy. Then laparoscopic liver surgeries. There are various studies which carried out, and robot-assisted pancreatic surgery, then colorectal surgeries, and so on and so forth. Robotic inguinal hernia repair is the next big thing that is coming up. So let's talk about why one should. What is the comparison? I would say the best possible enemy for, or a competitor, not exactly enemy, the competitor for robot is laparoscope. So what is the benefit of conventional laparoscopy? It has a well-developed technology over a period of time. Now we are in 2024. It's been a long way ahead of beginning of laparoscope. We are all almost well-trained in laparoscopy. So most of the time it is affordable. We can do it in tier 1, tier 2, tier 3 cities of India as well. So it's been the biggest advantage in our country, and it has a proven efficacy. While in case of a robot-assisted surgery, that is a newer technique. Learning curve is a bit as compared to laparoscopic surgery. But once a person who is well trained in laparoscopy can easily get trained in robotic surgery as well. So robot-assisted surgery, it has a benefit of 3D visualization. It improved dexterity, the movement, the 7 degrees of freedom we have inside the moment for the movement of the arms. Elimination of fulcrum effect here is a big thing. Elimination of physiological tremors if a surgeon has provided. Many times surgeons are hypoglycemic, they are overworked, overstressed. So tremors is something which is common with surgeons. So ability to scale motions, micro-anastomosis are really very much possible with robot as compared to which is difficult with laparoscope. And telesurgery is next big thing which is coming up with ergonomic positions. So conventional laparoscopy, we have, what are the demerits? We have a loss of touch sensation. We have a loss of, whatever the benefits we have seen in robot, these are the disadvantages with the laparoscopic system. So robot-assisted surgery, we have absence of touch sensation, definitely. It's very expensive at this moment. But gradually, initially when we started in 2018 in our institute, we had no support of insurance company. Not a single insurance company was ready to give us sanction. But now I'm happy that advent of almost six years now, in our institute, we are getting almost half of the insurance companies which are covering the robotic expenses for the patient. So high startup cost, of course, its investment is bigger, but as many institute and as many hospitals come up with use of robot, I'm sure it will be much cheaper and very accessible to the common man. So may require extra staff to operate, and it's a newer technology, and still the benefits are under, I would say, trials. So that's the benefit of, that's about the robotic surgery. Thank you so much.
Hello, thank you, sir. One question.
Yes.
Is there any made in India robot available, robotic surgical system?
I think we have it, but
one, I think SSI, something, Dr. Srivastava's.
But major institutes in India, they are using this Da Vinci.
Okay. Sir has covered almost everything very elaborately. Anyone?
I think sir has some question to ask. Sorry, sir, I am not getting you. Cost. Okay. Sir, it depends upon the institute to institute. But in our institute, to help patient, what we have done a package system. where we can charge, we are charging just, I would say, 1 lakh rupees above and extra to whatever laparoscopy is happening. Whatever the package the insurance company is giving, we are just charging not more than 1 lakh rupees. That is all thanks to our hospital management and the trustees who have taken this wonderful decision for the patient's benefit.
Hello. Okay, this is just like playing a video game with a joystick.
Yeah.
So our name suggests next gen, our next generation will be more pro in robotic surgery.
Absolutely, absolutely. The more and more advances are happening in the robot, then we will have a smaller and smaller versions of robot. Initially, it's like I personally feel it's like a mobile phone.
Yeah.
The way they are evolving, the same thing is evolving with the robot itself.
Okay. Thank you, sir.
Thank you so
And
much.
then we'll continue with our next lecture.
Yes.
That is the lasers in proctology.
Yeah.
Dr. Pramod Kadam sir will continue the same.
Yeah. Slide, please. Yeah. Sir, a newer topic which not exactly much newer, but definitely a hot cake in day-to-day practice. We have different lasers. It's not changing. So meanwhile, let the slides get ready. Is it so? I have piles. So anything in the anal region, they consider and label itself to be a piles. So even if the patient has fissure, even if the patient has perianal abscess, even the patient has a fistula in ano, or even a tumor or a rectal prolapse, anything in the anal region for a common man is nothing other than piles. So very often we get anal region pathologies in our day-to-day clinical practice. So out of that, let's discuss about laser uses in our day-to-day clinical practice. So what is laser? Basically, laser is light amplification by stimulated emission of radiation. So it was first in 1960 invented by Miamin, and in 1962, Leon Goldman was the first one who experimented the first use of the laser in the medical history. So the basic factor and important things here in laser, what we need to understand is there are tissue factors, there are laser related factors also. So laser related factors, to get the exact result, what we need to focus is power density, then the duration in which the laser has come in contact with the operative field, and the wavelength which we are using. Tissue factors are how is the local absorption at the site of surgery, how is the thermal conductivity, and how is the local blood supply. So a laser beam, once it comes in the contact with the target anatomy, it has a reflection part of it, it has a scattering, and then there is a penetration that happens in the form of a transmission. So in proctology, we use laser for various diseases like hemorrhoids, we have anal fissure, then we have pilonidal sinuses and anal fissulas. Anal fissula, I would say, recommend is the biggest advantage of laser for going ahead. In case of a complex fissulas, definitely. This is a small anatomy of the anal region. Anything and everything that happens is usually a lower 4 to 5 centimeter area. So we have internal hemorrhoids here, we have internal sphincter muscle, external sphincter, anal crepes, and this is the column of Morgagni. So basic pathology here in case of hemorrhoids is this. We have superior hemorrhoidal artery and its branches, we have internal iliac artery and its branches, and we have internal pudendal artery and its branches. These are the arterial and venous cascades, they form the basic supply of the hemorrhoids. Okay, when you ask patient, they will always tell you, "Doc, it's a fresh red color blood and it's never a chocolate color or never a dark color blood." So usually whatever said and done, it's my personal opinion that it's more of an arterial blood than a venous blood. So this anatomy is very, very important while dealing with hemorrhoids in case of a laser surgery. So per-rectal examination remains the most important part of the treatment. One has to be very careful about it. And I personally feel once, if you are thorough with per-rectal examination, you probably don't need a proctoscope. So proper patient's counseling and proper consent, and that's how we see. So on inspection, we can have fissures, fistula, genital warts, hemorrhoids, pilonidal sinuses, and can be a local skin diseases in the form of eczema or dermal cancers also. And dermatitis, again, we have a skin tags, and in case of a Crohn's disease, we can have multiple fistulas opening and a kind of a rectal prolapse as shown in the figure. So digital rectal examination is an integral part, followed by a proctoscopy. Now, let's talk about hemorrhoids. We have internal hemorrhoids and external hemorrhoids. Let's quickly rush to our main topic of laser rather than wasting time in anatomy, because we all are well versed. So let's talk about this. So we have grades of hemorrhoids. So grade 1, grade 2, grade 3 and grade 4. We know this well. Now the question comes is, patient comes to OPD and asks कि बाबा डॉक्टर साहब ब्लीडिंग हुआ था 4 दिन पहले, अभी कुछ नहीं हो रहा है, इससे पहले भी कभी नहीं दर्द हो रहा था और अभी मुझे लेज़र करवाना है. So that is what they say. So now the question comes is, are we as a clinician going to subject each and everyone for a laser surgery? No, definitely no. So what are the indications when we should opt for? Is it a grade 1? No, definitely not. Grade 1, you can just observe, you don't need to do any damn thing. Grade 2, if the patient is quite symptomatic, significantly, like once in every week, once in 2 weeks, he is having a significant blood and resulting into gradual hemoglobin loss over a period of time, that is the phase where you can opt and give an option of laser surgery. Definitely grade 3, you can have laser plus conventional. I would recommend. Only laser surgery in grade 3 won't be sufficient. And grade 4, definitely laser is not the option. You have to go for the other options in the form of a stapler or conventional ones. So selection of patient is the key here. If you select grade 2 or early grade 3, this is where you should have a patient selection. Okay, where you'll get a good results and patient will be really happy. So take a look at this laser hemorrhoidoplasty. It is called commonly as in a short form as LHP. It is a diode laser is used with 980 by 140/70 nanometer frequency. We have a I think we are not able to see the conical tip. I'm sorry for that. But the tip here is a pretty conical one. Okay, it's like the pencil which is lying down on your table. The tip of a pencil, you can see exactly that's the tip of the laser hemorrhoidoplasty procedure is. So energy of the laser is inserted centrally into the hemorrhoidal mass, and there is a direct about in 30% cases effect where the shrinkage happens, and successively over a period of 6 weeks we get a significant shrinkage of the pile mass. So now basically how does this happen? It is a controlled energy deposition which obliterates the pile mass from inside and preserves the mucosa and sphincter structure. For this I want you to focus here. See, if we give, take a look at this diagram. If we focus on this only, we introduce the laser probe, and only the vessel complex, blood vessel complex is given an energy so that the muscle, the internal sphincter and external sphincter is spared. So there is no question of transmission of energy if one does really carefully. So no chances of stricture in the post-operative period of 3 months, 6 months down the line. So yeah, so the homogeneous laser emission from the LHP fiber results in closure of the arteries entering into the hemorrhoidal cushion. Then we have a tissue reduction in the hemorrhoidal node and maximum preservation of the muscle, anal lining. There's no mucosal problem so far, and resultant there's no stricture. The major worry that happens in the patient's mind and post-operatively is the stricture, anal strictures. That is the deadliest, one of the deadliest complication of the anal hemorrhoidal surgeries. So hemorrhoidal mass shrinks. In addition to fibrotic reconstruction, it generates a new connective tissue which ensures that the mucosa adheres to the underlying tissues and that prevents the occurrence or reoccurrence of a prolapse or prolapse of a hemorrhoid. So take a look at this pictures. These are our own pictures where we have introduced this. On the left hand side, right hand side, you can see this is the laser probe which is entering into the hemorrhoidal mass, and you are delivering energy, and you can easily see on table the pink mass becoming whitish hemorrhoidal mass, and that's the end of the that's where one should stop the delivering energy at the local area. So what are the advantage? Post-operative period is less painful as compared to conventional ones. Conventional ones are pretty painful for the patient for a day or two or a week or more, almost 10 days. So it's a daycare procedure. You don't need to keep the patient overnight in the hospital. You can use a sedation and a kind of a local anesthesia combination. I believe sir would agree with this, rather than going conventionally with the spinal anesthesia, which would force the patient to be in the hospital for 24 hours. Chances of post-operative bleeding are minimal as you are dealing directly with the blood vessels and you are coagulating the supply which is happening. There's no need of post-operative dressing. No chances of rectal stenosis with definitely an experienced hand, and no chances of incontinence and no significant mucosal damage. Also can be done in post-operative CABG and postpartum patients. So CABG patients are usually on dual antiplatelets. Ecosprin, clopidogrel, Brilinta, various antiplatelets. In that scenario also you can use this technique. You don't need to stop antiplatelets 5 days, 3 days prior. With ongoing antiplatelet you can use this procedure. That's the biggest advantage, I would say. So anal fistulas here, I would say this is the one of the most commonly used indication of laser. Here we have different types of intersphincteric, transsphincteric, all those kind of fistulas being supraelevator can be used. Let's not go into theory part of it. Yeah, the conventional ones, and we have treatment for laser for fistulas in the form of ligation of lift, in the form of the long form is ligation of intersphincteric fistula tract and WAFT, video assisted fistula treatment. So this laser is the big new innovation in the treatment of fistula, where we first examine the anal canal, we search for the internal opening, we find out internal opening, and then we use methylene blue hydrogen peroxide to delineate the tract. Then with the help of a scoop, we cause the purposeful endothelial injury so that there should not be any endothelium which is left behind, which can lead to reoccurrence. And then with the help of liquid hydrogen peroxide, thorough cleaning of the fistula tract, and at the end we use the laser fistula probe and deliver an energy of almost 80 to 90 joules per centimeter. That is the most important thing which one should remember in the beginning, because more energy delivery will cause more adjacent tissue damage, and that can result into deadliest complication post-operatively after 3 months, 6 months down the line, in the form of anal stenosis. I've been treating anal stenosis quite often. It's been coming to us being a tertiary care center, and it's really painful for the patient also. Load the iliac fiber and we can deliver the energy. So that's the most important thing. Delivering of energy, how much energy for how much centimeter is really important. It should not exceed 100 joules for sure, for 1 centimeter, for 1 given centimeter. So again, we have to scoop the tract, confirm the cleanliness, and close the internal opening with the help of PDS. And that's, you can keep the external opening open like this, you can see. and it will gradually heal over a period of almost 2 to 3 weeks. Here you can see there's no conventional wound here. In case of a conventional surgery, I can show you the diagram. Take a look at this. Take a look at this. Such a big injury one has to do if it is a conventional surgery or any other format of surgery. But in case of a laser, you take a look at this. It's hardly anything. Patient can go back to his office next day. In our city, we have a problem that patients are so constrained. There are micro families where the husband, wife, kid is there. There's no third person to take care of them, and they are very curious about joining back to their day-to-day office. So this surgery, this option of laser on 15th post-op day, take a look at this. It's really nice. Patient can join office, sit nicely, minimum possible pain, minimum possible painkillers, and it's really a big boon. So PHYLAC laser advantage are basically it's an excellent primary healing rates, only minor reversible impairment of the continence, smaller perineal wounds, long-term dressing is not required. It is absolutely minimal pain, minimal complications, everything is minimal. Hospital stay is less, your expenses, the patient's expenses are less on post-operative and intraoperative expenses. Then let's talk about anal fissure. This is again one of the emerging problem. Most of the times the patients that comes to me in our OPD is usually this. And these are usually females who are between age group 20 to 40. And they give a typical history that, doc, I had this complaint of pain and burning and, itching at the anal region after passing motion. It's been started quite a long time when I was in my early college life. So I would say in Indian scenario, it is the commonest anal region pathology that we see in our day-to-day practice. So what is anal fissure? It's a small cut at the anal region, but it cuts, let it be even a centimeter or two length, but it pains, and it pains like hell, believe me. So how do we deal with it? It's acute fissure and there's a chronic fissure. Chronic fissure has a sentinel pile, and again, we can use a laser. Let's not go back to the theoretical part of it. Let's focus on our laser. Here, we have no cuts, no stitch, and of course, no blood loss. We can go from the side of the anal canal, I would say anal verge, almost 3-4 centimeter, make a small hole with the help of 11 number knife, and through that we can pass our probe, laser probe, and reach up to the internal sphincter, and with the help of delivery of energy, we can cut the internal sphincter, doing any open surgery at the local site. So what are the advantages? Again, it's a daycare procedure. You can discharge the patient on same day. Post-operative dressing is not required. Maximum pain relief is obtained within 24 hours and can be done in a pregnant and lactating females also. This is a common problem in last trimester, where the gravid uterus falls on the rectum and anal canal, and constipation is a big problem for the mother. We try, of course, we try as much as we can postpone till the delivery happens, but in certain situations we have to opt for this. We don't need much of painkiller post-surgery, and again, we can do it with antiplatelets on. All forms of antiplatelet we can go ahead with. So another indication of laser is pilonidal sinus. This is again a tricky situation where we have seen if we do a very, very vigilant treatment here in pilonidal sinus, then laser is the treatment of choice. But one has to be really experienced to deal with this, or else reoccurrence rate in pilonidal sinus dealing with laser is again a high, only because I feel we have still a little longer learning curve for surgeons for pilonidal sinus. So again, let's not get back to the theoretical aspect of it. Take a look at this. This is a primary pilonidal sinus being in the midline, one opening, and this is another opening with a pus discharge. We have conventional incision drainage, we have open wide excision, we have flaps various flaps in the form of rhomboid and all, Z-plasties and all, but this is what I would recommend, laser surgery. Here, take a look at this. This is my patient 3 weeks back done. Take a look at this, and this is the one which we did it in February month. Such a big injury that we gave to the patient in case of a open wound. This patient came to me from Germany. He had open surgeries done 3 times in Pune over a period of last 8 years. So we had no option. He was pretty infected one than to go for open surgery. Here we are dealing with vacuum dressing and let it heal with the secondary intentions. This is Z-plasty for you. See the type of pilonidal, the area involving pilonidal was literally small of 5 centimeter or so. But the rhomboid flap, it's not bad thing. It's definitely a good one. But again, one has to think, what are we going to give to the patient? For a pathology of 5 centimeter, we are giving a wound of this big. So now I would recommend this laser surgery. It is being really phenomenal, provided you have only one single track. Okay, if you have a multiple track in the surroundings, then definitely laser is not the treatment of choice. What will happen? You will end up in dealing with the primary tract only, and the secondary tracts will remain, and they will cause patient a reoccurrence. But always I would recommend that what is wrong in giving a choice to the patient and a chance to the patient rather than giving a bigger wounds. So similarly, like a fistulous tract, we clean the entire endothelial lining. We do a purposeful debridement of the sinus tract, do the endothelial injury so that we don't want that endothelium to remain there, so that there will be a lesser chances of reoccurrence. And we pass the we pass the laser probe, and again the principle is same. 1 centimeter you deliver 80 to 100 joules of energy. So again, benefits are far better in this typical case of pilonidal sinuses. Patient can join back to school or college or work immediately. No bigger wounds, no dressings, no expenses of the patient for a month or two for doing dressings and all. And economically much better to the patient. Smaller wounds, less pain, less painkillers, everything less. But major benefits. Thank you so much for listening patiently.
Wonderful lecture, sir. One question.
Yes.
Which diode laser is better, 980 or 1470?
980 would be better in my experience. It is better.
In pilonidal sinus with one track, if there are hairs inside, what is the first? We do need to curate first?
We need to curate first, clean it thoroughly with hydrogen peroxide, do curatings, and then subject
laser.
for pylon, then subject for
one
laser.
track with multiple openings, or
Definitely curating and definitely laser. No problem.
Okay. Thank you, sir.
Thank you.
Any question from audience?
Yes, ma'am.
Check.
The mic.
Yeah. Yes. Definitely, I definitely do it.
So we first perform MRI for fistula. So if there is a multiple track fistula, we can't use laser for that.
Multiple tracts, complex fistula, high anal fistulas, definitely it won't be successful. You can't reach to all the tracts because ultimately it is a blind procedure. So single tract, which is even a transpintric, you can give a chance of laser. It will give you much better results. But complex fistulas, supralevator, definitely conventional surgery then.
So you are suggesting for multiple tracks, you use laser in one track.
One
Another
track.
you
When there is, yes.
just curate the fistula.
Just curate
and
the
finish it
fistula.
off. Acha, okay.
Ji.
Thank you so much.
For getting good results.
Thank you. Thank you. Thank you all the chairpersons. One photo with all the chairpersons and speaker, please. Thank you, Dr. Pramod, for giving such a wonderful start to the conference and introducing robots as well as lasers in two different lectures. I would like to thank the chairpersons also for presiding the lecture was so beautiful manner. So we will break for lunch now. We have a lunch break of initially planned for 1 hour, but we'll be cutting it down to 30 minutes. So we would join here in 30 minutes and be starting in the next session. The lunch is just by the side of the room. Please join for the lunch. Thank you.
Welcome, Dr. Ashish Kale. I'd like to introduce him as a very eminent speaker, first of all. And he's the director of Asha IVF Center, director of Asha Kiran Hospitals, Pune. He's a FOXY member since many years. He's also the Family Welfare Committee Chairperson, FOXY 2325. He's a clinical secretary of ISA 2224, executive member of IH. He holds various posts. The slide is getting cramped up for that. But he's also a recipient of an IH AGL Skill Excellence Award in 23. He's ISA Youth Icon Award 23. He has many various publications in national and international journals. Over to you, sir. Thank you.
Good afternoon, everyone. After the post lunch, I think our glycemic index will increase now, and I can assure you I will not bore you, and it will be much more interesting because the newer concept of endometriosis I will be talking about. Today, I'm really thankful to Dr. Revati for inviting me, and also IMA AKLUJ and for all of you for attending in large number. Today I will be talking about fertility or preservation or enhancing treatment in endometriosis. All of us knows there are the two types of clinician, one who treat the disease with the medical what you call as drugs and medicines, and then there is another group of the people who are called as a laparoscopic surgeon or freelancing laparoscopic surgeons who operate. So it's always a debate that I should operate the patient first or I should do the medical line of treatment. As far as the fertility or that is a reproductive age group of the patient is considered, we need to have balance between the two. Why the surgical aspect is differ when we operate on the endometriosis? Because we know 15 to 20% of the couples has the endometriosis, and the fecundity rate of untreated endometriosis is anywhere between 2 to 10. What it means to us when the patient comes to the infertility to us and she has a 2 years or 5 years of infertility and there is no obvious cause is known, you do a laparoscopy, you find it out there is a endometriotic implants, and then we thought what is the cause of it is because of the early endometriosis which destroys the pelvic anatomy, and that's the one of the reason for infertility to come.
So we have got Dr. Suryanshi sir in the house. Yeah. So please join on the stage, sir, as a chairperson.
So we'll go one by one. When we talk about the infertility issues, whether it is a early disease or whether it is a late disease, it starts with the peritoneum. And the year back or maybe 4 years down the lane, the people thought that if we just do a fulguration, then it will be easier for us to treat the endometriosis. They take a bipolar and that starts fulgurating the disease. And now it is just a tip of the iceberg what we are seeing. There is a much more disease underneath the peritoneum, and we thought of doing the peritonectomy, whether the incidence or whether we like it, the approach, or we don't like it, but a total peritonectomy is the way forward, and that will take care of the detail of the disease. Because all of us knows the peritoneal fluid itself in the endometriosis, once you put the trocar, you see the blood in the peritoneal cavity. Don't get afraid that you are damaged some injury or you cause some vascular injury. It is not like that. If you see the blood in the pouch of Douglas, it could be because of the endometriosis, and this blood may have a potential deleterious effect on the oocyte qualities and the development of the embryos. We know the basic, the largest cell in the human body is the oocyte, and that gives the quality of the embryos in a future journey. So altered implantation mechanism may be a basis of infertility associated with the peritoneal endometriosis, and the consistency of the reduced expression of the integrin alpha that is called as adhesive molecule, which will cause the implantation in subsequent pregnancies. And when this is the paper in 2021 which tell you about the when and how should the peritoneal endometriosis should operate in order to improve the fertility rates, and these are the certain things I wish to show. Yeah. See, it is very easy. Once you start the surgery, there is a basic steps now which is involved in the endometriosis surgery. The first step is starts with the pelvic beam. The pelvic beam, there is a called as a, we always know there is a adhesions, the sigmoid adhesions. You do adhesiolysis. The second most important thing in any of the pelvic surgeries is to identify the ureters, because if you can damage the vasculature, you can have the bipolar in your hand, you coagulate and you can go ahead. But if you are inadvertently causes the damage to the ureter, then it will be a problem. So here we started with the mobilization of the sigmoid. The sigmoid is going to get mobilized, and you can see from the IP ligament the ureter is been seen. What you need to understand, you just do a ureterolysis with the blunt dissection, because the ureter has is a periureteric sheath, and the blood supply from the ureter is maintained from that periureteric sheath. And if you preserve that sheath and you just do the peritonectomy, then it will be easier for all of us to understand. If you do always do ureters, you cannot just see the ureter, see for the peristalsis. Gone are the days you identify it is a ureter and then you do the ureterolysis, rather than just saying the pulsation of the ureters, that things that nothing has been done. So it is always identify the ureters, get till the ureteric tunnel, you dissect down the ureteric tunnel, and then there is called as a peritoneum, which has the mostly affecting the ovarian fossa, and then the uterosacral ligaments, back of the uterus, and the other uterosacral ligaments, and the ovarian fossa. So initially we called as a butterfly technique of the peritonectomy, which will take care of the two wings of the butterfly, and the main body is from what we are doing. This is the one of the peritoneum from the left side. Then and the back of the uterus is the main body of the peritoneum, and then you can have the another peritoneum from the other side. The identification will remain the same. You go with the step by step from, because if you are not identifying the plane, you have to just move one step from the what you call as a where there is no disease. If you are going from the plane where there is no disease, you can identify the structures very well. You can use a harmonic, you can use a bipolar sharer, you can just use a scissors also. That's not an the effect of the instrument lies in the hand of the surgeon and not with the precision of the instrument. So any of the dissection can be taken care of by doing this. I will just fast forward it. You can see this is the ureter. Till the ureteric tunnel we have to go and just do the total peritonectomy, and this will improve our infertility rate. And that is much more important, because if we leave the diseased peritoneum behind, it will again cause adhesions, and it will cause increase in the inflammatory reactive and causes the bad quality of the oocytes. So coming down to the another things is, from the peritoneum we'll always talk about the ovarian endometrioma. Whether there is an endometrioma which is going to operate, or where I will going to give a medical line of a treatment for the endometrioma, it basically now we have to have a two clear-cut guidelines what to be deciding factor is. Whether the ovarian endometrioma is a bilateral, that is one of the things that we need to understand. Whether endometrioma is associated with the decreased AFC or decreased AMH levels, then my approach will be totally different. I need to understand the few questions before I address the endometrioma. What we know about the endometriomas, whether it is going to affect the oocyte quality, whether it is I'm going with the IVF stimulation, whether it is coming in my way for the worm pickup, that has to be talked about. And what is the recurrent treatment? If it is a recurrent endometrioma, whether I will go with the laparoscopy again, or whether I will first take care of the fertility of the patient and then I will do the needful. The incidence of the endometrioma is between 70 to 44% with the woman with the endometriosis. The fertility preservation is always, you have to ask yourself whether I will be doing the complete surgery for that patient. Because if there is endometrioma, I will do a cystectomy if the AMH is good. If the AMH is not good, it is better to just aspirate and just now do a thorough suctioning and get, because if you are doing a whatever technique, you do a hydrodissection, you do whatever it may be, the hilum of the ovaries are going to get damaged, because it starts oozing from the hilum, and then you start doing the coagulation at the hilum, and which will cause more The laparoscopic management is always there is not a debate now whether I will do a excision or whether I will do ablation. Excision, if I do, the chances of recurrence is less. If I just do ablation, the chances of recurrence is much more higher. Combined treatment, definitely I will give a GNH analog first and then I will do a cystectomy, or whether I will be doing a cystectomy and GNH analog. That will depend upon the disease and that will depend upon the stage of the endometriosis. If the endometriosis is a endometrioma which is less than 3 centimeter, I will not operate. I will just do a fertility treatment for that patient. If the endometrioma is more than 4 centimeter or 3 centimeter, and if it is a symptomatic, if it is there is a pain to the patient, then definitely I am going to operate. Guidelines for the same. I need to understand whether it is surgery, there is an invasive, it requires the risk of the anesthesia that has to be taken into account, and the relapse of the cyst. Because if the endometrioma I will be operating again, there is always a chance in the lifespan there is a recurrence of the endometriosis in that particular patient. So there are the category of the patients where I will favor the surgery if the previous interventions of the endometriosis is not there, the ovarian reserve is intact. What I mean by the ovarian reserve is intact, if the patient is 35 age and the AMH is 2 or 2.5, I will operate. But the same patient of 35 age and the AMH is less than 1, I will not operate because she is having the borderline AMH. The sonography features of the malignancy is not there. Definitely a patient is a candidate for the laparoscopy. History of the previous past surgeries, I will not operate because usually the bilateral endometrioma has a decreased ovarian reserve, or the patient will land up into more harm to the patient. So it is better not to operate on those patients. The cyst, and we need to talk to the patient before endometriosis treatment or laparoscopy, or for that matter any journey of the patient. You need to talk to the patient that there is definitely a role of a cryopreservation of the gametes. If she is a borderline AMH, I will stimulate her, I will do a cryopreservation of her oocytes so she can have a biological child later on in her career of the reproduction. So these are the things where you need to know how the endometriotic cyst is been operated, and okay. So there are the multiple things. You can use a cautery, you cannot use a cautery. If you are in a proper plane, then definitely you need to just do with the blunt dissection, because the capsule has a plane, and if you are dissecting between the two planes, there is definitely no blood loss. Your cauterization for the ovarian cortex is less. You can always have a better preservation of the ovarian reserve. And here if you are on the say on the left side, there is a bilateral endometrioma. The uterine is retroverted uterus. It is a blind dissections. Also sometimes just do a correction surgeries, because the retroverted uterus, even if you do embryo transfers, the chances of having successful embryo transfer is less. So correction of the anatomy is always the fact that remains the main treatment of the patients. Okay. It's not moving. Okay, yeah. See, here is the one of the patients in whom where the surgery is been advocated, because if the intestine and everything is adherent to the ovarian surface, it is better to operate. Because even if you do a Ohm pickup is a blind procedure by the sonography. So the bowel is going to get adherent, then inadvertently you are going to damage the bowel walls, and it is better if to do the surgery prior. And if the ovarian cyst of the endometrioma is in a bigger size, it is better to reconstruct the ovaries, because it will causes a good approximation of the two walls, and that can be taken care of. Coming to the just because you can't see, that doesn't mean it is not been existing. The living with the invisible disease is the true hold for the endometriosis patients. So classification of the DI, I will not go, because we have anterior DI or anterior segment, we have the posterior segment, that where the bladder is going to get involved. The bladder endometriosis is one thing that one should be deal with only surgery, no medical treatment is advocated, like the same as a posterior endometriosis where the bowel nodule has been there. So these are the anterior DI where you can see the bladder, and the posterior wall where the uterosacral ligaments or maybe the bowel is involved. You can have the vagina, intestine, you name the organ, the endometriosis is going to be there. So the first thing is like the urinary tract endometriosis. It accounts for 1 to 2% of the endometriosis. Mainly the bladder is the involving organ. You can have the ureter, you can have the kidneys and urethra. I will going to show you the one good clip of wherein the ureter, you can see there is the hydroureter, and you just give the nick to the ureter. It starts pouring out of the urine. It is better because if you are not operate that patient, she will go into a kidney which is going to get damaged, and later on the non-functioning of the kidneys are there. So if you seen on the ultrasonography there is a endometrioma, please make an attempt that you are going to see the ureter, see for the kidney, and also evaluate the kidney functions. If the patient is having the hydronephrosis, it is better, or hydroureter, it is better to operate the patient because that will give us more corrective surgeries than anything else. Again, it will remain the same. You just do potential spaces of dissection. There is a avascular, there is a pararectal space, and then there is a paravesical space. In those spaces, if you are in a proper plane, it will usually guide you the disease. You can just see here there is a paravesical space. I'm going to dissect it out. You can see the uterine, the umbilical, obliterated umbilical, which is the guidelines for that. Prior or medial side of the it, if you go on dissecting, there is hardly any structures, and this is the trademark wherein you are going to have a paravesical space. Why you need to dissect it out? Because if I'm cutting the ureter above the pelvic brim, or maybe I wanted to mobilize the bladder, because this ureter has to reimplant, and for ureter reimplantation you have to mobilize the bladder from all the sides, because it is a tension-free anastomosis. You can see, I'll just fast forward for the same. You can just take the psoas hitch, the bladder hitch with a non-absorbable or absorbable suture material which is available to you. You can use a vicryl for the psoas hitch. You hitch the bladder, and once you hitch the bladder, you can open the bladder in the suitable plane, and then you start reanastomosis. Reanastomosis, what usually need to understand, you make the incision on the ureter, which is more like we call as a funneling of the incision. You make the incision more as compared to the you required, because there are the chances. Nowadays we use a barb suture, hardly we use a vicryl, and which has a fantastic results, doesn't require any of the assistant, or for that matter any surgical betterment of the suturing technique. What you need to understand here is that the very well surgical principles is inside out, outside in. So the suture, first I will be going to take from outside in and then inside out, if you are going from the bladder to the ureter. If you are going from the ureter to the bladder, remains the same, and you have to maintain the things. The catheterization, ureter catheterization has to be done, and it usually we take out the ureter catheters after 3 weeks. You can just do, this is the I'm using here is the same vicryl. You can see outside in and inside out, and that will gives you a better approximation. The final things I will be able to no, yeah, okay, yes. Here you can just see what you need to understand. You need not to give it just too much of pressure on the suture material, because if you are too much of tightening of the suture material, it is not needed. It is the approximation of the two tissues what is needed in this particular juncture. Coming down to the bowel endometriosis, the symptoms, usually the patients coming of the symptoms for the bowel endometriosis is not that pertinent, because a patient come down to you for infertility. If you start doing the scan from the posterior vaginal fornix, and then you come down slowly above. What first thing, if you are, I'm going to have that ultrasonographic features of the endometriosis, you can have the puckering, or you can have a black nodule like a structure of the uterosacral. And if you're just sliding the probe from the posterior vaginal wall, she is going to have a little bit pain, and that is going to give you some clue that there is a definitely involvement of the bowel nodule also. Usually the bowel lumen doesn't, we never come across on the sonography. If you are well prepared the bowel, then you can only see there is a translucent area that is called as a between, there is a hyperechoic, hypoechoic and hyperechoic again, that you need to understand. A hyperechoic structures is a serosa of the bowel. So if you trace that serosa, the blackening nodule look like a black thing, and that is a usually you measure. The resection or just a shaving of the bowel nodule is depending upon how much is the depth of the bowel, of the nodule into the bowel. If the circumference is involved more than 1/3, then resection anastomosis is required. And if it is less than 1/3 of the bowel circumference, then usually the shaving will be suffice, because what we do are discoid excision. It's depending upon the plane where you are operating, because once you separate the bowel from the posterior part of the uterus, then you need to know what is the length of the nodule and how much it is far from the rectum. If it is more than 7 centimeters away from the rectum, usually any one of us can do. It's not only the surgeon's forte. Mind well, we are gynecologists. We always thought about pelvic anatomy in much more great depth rather than anyone else. So we should not fear about the fistula formation and all that things. We also see it's a technique. It is, even if the surgeon, based of the surgeon, if they are not well trained in the laparoscopy, they cannot able to do the anastomosis or these ureteric implants. We are better to do it with the suturing, because we sutures myomas in different locations. We are better at suturing. So I feel it is our forte to do all that things, and we can able to perform. See, always we thought of, if there is a leak occurs or there is a bowel leak, then what is the diagnosis? The first, because I'm going to give you some silent points how to diagnose the complications, because then all of you will say, if there is complication occurs, how can you diagnose the first things? Where the ureter and bladder is a forgivable organs. Usually the complications rate doesn't go that high if you are doing a proper anastomosis and you put the ureteric catheters for 3 weeks, nothing goes wrong. The bowel, definitely, if you are having on the stapler line, if there is a fat, if you dissect down the fat and in the stapler line there is no fat, no leak will occur. Usually why we are feared about the leak, because the fat comes into that stapler line, and that is causes weakening of that staple line. And that is the first incidence where you thought that you are not going to have an approximation of these two. I will show you that also in a video where we see there is a bowel nodule, and hope it runs. Yeah. Okay. See, these are the places where you have the central disease first. You need to have a pararectal dissection. Mind well, friends, it is a very holistic plane. There is nothing, no blood vessels major comes into the pararectal plane. You start dissecting, and in a normal hysterectomy also you start dissecting the pararectum, and then in the disease cases you better know, because what makes fearful for us is to anastomosis and the disease nodule. Once there is a rectum which is going to get stuck, all of us are thinking, nahi, kuch ho jayega, and then we just not do the complete surgery. Even if you just do a nick and it is a serosa is going to get damaged, even if the surgeon they do a silk and do the suturing, so you do the same. No, why we are worried about something is going to get happen and all that things. See, it is the fear in our mind that always we are running away from these particular diseases. You can, if you are in proper plane, and it is an art that you learn. It is not a 3-chip camera and 3D and all that things we required. It is the art of the surgery and the structures identification that's required. The rectal dissection, if you can see the pararectal, if you are both of the pararectal spaces are free, only the pivot point is your rectum, which is in the center. And if you start dissecting in the center, it will just cause, there are the two incidences where you can land up into a problem. If you are going too much near to the bowel, see, bowel has a fat. So if you are remove above the fat, it will not going to damage the serosa. And if you are too much into the fat, then definitely you are going to damage the serosa. If you damage the serosa, it's fine. Nothing will be wrong in that. You just suture it and get rid out of it. So what I mean, like what's the take-home message? The practice, practice and practice. If you are wanted to go into the things, definitely you need to understand the every patient's requires individual approach. And nowadays, the individualistic approach is the key. You need to do, now because I'm a great surgeon, I should not operate only. I need to take care of her symptoms, whether she is coming from her infertility, what is her AMH, what is her AFC. If the AMH and AFC and her age is advanced, it is better to do the IVF or the IUI cycles and then complete the surgery later on. And if she is a very young patient and only having the endometriosis, which is a symptomatic endometriosis, then and then only you should operate. Yeah, thank you. Thank you for patience.
Thank you, sir. Endometriosis is an enigma, and surgical management is really challenging and skillful, and optimization is very important. Sir has beautifully covered the topic with amazing videos. So I request our chairpersons to give their expert comments or any questions if they want to ask, please.
Dr. Ashish, excellent talk. I was writing questions and I was getting the answers in the talk only. So it was a very good thing which I had. Only one question, like you are like a laparoscopic surgeon, gynec surgeon. Also you have gone to urology, neurosurgeon and even surgeon. So like how is it ethically right, or we can say medically right, when we do operate and have some complication in it?
See, complications can occur with the urosurgeon also, oncosurgeon also and gynecologist also. So if it is endometriosis things, the consent at the beginning, if I am doing the sonography, I find it out there is a bowel nodule. I will give in a writing to the patient, there is a bowel nodule, there is a chances of the damage to the rectum, which I can able to handle, but I will call a surgeon just to have his opinion also on the table. But I will be operating, and because I am trained in operations, I can able to operate, because if the general surgeon is doing the open surgery for any colonic cancer, and how can he will be doing the surgery in the laparoscopy? That is the biggest thing. One should understand, if he is a very good surgeon in the open surgery, it's a periphery situation where there is no laparoscopic surgeon is available. How we can do that? So it is just, you need to call the surgical steps of the surgery is good, then nothing will went wrong.
So we should have a backup urosurgeon or a surgeon in the OT assist. Fine. You also mentioned about DII posterior, like about that serosa thing. Can you just explain about it? Like how do we diagnose on sonography? You said about the bladder, and you had that clip you said, or you don't have?
Yeah, I do have, but I'll just because it's there on my Facebook channel where I do a live demonstration. See, when you start from going from the posterior fornix, the first things will come up. Like just you, as a gynecologist, what we are trained just to do, the uterus should be in the one plane, then both the ovaries should be seen. If you are going from the posterior fornix, the first things you need to understand, it is a hypoechoic structure. That is hypoechoic. Lumen is a hypoechoic. The black things on both the sides of the lumen is the serosa. Okay. And that black line, if it goes and it starts showing something, some lesions, that is a bowel serosal nodule.
Okay.
I will definitely show it. That's
fine. Sir.
Is there any relation between infertility and urethral endometriosis? Urethral.
Yeah. See, infertility, usually if it is a urethral endometriosis, or for that matter vaginal endometriosis, it will cause a dyspareunia. For those patients, they are not able to consume the marriage also. In some of the times the patient comes down to us, their sexual activity is not that much, wherein they are afraid of having the intercourse. So that is one of the reason, and simplistic reason. And if you do just a per speculum examination, no sir, you will see, and the posterior fornix there are the spots, and that is a indirect evidence of the endometriosis.
So one last question.
Yeah.
When do you say no to for a surgery? Like, I will not operate this patient.
The bilateral endometriosis, I will not operate. Previous history of endometriosis, I will not operate. Advanced age of the patient, I will not operate. If the AMH is poor AMH, with any, even if she is young, I will not operate. Because those are the patients, I will take the stimulation, I will just cryopreserve her gametes, and then I will do completion of the surgery.
Any questions?
Do you believe in giving medical therapy to downstage in very severe cases and then operate? What is your view on that?
Good questions, madam. When you are giving, what we have a two drug of choice. We have what you call as a GNH analog. If the patient is a young adolescent, will not give a GNH analog. Then we have a Dynogest. The beautiful things in a 1 to 5% of the patient of endometriosis, if it is a bilateral endometrioma, you have adenomyosis. If you seen many of the patients, if there is an endometrioma on both the ovaries, usually have some of the component of adenomyosis. In those patients, if you give a GNH analog or for that matter Dynogest, it will suppress the disease. Then you operate now, you will cause a little bit not diagnosing it at the correct point. So better to operate. If you are planning to operate, don't give anything, you operate. And then you, because it's you are suppressing the disease, you are taking care of only what you are going to visualize. So majority of the time, even if you give something, it will cause a hampering of the disease and you are not taking out the disease completely. So it is better to operate first. Yeah. Thank you.
Thank you very much, sir. I would request Dr. Satish Doshi, sir, to please felicitate our speaker. Also, I would request the other chairpersons to please join in the felicitation. Thank you, sir. Thank you for a wonderful presentation.
Invite Dr. Ashwini Kare madam. She is a gynecologist and embryologist traveling from Pune. Thank you, ma'am. Today we are talking about mainly robotics and laser. And laser from head to toe has got so many uses and so many things that we can do with that. So today madam is going to discuss about use of lasers in IVF. So over to you, ma'am. And I would like to request our chairperson, Dr. Sushil Shinde, to please introduce ma'am before that.
Welcome, Dr. She's Secretary Pune OBGYN in 2020-21. She was a Treasurer Maharashtra Chapter ISAR at 2018 and 20. She's elected MCM Embryology ISAR 22-24. She is MCM Maharashtra Chapter ISAR 21-23. She's Chairperson of AMOX YTP Committee in 21-23. She's Zonal Coordinator of AMOX. She's a peer reviewer of Jogi the Journal and awarded as Foxy's Son IAC Traveling Fellowship in 2021 and Foxy Shanti Yadav Award 2022. Over to you, ma'am, on the lasers. We knew that IVF was the new thing few years back. Now the lasers is the new thing. So please take over.
Thank you so much for the kind introduction. Capacities, be it ophthalmology, be it proctology. So this is a very unique concept, and thank you so much, Revati, for having us here. It's really a pleasure to be here, and you have done a lot of hard work, as I can see here. So coming to use of this lasers in IVF, so basically this all started way back in the 1990s when people felt that if you could just put in a hole in the zona, probably that could be able to help in the implantations. So going back to what exactly an embryo is and at what stage you use lasers, that is why I would like to start with the first basic slide, that this is how an embryo develops, where in the first slide, day 0, you can see that a ICSI is being done, where a sperm is put inside the egg, that is a mature egg. Then this is the development. The first one is the development on day 1, where you see 2 pronuclei. Then the cell starts developing into the embryo, where the 4th image is basically of a morula, and the day 5 embryo that we see after 5 days of fertilization is the blastocyst. This is where our lasers and biopsies come in the picture. So this is the history of the embryo, which starts with the quality of the oocyte. So there are so many factors in the oocyte which are very important to make a good embryo. And the most important part of this oocyte is the polar body, which you can see down there. That is important because even that can be biopsied, and for that also at times you require laser. So this is how the fertilization takes place of the mature oocyte and a mature sperm. And this is the embryo assessment that happens in the lab. So now there are two methods of assessing this embryo. One is your non-invasive method, which has been going on for many years. That is, you see the morphology. As we just saw this appearance, you can call it 4-cell, you can call it 6-cell, you can call it 8-cell, or at times it becomes a morula, which is more than 32 cells, where it cannot be counted. Or there are the time lapse, where there are timed events basically that you can measure. Then there is time-lapse managing, which actually gives you the picture wherein multiple pictures are taken per second, and then you can exactly assess it morphokinetically. It means how is the morphology at that particular time. So it is measured on a graph where according to the day and time, the development is assessed. The second is your invasive method, which is the pre-implantation genetic testing. And for this testing, we require this laser wherein we have to biopsy these cells. So this is the cleavage stage embryo scoring that I was talking about, where you do a early cleavage check when the embryo is 2-cell, then a day 3 assessment is an 8-cell stage, and a day 5 is the blastocyst, which could either be an early or a late. So this is the most important thing which is going to be lasered and biopsied. So this is the blastocyst grading on day 5, where you can see it is an expansion grade. And there are two things that we basically stage it on. One is the trophoectoderm, that is the outer lining of the cells, and then there is the inner cell mass. Now, how reliable is this morphokinetic assessment? Basically, this is the only assessment that we have as of now, because bad morphology may mean bad quality. But a good morphology does not always mean a high developmental capacity, or you are not assured that a good quality embryo would 100% give you pregnancy. But when you biopsy these embryos and you get a euploid embryo, that means that it definitely is meant to implant. And hence the need came for PGT. So now what is this pre-genetic testing? You have 3 options in that. Either you test the patient for aneuploidies, that is your chromosomal defects, or single gene defects, that is monogenic, or structural rearrangements. So in whom is this euploidy done? So this is the most common indication why we biopsy the embryos. It is for advanced maternal age, which is very common now, and that is why these patients land up for IVF, and probably one of the reasons for failed IVF could be that we are not getting one euploid embryo. Recurrent implantation failures, recurrent pregnancy loss, cases of severe male infertility, and when we have to go ahead with just one embryo transfer. Then these are the monogenic disorders. So this is done in those patients when you know a specific family history. Like if the patient has a single gene disorder like Huntington's disorder, cystic fibrosis, Fragile X syndrome. So we only have to check for that. So there are various, and the third type is the structural rearrangements, that is your deletions, duplications. So PGTA is basically done either by FISH, quantitative PCR, or we do a comparative genomic hybridization, or a single nucleotide polymorphism, or the NGS, which is very common now, that is next generation sequencing. So the various pros and cons of these methods are given, that when you do it with FISH, you can analyze only the 5 chromosomes, that is 13, 18, 21, and X and Y defects. The rest of the other chromosomes are not assessed by this. When you do quantitative PCR PGTA, it is a low cost thing, but with a shorter turnaround time also, but it does not detect your segmental mutations. And the most important thing that it doesn't detect is mosaicism. So mosaicism is that group of embryos which may or may not lead to these chromosomal defects. So this quantitative PCR uses only 4 probes for each chromosomes. And the single nucleotide genes, it basically detects even unbalanced translocations. And NGS, which is the next gen sequencing, is the most commonly used these days. So it has the ability to detect this mosaicism also, and even the small segmental mutations also. It produces results in 12 hours, and it allows up to 24 samples to be screened per run. So when a lab has a huge load of this, the cost probably decreases. And that is why it happens that in few places, the cost is very high of this biopsy. It is because that particular lab has to run 24 samples at a time. If they do not get that, then the cost of each one increases. So we are talking about trophoectoderm biopsy here, which would require a laser before. So basically the trophoectoderm represents the entire embryo. And the embryos which were even classified as mosaic during the day 3 or the cleavage stage, they are evaluated as euploid in this blastocyst stage. And that is why this day 5 is very important. So there are 3 things that can be biopsied. One is your polar body, that is the oocyte, but then it will tell you only the maternal factors. The paternal factors cannot be made out from this oocyte polar body biopsy. Then is the cleavage stage or the day 3 blastomere biopsy. And then the day 5, which is the trophoectoderm. The problem with day 3 or the cleavage stage is that you have only 8 to 10 cells. And when you have to send it to a biopsy, you should at least send 3 to 5 cells so that something can be made out of that, because they have to amplify it 1,000 times. So that is why we do it from a blastocyst, wherein from a trophoectoderm, you can take multiple cells. So this is how the blastomere biopsy is. The day 3 one, wherein you take lesser cells, it has got a higher diagnostic failure rate because the number of cells are limited. A more robust analysis with low impact of mosaicism is from this day 5 biopsy. So, I'll just play this video. So basically, at that point, if you can see, a laser shot is made, wherein a small hole is made into the zona pellucida, which is the covering of the embryo, and you suck out these cells from the embryo. So because the trophoectoderm is made up of multiple cells, even if you suck in 8 to 10 cells, it doesn't make a difference to the embryo. The embryo again regains its shape and size. So this is how the biopsy needle is there, which is all done under an electron microscope. And you suck in these cells. So finally, for this separation also, at times a mechanical separation is good enough, or you have to give in a laser also at that point so that these cells are separated out. And this is the biopsied material, which you can see it is there in the tubing. So it is transferred and sent to the lab. You can even do the same thing for a day 4 embryo also. This is the morula stage, wherein the cells are more than 32 to 36. So here, instead of a laser, you can do the hole with this needle, which is a mechanical drilling. So even this is a better option than laser, but this causes a lot of damage because you don't know at what all points you are actually damaging this embryo. Because with a laser, you are very precise, and that spot is only within that 0.1 to 2 millimeter. So it is very precise. This is a little cruder method which was used before the lasers. So here also you can see a lot of cells are taken out. So basically this is the holding needle, which under the microscope you have to hold the embryo and the other needle sucks it.
So this lecture was too beautiful that even orthopedic surgeon can understand.
Aesthetic is very
and I
easy
agreed
to understand.
that so beyond pelvis there are also very important structures are there. So handle with care, orthopedic surgeons.
Go.
To chair this session, I invite up on stage Dr. Sadhna Koladkar ma'am. She is a senior ophthalmologist from Baramati and president of IMA Baramati. Ma'am, please kindly chair this session. I also invite Dr. Neelam Thalge ma'am. She is a senior consultant anesthesiologist Borivali, GC member Maharashtra State ISA 2123 and founder member and joint secretary of ISA Borivali, founder and director of Aditya Arogya Mangalam Trust. Ma'am, kindly chair the session. Now I request Dr. Snehalata Pawar ma'am from Baramati, a well-known pathologist practicing in Baramati, to kindly chair the session. Ma'am has been a director of late Manikbhai Chandulal Saraf Blood Bank. She's been a chairman of Mission Pink Health IMA Baramati, a past vice president of IMA Baramati year 2020-22. Moving on to the lectures, I invite Dr. Richa Kansal on stage to deliver her talk on robotic gynec-oncology. She is a consultant gynec-onco surgeon and laparoscopic and robotic surgeon practicing in Mumbai. Thank you, ma'am, for coming all the way from Mumbai. Now I request Dr. Harkan Ali sir to kindly chair the session. Sir, please.
Hello.
Sir is an eminent dermatologist practicing in AKLUJ and has specialized in lasers and cosmetology. So I request sir to kindly chair the session.
Mumbai. Oncosurgery has been mainly conventional. I think the sound is echoing. Is it okay at your end? Okay. So,
cancer surgeries have been mainly conventional, partly because of extensive resections that are required, and also, because traditionally there have been many concerns about the oncological safety, meaning the survival outcomes, whether the survival outcomes when surgery has been performed by the minimally invasive route, even by either by laparoscopy or robotic, is as good as the survival outcomes when the surgery has been performed by open. But of course, we know that there are a lot of advancements that are happening in every field of medicine, and thankfully, surgical field is no exception. And from open to we have progressed to laparoscopic and now to robotic. So of course there are many strong indications, gray areas as well. Some are contraindications. Over my further few slides, we will see those. So, I thought I would start with a very practical slide that, what is the scope of robotic surgery in a gynae oncology practice. So, of course, the prototype cancer that we treat with robotics is cancer endometrium, early stage cancer endometrium. So, where robotic surgical staging for endometrial cancer with complete, hysterectomy, bilateral salpingophorectomy, pelvic, with or without para-aortic lymph node dissection is required. Then, of course, the use of minimally invasive, as you all know, for a suspicious ovarian mass is still controversial. There are many theories that, okay, if the surgeon is efficient in doing, they should not, in extracting the ovarian mass without any surgical spill, then they can go ahead with frozen section at hand and all of that. But, I thought I'll avoid all those controversies. So in my practice, it being a tertiary referral practice, so we do get many patients who, when the surgery has been done outside for an ovarian cyst, and if malignancy has been encountered on histopathology examination, the patient gets referred to us for further management for ovarian cancer. So, of course, these are the cases where, we can do the restaging surgery by the robotic route, where, of course, we will need to do the hysterectomy, removal of the other ovary if they have not been removed, then total omentectomy, complete pelvic and para-aortic lymph node dissection. That becomes another indication for robotics. Then, of course, for cervical precancer lesions and very early microscopic cervical cancer, we can do robotic extrafacial or type 2 radical hysterectomy with or without lymph node dissection, but with vaginal cuff excision. Use of robotics for cervical growth with an obvious growth on the cervix is contraindicated. We will see the evidence behind it. Another indication for robotics in our practice is for risk reduction surgeries. So we all know that, almost 15 to 20% of all ovarian cancer patients that we see can be hereditary, and hence it is a part of international guideline to test each and every ovarian cancer patient for germline BRCA1 and 2 mutations. And if any of our patients test positive for BRCA1, BRCA2, then we do recommend germline testing in her close family members as well. Maybe it may be her sister, her daughter, and of course the male family members as well. And if any of the family members test positive for BRCA, then we do recommend risk-reducing surgeries. And of course, for Lynch syndrome, where a female is at an extra risk of uterine cancer and ovarian cancer, we recommend hysterectomy and bilateral salpingophorectomy above 35 years of age. So these risk-reducing surgeries, of course, we can do by robotic route. And another indication, which is actually very close to my heart, is robotic bilateral ovarian transposition for fertility preservation in young women requiring pelvic radiation, be it for cervical cancer, be it for rectal cancer, be it for pelvic bones, sarcomas of pelvic bones, lymphomas. So any young girl who may not have completed her in the pelvic area, which is obviously going to fire her ovaries, will lead to permanent damage to her ovaries, resulting in loss of hormonal function, premature early menopause at a very young age, and also permanent loss of fertility, what we can do is we can transpose the ovaries, to the upper abdomen. On the right side, it's just below the inferior border of the liver. On the left side, it's near the spleen. So this is what we can do for their fertility preservation. So these are overall the most common case scenarios where we do use robotics. Of course, all the cytoreductive surgeries for advanced ovarian cancers, suspicious ovarian masses, cervical cancers, they are generally by the open route. So like I said, endometrial cancer is the most common type of cancer surgery that we do by the robotics. I've just shown a small video here. So she was a 60-year-old lady with apparently early stage endometrial cancer. Biopsy was a grade 2 endometrioid adenocarcinoma. On MRI, there was a 3 centimeter growth, which was invading inner half of the uterine myometrium. There were no suspicious lymph nodes. Rest of the abdomen was normal. So she was, taken up for robotic hysterectomy. So of course, first step was opening of the retroperitoneal space, visualizing all the important structures, ureter, internal iliac, origin of the uterine artery, taking the infundibulopelvic ligament, followed by bladder dissection. So you all can see the high resolution magnified view that the robotic gives. Of course, this is still a two-dimensional view. The video, we can have only two-dimensional view, but the surgeon actually gets a very nice 3D view while operating. The instruments have, 360 degrees rotation. So ergonomically, they become a lot better. Conflict of interest here is that I am a laparoscopic surgeon as well, and I routinely do laparoscopies as well. So I'm not advocating robotics over laparoscopy, but it's just another modality, another advanced technology where wherever possible, which we are using. So this is the that was the uterine artery which was seen. So for endometrial cancer, it's a simple extrafacial type 1 hysterectomy. Actual parametrial dissection and resection is not required. So I think I'll just forward. So for malignant cases, I do not use any intrauterine manipulation, but we do use the vaginal tube for little traction and for distending the vagina, which helps in colpotomy and also finding a good plane with the bladder. So following after hysterectomy, we are here proceeding with the pelvic lymph node dissection. It's a very frequently asked question, what are the indications of pelvic lymph node dissection, or why do we do when the MRI report was normal? So, there was a very nice slide from Dr. Ashish Kale sir's slide, the presentation that, if we are not seeing it, it doesn't mean that that doesn't exist. So, of course, it may be apt for endometriosis, but it's extremely, true for oncology as well. So, MRI being normal can never ensure that there are no microscopic deposits in the lymph nodes. In fact, we have seen that not us, but huge international studies are there which have seen that when we do systematic lymph node dissection in cases of endometrial cancer, even when there was no evidence of lymph node disease on MRI, CT scan, or PET scan, almost in 30% of the cases, the disease gets upstaged, means we do find microscopic disease in the lymph nodes. For your information, the prognosis, whether the metastatic deposit to the lymph node is 2 centimeter size or whether it is just microscopic 2 millimeter size, the prognosis, is no different. It is equally worse. The stage again is stage 3, and the same adjuvant therapy which you would give for a 2 centimeter lymph node metastasis, which is chemotherapy and and radiation, same would be warranted for a 2 millimeter microscopic deposit as well. So, this should be convincing enough that, irrespective of whether the lymph nodes are looking enlarged, suspicious on the imaging, but we do consider, if there are risk factors in the uterus for that warrant lymph node dissection, it should be done. So in pelvic lymph node dissection, we clear the external iliac, internal iliac, and the obturator lymph nodes. And this is followed by colpotomy, which is like routine. So this is a video on paraortic lymph node dissection. So whenever indicated for endometrial cancer, the paraortic lymph node dissection has to go up to the left renal vein. The most common indications are, especially when you're dealing with a grade 3 malignancy, if the tumor size is more than 4 centimeter size, if myometrial invasion is to the outer half, and of course, if there is any suspicion on the imaging, then definitely, along with pelvic, paraortic lymph node dissection also becomes must. So this is the common iliac area that, that is seen in the lower part. Sorry. So now we are proceeding on the IVC. Pointer. So just above the bipolar forceps is the common iliac bifurcation, and above which is the aorta. So this is the lymph nodal dissection, which is being proceeded over the inferior mesenteric artery. So this is the inferior mesenteric artery that goes into the sigmoid colon and supplies the lower intestinal tract. This is the common iliac bifurcation that I was talking about, and similarly for the IVC, and this is the IVC and aorta. Just forward it a little. A good exposure and a good assistant is very important. Just a moment. The cursor is पे नहीं आ रहा है. So here we are removing the upper paraortic and the aortocaval group of lymph nodes. There it's the origin of the gonadal. So this is the gonadal artery having its origin from the aorta. And that's the left renal vein there. So in malignancy cases, there's a lot of neovascularization, that happens, and sometimes, yes, the blood, the field can be little bloody. So so this was about endometrial cancer. Now coming to the ovarian transposition for young women with pelvic cancers. So, as prognosis of many of these cancers has improved with the, best of the surgery, best of chemotherapy, then immunotherapy, targeted therapy, radiation, it's time to look at not just the survival, but also at the quality of life. What is the quality of life that we are giving to our women? So, we we of course know about cervical cancer. It's a cancer of young women, reproductive age women. It has bimodal peak. Of course, one peak is for the postmenopausal age group, but another peak is for the women in 30s. And apart from cervical cancer, even rectal cancer, it's very well known to occur in teenage group also. So we have treated many teenage girls, 18, 19-year-old, early 20s with rectal cancer. Then pelvic sarcomas, again, many of these pelvic sarcomas can occur in young girls. So imagine, after surgical resection, chemotherapy, whatever, if they are going to require radiation to the pelvic area, a 19-year-old girl becoming menopausal at that age is actually it's a tragedy. And of course, we need to do something for the ovaries. So, what we can do is, surgical transposition of the ovaries to the upper abdomen to save them from the effects of radiation. And, so that, the ovaries are preserved. So, like I said, loss of gonadal function in young women will lead to premature menopause, loss of reproductive and hormonal function, reduced quality of life, and common indications are cervical cancer, rectal cancer, lymphomas, and sarcomas of the pelvic bone. So the advantages of this, of course, we can always do egg and embryo cryopreservation, but actually, practically speaking, delaying the treatment for 2-3 weeks that are required for stimulation and then harvesting is actually, it's practically not possible for these young girls when, because this radiation is a very time-sensitive procedure. It cannot be delayed to that much time. So, so as compared to that, ovarian transposition can be done, immediately. It's a 2 days admission that is required. Patient gets planned for the radiation. They are referred to us for ovarian transposition. Today we are doing ovarian transposition, and after 4 to 5 days they can go back to the radiation department and start their radiation. So it can be that quick. And because we are doing by minimally invasive approach, by laparoscopy or by robotic, there is no recovery, there is no delay in the recovery, no bed rest from the surgery, and so on. And of course, like I said, it's a time-sensitive procedure, so usually there is no time for stimulation and harvesting. And another advantage is that it protects both the eggs as well as hormones. So this is the advantage that laparoscopic ovarian or robotic ovarian transposition gives us. So I didn't have the robotic video edited, and so I thought I'll just show you the laparoscopic. Cursor nahi aa raha. Again, cursor. Sorry. So, of course, the first step is complete, thorough evaluation of the peritoneal cavity and especially of the pelvis to rule out any metastatic disease. Sometimes rectal cancer can have, small deposits in the pelvis, which may not get picked up on any imaging. Ovaries may look little enlarged, little suspicious. That initial screening has to be done. That there should not be any peritoneal spread or any metastatic spread of the primary disease that is being treated. And then the first step is detaching the ovaries and the fallopian tubes from the cornu of the uterus. And then ovaries and fallopian tubes are mobilized upwards cranially along the infundibulopelvic ligament. And of course, we have to see ureter along the entire course, and it should be under vision. So, ovarian vessels, they derive their origin from the aorta and IVC, which are much higher, as compared to the pelvis. So, ovarian vessels, actually, they travel a very long length before they come to the pelvis and supply the ovaries. So, this length is the factor that, we can take the advantage of. And over this entire pedicle, which is actually coming down from the aorta to the pelvis, we devise our pedicle and along these vessels. And instead of coming down, this entire pedicle is rotated upwards. So in this part, it was, being separated from the mesentery of the cecum and the small bowel. Here, I'm dissecting in the lateral paracolic gutter to give the pedicle some more mobility so that I can try and take it as high as possible. This is the inferior border of the liver that is seen, and you all can see that the pedicle is almost being attached to the below the inferior border of the liver. Those are the costal margins that can be seen. So ovaries are attached using a non-absorbable suture material, which is proline, and same process is repeated on the opposite side. So these are the actual photographs. The first one is of the right side, and the second one is on the left side. We can see the bulge of costal margin is seen. So, why do we need to go that high up? Because pelvic radiation, scatter radiation is a very important phenomenon, wherein, though the major dose of radiation is going in the pelvis to the organ that is being targeted, but there is always a possibility of scatter radiation, some amount of radiation scattering to the nearby organs. And if the ovaries are transposed just above the pelvic brim, the success rate that can be expected is only 50 to 60%, because in some cases they may still receive some dose of radiation. But when we are transposing these ovaries to that high location, the risk of this scatter radiation becomes very less. Again, it's a very commonly asked question that, how do we do egg harvesting and egg retrieval there? It can very well be done under ultrasound guidance. A radiologist can help us. So egg retrieval is actually not a very big deal. The problem is that, the uterine transposition is still, it still has a lot of technical problems. So, we have been able to devise a simple technique for transposing the ovaries, but uterus is still there in the pelvis. And when radiation is given to the pelvis, the endometrial lining gets damaged due to radiation. So, of course, then we leave it to the expertise of our infertility specialists. They, give a lot of hormones to prime the endometrium. But again, because of this reason, the success rates for a actual pregnancy and live birth are still lower, especially in India. So while counseling, we never promise fertility. We still tell them that, it's still worth doing for hormones. That is what we always tell them. Some of them, especially when radiation is at a much younger age, less than 20 years, teenage. So in many of these cases, we have seen that they actually resume their menstrual function after, few months of completing the treatment, because then the regenerative power of endometrium is probably better as compared to if the radiation is given in, late 20s or 30s. So this is one point. Other thing is, of course, it's always a mutual collaboration. Infertility experts, they have a lot of ideas, on how to deal with it. Radiation oncologists, they also devise few methods that, if it is possible, they try to shield the uterus, and especially the central part of the uterus, from the radiation. They use a thick lead shield, if it is possible, especially if the radiation is being given for the bones. With mutual, understandings and adjustments, we still hope that many of these girls can have their, not just hormones, but also their fertility preserved. But definitely it's still, worth doing this procedure. So this is a video about parametrial dissection. Like I said, for cancer of the cervix, where there is a visible growth on perspeculum examination, recent guidelines suggest, after the publication of this LACC trial, that minimally invasive surgery gives inferior survival outcome and should not be done. So this is what we are practicing. But, with cervical cancer screening has become quite rampant, thankfully. There are many, women who are getting diagnosed in very early, either cancer as cervical precancer, CIN3, or with very early microscopic cervical cancer, where there is actually no growth on the cervix, but it's all microinvasive, T1A disease. So those are the cases that we can still do by the minimally invasive route, by robotics or laparoscopy. So of course, there we take the uterines at the origin, we dissect the ureters in the ureteric tunnel up to the UV junction, and try and resect all the perimetrium out along with the vaginal cuff. So she was a lady with the, initial pap smear had suggested high-grade squamous intraepithelial lesion. We did a leap, which was, suggesting a CIN3, but bordering on to, some micro-invasion. On leap specimen, the pathologist was not very sure. So we thought that, it would be better that we plan her for type 2 radical hysterectomy.
Sorry to interrupt, ma'am. We are running short. A little short of time.
I'll try to wind up my talk. Okay. So this was the trial that I was talking about, before 2018, all endometrial cancers, all cervical cancers were being done by laparoscopic and robotic route. Of course, we were doing Vadheim hysterectomy or type 3 radical hysterectomy for cervical cancer. But when in November 2018, this trial, which is LACC trial, it got published, it was quite surprising. It showed that, minimally invasive surgery for cervical cancer showed inferior survival outcome as compared to open. And, then all the international guidelines changed the recommendation for cervical cancer as to open. This is a very frequently asked question whether we can do laparoscopic Vadheims for cervical cancer. So the answer is that currently the standard guidelines do not recommend a minimally invasive route. All thanks to this trial, it clearly showed that the survival outcome was inferior with minimally invasive. The risk of recurrence, vault recurrence, and also the peritoneal recurrence was higher. And why did MIS show poorer outcome? The proposed hypothesis were either the use of intrauterine manipulators or because of CO2 pneumosufflation, which was causing tumor spillage and tumor cells to spread in the whole of peritoneal cavity. And also there were some doubts about the quality of surgical resection by the MIS route by some of the surgeons. So, future directions that, of course, we have not lost the hope that, cervical cancer patients would never be offered minimally invasive. These are the two trials, one trial who are studying robotics versus open Vadheim hysterectomy for cervical cancer, and the results of these trials are awaited. And of course, they have modified their techniques slightly, surgical techniques slightly, so that, the tumor, the manipulators are not used, and some protective mechanisms are used to prevent those spillage. And of course, robotics in ovarian cancer, like I said, if you all will ask all oncologists, any suspicious ovarian mass, we generally do not recommend by the laparoscopic route. And if one has to adopt a laparoscopic or robotic route, then one has to be sure that there will not be any peritoneal spillage with use of proper endobags and all. But as of now, the recommendation is to do a conventional open surgery. There are certain precautions which have recommended that, if the ovarian mass can be removed with no touch technique, rather than touching the ovarian mass, we resect. We develop all the surrounding peritoneal spaces, and the incision should be taken on the peritoneum rather than on the near the ovarian mass, so that it doesn't cause spill, and then one can go ahead. Regarding advanced ovarian cancer, of course, for upfront surgery, MIS has no role, but there is some thought process going on that post-neoadjuvant chemotherapy, when all the ascites has gone away, peritoneal disease has slightly shrunken, these are the patients, where minimally invasive cytoreductive surgery, could be a possibility, obviously giving the patient the benefit of lesser morbidity, lesser blood loss, and all. So there are trials which are ongoing for minimally invasive cytoreductive surgery in advanced ovarian cancer, and especially post NACT. So this was, but still investigational and only under ethics committee, they should be done. So this was, in short, the scope of robotics in gynae oncology practice. Thank you very much.
Thank you, Richa. It was very elaborate. We missed your formal introduction. I would like to say that we were co-registrar in Sion Hospital, and you were always very intelligent, humble, and very, I would say, very sincere co-registrar. And after that, she did MCH, one of the very few MCH gynec oncologists from all over India. So she did that from Tata Memorial Hospital. And I feel a surgeon should have lion's heart and lady's finger, and he should have a very humble attitude and to decide and to choose a patient very wisely. So very thanks to you, and I request our chairperson to add any expert comments if they want.
Thank you, madam. It was very elaborative lecture, and we truly believe that the theme is GenNext 2024. So robotics is going to be in a big way in our practice. Thank you so much.
Thank you. Thank you very much, ma'am. Thank you.
I request Dr. Sadhna Kollatkar ma'am to kindly felicitate our speaker. I request all the chairpersons to join in the felicitation. After this talk on our next topic, that is the role of lasers in cosmetic gynecology. Now I request our speaker Dr. Chandni Kharath ma'am to kindly come on the stage for the talk. I request Dr. Snehalata Pawar ma'am to kindly introduce our speaker.
First of all, I would like to congratulate all the organizers. After the sumptuous and delicious lunch, now let's embark onto the journey described by Dr. Chandni Kharath madam. She is an international board certified gynecologist practicing in Mumbai and Mauritius with more than 16 years of experience. She is the founder and director of Medrica. This is the first cosmetic gynecology center of Navi Mumbai. She is a trainer for aesthetics and anti-aging medicine, a convener and chief faculty for national and international workshops in cosmetic gynecology. And she has been awarded through hands of Shri Ramdas Athavale for her exceptional contribution to women empowerment. She has been awarded the Most Influential Woman Award 2023, and also she is the winner of the fashion show and is titled the First Mrs. SOGOG December 2023 at Gujarat State Conference, Foxy. Welcome, madam.
Very much for such a lovely introduction. And very, very good afternoon, respected dignitaries, seniors, my dear colleagues, friends, and lovely delegates. Foremost, I would like to congratulate the entire team of IMA AKLUJ for putting up such a brilliant academic extravaganza. And at the outset, I would like to thank dear Dr. Revati Rane for inviting me over, and moreover for asking me to talk on a topic very, very close to my heart. So, without any further ado, I'll hit start with my topic, which is role of lasers in cosmetic gynae. And yes, before that, for the previous speaker, Dr. Richa, I too have a history with Richa, the way you shared. So Richa happens to be my batchmate, a very, very dear colleague, a friend. So we were together in our UG days. We did our MBBS from DY Patil. So it's lovely having you, dear. Yes. So I'll start with cosmetic gynae in lasers. So, well, the domain of my talk is basically divided into two. It is what is cosmetic gynae? Because, well, I would not say it's the latest kid on the block. Over the years, it has definitely grown by leaps and bounds. But yes, let us accept certain bitter fact that a lot of us, we are still not well versed. We are not well acquainted as to what is cosmetic gynae about. And it is time we get sensitized and help our patients. And believe me, it is the need of the hour. To let you know, it is the fastest growing subspecialty in gynecology. And well, on that note, let me move further. So, well, my role as a designer is to make a woman feel her very best. When I say her very best, it's not, just the beautification, but believe me, as we run through the slides, you will realize, there are so many functional issues, not only aesthetics, which females are literally juggling with every single day. There are a lot of functional issues, and it is time we address them. So, well, the need for aesthetic gynae is definitely for real. We need to understand that the healthcare in India is moving from managing sickness to wellness and improving quality of life. When I say quality of life, please note it in inverted commas because it's very important. We need to understand the concept of beauty has extended from having right-looking cheeks to right-looking genitals as well. Okay, on that note, let me tell you, we always use the word cosmetic gynae. Though, we are addressing it as cosmetic gynae, but it is actually a misnomer. It is more of functional and aesthetic issues which we deal with, which we cater to. Then why do we use the word cosmetic? Because, whenever the word cosmetic comes, it's a human inclination. Everyone, be it a child, be it anyone, we have that inclination towards beauty, towards beautification. But it is much more than mere beautification. Okay, so well, women's perception is changing over the time. Yes, for sure. There's a lot of online content available. Well, everything comes with a flip side. So when we have Netflix, well, people are all glued up and they have become like couch potatoes. Well, the good side to it is, we have come, terms like vagina and vulva are very much normalized. They weren't. If just to give you a quote, I think sure a lot of us must have watched some series like Bollywood Wives. Even from that class of celebrity, people are not comfortable uttering words as vagina, vulva, or for that matter, even talking about menopausal health. So that's the need of our, females are becoming more vocal. They are stepping in, they are talking about their problems, but all they need is somebody to hear. They need all ears, and here we are to provide them with the best we can. So, well, we all have been knowing about facial aesthetics. It has been with us over years, Botox, fillers, threads, and so much more. Of course, breast aesthetics like breast augmentation, breast reduction, implants, breast lifts, so on and so forth. Even body contouring. Now we are adding a fourth dimension, that is aesthetic gynecology. So, well, let me also highlight to the point that when we say functional gynecology, aesthetic gynecology, cosmetic gynecology, these are all a kind of synonyms. Okay, and when I say functional, so let me quote something like urine leakage. If you believe the statistics, literally every fourth female, sitting right here is suffering, has suffered, or will suffer with urine leakage at some point of a time. It is that common. And it is not aesthetic, it is not cosmetic, it is very much a functional issue. If you look at the statistics of the diaper industry, it's a big boom. Compared to the baby diapers, the adult diapers, they're 3 times more. Why? Females literally switch over to it because they are very hesitant talking about their issues. They prefer, becoming socially recluse, but they are not vocal. So it's time we normalize this thing. If we say, yes, it happens, it is not part and parcel of aging. The sad thing is a lot of patients who come to me, they say, we have come up with this to our gynae, but they say it happens to everyone. That's not true. well, we have a lot of options. Yes, I totally agree that down the lane, many, many years down the lane, we were handcuffed. We didn't have much solutions, but now with advent of science and technology, we can definitely help. We can help them very, very effectively. I myself, I did my PG from a government setup. We have grinded all through and through. And then since more than a decade now, more than 12, 13 years, I'm exclusively into cosmetic gynae. And I've realized the need for it. The treatments are very, very effective, provided we as doctors, not only as gynae, as everyone are aware that yes, it is on the floor and we can definitely help our patients. Beauty is a mystery that has been with us for ages, that is for sure. As I may have mentioned, it's the fastest growing subspecialty of gynecology. Includes both cosmetic procedures to enhance the aesthetic appearance as well as the functional issues. So basically, what are we dealing with? We are dealing with the beauty of the bottom, caring of the most neglected part. In fact, I would say vulva, you can also label it as the forgotten organ. Come on, let us accept that, even I myself, when we started with our PG, we are all keen in doing a PV, giving the findings, vulva, examine each and every part. We never did that, okay? So bringing back her innate beauty, bringing back the vigor of the vagina, helping her gracefully. Well, that's very, very important. And now that lifestyles are changing, and people now, they have become more aware of it. They literally want to invest in their health, provided they know the options available and where is the right place and who can offer us such services. So, well, which problems do we need to treat? Or we treat in cosmetic gynae, pelvic organ prolapse, urine incontinence, recurrent vulvovaginitis, genitourinary syndrome of menopause, very, very common, vaginal relaxation syndrome, something like vaginal laxity, vulvodynia, sexual dysfunctions, sagging breasts, stretch marks, hyperpigmented abdomen, and genitalia, and so much more. Well, let me give you an example that when I say it's more of functional, literally the work which we do 80% is functional. Something like urine leakage, which I've already mentioned. Now, let me tell you, the highest number of surgeries which I have done till date, because I'll also explain the cosmetic gynae has two domains. It has surgical and non-surgical. Coming to surgical, the highest number of surgeries are for cases of labiaplasty. Labiaplasty is trimming the inner lips of the vulva, that is a labia minora. Now the indication is mostly functional. A lot of people think that it is a cosmetic indication. Females are coming because they probably want the symmetry. Why they come is probably it's not symmetrical or one is sagging more. But no, the indication is functional because females
It'll take few minutes for the audio visual to start.
No problem. So
you can talk. You
okay? I'll
if
be
you want,
audible
you
enough?
can. Yeah, I think the mic is working.
Oh,
Yeah.
lovely. Fine. So as I was saying, the indication mostly is functional, when there's asymmetry of the inner lips of the labia, that is one labia minora is sagging, it is hanging, it literally rubs onto the undergarments. Now the lifestyles are changing and we are more into body hugging clothes, body, fitting of clothes. So it literally hurts it, it invites infection, and that's the reason females actually opt for labiaplasty. So that in that case, it's not an aesthetic or a cosmetic indication, but very much a functional indication. Yeah, thank you. Please give me a minute. Okay, so this is what exactly I was talking about, that cosmetic gynae is divided into two. surgical as well as non-surgical. Now, when I talk about non-surgical, we have already discussed in what conditions or what are the indications. But what are the procedures which we do? We do something called as a PRP, that is a platelet-rich plasma. You know, we are in an era of holistic medicine, regenerative medicine, organic stuff. Believe me, PRP, we literally call it as an elixir. You know, when I use the word elixir, it is something, you know, if you add it, it adds on beauty, something which has magical powers. And literally it is. We do use fillers, you know, as we have plumping of lips of our face, you know, fillers are used even in the intimate area. We do something as fat grafting. Very, very important, the foremost is EBDs, that is energy-based devices. When we talk about energy-based devices, you know, gradually when you get acquainted with this domain of cosmetic gynae, a very, very effective and a beautiful domain, in fact, you know, you'll always hear about a lot of stuff, say lasers, radio frequencies, HIFU. In fact, my talk is on lasers after this. But the thing is, you know, when we talk about energy-based devices, these are only the 3 options available globally. You know, they work on almost the same mechanism. The results are same. You know, it's just using different technology. Okay, because there's a lot of confusion as to, you know, is a radio frequency, HIFU and lasers, you know, are they working in the same way? Then also we do a lot of genital bleaching or intimate bleaching. There is carboxy therapy, even laser hair reduction. Surgical procedures, there are a lot, you know, you can just run through. But when it comes to labiaplasty, hymenoplasty, and something like clitoral hood reduction, these are very, very commonly done. I do a lot of breast aesthetic as well, and even liposuctions. So, well, as I just made a mention of lasers under energy-based devices, lasers can be either CO2, that is carbon dioxide, erbium, diode, Nd:YAG, or Q-switch lasers. So, well, talking about the first half is what we actually need is we need better teaching, better implementations, and customized treatment, which is very, very important. It is not like a one protocol fitting all. You know, it should be tailor made. It should be indicated according to the needs of the patient. And creating awareness, you know, platforms like these, you know, extreme esteem and renowned platforms like these, and so many others. These are the channels through which we can spread awareness that yes, we have technology in hand in which we can definitely help you through. So it's all about a teamwork. You need a urogyne alongside, you need a plastic surgeon, you need a dermatologist as well as a counselor. A very patient counselor is the key. There are very, very few interesting things. Of course, we'll not be going in details of it, but we have something like, you know, G-spot augmentation. There are orgasmic disorders. It's a different topic in itself, but it's important to throw light on it. There's something called as P-shot. You know, this is a very interesting topic coming to the male domain, because erectile dysfunction, well, males do talk about it. So now it's time that even females talk about their problems. So this is one thing, but as I told, people still have that embarrassment, still have that hesitancy. So, you know, even at my center, when we are doing everything from head to toe, you know, whenever, and we have services for P-shot. P-shot is indicated very effective for a case of erectile, it's stop working. It's working? Okay. So as I told you, P-shot is nothing but injecting PRP right in the root of the penis, you know, very effective in a case of erectile dysfunction. And as I was throwing light, that still there is embarrassment, there is hesitancy. So, you know, all my male clientele, which I get for these procedures, of course, we have an andrologist on floor as well, but they come through my husband, who is actually a CVTS surgeon. He's a cardiac surgeon, but they'll approach him, you know, in our center, and he'll say, ki, ma'am ke paas ye services hota hai, you know, I would like to get some information and then go ahead. So yes, it's time we make it, we normalize things. There is something called as the MCLR chair, you know, very beautiful, beautiful technologies. I'll just throw some light with pictures later on. Well, definitely age is just a number, so very true, and let's beat it. This is something very interesting. I incorporate this in almost all my talks, and if it's well visible enough, any clue, anyone as to what is it? People who already know should not answer. Anyone? Can a probable guess? A wrong guess? Not a right guess, a wrong guess? This is actually real-time 400 vulvas. These are the POPs, plaster of Paris, and caved directly on real-time patients of 400 patients by a very renowned artist by name of Jim McCartney. If you go to US at Miami Beach, there is erotic art museum. You can actually see this, and he started with this project in 2006. And down the lane, you can actually read that for 400 women, their private parts have gone public. The reason to do this was just to normalize that, it's an organ, it needs its due importance. Well, on that note, let me go a little further with lasers in cosmetic gynae. And of course, yes, who will need it? Anyone and everyone. But still, majorly in the postpartum period, we have something very beautiful, which is called as a mommy makeover. Of course, it's not a scientific term, but it's a fad, and it's like a celebrity-driven word. But yes, the need of the hour again. It is, there are 2-3 surgeries which are tailored made according to the patient. Something like, post-delivery, when I say mommy makeover, probably you're having a pouch, you're having saggy breast, you're having laxity of the vagina, you want some breast lift. So, then we cater 2 or 3 surgeries what are indicated in that patient, and that is labeled as a mommy makeover. Of course, premenopausal, postmenopausal females, juggling with vaginal atrophy, vaginal dryness, and so much more. Even on that note, a lot of patients who are on chemotherapy, or cancer survivors, in those cases, I have a lot of patients who come with, severe vaginal dryness, breast CA survivors, and they don't want to go for any hormonal replacement therapy. So when we do all these procedures with lasers and energy-based devices, these are actually a big rescue for them. So, but what has changed? It's phased and evolved as functional and regenerative gynecology. There are a lot of non-surgical treatments, as I just made a mention, a lot of EBDs, that is energy-based devices. Let me move further with this. So yes, aesthetic functional and regenerative gynecology shift to lesser invasive technology. So understand that when we talk about non-surgical, when I started, there was a lot of demand for surgical cosmetic gynae. But now, since past 5-6 years, there's a lot more demand for non-surgical. Because, times have come when people, they don't really want to be handcuffed. They want, how we say, fatafat, step in, step out procedures. So these procedures are literally, you need no admission. It comes with no downtime, which means after the procedure, you can literally go back to your work, you can resume the work that very moment. Absolutely no anesthesia, no needles are involved, so no pain. So it's very important that, we know a bit all of this. Yes, as I told, everything comes with a flip side. It needs a series of sessions, which are very beautifully placed in 1 month's time. And in a series of 3 sessions, the treatment is really effective and it suffices. I will just throw some pictures. As they say, a picture speaks a million words. Talking about lasers, what I have in my hand is a diode laser. I know it's very new for a lot of us, but then we can just run through the pictures. This is something called as a CO2 fractional laser. These are all vaginal probes. Okay, these pictures are right from my center in Mumbai. And this is something called as radio frequency. If you have a closer look and you see the probe which I'm holding in the hand, it's the size of a finger. So you can imagine, when I put that in the vagina, how comfortable it would be. Even PV at times, we sometimes use 2 fingers. So this is just the width of a finger. This is a panel which has radio frequency, MNRF, micro needling with radio frequency. These are different technologies. As I told you that, we choose according to the need of the patient. It is tailor made according to the patient's need. This is again HIFU. It's a 4D HIFU. 4D as in, there are other pros because I do a lot of facial aesthetics as well and body contouring. So the long one which you can see is a vaginal probe for HIFU. This is PRP, which I just made a mention of like an elixir. This is again an HIFU. These are a glimpse of our training courses. We run a lot of training courses as well. This is this is an MCLR chair from BTL. We have a lot of chairs using HiFem technology. I should be throwing some light on it. When we talk about Kegels exercises, it's very, very important for all of us. It's humanly not possible to do a more than 10, 15, max 20 Kegels, and and do it repeatedly. So the beauty of these chairs is you actually sit on them, and in just in a matter of 28 minutes, they give you around 11,800 Kegels, contractions. So, you're all clothed, no undressing, no changing, nothing, only the metals of your body. Of course, it comes with certain restrictions of if you have a pacemaker, even for that matter, copper T or knee implants. So those are contraindication. Rest, it is super indicative. When I tell about Kegels exercises, we all know. It is a must for everyone. Again, on that note, though I'm not snatching away Sir's talk, but even for a case of erectile dysfunction, it's very, very effective, giving a P shot and giving a HIFM therapy. So yes, lasers we have been using in gynae since long. I'll just interrupt. How much time do I have? Okay, so just 5 minutes. Yeah. So I'll go a little quick with this. So let's look at gynae practice differently, from a different perspective, from a lens of a doctor, counselor, designer, and a team player. Okay, so these are aesthetic gynae surgery. Let me not go too much in detail of this. So what's the scope in your practice? Of course, cosmetic. See, let me be very frank, there's a very beautiful quote by a plastic surgeon, and I would like to re-quote it, that, I actually call vulva as the second face of a female. If you look very closely, how we have two eyes, the tip of the nose, two lips, each and everything is present down there as well. Literally every part, and every part has certain issues as well, and we have treatment options for it. So it's time we make our patients aware that, yes, there are options and that can be treated. This is very important when it comes to functional issues, say something like urine leakage. Females have also, our patients have also shared with us that, when they get intimate with their partner, there have been episodes of leakages. So, that's very, very embarrassing. So, it's time we start addressing such issues. When it comes to sexual, emotional, if you're confident it shows out as well. So, that's very true. So, let's address that. Talking about marital divorces, well, the statistics has been super, super high. And, vaginal laxity, vaginal looseness, marital conflicts, these are the reason for it. Let's talk and let's accept it. And it's time we reclaim, restore, revive, reconstruct, and repair. Well, these are all the surgical aspects, and I'm not going in details of it. As we told, we treat urine incontinence very effectively. Vulval bleaching is that. As Asians, we are comparatively have darker skin down there. Nowadays, with, trends of monoknees and big knees, people, they want to look their best. They don't want to have any embarrassing patches. So we do help them with that. I would also like to make a mention that we are not here to change any beauty standards, Whenever you talk about wrinkles on your face, they are beautiful because they talk about your experience in life. They talk about your age. So, embrace it beautifully. But if you want to get rid of it, we do have options because every person is different. Somebody likes white hair, somebody likes black, somebody likes blonde. So, now we have options for everything. Well, that's laser for you. I'm going quick. Just 2 minutes. Okay. So important is to understand, I'm not going in the mechanics and the physics or the dynamics, but it's important for us to understand that we're treating so much more. As I told you, perimenopausal, postmenopausal, vulval atrophy, vulval dryness, incontinence, prolapse, all these issues are very, very effectively treated. And just 2 minutes so that I can just throw on. And lasers I've already mentioned. We have CO2 lasers, we have diode lasers. There's something called as fractional laser, which we just need to understand. Okay, in one line, what is the mechanism? What are we actually doing when we are giving you this laser-based therapies? So, we are actually giving an injury, inflicting an inflammation. It's basically giving you thermal energy, and this in turn, it induces the production of new collagen, which is called as neocollagenogenesis, okay, and neovascularization. So this is the key that how it literally works. Collagen is naturally present in our body, but as we age, as the hormone surge go down, there is depletion of collagen, and that's how we help you. So these are a lot of slides. We have been doing a lot of study on our patients as well, and proven over time that they have been very, very effective. So this a couple of more slides. Awareness, which is very, very important. Availability, that yes, we have such services. Cost factor. Okay, training, getting trained, making them aware, and having a global understanding, right choice, selection of the right patient, perform it at the right place with the best team, with the right infrastructure. And yes, need for such clinic in India, it's a desperate, desperate need. And we are trying our best to reach out to each and everyone possible. And I'm going quick because this gives a description. Yeah, this is a very interesting slide that, as I made a mention, that something called as RF, called as radio frequency, HIFU or lasers, times have come where we are stage of hybrid devices, which means you can have 2 or more technologies together on the floor. And we do have it at our center, and this is very much the future. Well, these are our real-time patients treated very, very effectively. Lichen sclerosis, vulvar vestibular syndrome, vaginismus, and so much more. And I know Revati has been looking at me and the time. So yes, last few more. So these are training courses which we run at our center. We have very effectively trained a lot of doctors. Yes, so this is again the HIFM chair which I was talking about. You can literally sit like this, all clothed, and it's super, super effective. So this is... yeah, so this is the second last one, yeah. So on that note, I would also like to invite all of you. I'm also the chairperson of Aesthetic Gynecology Committee, AMOGS, that is Association of Maharashtra Obs and Gynae. We run a lot of awareness series, a lot of webinars, a lot of articles are published as well. These are all absolutely free of cost. So as a chairperson, I urge and invite all of you to be a part of it. And lastly, this is my center in Mumbai. I extend a warm invitation to all of you. Please drop in. You're more than welcome. And thank you very, very much for being such a patient audience. Thank you.
Thank you, Chandni. I feel the aim of the conference is the name, as the name suggests, is Generation Next, GENEXT. And though everyone here is not a gynecologist, I feel as a, may it be a dermatologist or any female, as a patient, we come across so many patients who have functional problems. Yes. So, we just want everyone to know want everyone to get introduced to the field of cosmetology and the need of it in the society. So thank you. Thanks a lot.
Thank you very, very much. And you very rightly said, it's a very beautiful initiative. It is an innovative thought and a very noble thought, because not only for gynae, for each and every practitioner, forget being a doctor, for each and every person, for each and every female, it's important to know our problems and also to know that, yes, it can be helped. Yes.
Yeah, and I would like to request chairperson to add any valuable comments if they want.
Thank you, Chandani. It was your lecture was like a bag full of surprises and lot of new things for us, and thanks for making us aware at least, because with few exceptions, lot of us were not aware of these things. Thank you.
Thank you. That's so, so sweet of you, and absolutely my pleasure, ma'am.
Being a dermatologist, I always come across with such type of patients. They come to me, they ask me, but they never come again for the follow-ups and all these things. So awareness need to be created into the society. So you gynecologists need to be take the initiatives for all these things. Thank you.
So we welcome everyone to our training courses as well. And please join AMOGS. As I told, it's a charitable association, absolutely free of cost, creating a lot of awareness. So yes, we are trying to do our bit.
Thank you. Now I request our chairperson, Dr. Neelam Nalge ma'am, to kindly felicitate our speaker. I request all the chairpersons to be on the stage. I request Dr. Savita Guzar ma'am to kindly felicitate our chairpersons.
Khode and Dr. Aniket Inamdar for the next session.
And Dr. Sanjay Sheet, Dr. Kiran Patil to host next session. Dr. Amol Shinde sir, he is a senior orthopedician in AKLUJ, Culture Secretary IMA AKLUJ. Dr. Nilkan Korke sir, he is a endoscopic surgeon, orthopedic surgeon in AKLUJ. May I invite Dr. Daifare sir to deliver a lecture.
First, I would like to congratulate all organizing committee, IMA AKLUJ, all doctors, all members, all active peoples as a routine for organizing very nice conferences, and especially you all doctors are so charming. I never miss any conference which is organized by AKLUJ people, definitely. So, after this post-lunch session, we are going to present on a very, very interesting topic. See, connect.
Sir, may I ask Amol Shinde sir to introduce Daifare sir?
Yeah. Yeah?
Chairperson, he wants to talk.
Okay, yeah, no problem.
Good evening, everybody. I first appreciate all the enthusiasm and alertness of all the delegates present here, even after in post-lunch session. Here I am going to introduce such a dynamic and very handsome, good-looking person who is very well known to the people all over the Maharashtra through the television as well as in the conferences. Dr. Vijay Daifare sir. He has pursued his master's in surgery, did his DNB and MCH. He is a practicing urologist, andrologist, sexologist and stem cell therapist. His area of interest is in prostate, stone, then female urology, pediatric urology, renal transplant, penile implant, endoscopic surgeries, microscopic surgeries, and the treatment of sexual dysfunction in males and male infertility are his special area of interest. He is the president of the Dr. Daifare Medical Foundation Trust at Sri Chhatrapati Sambhaji Nagar. He runs very much centers across the Maharashtra as well as in Dubai. And he is a very regular motivational speaker in Sukhi Jeevanacha Mantra at Sam TV and Lokshai Marathi television. He has been awarded with many of the prestigious awards like Rashtriya Vikas Ratna Gold Award at New Delhi in 1999. In 2002, Phule Shahu Ambedkar Award. Then in 2019, Lokmat Maharashtra's most stylish doctor award. As I rightly said, it's a very dynamic person. And then he was a president, secretary in Lions and international conferences. He had many publications nationally and international conferences. He's attended more than 100 national international conferences and workshops. And he has been awarded by the SAM TV Global Achievers Award in Dubai in 2022. It is very pleasant, sir, to have you here. And please, give us actually an informative talk on the selective subject what you have chosen. Thank you so much.
Thank you very much, chairpersons, for such a nice introduction. And thank you for all our doctors who are attending so sincerely and definitely will enrich with a very good new concept today. So most important, the topic which specially given by your team, you can say Santosh, by request ki present something different as a routine, because we want to definitely present some new topics where what is the peyronie's disease, what exactly peyronie's disease, and how it works, what is pathophysiology, what are the other details of this disease. Friends, I'll tell you, in Department of Andrology, erectile dysfunction, male, erectile dysfunction, female, definitely you might be surprising what is the incidence of erectile dysfunction in male or in females. Basically, I will tell you, equally, even 40% is the percentage of dysfunction in a female, and equally in males also. The only reason female doesn't present, or can you see somebody? I have to forward it. So they don't present. Basically, prominently, whenever there is a problem in sexual dysfunction, only in my all OPDs, previously it was the only trend, only males are coming, that too with fear, and then nobody is seeing me going to clinic, but that scenario is totally changed now. Whenever I started this, my all talks, since more than 8 years, I've been doing live talks on sex education, sexual awareness, and sexual safety. And that talk had made the people to accept that this erectile dysfunction is not only concerned with sexual activity. Even in our training program also, nobody has taught us what are the uses of penis. I'll tell you, penis is the reflection of your mind, body, and heart. That is an indicator which is made by the nature for the purpose of. See, this, you remove something or add something. Yeah? See it and, yeah. So, how that organ is important, the circulation, the blood supply, the vascularity of the penile region is definitely indicates your health of the heart. If 25% of block has occurred in penile artery, at the same moment, 50% of block has already occurred in the cardiac region. And that is the reason you can say it is an indicator of your body, it is an indicator of your cardiac health. Basically, in Nair Hospital, I did this genital urinary surgery in 2000, did DNB also, and when we have started these talks on SAM TV every Friday 11 p.m. and on every Saturday on Lokshai Marathi. These all talks are interactive talks. I'll say first time we have started such a talks, and we are successfully doing it for more than 8 years because we are giving answer to the public question, and they came to know that definitely we can get a solution. We have a Facebook page also where you can see every episode since more than 8 years which we are performing in different languages. Even we have written a books in Marathi, Hindi, and English languages for the purpose of school students, those who are school going. They must know the sex education, and they must be aware that why it is important, both in male as well as both in females. These are the multiple centers which are in Maharashtra, where all our nodal peoples, they are organizing, and we are operating at both the places, Mumbai, as well as we are operating at Aurangabad. So what exactly is the Peyronie's disease? You can see over here, it is a Peyronie's disease, an acquired condition of the connective tissue of the penis that affects 0.5 to 2% of the male population and is marked by fibrotic plaques in the tunica albuginea, and it results in penile curvature. You can say many times you can get a curvature up to 90 degree. It can be downward, it can be upward, it can be a total deviation which is affecting sexual function. So what are the 3 effective ways to treat this Peyronie's disease? We are going to see it one by one. Now, first of all, we'll see what is the etiology, what causes the sexual dysfunction, and what causes the bend in the penis or deviation in the penis. You know, there are, which are the causes you can say, although Peyronie's disease can occur at any age. So 50 to 60 is a common. It has a higher in certain population with associated surgeries. We did a prostatectomy. It also occurs in ED, in the initial parts. And broadly, we'll see how it affects the pain and deformity also. So you can see in this graph, the peak is at, you can say, 40 to 50. So these are different associated comorbid conditions. Erectile dysfunction, diabetes mellitus, patients with going the surgery. Now, what causes Peyronie's disease? Friends, you are knowing there are 476 sex positions. How many people know more than 4? We don't know. And how many people they are performing? we also don't know that. See, reason is that, see, when we are studying the pelvic anatomy, if somebody will ask, nobody want to discuss about sexual process. All want to discuss about delivery process. Everything they want to discuss, everything they want to celebrate. They want to celebrate pregnancy, they want to celebrate delivery, but they don't want to celebrate the process by which that pregnancy has occurred. And that is the reason, is one of the cause of infertility. I can say in my OPD, after our treatments, more than 50% of IVF, definitely they are getting away. You can understand the reason and how the penis get traumatized. Nobody, they perform the procedure in a dark. They don't show anything. Means I always feel surprised. How we will get the tactile sensation? How we will get the visual sensation? And then why will not develop ED? What badly this penis is affected when you are performing in odd positions. Commonly, people know only one single position, just lie down on a bed and other partner is lying on her. In that position, pelvis is very badly packed and it rubs to the penis. You can see in this video how it injures. You can see due to bad position of a pelvis, it is affecting the dorsal part. You can see over here. That constant friction at 12 o'clock position, what it generates, there is a generation of a plug. And when this plug gets contracted, you get a penile contraction. Again, you can see which part of the tunica is affected by this peronis. This peronis is a very bad disease, I can say. Many people are having it, but nobody is accepting that he is having bent penis. They will say it is of no use now. Now its work is over. No, its work is still there till the end of your life, because it not only just do the sex, it pees, it contains genitourinary system, it has a work of circulation, and it has an indicator of our body health. See how this all tunica is badly affected, in which cases where there is a formation of a tumor. This tumor, or after trauma, inflamed tissue start growing. When again that growth is affected, day by day it is calcified, nobody gives that attention. There are nodules in penis, let it be. When they come to us, see what happens if you go in next stage, when there is trauma, when there is an infection, and in which condition you enter. You can again see here, whenever you are performing, take care. At that time, you might feel very much enjoying, my penis is getting rubbed very nicely, I am getting very nice pleasure. But what will happen, unless and until there is a proper angulation, nobody is in the position where female is lying down and the man is standing. Nobody knows the cowgirl position, nobody knows the reverse cowgirl position, just they know the position, just lie down on the bed, thighs are obligated. Some partners I have seen, they don't know where they are doing the act. They get an injury, they get a hitting, and in combination of injury, in combination of formation of a plaque in cases of diabetes, what happens, you can see in this video. Here it is getting traumatized, then again, due to disease, or any degenerative disease, trauma added by the growth of some tissue, abnormal tissue, calcification, sometimes due to very harsh masturbation, such types of micro traumas occur. Even in young age, they have a habit to bend the penis by hand. So now, as you are dealing with laser, something different sources, how they are useful. That's why I added this ESW level, and how it works, I'll elaborate very nicely over here. Extracorporeal shock waves are the high pressure, low frequency sound waves generated by the device outside the body, applied to the affected tissue in a site specific manner. So whether the shock wave therapy is a, what is the placement, what are the outputs, what are the limitations, definitely we are going to see it. So which equipment, again it is important. See, there are, once we get a new modality, you get hundreds of lasers. Once you get some, again, roll of lithotripsy, so many lithotripsy peoples, even stone peoples who are giving the treatment for calculus disease, now they are diverted to andrology, because kidney stone is not seen, but this type of calcification will make the person dysfunction, will make that person to rush towards doctor. So how this lithotripsy works? Definitely it works, this low intensity, and how this relieving the pain, how this is revealing the deviation. I'll say again, it is not a cure. As a isolated person who is not a surgeon, I'll tell you, the person who can treat each and everything, only these people should go for these line of treatments, because patient as the last source, whether you can make me fit, either you can make me sexually function, that is most important. So about curvature, only 21 to 74% there is a reduction of a plaque. Remember this one also. And this we have to give not to a mature plaque, it is an immature plaque in that case. And for pain relieving also, it works in 68% of cases. Now, sexual function, erectile function, how this lithotripsy works in erectile function, how it works on vessels, how it works on vessel walls, that is also very much important. There is still controversy, but as a surgeon, at the end, if you are giving the result in proper way, what patient will say to you, sir, whatsoever possible for you, try to delay it, because they are afraid for the surgery, because it's a delicate organ. We also keep on doing that. The follow-up is very much important. Now, we are directly on ESWL. So which machine, which instrument, which source is much more better? It comes by experience only. Dornier Aries, what exactly Aries? Now you can say the limitation and how this works. It is an accelerate recovery through intervention of extracorporeal shock waves. You can say it is not a treatment. It is not an end therapy. It is a supportive therapy. And if may require, you can go for the surgical part also. You can see this is the system which is working. Some simple description I will give over here. How is the setting, how you have to give the setting, and then how it is practically given. That also I'll give a small demo. So these are the different parts of the machine. Then that machinery part I will not go, but I'll say these are very manageable. You can manage it nicely. There are different levels. There are different zones. We have to adjust the shock waves on this display. You can see very nicely. Here are the setting of a display, 1000, 2000. What are the number of shocks what you are giving? That is measured. These are different levels, 1, 2, 3, 4 like this. We have to manage manually. Here are the different displays. In that display we will not go. So in what cases, in what areas, which are the areas where it works, that I will see. This all the machinery parts we can see anywhere. Now directly we will go for what purposes in urology, in orthopedic and sport medicine, and in aesthetic also. And aesthetic, like a cosmogynec, there is a cosmetology in andrology also. Why only women? Men also want to be strong. Men also want to be you can say very robust. It is like a second phase. I'll tell you, some people say that, why at this age, why you want to make the penis erect and sizable? Sir, if it doesn't occur, even if I will not perform, but if I'll see it when I'm paying, when we'll see it when paying others, when I'll see it is feeling to my hands during my washroom, then I feel comfortable, because it is directly related to, size is directly related to psychology. That is the reason. So, in erectile dysfunction, it promotes growth of blood vessels, thereby increasing penile blood flow, improving both erectile function and sexual satisfaction. There are some chronic pelvic pain syndrome. These are also very important condition. In urology also, some cases you are treating, but you are not getting the result. There are some patients with penile pain. You might be very badly bothered. What to do with this penile pain? I get a pain in penis. Whether it is going to relieve just by painkillers? No. There is a pathology, the significant improvement in pain, urological condition, and erectile function. It reduces the pain. There are some peyronietic disease in that case, especially these waves. These are the area where you have to hit. How much is the setting? There are 5,000 shock waves. You have to do 6 sessions, 1 to 3 times in a week. Depending on different condition, we have to, in these pelvic pain conditions, these are the locations in perineum. In females also, you can give this area very bad pelvic pain, not getting relieved by any symptom. Even sometimes they undergo surgery, hysterectomy also, but still it doesn't get relieved. In such a cases, this is required. Again, in peyronietic disease, what is the role of this laser? ESWL reduces pain, break up collagen, reduces inflammation, and reduces normal healing. These are the other orthopedic condition, pains and aches in the body, the tissue which is affected badly, back pain, plantar fasciitis, jumper's knee, tennis elbow, shoulder pain. These are the additional advantages you can take with these lasers. So in cosmesis, in rejuvenation also how it works, it promotes skin collagen remodeling, stimulates microcirculation, reduces inflammation, and tightens the fibrous tissue. Now, these are the different conditions where what are the sessions, 5,000 for the GED, chronic pelvic pain 5,000 setting, chronic prostatitis, and in Peyronie's level 7, level 9, the sessions are higher. You can say up to 6,000 to 7,000 because it is a plaque. Again, this is the procedure where you can see how it is penetrating, how it works. Hardly in 2 minutes I'll finish. So here you can see how lithotripsy is given. You can see over here. So you have to focus which area. This is most important. Even if you are having lithotripsy with you, and if you are not hitting proper crura, proper perineal region, then it is of no use. You have to do like this way. First, we have to go at the base of the scrotum. At base of the scrotum, you have to proceed with the shock. And then, right side you have to cover. After finishing the shocks, then you have to switch on to the next side. Like this way, you are going to cover the area, right side, crural region, left side, crural region, base of the penis, and again you have to go for the root of the penis. So these are the different injectable therapies also. Now, last modality where you can say nothing worse, the curvature is not going off, then we go for the surgical procedure, and here you can see how surgery works. So this is a typical case, you can say. Remember friends, whenever you are operating on penis, every millimeter of a skin is important. Here you can see, whenever you are operating, always you should not afraid giving infiltration in a diluted form with adrenaline. It's a dilution, you can say 1 in 2 lakhs, that has to be mixed in 50 ml of normal saline and 5 ml of the xylocaine with adrenaline. This is the stay suture for the handling throughout, for having the traction, all these purposes it is used. Now most important, here I will show you the incision. Whenever you are operating on penis, it is very, very important, you should be at least more than 1.5 centimeter away from the corona, because after incision, that skin come back. Even your audio also go. It's operating on a penile tissue. It is a very, very important to preserve the skin. Again, you have to deglow the penis till root, because there are some tuckings at Buck's fascia level. There are some tuckings at even pubocysis region where you want to lengthen. Sometimes we cut the suspensory ligament. We can show when we get the video. And most important part, when you are operating Peyronie's plug, imagine everything is hidden in other cases. First question which patient asks, whether I will get all the erection or not. You can say about stone is removed, not removed, but about erection, you cannot say anything unless you give the result. So back. Here you can see. So cut must be a sharp cut, so that till you are going on Buck's fascia, there should not be a intervening, even see the distance. Because when at the end you are suturing, there should be a gap, there should be a step between corona and the incision, because practically the step which is there at corona is very, very important at the time of sexual activity for the purpose of orgasm to female also and orgasm to male also. Like this we continue, and next step is whenever you are operating, if you come across a constriction bands, because this constriction band is due to phimosis, or in diabetic cases the skin is already very not pliable. So in such a cases you must go for cutting off a skin till there is a constriction band, because unless and until you cut up to that band, you cannot deglow the penis till the root. Now next step you can see over here. Always remember, like less use of scissor. What happens, this tissue, when you poke the tissue at the dorsal region, there are much more chances you can definitely affect the neurovascular bundle, and output is most important. What surgery you are doing, at the end, the patient has to get the erection. So this we are going till the root. So in any dissection till the end, we are not using scissor. Reason is that only to prevent any damage, because on lower side there is the urethral part. Here, again, what I was saying, to give some length, additional length. Nobody will say, why you are given me 1 inch extra? Anybody will say, no, he will be happy, sir. After operation, I have got one much more. So what next? So this is the area where I'll say the dorsal dissection of neurovascular bundle, and this is the area where there is a plaque. This plaque has to be excised, and for that excision, this is the most important thing. When you are raising the neurovascular bundle, it has to be opened at one place only, and you have to poke the tissue, and we have to poke the tissue in such a way you can go ahead across completely with a single poke. You can raise the. I feel we should go for it is just end part only. Till that we can have a discussion. If there is any, you can show a query. Only one slide is remaining. Till then we have some discussion to save the time.
Thank you very much, Dr. Vijay, for your such a nice informative lecture. Any question from the audience?
Because Peyronie's plaque itself is such a condition where you might be feeling there might be how many patients will be there. Whether it is back? No. Just one last slide is remaining. Yeah, it will take some time. Yeah. Okay, it's all right. So this is the dissection of dorsal complex. Okay, a few slides only. So this we can say this is the excision of plaque. We are totally exiting from the base. Now, this is the post-op video, and some videos we have taken how the vascular bundle, then there is the fossa, this is the suturing, this is the end result, this is our operating team, and this is the center we are coming in Dadar very shortly, where everything related to andrology, everything related to ED, and all things at one roof we are motivating. And friends, thank you very much for such a kind and patience listening. Thank you, chairpersons also. Yeah.
Thank you, sir. Thank you very much, Dr. Vijay, for this your informative lecture. Any question from the audience? No. Any question from the audience? Thank you.
I would like to invite Dr. Korke sir to felicitate Dr. Daipale sir. All the chairpersons kindly join. I would like to invite Dr. Raju Rani sir to felicitate all the chairperson. Now there is a 10-minute break, tea break. Vijay sir. Oh.
बंद केली चालेल कारण लाईट
तेव्हा प्रॉपर स्क्रीन को ऑफ
आपण त्याला
from IMA AKLUJ branch, and Dr. Savita Gujar Madam, Senior Obstetrician Gynecologist from IMA AKLUJ branch. Dr. Savita Gujar Madam is organizing secretary of this EVECON 2024 and in charge Women Doctor Wings IMA AKLUJ branch. I request Dr. Amol Shinde sir to introduce Dr. Jayesh Lele sir, please.
Hello. Yeah, good evening, everybody. Some faces really does not need an introduction. As the name itself, Dr. Jayesh Lele sir. He's the chairman of the IMA National Health Headquarters. He was a vice president of IMA Headquarters from 2022 to 23. He was working as an honorary secretary general for the IMA Headquarters from 2020 to 2022. National Secretary for IMA Hospital Board of India from 2016 to 2020. He was a president of IMA Maharashtra in the year of 2015 to 2016. He was Honorable State Secretary IMA Maharashtra from 2010 to 2014. He is a recipient of IMA Professor Sridhar Sharma Oration Award for the year of 2017 and 18 in the recognition of the services rendered to the IMA headquarters. He held various prestigious posts in the IMA branch, state as well as in headquarters. He has received awards from the IMA headquarters and IMA Maharashtra like IMA National Individual Community Service Award in 2015. He has delivered Thane Oration on CEA at MAPCON 2016. He was a past president of Maharashtra Medical Council. Sir, it's an indeed pleasure and privilege to have you here on the dais for your prestigious words. I welcome Dr. Lele sir on behalf of EVECON and IMA AKLUJ. Thank you.
इथे नाही तिथलं Thank you for your kind words. First of all, since morning you have been listening to the lasers and robotics and must be worrying that how this topic on health scheme has come into the IMA. But let me tell you that IMA, as you know very well, that IMA is working for the members as well as working for patient at large. And definitely last couple of years, in fact, IMA has been a brand ambassador. Various schemes, I think Dr. Arankar sir knows very well. One of the scheme which is run by Maharashtra is a social security scheme, which is very important. Similarly, we have this new scheme introduced around 6-7 years back, and it is meant for the members. And really, it is a different kind of a scheme because basically here what we want to give to our doctors, members as a family, that this scheme is not only going to help them and their family members, because no other scheme is open for family members. Salient feature is that up to the age of 80 anybody can join. Any IMA member up to the age of 80 can join. No other health insurance scheme will give you that. Basically, this is not going to give the entire amount to the doctor's family or a patient, whoever is diseased. But definitely this is a medical aid scheme wherein various mediclaims, they, you know very well, either TPA is there, Vikram knows very well how much they cut every in and out. So what we have done is to bridge the gap between that scheme which is going to cut that. So what we are going to give is the IMA members as a family contribute to the disease, patients' families, and similar to what the social security scheme works, or our PPS scheme works. Here, what we are giving is that every year some contribution for a member or a member's family, even a child can be introduced into this scheme very well. And this scheme will help in the long way that whatever the deficit is, you are going to get it from the Mediclaim, which will be filled up by this scheme. So I will just quickly run through the scheme. So just to add to that, as I mentioned, various heart disease, whether it's angioplasty, bypass surgery, valve replacements, or some cancer surgery, all malignant diseases, brain tumors, hip and knee replacement surgeries, all other major surgeries are being covered. Road accidents and the traffic accidents are covered from the year 1 itself, because there is a little change that at a later age, that is around 40, 50 and 60, there is a gap of about 2 years moratorium for that particular thing. But for road accident, we have given it clear. So benefits to the scheme shall be available to all the IMA members, as I mentioned, her spouse, children, parents, in-laws also, because otherwise no other scheme is going to give that. Any individual IMA member can enroll this. It is very simple, no questions asked, no examination done. As per the age, we have to be in that every year. What they contribute is the AF, that is the assistant, annual membership and advanced fraternity contribution. See, every year there will be contribution, will be only advanced fraternity contribution. Annual membership is separate, and ultimately every year at the end of the year, whatever the contribution we have given it to the members, that will be recovered partially from the member, and it will be put into the corpus so that it can be used for the future, because it is the scheme is running up to the doctor's age of 80 years, which is a very long scheme is there. So this is the chart which is showing us when to join that annual members and AFMC, that is that 18% GST, as you know very well now, from last year the GST has started applicable. So this is the scheme is there, and AF means admission fee as per the, again it is as per the age. 1,000 is for the below 35 and up to the 70 to 80 is 10,000. Once only that is to be paid. So this is the chart. I will give the details to the Dr. Santosh, you can circulate it. Every member, beneficiary member, has to pay 500 rupees every year for that contribution. 250 will go to the national IMA as a central share, and 50 will go to the local branch. This is from last year only we have made change, so that every branch and a state also will get benefited, because formally I think social security schemes we are not giving anything, but here we are going to have already been introduced, so that every branch also gets the benefit out of that. So this is the contribution financial assistant which we collect it from the age wise, again from the children to 2,500 contribution. So up to the age of 70 to 80, 10,000 per year will be contributed by the member. Management is, again, it is as per the normal constitution of the scheme. National president, secretary will be the ex officio, and then the chairman and the secretary, and there is a scrutiny committee which is very important. Every week we have the online scrutiny meeting, and whenever you have submitted the forms within 15 days, we will give you back the money as well as the original receipts are returned. Because many times you have to get another claim from the Mediclaim, any of Mediclaim of your choice. So we return immediately the original bills, because we don't keep the original bills. So this is the scrutinizing team, and every claims 99% they are settled in 60 days. In fact, last 3 years during the Corona time, when the Mediclaim was not giving enough money, this scheme came very handy to all the doctors. You know very well that 21 and 22 we lost almost 1,800 doctors across India during the Corona, and whoever the member was there, we have given the money to them within 15 days to the family. So this is the amount which we have generally kept it as a reserve. Angioplasty per stent 75,000, CABG up to 3 lakhs or malignancy, medical aid and with admission 50 lakhs, hernioplasty, cataract, total knee replacement, like that. We have certain fixed amounts are there, which is an additional amount which you can get claim from the Mediclaim. So procedure is very simple. There is a form is to be filled. You submit the Xerox copy of all the documents. If need be, we'll call for the original documents. Otherwise, we just take all the copies of the medical certificates. And generally, we do the scrutiny with the branch also. Because that is how our system works. Social Security scheme, Arankar sir knows very well, how the money is paid by the branch to the particular disease family. So similarly, within 15 to 20 days, the check is immediately disbursed. And 75% of the total bill amount exceeding the sum of the each disease of the procedure as a limit. That is how we have kept it. So this comes very handy. And all those people, that's those joining below the 55, 1 year is the moratorium. That is the locking period which I just mentioned. We are trying to cut down maybe during this year's Central Council meeting, we'll try to cut down to only 1 year for the 70 years. And up to the 55 years, that 1 year will be removed, one clause, so that we are going to reduce that. And here, whatever the last, if you see that till December 22, we had 1,560 members, and we have given the amount to the headquarters also, whatever the share was there, because certain share we have to give it to the headquarters. And the primary objective is to extend the helping hand. That's why it's a medical aid in addition to what you get the Mediclaim. So this is nothing a primary Mediclaim, but this is a medical aid. And again, one must say that it is open for all the members, families, spouses, parent-in-laws. So all those things will definitely increase the membership. It is just growing because only 6-7 years have worked on this. And we are working on this very well. The scheme is being open to all. If you have any questions, you can ask. Otherwise, I will send the forms to everybody. Online, you can join by paying the fees and you can be the member of this very important scheme. So as the IMA, which is helpful for the members as well as the families, so similarly, this is going to be a very helpful scheme for all the members and the families. Thank you.
Thank you, sir. And this is a very wonderful scheme, and by the looks of it, it looks to be a very viable, and definitely it is a very well crafted out scheme, because many times we don't get the full amount from the TPAs, and there are clauses. This lens won't do, this thing won't do, so we end up losing a lot of money. And sir, just one question. Like everybody knows, sir is a master of digitalization. Everybody knows sir has done the entire IMA database he has digitalized, and that's a great thing he has done. Sir, this thing will also be on an app based or something. Are you planning to do it?
This is not on the app, but the all payments and everything has on the forms digitalized.
Right.
So you just fill the form, pay the money, and you are the member next day from the scheme.
Perfect.
The offices, as you know, there are a lot of offices like AMS offices in Hyderabad, CGP offices in Chennai.
Right.
This office is in Thrissur.
Okay.
Near I think Coimbatore.
Coimbatore, okay.
So like that it works there, and the secretary is situated from the Thrissur, and the entire committee scrutiny meets on the web, because we don't travel much. We just wherever possible we do that. But our intention is to expand and give the benefit to the member.
Right.
However, the social security scheme is working for that.
Actually, sir, I asked that on the behalf of members, because many of the times it happens that I have paid the money, I am a member, but they want something, am I enrolled, is my everything clear? So, you know, that kinds of queries are there. So, I am damn sure, sir, you are there.
There is a website.
Okay.
There is a website available. You can check your membership, you can check your fees, whatever is paid. Payment is also online, so there is no problem.
Wonderful.
If any query is there, we immediately solve that, whatever queries are there, and email is there. So you don't have to travel or anything like that. Because here, that's what our intention is, that even social security, there is no checkup.
Yes.
We trust the doctor, we trust the member.
Right.
So like this here also, we don't ask the checkup. That's why 1 year we have kept as a lock-in period. So from second year on, first year also, like social security scheme, any accident case is allowed. But other than the accident case, somebody malignancy or anything, we pay only from the second year onwards. That is the normal claim.
Right, sir. Thank you.
Yeah, sure. Thank you.
Anybody has questions regarding this?
My question is apart from this lecture. during the as you are concerned with the health schemes of the national and state level, during the COVID period, some of our colleagues has lost their lives. Whether the family members has been given 50 lakhs by the state government or not?
And I will give more details because that's just now when our the moderator explained that I was a secretary from 21 and 22. I was, in fact, one day I will give you one incident that Feb 21, in the parliament this question was asked that how many doctors have been given the benefit of that 20 lakh scheme projected by the honorable court. I mean, not honorable court, honorable government. And in fact, the parliament could not answer that question because they never had the data. They never had data, and I was sitting in the office at headquarters, Secretary General's office, and CID came to me to ask me that you are telling that 1800 doctors have lost that time, till that time. Do you have the data? And within fraction of 5 seconds, I gave him the entire data. So I told him, I said, this is our machinery has been working immediately from March 20, when the COVID started and we saw that doctors are dying across India. We started keeping the entire India's doctors' health. Dr. Dinesh was one of the part of that particular this thing. And we kept everything. Unfortunately, out of the 1800 doctors what we have surveyed, only I think the money has been given to nearly 116 or 120 doctors. Rest are healthcare workers. So total 800 workers have been given, total healthcare workers. But from IMA, we ran the scheme and we gave to the needy doctors 10 lakhs of rupees because IMA cannot give 25 and 50 lakhs. So IMA has given almost 40 doctors family 10 lakhs rupees each, which we collected from our members. So government has not done money what it was promised.
Thank you, J.S. Lele sir, for a wonderful elaborative lecture. May I request Savita Gujar ma'am to felicitate Lele sir. May I request others to join, ma'am? Sir, to come on the dais. I request Vikrant Desai sir to introduce sir.
Thank you. It gives me a great pleasure to introduce our President sir, Dr. Dinesh Thakre. Sir has done his MBBS, PG Diploma in Pathology. He has done LLB. Sir has certificate in UNESCO Bioethics. Sir is MA in Journalism and Mass Communication. Sir is MBA in General Management, BA in English Literature, and many more to the list. He is a member, Steering Committee, World Medical Association, National Secretary, IMA Hospital Board of India. He is President, IMA Maharashtra State. He has been National Co-Chairman, IMA Medical Legal Cell. He has been National Vice Chairman, IMA Food Safety Initiative. He has held various posts in IMA at branch, state, and headquarters. Welcome, sir.
Thank you, Vikram, sir. So, good evening, all of you. Today's topic is tackling challenges in medical practice, role of local branches and IMA members. Now, the current and near future scenario is lawmakers feel that we are under-regulated. So, they are bringing in newer and stringent laws or changing penalty to imprisonment, like in CE 2010, CP 2019. They are bringing Anti-Corrupt Practice Bill, Right to Health Act, etc., etc. And they have withheld Violence Against Doctors Bill. So this is the stand of lawmakers. Now, after lawmakers, government feels that the acts passed by legislature are lenient. So what they do, they make the rules stringent and innovative, like in biomedical waste rules, PCB entity rules, hospital registration rules, electric and structural audits. Even they are violating the basic principle of the law that any rule, any act should be prospective. But the GR in 2021 clearly shows that they are interested, in case of medical field, to implement the rules retrospectively also. Then comes the judiciary. Judiciary feels that acts and rules are pro doctor. So what they do, they apply stringent formula in CPA for compensation to go in tours. They punish doctors for bad handwriting. They want doctors to display their mark sheets in all UG and PG exams in OPD. Don't you believe? SC fines 3 doctors for poor handwriting. Madras SC asks doctors to display their attempts in clinics. So I hope one day they will ask judges to display their LLB degrees or certificates in the courtroom. Now, judiciary give more importance to documentation than the untiring efforts of the doctor behind those documents. That is the harsh reality. In their flow of interpreting words, sometimes they fail to empathize with the healing hands. Rather, I should say most of the times. Precious time of doctors get wasted. Science students are choosing law as a career than medicine. They feel it's better to punish doctors than to get punished being a doctor. Then comes the police. Police feels that the doctors are villains, taking advantage of fiduciary position. They arrest doctors in cases of medical negligence, that is IPC 304A, under the cover of maintaining law and order. They treat doctors like criminals. Example is the IPC 302 that was slapped in Dr. Archana Sharma case. Now then comes media. I am giving the overview of the various strata of the society, what they feel about us. And they are our brothers and sisters only. My brother may be lawyer, my brother may be in judiciary, my brother may be in police or in media. So what they feel? The media feels that the doctors are inhuman, hardcore criminals and have no empathy for helpless patient. So they start media trial. They make public opinion negative and at the end they end up defaming the doctor. Like this. लुटारूंना आम्ही संपून टाकू लोकशाही लोकमतची चळवळ. As if there is no lutaru in media. Then finally comes the public. Public feels that they will not get justice on making complaints. And even if they misbehave, all the machinery will fear them. So they take law in their hands. They themselves want to punish the doctor. And unfortunately, major section of the society supports them. Unfortunately and usually, the assaulter who misbehaves with the doctor is praised by the public and media that he is fighting to help the poor patient. That is the perception of the public. Though the doctor may have tried hard to save the patient, still that is the perception about such so-called local politician or समाज सेवक. So what happens? ये बात अलग है कि मेरा कातिल भी वही था, that is the assaulter, और उस शहर में तारीफ़ काबिल भी वही था. Then some of our own colleagues feel that all other doctors are black sheep except me. They help all the entities in their deeds. They defame their own fraternity to please their masters, to satisfy their own superiority complex. That is all reality I was talking about. If such are the facts, what is the way out? What is the solution? Who will change the scenario? Who will work to change the laws to stop our harassment? And who will change the perception about us? And who is our Masiha? Usually common answer that I get from our members, government should do. We should request or do protest to get it done. Authorities should appreciate our intelligence. Judiciary should appreciate that there is no mens rea, that is the basic principle again in the law. Police should be polite to us. Media should not publish defamatory stories, and public should complain at proper forums and do not take law in hands. That is what we expect, and that's what common answers I get. Question is, can we do something? या फिर ऐसा हुआ है कि रोशनी की तवक्को है अब उधार के चरागों से, हवा ने हमारी शम्मा को कब का बुझा दिया. Of course, we should expect others to do the things and favors to us. But what if they are not doing? We are strong enough mentally, socially, financially. We are intelligent enough, wise enough to address the genuine concerns by acquiring some new things, to give befitting reply to each of the assaulters in a language which each one of them understands. Now what Dr. Abdul Kalam said, my impression of the American people can be summarized by a quotation from Benjamin Franklin. Those things that hurt, instruct. Those things that hurt, instruct. I realize that people in this part of the world meet their problems head on. They attempt to get out of them rather than suffer them. And we find exactly opposite situation in India. Best way to solve a problem is to turn back and face it. That's what Swami Vivekananda said. And best way to predict future is to create it. That is what Abraham Lincoln said. Can you do it? Let's see it. But there is a question. But सिर्फ सोचने से कहाँ मिलते हैं तमन्नाओं के शहर? सिर्फ सोचने से कहाँ मिलते हैं तमन्नाओं के शहर? चलने की जिद भी ज़रूरी है मंजिलों को पाने के लिए. हमको चाहिए तो सब कुछ, लेकिन चलने की जिद नहीं. Let us see. So there are 12 modules to achieve this. Talk on each module is of 30-40 minutes each. Today I will just give gist of each module. First module is make effective communication an integral part of our daily practice. Remember our old practitioner, general practitioner. How? The chapters, sub-chapters should arrange a workshop on to train hospital staff initially to enhance their communication skill. Why I am talking specifically about hospital staff? Because first contact is the reception counter. The most important contact is the reception counter, and most of the cases of abuse and violence start from reception counter. Now, if communication should be effective, it should not be just communication. Just example is, उसने इतना कहे के फ़ोन रख दिया कि कोई आ गया है. उसने इतना कहे के फ़ोन रख दिया कि कोई आ गया है, मैं आज तक समझ न पाया घर में या ज़िंदगी में. So that is lack of effective communication. Again, in cinema films, when a patient dies, the doctor says, I am sorry. We have seen this in all films, but in today's era, it is risky to say that I am sorry. Many times, it is an appropriate, lawful demand of the patient that doctor should give him sufficient quality time. As a patient, we also expect the same. Answer all his queries gently with empathy. Especially visiting doctors. Regarding visiting doctors, he can say, "Gar jo tum puch lete mera हाल तो क्या हो जाता? माना कि कोई रिश्ता नहीं दिल का, पर तेरा दिल गर बेचैन हो जाता मेरे लिए तो क्या हो जाता?" Like this. Second module is proper documentation and relevant training to the staff. Don't allow any Tom, Dick and Harry to humiliate you just because you are poor in documentation. Doctors are most intelligent people in the society. They should use their talent to be perfect, at least in the documentation. शायर अल्लामा इकबाल says, खुद ही को कर बुलंद इतना कि हर तकदीर से पहले खुदा बंदे से खुद पूछे बता तेरी रजा क्या है. You have heard, all of you have heard this. Now let's see what Dr. Dinesh Thakur says. खुद ही को कर कलमी मजबूत इतना कि हर फैसले से पहले हर एक साहब मीन्स जुडिशियल पर्सन, गवर्नमेंट ऑफिशियल, तबीब यानी डॉक्टर से खुद पूछे अब तू ही बता कि तेरी खता क्या है. खुद ही को कर कलमी मजबूत इतना कि हर फैसले से पहले हर एक साहब तबीब से खुद पूछे अब तू ही बता मेरे बाप कि तेरी खता क्या है. आंसर बाय द हॉनेस्ट डॉक्टर कम्युनिटी इज लाइक दिस. खता तो मैंने बहुत बड़ी की है. दिस इज द आंसर फ्रॉम ऑनेस्ट डॉक्टर. खता तो मैंने बहुत बड़ी की है, मरीज के पहले अपना गिरेबां बचाया है. मुकम्मल इलाज करने इस्तेमाल करना है मेरा जो जहीन दिमाग, वो मैंने आज कागजातों को मुकम्मल बनाने में लगाया है. I am a pathologist. I would have been more happy to deliver talk on pathology, but I am using my brain for all the medical legal issues. ये अल्फाजों के सरदारों, originally it was अल्फाजों के गुलामों, but it can be contempt of court. You have seen the recent example. ये अल्फाजों के सरदारों, तुम नहीं दे सकते मुझे इस खता की सज़ा, क्योंकि 100 बका एक लिखा अमल करने को तुमने ही मुझे मजबूर किया है. ये अंधा कानून है जो अंत में मरीज का ही नुकसान कर रहा है. Solutions, there should be solutions also. First is continue fight to repeal unnecessary documentation. That is one. Efforts to bring in better documentation, that saves us. Till then, follow compulsory documentation. Most of the time, an IMA leader talks about many things, we should do this, we should do that, and people feel that that is the reality. That is what he was suggesting. He is suggesting that document should be like this. But till that time, till that thing happen, till the changes happen in law or in rules, you have to follow compulsory documentation. Learn how to maintain documentation happily, properly, and wisely with minimum stress. The hospital chapters, HBI chapters or branches should arrange workshops to train doctors and hospital staff to enhance their documentation skills to keep proper and relevant documentation with minimum stress and time. Smart monitoring with delegation of work to the staff. Third module is synergy and cognitive empathy. The HBI chapters should arrange workshops to provide tips, training and guidance to members on handling all kinds of situations of professional distress, all kinds, I am saying, acquiring life skills, developing cooperation for mutual financial benefits like bulk purchase, hiring common agents for various services we need. That is, saving is earning. Doing efforts to improve relations, contacts and level of mutual perception by organizing interactive sessions with various authorities, law implementing agencies, judicial authorities, advocates, journalists, social reformists, public figures, etc. Suggesting staff welfare programs or schemes, organizing various staff training programs. Training the members and their staff on how to be morally, ethically and legally correct. To integrate self-regulation practices into daily routine practice in the hospital. This is again a 30-minute talk. Now, this is a quote that I have developed with the example, with the experience in this field working for doctor fraternity. We have to make our medical practice society-oriented with obvious, deliberate and transparent disclosure of empathy and self-regulation. This is the only solution. That is what I feel. Such an interactive staff training workshop can be organized like with topics like what mistakes we do as perceived by others. This is for staff. Rights of patients and attenders, responsibility of patient and attenders, various situations that may arise in your hospital, how to act regarding hospital violence, how to act regarding various non-medical situations, various medical situations, and how to act as per various acts, rules, regulations, specific rules, specific regulation, like that in POCSO Act. Fourth model is various insurances related to hospital. Appropriate choices for sound sleep. HBI subchapter should arrange talks of office bearers of IMA PPS, Professional Protection Scheme, to provide guidance on why professional indemnity insurance is in need of hour. Whether to take personal or hospital indemnity or both or why. And why. Dr. Jain Naurang sir is sitting here, a pioneer in the new scheme that we have brought under Social Security scheme. That also we should go through. Then how much amount of cover to take? Insurance of instruments, hospital building, fire, theft, etc. Group insurance of staff. After all, peace of mind and sound sleep is our basic right also. Let us understand this. Fifth module, medical jousting prevention cell. Medical jousting means criticizing the treatment that patient has undergone so far before consulting you. It is the most common reason behind rising cases, maybe civil or criminal, and abuse or violence against doctors and hospital. So to prevent medical jousting is of utmost importance. The HBI subchapter should form this cell and provide concrete solution to stop menace of bad mouthing, which leads to most of the hospital abuse, violence and court cases. We can provide the draft. Promotion of harmony and spirit of brotherhood for benefit of all. Sixth is medical legal cell. Whenever there is a medical emergency, the doctor handles it confidently because of his previous training. But whenever there is a medical legal emergency, he feels helpless and depends on lawyers who have insufficient medical legal knowledge. Therefore, HBI chapter should form this cell with the following aims and objectives: to impart basic medical legal knowledge to the IIM members, to train IIM members to be ethically, legally correct in daily practice, to boost confidence in common IIM members to face any medical legal situation in daily routine practice. Now, this is coming in the UG curriculum. To suggest such changes in practicing medicine, which may either nullify or minimize adversities caused by a particular legal order. That can be done by the medical legal experts in IMA. For example, in POXO Act, there are some provisions which may land you up in a jail for 6 months. But taking some minimal precautions will avoid it. Seventh is public awareness against legal jargon. During daily regular interaction with patients, relatives, people from different strata of society, you should make them aware about legal jargon related to documentation. During our counseling, you can tell them repeatedly that I had to take so many signatures and consents because of so and so legal provisions. Because number of signatures are inversely proportional to the trust. The more trust you have, signatures should be less. You feel that I am frightening you by telling complication of that treatment, but the rules compel me to do so. We trust each other, but the legal provisions compel me to do such a documentation as if we don't trust each other. Cost of this treatment has increased because of so and so irrelevant rules. Because who will tell the patient our side? Media will tell, government will tell, lawyer will tell. Who will tell them that is what we are going through? We can tell them, we ourselves should tell them while counseling. Also, we need to identify the people who have the power and authority to direct us what we should do, what we should not do. We have seen this during COVID era, and irrespective of their knowledge about the intricacies of medicine. तंग आ गए अब हम तो, it was like during COVID era. तंग आ गए अब हम तो रोज़ आते सरकारी फरमानों से, हमने तो सरकार बनाई थी कितने अरमानों से. So public awareness against legal jargon. According to me, only way to get rid of the legal jargon, especially Consumer Protection Act, is liaising and lobbying with the politicians and lawmakers. A second practical way to get some relief from hospital registration, biomedical waste, fire NOC, electric audit, structural audit, and various licenses is liaising and lobbying with law implementing authorities as of now, till the relevant amendments takes place in rules and acts. 8th module, that is reciprocal public grievance redressal. Majority of the complaints of patients and their relatives, NGOs, or civil society organizations, or outfits of civil society organizations or outfits, so-called outfits of so-called political organization, the majority of complaints can be resolved through proper counseling of and across the table interaction with the aggrieved parties and concerned medical professionals and vice versa. HBI subchapter should establish this cell with the involvement of reputed members of society for reciprocal grievance redressal for the members of all strata of society and our members too. Such a redressal cell at IIM Nagpur has shown good results. You can take their guidance. 9th module is assault study and response cell. Whenever an unfortunate incident occurs at any hospital or otherwise also, some miscreants try to take undue advantage for their illegitimate gains by unnecessarily harassing the doctors by various means. Most of the time, we know the habitual assaulters in the city, but we prefer to be unresponsive for the sake of peace of mind. आपल्याला काय करायचं आहे? So who can be such miscreants or assaulters? Media, local politician, police, various authorities, public figures, judiciary, or any XYZ. Who were the assaulters in Dr. Archana Sharma case? Local politician, media, and police. Now, this is the quote by President of India, 16 Jan 18. As doctors, your services must be available both to those who can afford your fees and also to those who are less fortunate and cannot. It is for society to profit for medical science, and it is not for medical science to profit from society. President of India on 16 Jan 18. Shouldn't this tweet be considered as assault on doctor? Some doctor, Mr. Wasim Ahmed, had replied very well that all general public should give free real estate land for construction hospitals and also should give free education and free food to doctors and family members, like that. Assault on doctors. During COVID pandemic, Mumbai Police Commissioner gave a statement on doctors. Don't treat patients like commodity. I have got relieved of corona just by paracetamol. This is again an assault on doctor. Most of the time, all these wise men target black sheep within us. Right? First they target black sheep within us. Shout at them to follow legal provisions and to be ethical. But what happens next? What happens next? They accept the bribe, things go on. Happening in the life? ये बंद कराने आए थे तवायफ के कोठे, मगर सिक्कों की खनक देखकर खुद ही मुद्रा कर बैठे. So agony of innocent doctor is that हम पर तो कोई जुर्म साबित ना हुआ, हम पर तो कोई जुर्म साबित ना हुआ, मगर तोहमत लगा के वो मशहूर हो गए. एक बंदा हमारे यहाँ आमदार बन गया ऐसा कर करके. So it is all about how you respond to assault on you. Now the video is not running. We have tried a lot. तुम्ही इथे ही मांजर बघू शकता. ही मांजर तिचं जेवण करते चिपशामध्ये. थोड्या वेळाने एक उंदीर येतो आणि तो उंदीर त्या मांजरीला हाकलून लावतो, स्वतः ते खातो. तर माझ्या मते हे मांजर म्हणजे मेडिकल प्रॅक्टिशनर्स आणि तो उंदीरमध्ये ऑल सॉर्ट्स ऑफ असॉल्टर्स. तुमचं स्वतःचं जेवण स्वतःच्या तुम्ही याच्यातून खात आहे शांततेनं आणि तो उंदीर येतो आणि तुम्हाला हुसकावून लावत आहे. तुमची चूक काय आहे? उंदीर तुमचा नैसर्गिक खाना आहे. ते सोडून तुम्ही त्या उंदराला घाबरता आणि इथून पळून जाता. तर चूक त्या उंदराची नाही, चूक आहे मांजराची. त्यामुळे चूक आहे मॉडर्न मेडिसिन प्रॅक्टिशनर्सची. टू आयडेंटिफाय अँड न्यूट्रलाइज म्हणजे असॉल्टर स्टडी अँड रिस्पॉन्स सेलने काय करायला पाहिजे? टू आयडेंटिफाय अँड न्यूट्रलाइज सच असॉल्टर्स, द लोकल ब्रांच शुड फॉर्म दिस सेल टू फॉर्म्युलेट and implement a well-planned strategy to respond to them by using all sorts of साम दाम दंड भेद. हे जर 30 वर्षापूर्वी 20 वर्षापूर्वी म्हटलं असतं तर तुम्ही सगळेजण ओरडले असते माझ्याकडे, काय सांगता डॉक्टर तुम्ही, कुठे तुम्हालाही पडते आज. स्पीक दॅट लँग्वेज ओनली विच रिस्पेक्ट टू एंटिटी अंडरस्टँड्स. हा पण व्हिडिओ चालणार नाही. याच्यामध्ये एक वाघ आहे आणि एक कुत्रा आहे. हा कुत्रा त्यावर भुकतो आहे. तो वाघ म्हणजे मेडिकल प्रॅक्टिशनर्स आणि कुत्रा म्हणजे ऑल सॉर्ट ऑफ असॉल्टर्स. तो कुत्रा भुंकतो, त्या वाघाला दोरीने बांधून ठेवलं आहे. दोरीने म्हणजे आज जेवढे काही लॉज रूल्स सगळे बांधून ठेवले आहे, सोसायटी बांधून ठेवला आहे. तर तो एक रिप्रेझेंट करतो मेडिकल प्रॅक्टिशनर्सला, हा वाघ ज्याला बांधून ठेवलेला आहे. हा कुत्रा म्हणजे जो फ्री आहे भुंकायला. हा वाघ बांधला असूनही त्या कुत्र्याला गच्ची पकडतो. सो स्पीक द लँग्वेज दे अंडरस्टँड. स्पीक द लँग्वेज अंडरस्टँड. आता डॉक्टर्स मारायला लागले पेशंटला. आधी काय होतं, पेशंट अंगावर आला, रिलेटिव्ह अंगावर आले की डॉक्टर पळून जायचे. आता बरेच ठिकाणी रेसिडेंट्स आणि आमच्या मेडिकल कॉलेज अमरावतीला डॉक्टरांनी मारलं. इथे मनसे तालुकाध्यक्ष अशोक पाटील यांना पुराव्यासह न्यायालयात हजर राहण्याची नोटीस. पत्रकार परिषद व उपोषणाचे भांडवल करून बदनामी केल्याचा हॉस्पिटलचे संचालक यांचा कायदेशीर दावा. आता हे असं उलट जेवढं होईल, जी भाषा समोरच्याला समजते त्या भाषेत तुम्ही बोलले तरच काही होणार, नाही तर काही होणार नाही. आणि याच्यासोबतच कंटिन्युअस पॉलिटिकल लायझनिंग पण चालू असणं आवश्यक आहे. नो ॲडमिशन ऑफ कंप्लेंट इन एनी फोरम इफ देर वॉज अ व्हायलन्स बाय पेशंट साईड इन द पास्ट. एक्सक्लुजन फ्रॉम CPA 19 विथ एस्टॅब्लिशमेंट्स ऑफ मेडिकल ट्रिब्युनल्स. आम्ही स्वतःला रिस्पॉन्सिबल समजतो, रिस्पॉन्सिबल आहोत आम्ही. आमचं चुकत असेल तुम्ही शिक्षा द्या, पण जज लोक ज्यांना काही समजत नाही मेडिकलमधलं त्यांना तुम्ही आमचे जज नका बनवू, मेडिकल ट्रिब्युनल्स बनवू. आम्ही तयार आहोत. गाईडलाईन्स फॉर प्रॉसिक्युशन ऑफ डॉक्टर्स बेस्ड ऑन ऑनरेबल सुप्रीम कोर्ट गाईडलाईन्स. Prospective application of rules framed under various acts. prospective application. नंतर फायलिंग कंटेम्प्ट ऑफ कोर्ट फॉर नॉन इम्प्लिमेंटेशन ऑफ फेअरेबल ज्युडिशियल प्रोनाउन्समेंट्स, अशा बऱ्याचशा गोष्टी ज्या सुप्रीम कोर्टने आपल्या साईडने दिलेल्या आहेत त्याविरुद्ध कंटेम्प्ट ऑफ कोर्ट टाकणं आवश्यक आहे. देन चॅलेंजिंग अनएक्सेप्टेबल अँड लिगली नॉट टेनेबल लिगल प्रोव्हिजन्स इन व्हेरियस रूल्स अँड ॲक्ट्स. Whenever a new police officer joins any police station in your city, gift him copies of Jacob Matthews judgment, Martin D'Souza judgment, and State-Specific Medicare Protection Act with highlighted important provisions. नवरंगी साऱ्या गोष्टी नेहमी सांगतात. 10th मॉड्यूल इज व्हायलन्स अगेन्स्ट डॉक्टर्स. हा तर 1 तासाचा टॉपिक आहे, मी एका स्लाईडमध्ये संपवणार आहे. HBA सबचॅप्टर्स किंवा ब्रांचेस शुड अरेंज टॉक्स टू प्रोव्हाइड ट्रेनिंग टू मेंबर्स अँड देअर स्टाफ ऑन ऑल आस्पेक्ट्स. आता हे आपलं दुर्दैव आहे की हे ट्रेनिंग आपल्याला घ्यायची आणि आपल्या स्टाफला घ्यायची वेळ आली. प्रिव्हेन्शन, अँटिसिपेशन, प्रिपेरिंग फॉर हँडलिंग अँड पोस्ट इव्हेंट रिस्पॉन्स टू एनी इन्सिडेंट ऑफ अब्यूज अँड व्हायलन्स. याचा 1 तासाचा टॉक तुम्ही घेऊ शकता. रिपीट करतो. प्रिव्हेन्शन, अँटिसिपेशन, प्रिपेरिंग फॉर हँडलिंग अँड पोस्ट इव्हेंट रिस्पॉन्स टू एनी सॉर्ट ऑफ अब्यूज अँड व्हायलन्स. 11th मॉड्यूल इज healthcare delivery to be led by medical profession. As you are aware, the leadership in the healthcare delivery has slowly and steadily been passing into the hands of entrepreneurs of all backgrounds, and the medical profession is at risk of being relegated to the sidelines. Group practice फार महत्त्वाची आहे. 10 लोकांनी एकत्र येऊन हॉस्पिटल टाकणे, त्यातलं एकाला ॲडमिनिस्ट्रेटर बनवणे आणि हॉस्पिटल टाकणे. कॉर्पोरेट हॉस्पिटलची गुलामी ही करू नये. ती आपण सगळेजण इथे बसलेलो आहोत त्यांनी ही काळजी घेतली पाहिजे की आपण स्वतः आपले मुलं आणि आपले मेंबर्स यांना ही आपली सांगणं जबाबदारी आहे की कॉर्पोरेट हॉस्पिटल जॉईन करणे म्हणजे गुलामी. आणि येणाऱ्या काळामध्ये इतके मेडिकल कॉलेज उघडत आहे, इतके डॉक्टर जमा होत आहे की आता आपल्या प्रोफेशनचं कचरा होणे ज्याला म्हणतो आपण ते सुरू झालेलं आहे. आणि ते कचरा होण्यापासून वाचायचं असेल तर बेस्ट इज ग्रुप प्रॅक्टिस. अँड अगेन need to stop entry of non-modern medicine personal companies in our fraternity. आपल्याला रेफरल द्यायचं आहे तर आपल्या फॅटर्निटीला, आपल्याला रेफरल घ्यायचं आहे आपल्या फॅटर्निटीकडून. मॉडर्न मेडिसिन डॉक्टर शुड बी द लीडर ऑफ द टीम इन एनी गिवन मॉडर्न मेडिसिन हॉस्पिटल. हे कन्फर्म आपण स्वतः केलं पाहिजे. ग्रुप प्रॅक्टिस अँड रिसिविंग अँड हायरिंग सर्व्हिसेस ओनली फॉर मॉडर्न मेडिसिन डॉक्टर इज द नीड ऑफ आवर. लास्ट मॉड्यूल ते सगळंच कठीण आहे. If there is a case or abuse against doctor in the city, some colleagues talk against him. They are damn sure that doctor must have been done something wrong. याचंच काही चुकलं असं, यानंच काही गडबड केली असं. माझे पेशंट माझ्यावर कधी अंगावर येत नाहीत, याच्या कशा काय आले. आजकालचे नवीन पोरांना तुम्हाला सांगतो मी, काही असं पेशंटशी बरोबर बोलत नाही. सम अदर्स चूज टू रिमेन अनरिस्पॉन्सिव्ह ऑर अलूफ. आम्हाला कळते की असं असं झालं, मला बिझी आहे, मी बिझी आहे, माझ्याकडे पेशंट जाऊ शकत नाही, असं प्रॅक्टिसमध्ये होतं. अँड आय विल रिस्पॉन्ड ओनली व्हेन आय फेस द प्रॉब्लेम. आम्ही अमरावतीला काय केलं आहे की रॅपिड ॲक्शन ग्रुप तयार केला आहे व्हॉट्सअपचा. त्याच्यामध्ये कुठे काही प्रॉब्लेम होत असेल तर तो फक्त टाकून देतो की बी रेडी किंवा रीच. तर आमच्याकडे अशी प्रॅक्टिस होऊन गेली की कमीत कमी 40-50 जण पोचून जातात 10 मिनटात जवळपासचे. त्याने खूप फरक पडतो आहे. तर तो प्रत्येक ब्रांचमध्ये झाला पाहिजे. अँड आय फील डॉक्टर्स आर नॉट ॲट ऑल ॲट फॉल्ट because it is the overall mentality of the society like that. है ना? Thank God that whole is not in our hand. Mentality of many of us, Indian society or otherwise human society. लगेगी आग तो आएंगे घर कई जद में. लगेंगे आग तो आएंगे घर कई जद में. यहाँ पे सिर्फ हमारा मकान थोड़ी है. पाहून घेऊ जेवेल ते. काही रूल आला असेल, काही प्रॉब्लेम आला असेल, गव्हर्नमेंटने काही GR काढला असेल, कोणी कोणाला मारलं असेल, बघून घेऊ. 100 डॉक्टर आहेत गावात, त्यांचं जे होईल ते आपलं होईल. आणि दे डोंट सपोर्ट द एफर्ट्स ऑफ IMA काय करते हा क्वेश्चन फिक्स आहे बिलकुल. IMA काहीच करत नाही. त्यामध्ये काय करतात, कोणत्या कंडिशनमध्ये आहे, टूटा बिखरा हुआ हूँ मैं अपने ही वजूद में. 4 भिंतीमध्ये माझा दवाखाना आहे आणि तिथे मी राजा आहे. ICU आहे माझ्याकडे, 100 पेशंट मला दाखवतात रोज वगैरे वगैरे. टूटा बिखरा हूँ मैं अपने ही वजूद में, रोज कील ठोक रहा हूँ अपने ही ताबूत में. सो स्ट्रॉंगर HBA मीन्स स्ट्रॉंगर युनायटेड ओनर्स, हॉस्पिटल ओनर्स. कोणतेही ब्रांच किंवा IMA दे शुड बी स्ट्रॉंग इनफ. अँड फॉर बिईंग स्ट्रॉंग द चॅप्टर्स आर नीड टू कोऑर्डिनेट विथ द वर्क ऑफ स्टेट ब्रांचेस. हा नॅशनल ब्रांचेसोबत जे काही चालू आहे त्या सगळं कोऑर्डिनेशन आपसात होणं आवश्यक आहे. आणि आपलं काहीतरी कॉन्ट्रीब्युशन यात असणं आवश्यक आहे. सोप्या भाषेत सांगायचं झालं तर आतापर्यंत आपण प्रॅक्टिस म्हणजे एज्युकेशन घेतलं, MBBS झालं, MD झालं, त्यानंतर फेलोशिप एखादी घेतली, मग एखादी सुंदरशी मुलगी बघितली, तिच्याशी लग्न केलं, गावात आलो, छानपैकी हॉस्पिटल बांधलं आणि मस्त प्रॅक्टिस सुरू आहे. असं आतापर्यंतचं 5 वर्ष आधीपर्यंत चित्र होतं. आता या सगळ्यासोबतच स्वतःची प्रॅक्टिस वाचवणे यासाठी 5% टाईम देणं आवश्यक आहे. लीडर लोक आहे जे याच्यातले ज्यांना पॅशन आहे त्यांनी 5% वेळ द्यावा, ज्यांना पॅशन नाही आहे त्यांनी 2% वेळ द्यावा. की ही कशासाठी? माझी प्रॅक्टिस वाचवणं आवश्यक आहे. मला जर पुढे जगायचं असेल, 50 वर्ष प्रॅक्टिस करायची आहे, 40 वर्ष प्रॅक्टिस करायची आहे, माझ्या मुलांनी प्रॅक्टिस करायची आहे, तर मी माझ्या वेळेमधला 2% वेळ या कामासाठी देईल. हे सगळ्याला खूप मोठी टॉपिक आहे, याच्यामध्ये आपण जास्त बोलू नाही. आणि अशा प्रकारचे काय म्हणतील त्याला आपल्याला वर्कशॉप्स आपण घेऊ शकतो. हे जे काही बोललो, एक 30-30 मिनटात 40 मिनटात एक टॉपिक आहे, त्याविषयी आपण बोलू शकतो. एक कविता फक्त मी वाचून दाखवतो, माझ्या आवडीची आहे. ती मला किती ठरवलं आणि मला माहिती आहे इतका वेळ झालेला आहे, सगळ्यांना जायचं आहे, पण ती कविता इतकी माझा टॉकच मी कंप्लीट करू शकत नाही. ही 4 जून 2017ला मी लिहिलेली पोएम आहे. आणि माझी इच्छा होती की दिवसेंदिवस इरिलेवंट होत जावी, त्याचं रिलेवन्स कमी होत जावं, पण अनफॉर्च्युनेटली त्याचं रिलेवन्स वाढत चाललं आहे. टेक्नॉलॉजी नॉट ओव्हरपॉवर्ड इन पास्ट सो रिसेंट. Human skill and senses had no replacement. Was custom to keep faith in any odd, the healer, the lifesaver was next to God. जेव्हा राम आरणकर सर, नवरंगे सर प्रॅक्टिस करत असतील त्यावेळेस द हिलर, द लाईफसेवर वॉज नेक्स्ट टू गॉड. टेक्नॉलॉजी रोड इन सो स्पेल बाउंड. स्किल लॉस्ट सुपिरियरिटी, इनोव्हेशन्स सो साऊंड. कॉन्करंट हाय इन्व्हेस्टमेंट ऑफ मनी अँड टाईम. रेडिओलॉजी स्पेशलिस्टने विचारा. गव्हर्मेंट फेल टू कॅटर, प्रायव्हेट सेक्टर प्राईम. त्या काळामध्ये खासदार लोक गव्हर्मेंट हॉस्पिटलला ॲडमिट व्हायचे, आमदार लोक गव्हर्मेंट हॉस्पिटल ॲडमिट व्हायचे. स्पेशल म्हणजे गव्हर्मेंट हॉस्पिटल म्हणजे बेस्ट होतं. बट गव्हर्मेंट फेल टू कॅटर, प्रायव्हेट सेक्टर प्राईम. CPA created consumers in 1995. CPA created consumers, no one bothered in 1995. Now consumer wants result for services me paid. पैसे दिले, मी लाख रुपये खर्च केले, 2 लाख रुपये खर्च केले, माझा पेशंट मेलाच कसा? 5 लाख रुपये खर्च केले, कसा काय मेला? एव्हरी पेशंट युनिक अँड स्किल टू बी पेड, बट नो, त्यांना समजतच नाही. हाय एक्सपेन्सेस अँड वेल्दी डॉक्टर, फेथ असाईड. सो डॉक्टरने प्रॅक्टिस टाकली, 2 वर्षामध्ये गाडी, बंगला, हे ते कसं काय झालं? रोबोटिक्स अँड ऑटोमेशन, दिवसभर वाचलंच आपण आज. रोबोटिक्स अँड ऑटोमेशन हे 2017तली गोष्ट आहे मी लिहिलेली. रोबोटिक्स अँड ऑटोमेशन टू टेक ओव्हर इन फ्युचर. कदम सरांनी खूप सकाळी छान सांगितलं आपल्याला. सिस्टम विल ट्रीट मी ॲज जस्ट अन ऑथराईज ऑपरेटर. मग अशी पाहायला आपण कुठे बसला तर सर्जन त्या कन्सॉलमध्ये बसून जस्ट अन ऑथराईज ऑपरेटर. पॅथॉलॉजिस्ट ते गेले त्या कामातून, आज फक्त पॅथॉलॉजी सहीच करायला लागते, सगळं मशीनच करत आहेत, बरोबर. आणि नेक्स्ट इन लाईन आहे रेडिओलॉजिस्ट. सर्जरी मला आज दिसलं, शुअर झालं. मी आता असं विचार करतो आहे रेडिओलॉजिस्ट पहिले घ्यायचं की सर्जरी पहिले घ्यायचं. मग पॅथॉलॉजिस्ट नंबर 1वर आहे. तर मी असं म्हणू शकतो की काही वर्षामध्ये सर्जन येतील सेकंडवरती. सो रोबोटिक्स अँड ऑटोमेशन टू टेक ओव्हर इन फ्युचर. सिस्टम विल ट्रीट मी जस्ट ॲज अन ऑथराईज ऑपरेटर. नो फेथ अँड हाय लिटिगेशन्स टू बी अ सोशल चेंज लाईक वेस्टर्न वर्ल्ड. लॉ विल मॉनिटर अँड पेनलाइज मी टू बी इन इट्स रेंज. जास्तीत जास्त कसं पकडता येईल डॉक्टरांना, हा लॉ, तो लॉ, तो लॉ, तो लॉ, तो लॉ. सो लॉ विल मॉनिटर अँड पेनलाइज मी टू बी इन इट्स रेंज. दो could not prevent it, but to resist. Say in formulating laws to have is a must. डॉक्टर लेले सर ह्यासाठी खूप भांडत असतात की लॉ जेव्हा फॉर्म्युलेट होतात तेव्हा त्याच्यामध्ये आमचा से तरी असला पाहिजे कमीत कमी. त्यासाठी जे काही करत असतील ते लेले सर खूप यांनी नॅशनल लेवलला करत असतात. स्ट्रिंजंट प्रोव्हिजन्स मोर अँड मोर अदरवाईज. स्ट्रिंजंट प्रोव्हिजन्स मोर अँड मोर अदरवाईज. लिव्हिंग अफॅथी विल रिटेलिएट, बी प्रोएक्टिव्ह अँड वाईज. हा सल्ला आहे, फॉलो कराल नाही कराल. म्हणून मेरे जज्बातों से इस कदर वाकिफ़ है मेरी कलम. मैं इश्क लिखना भी चाहूँ तो इनकलाब लिखा जाता है. बाय हुक और क्रूक टू विन पॉवर इज लॉ मेकर्स प्रायोरिटी. बरोबर आहे, पाहतोच आहे आपण. बाय हुक और क्रूक टू विन पॉवर इज लॉ मेकर्स प्रायोरिटी. नीड टू रिस्पॉन्ड टू इट दॅट वे आय एक्सेप्ट दिस रियालिटी. जी भाषा समजते त्याच भाषेमध्ये बोललं पाहिजे. नंबर विथ युनिटी, न्यूसन्स, लॉबिंग ओनली गेट्स हिड. बाकी कोणीच विचारत नाही डॉक्टरांना. सॉफ्ट टार्गेट्स. नंबर विथ युनिटी, न्यूसन्स, लॉबिंग ओनली गेट्स हिड. टू स्पीक अ लँग्वेज द लॉ मेकर अंडरस्टँड ई टाइम्स नीड. 2017मध्ये हा विषय झाला की टू स्पीक अ लँग्वेज द लॉ मेकर्स अंडरस्टँड अ टाइम्स नीड. टू सेन्सिटाईज गव्हर्नमेंट अँड कलिग्स टू ॲक्ट. गव्हर्नमेंटमध्ये आपले लोक आहेत, कलिग्स हे सगळे मी तुम्हाला 7 सांगितले. ज्युडिशरीमध्ये, मीडियामध्ये, आपल्या वकिलांमध्ये, सगळ्या अलग अलग स्टार्ट ऑफ सोसायटी. टू सेन्सिटाईज गव्हर्नमेंट अँड द कलिग्स इन व्हेरियस स्टार्टा टू ॲक्ट विथ मी इन सेंटर. मी म्हणजे डॉक्टर इन सेंटर. एजिटेशन्स इन व्हेरियस फॉर्मॅट्स. इन स्ट्रॉंग IMA लाईज सेल्फ रिस्पेक्ट अँड डिग्निटी ऑफ प्रोजेनी अँड मी. माझ्या मुलांचं भवितव्य. इन स्ट्रॉंग IMA लाईज सेल्फ रिस्पेक्ट अँड डिग्निटी ऑफ प्रोजेनी अँड मी. स्ट्रॉंगर IMA मीन्स नथिंग बट स्ट्रॉंगर मी. So join IMA mentally, physically, financially. Justify IMA from the bottom of the heart. Enjoy IMA because it supports our self-respect and livelihood. Thank you.
Thank you. Thank you so much, sir, for such a detailed, informative lecture with very beautiful, appropriate poem and shero shairi. Thank you so much. Any
check.
Thank you, Dr. Dhakre. Such a serious and sensitive topic. You made it very easy and light with your shero shairi. I feel all these modules should be incorporated in our medical curriculum. Our children, those who are becoming doctors, should be mentally strong. Like they are intelligent, we all know, but they should be mentally, physically strong to fight with the society. They should not practice like as we practice very sincerely and all. They should also practice, but they should be very strong. Tit for tat, म्हणजे जशास तसं त्यांनी उत्तर द्यायलाच पाहिजे. I appreciated your point very much. Thank you.
We senior doctors are parents, medical parents or educational parents of the medical students. So this is the job of parents to teach and to imbibe these things into our children.
So very thought-provoking lecture, and most of us, we talk about problems. Very few of us talk about solution. But actually creating a roadmap is next level. Salute, sir, salute. And I'm sure with strong IMA leadership and united members, we'll be able to fight our way back. Thank you, sir.
Dr. Dinesh Thakre sir is Apla Manus, IMA Maharashtra. Very informative lecture in a very shairana mizaz. The way you have quoted the shair, actually I just want to give a small token of reply from all of us here, sir. कि कहने को बहुत कुछ है, सिर्फ एक बात कहना चाहता हूँ. शायर जनाब दिनेश ठाकरे सर, कि आपका एक उसूल है, आप बताना चाहते हैं, लेकिन हम भी एक बात कहना चाहते हैं कि न कायर बनो, न कायर बनो अपने ही दयार में. बस एक अर्ज है कि अपने उसूलों के आप मायार बनो. मायार मीन्स इट इज बेसिकली पर्टिकुलर लेवल ऑफ रैंक एंड क्वालिटी एंड प्रोफिशिएंसी. The message what you have delivered at the end of the day, it was phenomenal, sir, and we are very much privileged to hear your every word and your every shair and andas. Thank you so much from all of us.
Thank you. At the end, just I want to mention that all the modules, each module is of minimum 30 minutes, and you can have a full day workshop regarding if you want to fight out at the branch level. So things are available. Now it is up to the branch to take, what not to take. Thank you very much.
Thank you so much, sir. I request Dr. Vikrant Desai, sir, and to felicitate
Hello.
I request Dr. Satish Joshi sir to felicitate all our chairpersons. Thank you, sir. Now we'll continue with the next session.
I would like to call upon Dr. Sunil Naruti and Dr. Digvijay Rao to conduct the next session.
I request Dr. M.K. Namdar sir. Actually, sir needs no introduction as a chairperson for upcoming session. Then Dr. Rajiv Rane sir, he also doesn't need introduction. He is senior pediatrician from AKLUJ. Then Dr. Sunita Karande madam, she is senior ophthalmologist from Pandharpur, practicing since 22 years. Dr. Nitin Ghorpade sir, he is vice president IMA Maharashtra. And Dr. Asha Jadhav madam, she is joint secretary IMA Maharashtra. I request Narone sir for next lecture.
Naurangi sir.
Hello. It's my great pleasure to introduce Dr. Naurangi sir. As Dr. Amal Shinde sir has mentioned, some of the person doesn't require introduction as such, and Dr. Naurangi is one of them. But to complete the formality, let me go through some of the salient features as far as his biodata is concerned. He is a pediatrician. He has achieved gold medal in MBBS, DCH and MD Pediatrics. He has completed his legal degree, actually LLB. He is past president of IMA Pune and IAP Pune, vice chairman of medical legal cell, and so many things are there to his credit. Along with all these, apart from these achievements, he is a good, he is a marathon competitor. He has donated 65 times blood and we had such an eminent facility today, eminent paternity today to talk on this subject. Dr. Lele, Dr. Naurangi, over to you.
Respected chairpersons, respected president, respected Dr. Lele, all my colleagues and Dr. Santosh Khadtare, Dr. Arankar is also here, my colleague Dr. Marathi is there, and it gives me indeed pleasure to address this august audience, and I am speaking at the occasion of this EVECON, and that is why I selected a different topic, which is entirely a different topic. That's a collection of different acts which are applicable to adolescents. And adolescents in particular, of course, I will give the stress on the POXO Act, which came in 2012, one of the latest acts which is affecting the medical practice, not only the gynecologists, not only the pediatrician, the surgeons, but also the family practitioners. And that I will take at the end. I know the time given to me is limited, so I won't waste much time on the initial introduction. But I have compiled several acts together which affect this age group. Now, what is meant by adolescent age group is pretty defined in girls. So somewhere pre-adolescent 9 years to till the time menarche, and menarche to adulthood. So that is a defined period for the girls. What about the boys? It's anything between 9 to 14 years and 14 to 16 years and 16 to 18. Pre-adolescent, adolescent, post-adolescent till they become adult. So whatever is below the age of 18 is covered by pediatricians. That is number one, because that is always a question. What age group you consider as pediatric age group? And number two, what are the various differences as far as law is concerned between the adult age group and the child age group? There are certain recent changes in the Juvenile Justice Act and how they apply in our practice. So all these I will be covering. In a nutshell, each is a separate topic, as our president was saying, just like that each of these topics at least require half an hour. But that is not the point. My aim is just to give an introduction so that you think on those lines, and then we can have detailed discussions afterwards. But majority the common things which I will take first, and POXO I will talk about the last, because many know something about it, though not the real things and what way we have to tackle the cases. We have tackled POXO cases also. So coming to the aspect of consent, this might be new to at least 50% of the audience. That consent is a topic covered by Indian Contract Act as well as Indian Penal Code. And Indian Penal Code consent is relevant over here. Sections 89, 82 to 89 and even extended to 91 covers the topic of consent. This is protective to the doctors, because ultimately when we are doing surgery, we are doing any procedure, giving injection or even touching the patient, these are all criminal acts if the topic of consent would not have been there. So consent is an exception to the general rules of Indian Penal Code. But here, as far as age is concerned, only those relevant points I will talk. That we know that who can give a consent? Any person who is of the age of majority, that is age of 18 and above, and of normal conscious mind. That is called sound mind. So these are the two prerequisites. Adult, more than 18 years, and conscious mind, sound mind. But here I am telling you something different. A child below 7 cannot consent. So that is taken for certain as per this Consent Act under Indian Penal Code. It is defined. Age of 7, below the age of 7, no need to take the consent. Age of 12, you must take the consent. Now this is different what I am saying. So this is 12 to 18 years age group when children require so many, or adolescents require so many surgeries on procedures like tonsillectomy, appendicectomy, hernia, hydroceles, and so accidents and so many things. You require to have additional consent. I am not saying they are the consenting party. You require the consent of the parents or consent of the adult caretaker. For example, in the case of hostel, it will be rector. In a case of an orphanage, it will be the director of the institute. But then you require the child's consent and an additional consenting party. So that's to be understood. Why? Because Indian Penal Code says that a child below the above the age of 12 does understand the implications of his actions or inactions. So he can be made liable. So that we'll see in a minute. So above the age of 12, please take additional consent. That is required. In writing, you should take a consent. Above the age of 12, child's or adolescent's consent is a must. But what about between 7 to 12 years? It is up to the judiciary whether he is understanding or not. So you may escape not taking a consent, but above 12 you will not escape. So this is a new point. Please make it routine to take the additional consent. Main consenting party will be the adult, parent or the caretaker, but additionally the consent of the child is required above the age of 12. 15 of the girl, even with consent, but it had taken consensual sex into consideration above the age of 15. So what IPC said, that below the age of 15, even with the wife, childhood marriages are there, even with the consent is a rape. Above the age of 15, if the consensual act is there, it is not rape. However, the things have changed after POXO Act, and any act of sexual intercourse below the age of 18, even with the wife, even with the consent and consensual mind, is to be now called a rape and reported to the police. So that's the difference. Now, which will prevail? Is it the Indian Penal Code or the POXO Act? The question is answered like this: whichever is a later dated law will prevail, that is number one, and whichever is a special law will prevail. That is why POXO prevails. And therefore, any sexual act below the age of 18, either with a boy or with a girl, so it is gender neutral. I will come to that in a minute later once again. That is now rape and therefore reportable. So please remember that POXO will supersede the provisions in Indian Penal Code. Now coming to MTP. MTP does not say that MTP below the age of 18, MTP, it only says that if MTP is done on a minor, that means below the age of 18. You know what age we see for MTPs and cesarean sections? 11 years is the youngest I have seen. 11 years. 11 years old girl has undergone a cesarean section for the primipara. And very unfortunate. But this happens. So MTP is allowed, but then you require the consent of the adult caretaker. Of course, above the age of 12, you require the consent of the girl child also. That apart. But what is the conflict of law is that MTP Act came in 1971. It has been thoroughly revised in 2010 and also in 2022 because the MTP weeks have gone up to 24 weeks. But POXO says that if the girl undergoes MTP below the age of 18, see she has undergone MTP below the age of 18, then it is reportable to the police. Because the very fact you have done MTP, that means she had sexual relations, either assault by force or without her mind, whatever, with consensus, without consensus, irrespective of that, it is a crime under POXO Act. Therefore, it needs to be reported to police. Now see the difference, another difference. MTP is for keeping the thing secret. You are not supposed to disclose to anybody except for two situations. One, on requirement from the judiciary or a written request from the investigating officer. So these are the two situations where MTP information can be given, otherwise no, not even to the relatives, not even to the family members. But POXO says it is mandatorily reportable to the police. So these two differences are there. So please remember again, POXO Act has come in 2012. It will supersede MTP Act as far as confidentiality aspect is concerned. One thing which I would insist, I mean, so many gynecologists must be there, or though people who are running the hospitals where MTPs are done, inevitable abortion, threatened abortion, not the threatened, sorry, inevitable abortion or incomplete abortions under life-threatening situations do not attract the provisions of MTP Act. So there is no reason that you should withhold that my center is not recognized with MTP Act, because for MTP you require three things to be recognized: the center, the doctor and the indication. All three are required. So here any hospital can undertake the completion of that abortion if it is inevitable or incomplete abortion. It's a life-saving situation. This has come to me just yesterday, and therefore I added this particular line that inevitable or incomplete abortion does not attract the provisions of MTP Act. There is no rule. Coming to PCP and DT, many times the girl children come to the sonologist or the family doctor that she knows that she is pregnant, she has missed the period. Many times with the advertisements they do the UTP also at home. Home people don't know about it, and I can say with sadness in my mind that more than 60% of the children in bigger cities are sexually exposed today. More than 60%. This statistics came in Nelson's textbook in 1969 edition. Sorry, 1975 edition. I was surprised, but this has come true in Indian shores also. So this is very unfortunate. But anyway, once the girl is pregnant, she wants to confirm it. The UTP is done, but she wants to confirm it with PCP, with the ultrasound. So she comes either to the family doctor or the gynecologist, or to the family doctor or to sonologist saying the pain in abdomen. They hide the history of missing period. And we have to be very cautious. in this particular case. It is my humble request and suggestion that these are some of the practical tips. Every female coming to the sonography clinic, assume her to be pregnant and ask for an F form, or at least make an attempt to ask the history of missed period. Pain in abdomen is a general, ज्याला आपण म्हणतो ना बहाना आहे. So general bahana hai. And then you find pregnancy and then you are not filled F form and people have got caught. In Pune we have got several such cases that it has been harshly applied in Pune city. So they got unnecessarily caught in this F form business and so many cases occurred. Always for PCPNDT, MTP, both these gynecologists and any center which is doing these things, I request that you must go ahead and do not treat the patient unless it's life threatening, unless the person produces Aadhaar card. Aadhaar card is your friend because that is an age proof, issued government identity proof with a photo ID, and therefore Aadhaar card must be attached to your case paper. That is number one. And number two, anybody coming to your clinic for pain in abdomen, please be that, bell must ring in your ears that it could be something sinister. You should not get, सरांनी मगाशी सांगितलं त्या पद्धतीने आपली मान अडकवून देऊ नका. त्याला मदत करा, अवश्य मदत करा, पण नॉट टू द एक्सटेंट दॅट यू गेट कॉट इन इट. एवढा तरी आपण काळजी बाळगली पाहिजे. Then Indian Contracts Act, just to mention that the contracts done with the child are void in ab initio, means they are not tenable legally, they are not legally enforceable. थोडक्यात म्हणजे कित्येक प्रॉपर्टीज असतात मायनरच्या नावाने असतात, त्यांचा हक्क असतो. You cannot enter into a final agreement. The child has full authority to revoke that particular agreement done. So be very careful about entering into contracts with the adolescents. So that's apart. About Motor Vehicle Act, child below the age of 18 should not be given vehicle because they don't have the driving license. But child between 16 to 18, there is a provision that they can be given two-wheelers, automated, without gear system, below 50 cc. And there is no vehicle below 50, all are 60. So actually the companies are breaking the law, but police also ignore those things. But 16 to 18, 50 cc vehicle without gears is allowed. But parents can be penalized. If parents are giving non-automated, that means gearless, geared vehicle, two-wheeler, four-wheeler, they can be taken to task. I have not seen any such case, but the provision is there. How long to preserve the papers? In adolescents, children, how long to preserve the papers? The documents, medical, sir said that these are documents are indeed your friends in case of medical legal crisis, but they can become worst enemies if you don't preserve them well, if you don't keep them secret, or if you don't have the papers at all. So how long to preserve the documents? Till the person reaches the age of 21. If the adolescent has come to you at the age of 9, somebody has come to you for MTP at the age of 14, preserve the papers. See, MTP access for 5 years. I am saying till she attains the age of 21. Because she has all the authority to demand the papers 3 years after attaining the majority. That is up to the age of 21. And last sentence is important. If the police have already registered the case, preserve forever. Preserve the papers forever. That means till you die, till the doctor dies. Case can come up anytime. Confidentiality and secrecy, this is governed, this is a very delicate issue. This is governed by ethical norms laid down by NMC. There is always a dilemma whether to disclose the health matters, delicate and intimate issues confided by the child to the parent. Many times the issue comes that the child has come of sufficient maturity, age of 14, 15, 16, 17, she is pregnant, she has come for MTP. MTP is a life-threatening surgery. I would say it should not be taken lightly. You are supposed to keep the grouping cross-matching done. You have to keep the patient indoor. We say that it should not be disclosed. It's a child. Please remember, it's a child. So the responsibility is on the parents, and therefore whether the parents should be informed, where the confidentiality goes. See, this happened in some of the cases where unfortunately the patient, the girl child, landed up in DIC with a O negative blood group. It becomes very difficult. So always in private setup, we are all talking about private. Government is different story. About private setup, never do it without informing the parents. and confirm their parentness by asking for their Aadhaar card also, because they can bring any adult saying that they are the parents. So be very careful about that. This is the issue in UK also. That's what I said, that this is a very delicate issue. त्याचं उत्तर त्यांनी गोलमालच दिलेलं आहे की ह्या कॉन्फिडेन्शियली सांगितलेल्या गोष्टी पेरेंट्सपर्यंत सांगायच्या की नाही. Whatever is confided with the doctor should it be told to the teacher or not. Change of sexuality is also one of the issues these days coming up. मी मुलगा आहे पण मला मुलगी म्हणून वाढायचं आहे. हे सगळे issues they sometimes they talk to the doctor, but whether it has been to be communicated directly to the parents, that's the point. Next act is the Juvenile Justice Act of 2000 and completely changed in 2016, and it is in tune with the constitutional articles that there should be separate treatment and separate criminal proceedings against the juvenile offenders. Now juvenile offender is an old term and now it is replaced by the child in conflict with law. थोडक्यात म्हणजे it's a old wine in the new bottle. Meaning तेच आहे. Instead of calling juvenile offender, now they should be called as child in conflict with law. There are certain important 4 or 5 principles. One is the presumption of innocence, dignity and worth. So the child should not be humiliated, confidentiality should be maintained, and it's a separate entity by itself, should not be just taken as a miniature adult. That is a miniature adult. Then there is a juvenile justice board in each district. Already it has been established irrespective of criminal procedure code for childhood cases. SJPU is established in all the districts. SJPU is nothing else but special juvenile police units. It's a separate than police units. They may not be available everywhere. No police lockup is allowed for children below the age of 18 or no regular jail. Bail is the rule, and in case of detention, that means in adults we call jail. In detention, it should be done in the observation homes and not the regular jails. However, after the Nirbhaya case, the rules have been changed, the laws have been changed, and that says that heinous offences done by a child, heinous means that is also defined, by a child above the age of 16 but below the age of 18, modified after Nirbhaya case. Heinous act is defined where the sentence is more than 7 years. 7 years. Case must be disposed of in 3 months by the Juvenile Justice Board, then followed by the regular courts, regular criminal courts. However, even if they are punished, they will be not put into the regular jails but in the reform homes. So actions will be taken, but they are to the lesser extent than what a regular criminal will face, adult criminal will face. Another thing which I would just highlight, that Maharashtra unfortunately is coming on the map of narcotics and offences about narcotics next to Punjab. So here is the age group, that adolescent, adult, they are before childhood, 7 years, 9 years, 10 years, 11, 15, 16, 18. So they are the children who are tempted, they are forced to taste these various narcotics so strong that in our medical school days, we were thinking that LSD is the strongest. Nowadays, I think I'm not an expert in that at all, but it's 10 to 100 times more potent than LSD. So these types of narcotics are there, and they are given by the adults initially free of charge, so that it makes a habit. These habits develop, narcotic dependence develops in 7 to 10 days, and therefore this has become a big criminal racket in Maharashtra. So over here, they use the children as vehicle. They use the children to transport these banned substances, so that once they are caught, the punishment is much less. But to give the such children and act them, make them do these things itself is a very big act of crime, and they are now given a punishment of 7 years plus in the jail. So it's a heinous act. Mental Health Act is a separate act, and I won't go in any of this because it affects mental conditions, and psychiatric acts are very much the things in the offering for children age group and adolescent age group. And this is my last topic, so we'll be just elaborating in 5 minutes next, POCSO Act. And it's extremely important to know the basic principle of section 19, 20, 21. Now, what is this POCSO Act? It's specially carved out criminal act, and it's a special acts which override the customary acts, which I already mentioned. All sexual offences are grouped together. for both male and female, so gender neutral. What is meant by POXO? Prevention of child sexual abuse. Sexual assaults, so they are defined now. Sexual assaults, harassment, pornography, social media, all are covered. Repeat offenders get harsher punishment. Presumption of innocence is there because it's a child age group. Clinical presentations and manifestations differ a lot, and offences are all cognizable, non-bailable and non-compoundable. Non-compoundable means no compromise. Many times we feel non-compoundable म्हणजे काय तर तिथे कॉम्प्रोमाइज अलाउड नाही आहे, दोन्ही पार्टीजनी मिळून तसं होणार नाही. इट हॅज टू गो थ्रू ज्युडिशरी. नाउ व्हाय दिस पर्टिक्युलर ॲक्ट हॅज कम? दिस हॅज कम with a absolute need that almost 53% of this is a statistics in 2009, that 53% of Indian children directly or indirectly have undergone child sexual offense, assault, etc. of minor variable degree, and usually it is done by the family members, kaka, mama, bhacha, putanya, and the friends, somebody who is in trust of that child, and that is why it goes unreported. And number 2 point is that any such sexual trauma to the child's psychology leaves a long-lasting effect on the child forever. Long-lasting effect on the child forever. It's a very traumatic situation. They can't express, and they are victims, and that is why this law has come in a very harsh way. So every child is vulnerable to abuse, be it physical, verbal, emotional, sexual. More than 53% of the children report facing one or more forms of sexual abuse, and so on and so forth. Now they have defined, and WHO expanded the definition of sexual violence. Instead of just rape, assault, they call it now sexual violence. Any sexual act or attempts to obtain a sexual act using coercion. Coercion is force, threats of harm or physical force, also unwanted sexual comments, advances, acts of traffic or otherwise from and or directed against a person's sexuality regardless of relationship to the victim. So this is all now included in sexual violence. So much wider connotation than rape alone. And suspect, we have to suspect, this is important slide, we have to suspect whether this child has been subjected to this violent act, sexual violence. The child is not going to tell directly. Neither she or he would have understood what is happening to him. Sudden emergence of sex-related problems like excessive or public masturbation done by an adolescent, age-inappropriate promiscuity, seductive behavior, failure to thrive, खाण्यामध्ये लक्ष नाही, किंवा overeating, withdrawn, excessive daydreaming, superficial relationship, घरामध्ये आई वडिलांमध्ये सुद्धा त्यांना डीपली इंटरेस्ट वाटेनासा होतो, पुअर रिलेशनशिप विथ द पियर्स, लॅक ऑफ सोशल स्माइल, बेड बेटिंग, थम सकिंग. सी बेड बेटिंग इज ओके अप टू 2-3 years, but if it occurs afterwards, these are some of the problems. Enuresis, recurrent urinary infections, substance abuse, completely withdrawn or aggressive behavior, suicidal attempts or even ideation. These are some of the things which don't appear directly as sexual abuse, but we have to suspect them that this could be one of the things. Why I'm saying why it is important that we suspect it, it will come to you in a minute. So I already told you more than 95% of the sex offenders are relatives, neighbors, friends. Hence a majority of the cases go unreported. Amongst these are reported 90% are not believed because they are the known people. And one of the reasons of lack of reporting is lack of evidence is doctors do not document it correctly, or they do not collect the evidence correctly, continue to use the two-finger test which is banned now, and the private medical sector does not want to get into the lafda of police cases and all this. So these are the cases, and that's why it is made mandatorily reportable when you suspect. Now I'll just explain one, and rest are practically the similar ones. Penetrative sexual assault, in short, intercourse and an attempt to intercourse, and if it occurs, then section 4 defines what is the punishment for that is 7 years. Whereas what is meant by aggravated, if it is done repeatedly and a person in trust, it is called as aggravated, and the punishment is 10 years. So same way it is there for assault, aggravated sexual harassment, that is also punishable, and so on and so forth. Now here comes the important section for doctors, is that forget about this technical jargon. Just as medical people are used to use difficult language, lawyers are also doing the same. Notwithstanding anything means in spite of. In spite of anything in the criminal procedure code, any person, including a child, who has apprehension that offence is likely or has knowledge that the act is already done or attempted or abetted, see, any person, that includes doctor, he shall provide such information to Special Juvenile Police Unit, SJPU, आपण मगाशी बघितलं, or if they are not appointed, local police. Protective, medical and rehab steps are to be taken, including information to the Child Welfare Committee within 24 hours. No such information will incur civil or criminal liability. Inform the police on phone. This is how to inform the police. That's the question. Many times this is a practical question. This we also faced initially when it came. जेव्हा आम्ही सांगितलं की तुम्ही पोलिसांना कळवून टाका, बिचारा गायनोलॉजिस्टना इतका हॅरेसमेंट झाली, तुम्ही या पोलीस ठाण्यावरती, त्यांना काही ॲक्ट माहिती नाही, मग तुम्ही हेच कसं ठेवलं नाही, प्रॉडक्ट्स कसं ठेवलं, प्रिझर्व त्यांनी दिले सलाईममध्ये प्रिझर्व करा, तुम्ही फॉर्मॅलिनमध्ये कसं फॉर्मॅलिनमध्ये ठेवलं आहे, साध्या पाण्यात का नाही आणलं, म्हणजे ॲक्च्युली दे आर सपोज टू कम टू युअर प्लेस अँड सील ऑल द एव्हिडन्स. यू आर नॉट सपोज टू ट्रान्सपोर्ट इट फ्रॉम युअर प्लेस. इतक्या गोष्टी आहेत. तेव्हा थोडक्यात मी सांगतो, जस्ट इन्फॉर्म ऑन telephone to number 100. 100 is a universal number for police all across India and every call is recorded. That is number one. Also inform by email, this is a practical way out, to the Commissioner of Police of that district so that you have a proof and your work ends. आपण जर पोलिसला मस्त म्हटलं की तुम्ही लिहून घेतलं का, मग तो नंबर तुमचा बकल नंबर तर हल्ली देत नाहीत. लेडी पोलीस ऑफिसर्स तर देतच नाहीत नाव. हा पुढची डिफिकल्टी आहे. म्हणून 100 नंबरला करा, मग लोकल पोलीस स्टेशनला करा आणि CP, दॅट इज कमिशनर ऑफ पोलीस ऑफ एव्हरी डिस्ट्रिक्ट, सेम युनिफॉर्म ईमेल ID, cp.pune@gov.in etc. अशा तऱ्हेचे तो ईमेल ID आहे. तुम्हाला ईमेलने 4 ओळी लिहून पाठवायला पाहिजे. दॅट इज द इन्फॉर्मेशन. यू आर नॉट सपोज टू सेंड अ पेशंट, यू आर नॉट सपोज टू, दे आर सपोज टू कम टू यू. ओके. नाव ऑब्लिगेशन ऑफ द मीडिया, स्टुडिओ, फोटोग्राफिक, त्यांना पण त्यांनी कळवणं महत्त्वाचं आहे. फॉल्स कंप्लेंट करणं पण शक्य आहे, त्यामुळे त्याच्याविरुद्ध देर इज अ सेक्शन अगेन्स्ट दॅट. बट देन इफ अ चाइल्ड मेक्स अ मिस्चिवस फॉल्स कंप्लेंट, चाइल्ड मीन्स चाइल्ड बिलो द एज ऑफ 18, देर इज नो पनिशमेंट फॉर देम. दिस इज इम्पॉर्टंट अँड दिस इज माय लास्ट पॉईंट सर. दॅट सेक्शन 41, that the provisions of section 3 to 13, म्हणजे आपण जे सगळं ऐकलं, shall not apply in case of medical examination or medical treatment of a child when such medical examination or medical treatment is undertaken with the consent of his parents or guardian. So inspection, palpation, per vaginal examination, per speculum examination, per rectal examination are not prohibited by this act. This is expressly cleared and even without written consent. So that is a part and parcel of a clinical exam. हा एक डाऊट निर्माण झाला होता की whether we can go ahead with this type of testing for a child below the age of 18, 16, 17, etc. That is, it is not forbidden at all. It is taken as an implied consent and nobody will question and catch you. So with this I end my talk. It can go on, but this provision should be known to all the doctors, family doctors, the sexual medicine people, the gynecologists, the people who run the institutes and hospitals, and any doctor for that matter. All officers should be knowing about the POCSO Act and what are the important provisions of various acts as relevant to this age group. Thank you very much once again, sir, and thanks for the patient listening. And I hope that some take-home messages I could give and deliver. I have compiled this because this topic was given to me by Talegaon Medical College, and initially I was wonderstruck that what am I going to speak about this. But then once you sit down and think about what could be the various implications of various laws as applicable to this age group, I thought this is a very good topic and all encompassive, discussing about many laws in this perspective. Thank you very much.
Thank you, sir, for your excellent talk on this most important topic. I request chairperson to have a comment.
Very excellent talk with such situation. But I want to ask one question. Whether if such situation comes in private practice, can we refer this patient to government hospital, or it is mandatory to tackle that situation?
No, madam, this is a very good question, and I will give you two examples of this. First and foremost, any such situation, because a girl can be having a lot of bleeding also at that time. So over there, inform the police on telephone, as at what I said, give the first aid and send them to the government hospital. But sending alone is not adequate, because she may not go there.
Yes.
So it is better that you go along with them to the government setup, because to collect the evidence is very difficult, as what is described in this textbook, in this law. So I would say that unless you are trained for that, don't think of taking the proper evidence and swabs and all those things. It is better to send it to a government hospital. Send means accompany and send, because here is a time where the child may not be reaching the government hospital. They will go here and there and there. So it is our duty to inform police and shift in your vehicle along with the parents to, or along with the whoever has come to the government institute, and hand them over.
And if at all the situation, legal situations comes afterwards, म्हणजे आपल्याला लिगलसाठी बोलवलं जातं का पहिल्यांदा अटेंड करणाऱ्या डॉक्टरला?
हो, बोलवलं जातं.
Yes. Thank you, sir.
Yeah, as an expert, and you have witnessed this firsthand, so you are called for it. I think, sir, the first case of POXO in Maharashtra came from Arankar sir's place, Indapur, and I faced this hurdle to save the pediatrician. He was kept up in the police custody for 7 days without any fault, then in the judicial custody for 7 days, and the judge was just not listening, and we had to send a lawyer from Pune, accompany over there. Even Supriya Sule could not do anything. So ultimately it was a senior lawyer, Mr. Vasant Nimbalkar, who could go over there, convince the magistrate, and then make him release. So he was under custody for 14 days. 2012 December, law is passed. This happened in last week of 2012. Unfortunate. And the case went on till 2020. And now he is acquitted. So very difficult law. Please be very careful about it.
So can we deny such patient?
Can we
If comes
deny?
in private sector, and if at all we suspect that
So,
this is of this
madam,
sort.
you cannot deny. You have to inform the police and arrange for further treatment in a government setup. But if the child is bleeding like anything, or in shock, or in such critical condition, you have to treat first. Then inform the police, then shift her.
This is a span in 2 months that I have opportunity to listen lecture of Naurange sir. Sir was there for
Thank
the
you.
installation of Sangli branch,
yeah.
where they have given a talk on a medico-legal cell. That was excellent too. I remember the quote of Abraham Lincoln: "The best teacher is that who make difficult topics simple for the students." So it is a very difficult topic at odd time, but you made so simple. Even a person like orthopedic surgeon can understand all the consent. And this one good thing find about this is that pain in abdomen, you have to take more precaution, and I don't have to deal with it. And you have just seen the biodata of sir, but you are not mentioned few points that I want to highlight. Sir is working in at Pune, and especially at the charity commissioner for 30 years, and he helped really. He was there in the court for almost all hearings, and he is the person who are pioneer to pass all the amendments for the IMA. So let's have a big hand for the legendary IMA personality. And secondly, sir shown all the juniors how to work, because I came to know at Pune there are 4 Xerox machines at the Pune setup, and sir has to take a Xerox for his personal hospital. Sir went outside, given 10 rupees and taken 10 Xerox, not misuse the Xerox machine of the IMA for his personal things. That's the symbol how to work a person for the association. So you are always highlight, your topic is always good, but your qualities and your devotion, as Thakre sir said, that stronger IMA, stronger me. That is the concept, and that is the thing you taught all the juniors. Thank you, sir, for your lecture.
Thank you, sir. I request Dr. M.K. Namdar, sir, to felicitate Naurange, sir. I request all to join. Next topic, social security scheme. Sir. I request our speaker, Dr. Prakash Marathi.
And honor and privilege to introduce one of the legendary from the Maharashtra State IMA. Nothing but Dr. Prakash Marathi, sir. Sir is a past president of Indian Medical Association, Pune. Sir also a well-known ophthalmologist and he is a member of Maharashtra Ophthalmological Society, Pune Ophthalmological Society, past senior vice president of IMA Maharashtra State, honorary secretary Social Security Scheme, IMA Maharashtra State, central working committee member, IMA headquarters New Delhi, trustee IMA Pune and POS, member legal affairs, expert group of committee AIOS, President's Appreciation Award by National IMA Headquarters, New Delhi, President's Appreciation Award by IMA Maharashtra State for the year 2013, 2014, 2018, 2020, 2021, and I still remember in one forum Lata Mangeshkar said that don't nominate me for the awards because if I am nominated, nobody other is going to get it. So in 2021, I think Sir requested the IMA committee not to nominate me for this award. President's Special Felicitation Award by IMA Maharashtra State for the year 2021. POS led Dr. Asha Kelkar Award 2022 by Pune Ophthalmological Society, past managing committee member, All India Ophthalmological Society, chairman, Maharashtra chapter of ISMS ICS. So rather than wasting time, I request Marathi sir to start his topic.
Thank you, Dr. Gorpade, for wonderful biodata. I think you all spoke much more about me, not deserving that much. Respected President of IMA Maharashtra, Dr. Dinesh Thakre, Dr. Jayesh Lele, who is the Senior Vice President of IMA Headquarters, my mentor, Dr. Jayant Naurange, past President, Dr. Ram Arankar, then organizer of this particular conference, and team of IMA AKLUJ, team of organizing committee of EVECON, everyone who is sitting there in the hall, thank you so much for giving me this opportunity to speak on difficult and separate subject related to each one, junior as well as senior doctor, who is related to IMA, and that is Social Security Scheme. Recently, Social Security Scheme, there are so many rules and regulations which are changed. So it is the new Social Security Scheme. And there is question in each and everybody's mind that what is Social Security new scheme? Our mentor, Dr. Ram Arankar is here, who has worked a lot in the past for promoting Social Security Scheme everywhere in the state of Maharashtra. And recently, our past chairman, Dr. Jayant Naurange, who is the pillar of Social Security Scheme, pillar of IMA Maharashtra, he has guided for Social Security Scheme. And you must have noticed that not only these office bearers, our recently nominated chairman is Dr. Raj Gopal Kalani from Parbhani. He is working wonderfully and increasing the membership of Social Security. I am fortunate to work for Social Security Secretary for last 5 years. Dr. Suhas Nene is treasurer, Dr. Amrish Shadi joint secretary. Not only the office bearers, but there is a managing committee of Social Security Scheme across Maharashtra state. There are various volunteers working at Pune, and everyone is contributing a lot as zonal member in each and every branch of IMA Maharashtra state. And this particular question must be there in your mind. What is Social Security Scheme? That is the first question. And second question is, what is new Social Security Scheme? Well, coming to this particular place, Panchgani, Dr. Naurange sir said, most of the people they ask, we do not know about Social Security Scheme. But this is the wrong question. Because whenever someone dies in the branch, the call comes to us. Doctor, zara baga amcha member hota ka social security scheme. So people know how to inquire whether the dead person was member or not. But people say that they do not know about social security scheme. I think this is a little bit controversial. So promote a social security scheme in your branch everywhere. And why you have to do so, it will be covered in next 15 to 20 minutes by me. Basically, the scheme started at Pune. That time, IMA Maharashtra State Office was there at Pune in 1990. And till 2005, it was at IMA Pune. After that, IMA Maharashtra State Office got shifted to Mumbai. And from 2005 to 2019, it was at Mumbai. But after 2019, it was advised, and again it was shifted to Pune. And after 2019, till today, it's at Pune premises. And one more thing to be added, since 2019, but in 2024, we have redesigned this particular scheme. And the name of the social security scheme is Sanjeevani. So new Sanjeevani is given to the scheme, and hence this app name has been given. What are the objectives? First important thing, most of the doctors, they are in good financial position. They do not need any support nowadays. That's what they feel. But what are the objectives? Provide immediate financial help to the family of deceased member to cope up the financial crisis in the immediate period after death of the member. Imagine the working doctor on one fine day probably is not there. His family doesn't know where the bank accounts are, where the financial funds are. And that is the real time when this money is needed. And second important thing is we are there, we have gathered here for the conference. So increase brotherhood amongst the Indian Medical Association Maharashtra State Life members. So brotherhood has to be increased. Our President Dr. Thakare sir has also said that we must come under one roof. We must work hard for our unity. Now membership strength increases year by year. You must have seen. In 1990, it was just 336. And now it is 8,675 is the enrollment number. We are happy, but not that happy. So 8,675 is a good figure, but not that good figure. Because we are aiming at least 10,000. And you are the real people who you are supposed to work for this. This particular slide is very important. You sow nominee reaps. You must remember in these days of mango, you are eating mango. Who has sowed that? Your forefathers. And if you sow mango tree today, probably your grandchildren will eat. So that's the thing you have to remember. Most of the doctors, they ask, Doctor, आम्ही पैसे दिले कधी मला मिळतील? अरे बाबा हे तुझ्यासाठी नाहीच आहेत. तुझ्या नॉमिनीसाठी आहेत. So that's what you have to remember. This money is given. स्वार्थ आणि परमार्थ दोन्ही साधला जाणार आहे. So you are contributing for yourself. That way it is given to your nominee and your family. Means you are doing something for your colleagues and their families. So that is paramartha. Swarth means whatever you have invested, you are going to get it. So what is the basic aim? It is a financial assistance to bereaved family of member doctor to overcome the crisis period. The difference, people ask us, Doctor, LIC is better, mutual funds are fantastic, shares are very good, FTs are that nice, then why you are not giving us that much amount? See, it is not to be compared with these things. So no difference between LIC and other insurance schemes because our scheme is comparatively small, there is variable premium, almost zero operating cost, and disbursement only on death. This is very important. Don't ask when you are alive. To disbursement only on death. And fourth point is no premium liability after 25 installments. Once you pay 25 installments, there is no liability. And you get the benefit amount, not you, but your nominee. So no medical examination. This is very important. In the past, it was no medical examination for every admission. But nowadays, except 55 and 60 years. We have seen the people, age is 59 years, 11 months and 360 days. Sorry, 11 months and 25 days. And they apply. They are just reaching 60. This is not correct. People getting comorbidity like cancer, heart problem, and then they apply. This is not good. So we have done compulsory medical examination in the age group of 55 to 60. That is for benefit of the scheme. So we have to take care of our scheme also. So promptest of payment, we just deliver that payment within couple of days, within 24 hours most of the times if the documents are complete. So usually 1 to 2 weeks if the documents are not complete and with the list of the formalities. What are the benefits of the scheme? So benefit starts after 1 year. Just remember, suppose today you are becoming the member. This year you are not going to pay your paternity fund contribution. That is called as FFC. So 1 year is the rest period. So you are not going to get benefit also, except one condition. That is very important. And what is that except? It is the accidental death. So if there is the accidental death, in that 1 year also, one can get the benefit. So benefit starts after 1 year of membership, except in case of accidental death, where benefit is extended even before completing 1 year. So about tax benefits. No tax to beneficiary and tax exemption on premiums. So contribute for 25 years. This years is again misnomer. You have to contribute for 25 FFCs, paternity fund contribution. Because the year you are admitted, it is not to be counted. Next 1 year is the rest year. So your first installment starts after that. So you have to calculate 25 FFCs. So as the membership number grows, the scheme becomes more and more stronger. Highlights. IMA Maharashtra, this social security scheme was established in 1990. That time there was a think tank at Pune. Founder chairman was Dr. Y.G. Kelkar. After that, people like Dr. Ram Arankar, Dr. Jayan Navrange, Dr. Shyam Damble, they took that scheme forward. And effective membership, as I told you, it is 8,675. This important figure, 591, they have died so far. And we have helped families of these 591 people whose families were benefited. So this figure is going to get increased day by day. Membership should also increase. So what is our goal? Our goal is to reach 10,000. So minimum 500 members should be there every year. And who is going to do this? Not Dr. Navrange sir, not only Dr. Arankar sir, not only myself. All of us have to contribute a lot. So what amount we are going to give to the nominee and family? So it is death claim benefit of rupees 10 lakhs with due deduction. What we do of the payment what you give to us, that is FFC, all the corpus fund is invested in nationalized banks, mutual funds and other safe securities permitted by charity commissioner as well as by income tax. So we are taking care of all your amount which is very well invested. How does the scheme work? What is the eligibility? So life member of IMA, you have to be doctor, minimum MBBS, not enough. You have to be life member of IMA up to the age of 60 years. So most of the people, they say, doctor, you just do it for more than 60. No, it can't be done. So catch the youngsters. So who is your daughter, your son-in-law, your daughter-in-law, your relative? So those young doctors are to be advocated for this. So don't wait. What are the requirements apart from proof of life membership of IMA? Duly completed application form, age proof, online or check or DD of appropriate amount. Even online facility is there nowadays. Name and signature of nominee. This is very important. Photograph, passport size photograph of member and his nominee. Aadhaar and PAN card of both. And this important thing is no medical examination is required before 55 years of age, but required afterwards up to the age of 60. That's what I have said. Now what you do, you are contributing rupees 200 for each death. So out of that FFC of 200 per death, rupees 140 is paid to the nominee and rupees 60 goes to the corpus. Interest of that corpus takes care of FFC payment after 25 years. When you don't pay after 25 years, on your behalf, scheme pays. So after 25 years, scheme has to pay. From where that money will come from? It is from this corpus interest. So scheme is automatically taking care of your payment after 25 years of your installment to the nominee of the death of member of this person who is there in the scheme. This table is very, very important. Just few highlights of this particular table. Admission payment. What I have told you, catch the youngsters, catch the young. Because if you see, the paternity fund contribution is 12,000, which is unique. It is with us. Again, admission fee, if you see 1,000, 2,000, 3,000, 3,000. So up to the age of, say, 50, it's fine. But this is the real group of 50 to 55 and 55 to 60. What we have done, we have increased a little bit. This is 10,000 and this is 20,000. Why? Because this is the group which gets benefit maximum after their death. Consider the person who is getting admitted around the age of 60. So he has to pay up to the age of 25. There is a chance that he may be dead before that particular period. So late admission, we have increased that admission fee. So rest is same for all. 500 is, that is fee for 2 years, 2 annual subscriptions, 250 multiplied by 2 for each and every one. Then GST has to be paid. And this is a grand total. So if anyone has to become the member, youngster has to pay just 13,770. And that way, when the age increases, this is the maximum amount, 59 years of age, 36,190. So this table is there. I have got the forms with me. 50 forms are there with me. I am going to give these forms to the organizers. Just take those forms with you, and you can convey that message to youngsters, juniors, as well as seniors. So this chart is also given in that particular application form. What is the highlight? Now this is the question, including Dr. Ram Arankar. Everyone is curious about what is the new social security scheme? What is the real Sanjeevani? So these are the highlights. Rather, there are so many complicated things you are not going to understand. But just I have highlighted few things. New enrollment for membership, less charges for youngsters. Just remember, less charges for youngsters. Less FFC for youngsters. So youngsters, they have to pay just 6,000. You are going to pay 14,000. More than 45 years of age, 14,000. Youngsters is going to pay 6,000 only. So fixed throughout the tenure. This is very important. That amount of that age is freezed for 25 installments. It is not going to increase. One more thing. You may ask me the question, Doctor, why only 10 lakhs? I want more. I want 20 lakhs. I want 30 lakhs. Yes, that facility is there. So members can opt for multiple units, 1, 2, 3. So one membership, additional 1, 20 lakhs. Additional 2, 30 lakhs. Additional 3, 40 lakhs he can get. So the youngster who is just 35 years of age has to pay 6,000 as FFC, can think of purchasing 3 or 4 units, and in turn his nominee will get 30 to 40 lakhs. So this is the way 10 lakhs can be increased, and youngster will get benefited of paying less amount of FFC. So members can opt for multiple units, 1, 2, 3. This member has to pay complete admission charges for each unit. It will be the separate admission fee considered for each and every unit. Fourth point is fixed FFC for existing members more than 45 years of age, including me. Every one of us more than 45 years of age. The FFC for us is 11,800 plus rupees 250, that is the annual subscription, and 18% GST. So it comes around 14,000 plus. And it is fixed forever. Next point is fixed death benefit of rupees 10 lakh with due deductions. Now here the question comes, Doctor, we want little more. Why only 10 lakhs? What is the answer? Purchase multiple units. If your age is less than 60, still you can purchase new particular policy, 1 more unit. But you will have to start, suppose your first policy has completed 10 FFCs, and today you are taking admission. For that unit, your first FFC will start from that. So first unit particular will be finishing 25 installments as early as possible, and this particular next unit will take a little more longer. Then concession and advance payment of FFCs. What we have done? Pay 2 or 3 FFCs in advance. So 3 FFCs are paid in advance. Few people have taken this advantage. That is discount given on that particular amount. Then deposit of GST reserve to help payment of GST every year. Even for that we have given concession. Exit option at appropriate senior-most age. This is very important. This is little remote. The person who attains the age of 75 to 80, and if that seniority is there, he will be given in his lifetime, when he is living, rupees 10 lakhs with due deductions. Like after death, nominee will get. But here there is a chance of exit policy if you are of the age of say 75 to 80, and if you are there in that seniority list. All existing members, now this is a different category, we are more than 45. All existing members below 45 are joining the new scheme by default. They are not given the chance of remaining in the old scheme. More than 45, they were given the chance to remain in the old scheme. But less than 45 automatically go into the new scheme. Their FFC will be as per their age slab. That next particular table will be shown after that. Now those existing members who want to continue, old scheme members. Now few of them are there, 20 to 30. They were given the chance up to 15th of March. They said, no. Doctor, आम्हाला नको पाहिजे संजीवनी वगैरे, आम्हाला जुनच पाहिजे. they are paying as per number of deaths calculation. So 3 important things. Every year FFC will be calculated according to the number of deaths. Their FFC may decrease, their FFC may increase. And there is quite chance that they have to pay more FFC because number of deaths are going to increase year by year. Exit option at appropriate senior most age, there it was 10 lakhs and here it is 6 lakhs with due deductions. So exit of policy is also there available and it is for 6 lakhs amount. Then fixed death benefit, rupees 10 lakhs with due deductions. It is same, 10 lakhs for old, 10 lakhs for new. It is same one. Now there is one more category who have already paid 25 installments. Dr. Ram Arankar, Dr. Jayan Navrange, all these people have already paid 25 installments. They are just silent members. There are few members, their age is 92 years, 90 years, they are very old. For them, there is one policy we have designed. And what is that? Retired senior most members, exit option for retired members, and we have selected 20 super seniors. They are 20 super seniors this year. They are given rupees 5 lakhs with due deduction, not 10 lakhs, only 5 lakhs. But still people are taking it. So we have given that 5 lakhs in their living lifetime. And afterwards, they will not be connected to social security scheme. Fixed death benefit, rupees 10 lakhs with due deductions is also available for them. If they are not taking that particular 20 senior most people, when we identified, if they are not choosing, they are also going to get 10 lakhs. If they are not opting for that, their nominee will get 10 lakhs. Now this fee structure is very important. Consider the doctor who is IMA member whose age is less than 30. The youngster in your family has just to pay 6,000, only 6,000. So this is very attractive. People are not going to tell you because you are going to pay 14,000 and he has to pay only 6,000. He can purchase many more units. So this is a real advantage of the Sanjeevani scheme. So youngsters, what the questions youngsters had in their mind, why we should pay for the old generation? Why we should pay for old people? Now the answer is, youngster has to pay less and seniors have to pay little more because seniors may get benefited. So this is the answer by the way of Sanjeevani scheme. So just see, age groups are there, paternity fund contribution is increased as per age increases, and this is the real advantage which youngsters can take. That does not mean that people less than 60 are to be registered. They also can become the members. So in short, again this is the very important slide. For age less than 45 years, points 1 to 5, what I have told just now, will be applicable as FFC. For age more than 45 years, points 6 to 7 will be applicable as FFC for new Sanjeevani joining members. And for age more than 45 years, most of us are sitting here, 45 years old members, opting for new Sanjeevani SSS, the fixed FFC will be rupees 11,800 plus 250 plus 18% GST, so which comes 14,219, which most of us have paid. So out of 6,000 members, around 3,000 members have paid within 1 month and 1 week. So if you have not paid, pay as early as possible via payment gateway on our website. This is the thing about the discount I wanted to tell you. You want to pay 1 extra installment, 5% discount. 2 extra installments, 8% discount. And people have opted for this. 3 extra installments, 10% discount. So this is the discount given for advanced FFCs. So these things were about new social security scheme. So I think there were so many questions in your mind, and I think I have tried to elaborate important highlights of that new Sanjeevani. Again, schedule of FFC payments. Every year, just remember in the month of April, the notice comes. Even if the notice doesn't come, inquire. If your light bill doesn't come, if your telephone bill doesn't come, you inquire yourself. The way you have to inquire in the month of April, try to pay. Then the email may come, or post or SMS may come, and that intimation you have to follow. Latest by first 2 months, April and May, routine amount is to be paid. That is 14,219 without any late fee. Then there is a slab of 2 months, June and July. There is late fee of 100 and GST. That is 118 rupees to be added. That comes 14,337. And last 2 months, August and September, late fee of 354. I always tell to our members, out of 12 months of year, you have got the chance to pay FFC of 6 months. This is a very big period. Still people do not pay. Still they become defaulter. And still they ask us, ki doctor वेळ नाही मिळाला, आम्हाला का नाही सांगितलं. So just inquire everywhere in the month of April. You have got a chance to pay FFC for 6 months of particular year. Still you are lazy. Still you are not paid. Chance still is not gone. National Social Security Scheme, you have not paid, chance is gone. But we are little liberal, Maharashtra Social Security Scheme. No payment on 1st October, what happens? Automatic deletion. Stopped, everything is end of life? No. You can restart till next 2 years. You have got 2 years in your hand. These 2 years, by refilling the form, extra payment, maintaining the seniority. What happens? Suppose you are 55 years of age. अहो डॉक्टर आता आमचं घरा ना काहीतरी तर काहीतरी काय करा जुनी सगळी थकवलेली FFC भरा आणि 95व्या वर्षी जर तुम्ही नवीन ॲडमिशन घेतली असती जे मी टेबल दाखवलं तेवढे पैसे परत भरा आम्ही घेतो तुम्हाला फार होता तो मग नका घेऊ म्हणजे पैसे बुडाले तुमचे मग हे जे एवढे पैसे वाटतात त्याच्या बदल्यात तुम्हाला फार पैसे मिळतात म्हणून लोक तरी तो चान्स घेतात 2 वर्ष ती स्कीममध्ये जिवंत राहण्यासाठी तुम्हाला मिळतात आणि एक फायदा होतो सिनियरिटी इज मेंटेड समजा तुमचे आधीचे 8 हप्ते भरलेले असतील तर हा 9वा हप्ता धरला जातो ते 8 हप्ते बुडत नाहीत लक्षात आलं सो मेंटेनिंग सिनियरिटी दिस इज नोन ॲज रिवायवेबल डिफॉल्टर याला काय शब्द वापरला आपण डिफॉल्टरला रिवायवेबल डिफॉल्टर आणि एकदा का त्याने काहीच नाही भरले 2 वर्ष पण आम्हाला त्यांनी आमचे एक नंदकुमार शाह म्हणून सिनियर डॉक्टर होते फालतू स्कीम आहे म्हणलं तुमची कोविडमध्ये आमचे हळवे डॉक्टर त्यांच्या मागे लागले यांच्या नादी लागून मी हप्ता भरला म्हणले फालतू स्कीम आहे आणि त्याच्यानंतरच्या पुढच्या वर्षी रिवायवेबल डिफॉल्टर होऊ शकत होते मेले कोविडमध्ये आणि त्यांच्या फॅमिली आमच्याकडे आल्या अशी 2-3 उदाहरणं आहेत स्कीमला शिवाय देऊन आणि नंतर दुर्दैवाने मेले त्यांना एक पैसा पण नाही मिळाला म्हणून चान्स घेऊ नका आणि त्याच्यामध्ये राहा आणि नवीन लोकांना मेंबर्स करा सो डोंट बिकम परमनंट ऑर टोटल डिफॉल्टर अपार्ट फ्रॉम द फर्स्ट लाईन नन अदर शुड ऑकर फ्रॉम 2020 मे व्हॉट वी हॅव डन वी आर ॲक्सेप्टिंग द पेमेंट घर बसल्या विदिन सेकंड्स यू गेट द रिसिप्ट पेमेंट गेटवे ऑनलाईन जर का तुम्ही वेबसाईटवर भरलं तर पुढच्या मिनिटाला ईमेलने तुम्हाला रिसिप्ट येते कुठल्याही प्रकारचा त्रास लागत नाही सो थोडक्यात IMA महाराष्ट्र मेंबर्स दिनेश ठाकरेंच्या प्रेसिडेंटशिपमध्ये किती आहेत 50,000 आमचे मेंबर्स किती आहेत 8,625 ऑफकोर्स देर इज अ लिमिट लेस दॅन 60 इयर्स ऑफ एज 10,000 करूया ना काय हरकत आहे 8,500चे 10,000 करायला काहीच हरकत नाही सो हिअर वी वॉन्ट हेल्प फ्रॉम ईच अँड एव्हरी वन नॅशनलचे जवळजवळ 4 लाख म्हणतो आपण त्यांचे जवळजवळ 17-18 हजारच आहेत आणि दोन्ही मिळून तुम्हाला नॅशनलचे आणि स्टेटचे मिळून आपले 10 लाख त्यांचे 10-11 लाख 20 लाखाच्या पेक्षा जास्ती तो अमाऊंट तुम्हाला मिळू शकतो आणि मगाशी मी म्हणाल्याप्रमाणे जर युनिट जास्ती घेतले तर 30-40 लाखसुद्धा मिळू शकतात आय थिंक आणि परत असं म्हणू नका की याच्यापेक्षा जास्ती म्युच्युअल फंडमध्ये मिळतात शेअर्समध्ये मिळतात शेतीमध्ये मिळतात सोन्यामध्ये मिळतात ही स्कीम आपल्या कलिगच्या मदतीसाठी त्याच्या फॅमिलीसाठी स्वार्थ आणि परमार्थ दोन्ही साधला जातो आपण कुठेतरी वाढदिवसाला गेलो लग्नाला गेलो प्रेझेंट घेऊन जातो मृत्यू होतो तुम्ही भेटायला जाता काय घेऊन जाता काहीच नाही तर या मार्गाने आपण त्या फॅमिलीला पर हेड 200 रुपये तरी देतो आणि काहीतरी लमसम अमाऊंट त्यांना मिळते आणि आपल्याच एका कलिग्सला मदत होते आणि ही स्कीम त्या निमित्ताने चालते आपण सगळ्यांनी लक्षात ठेवायला पाहिजे तर म्हणून आत्ता जे काही मेंबर्स आहेत अगदी पहिल्या बॅचचे तरी किती भरलेत आतापर्यंत पैसे फक्त 35,000 भरलेत 25 हप्ते म्हणजे 35,000 दुर्दैवाने ते गेलं तर त्यांना किती मिळतात आता 10 lakhs आहे का नुकसान स्वार्थ परमार्थ म्हणतो तो मी याच्यासाठी तर म्हणून पर मेंबर तुम्ही जर का पर डेथ 200 भरताय अशा दृष्टिकोनातनं त्याच्यातनं बघितलं तर तुमचा लॉस काहीही नाही बिकम मेंबर्स ऑफ सोशल सिक्युरिटी आणि विशेष करून कोविडमध्ये सगळ्यांच्या आपल्या लक्षात आलं की काय घडलं आपण काय गमावलं आयुष्यामध्ये तर मला वाटतं IMAची बांधिलकी ब्रदरहूड टिकवण्यासाठी आपण आपल्या कलिग्सना निश्चितच मदत केली पाहिजे आणि 55 ते 60 आम्हाला असा अनुभव आला की कॅन्सर झाला डायबिटीज झाला हार्ट प्रॉब्लेम आला म्हणून येतात तर त्यांचं मेडिकल चेकअप आम्ही कंपल्सरी केलं आहे आणि आमचा राईट आम्ही राखून ठेवलेला आहे की त्यांना ॲडमिशन द्यायची की द्यायची नाही आय थिंक विथ दीज वर्ड्स आय एम कमिंग टू द एंड आवर लीडर डॉक्टर दिनेश ठाकरे इज हेअर देन डॉक्टर राजगोपाल कलावनी हु इज फ्रॉम परभणी डॉक्टर राम अरणकर सर इज देअर आय एम वर्किंग ॲज सेक्रेटरी विक्रांत देसाई our treasurer was here Dr. Jain Naurange who is the backbone and pillar of social security who is there with us each and every day Dr. Suhas Nene is the treasurer and Dr. Amrish Hade on behalf of all social security scheme I am very much thankful to our AKLUJ team. Dr. Santosh Khadtare called me की आपले राम आरणकर सरांनी खरं भाषण द्यायला पाहिजे होतं. I am very thankful to him and Dr. Naurange that they gave me the opportunity to deliver on social security scheme. I think they are the real people. I have tried on their behalf. Hopefully, I have tried to convey my message to each and everyone. Thank you so much for the opportunity.
Excellent talk, sir. I'm sure all the members who have not enrolled in this scheme will enroll in this scheme after listening your lecture. Thank you, sir.
Any query? There are forms. Dr. Santosh Khadtare, I request you, there are 50 forms. These are freshly printed forms. And you can distribute amongst various branches like Baramati, AKLUJ, Indapur. And office bearers can take that opportunity that don't waste these forms. Distribute these forms amongst your members of your branch and make them social security scheme members. Thank you so much again.
Thank you, sir, for such a nice talk. I remember the quote of Abraham Lincoln again about democracy: from the people, by the people, for the people. So scheme is same thing, from IMA members, by the IMA members, for the benefit of the IMA members. You really told everyone deeply regarding the various loopholes also. I have seen in the private companies, they make a loophole to reject the any benefit. But here we are benefiting our colleagues. So you are rather helping. I know the incidents at Jaisingpur 2 years back, and there was a death of one of the IMA members, and within 15 days he had received 15 lakhs check at his home. So this scheme is really helpful to all the IMA members, and I assure on the behalf of Santosh Khadtare, I think he is not there, that you are expecting that this your strength will go up to 10,000, and within this span it will definitely reach 10,000. Thank you, sir.
I request Rani sir to felicitate Marathi sir and also others to join with felicitation. I request Dr. Khadtare sir to felicitate all our chairpersons.
Thank you very much, sir. With this, we end the session and the lectures for today. So we'll be taking a break of half an hour, and after that, we'll be meeting for a cultural program, which is a much awaited program. We have got wonderful dances, fashion show, small walk by our members. So we request all to be present and enjoy the show and enjoy the night. So after an exhaustive session today, I hope so everyone must have traveled a lot from far, so it would be a very good relaxing evening. So I request everyone to join by around 8 p.m. for a cultural program and wonderful dinner, banquet dinner. Thank you.
Good morning, one and welcome to all on this beautiful Sunday at Panchgani. Today's our first session. We will start. First, I will welcome Dr. Prajakta Purandare ma'am. She is MD Obs and Gynec, work as a lecturer in OBG in KM Hospital, and she is a past president of Baramati OBG department, Obs Gynec. Welcome, ma'am.
Good morning, all. I welcome our next second chairperson, Dr. Navneet Desai ma'am. She's a consultant and director at Shobna Maternity Home and Jonah Hospital, Mira Road, and scientific secretary, AFG Mumbai. Welcome, ma'am. They don't have mic.
I request Dr. Navneet Desai ma'am to introduce our first speaker, ma'am, Dr. Anuja Kulkarni.
Hello.
So good morning, everyone. The first speaker for today is Dr. Anuja Kulkarni. She is a consultant obstetrician and gynecologist at Mamta Hospital, Latur. Her special interests are in laparoscopic and hysteroscopic surgeries. She has many papers and publications to her honor. I welcome you, madam. The topic she'll be talking on is lasers in hysteroscopic surgeries.
At the outset, I would like to thank Dr. Revati Rani and organizers of EVECON 2024. Good morning, everybody. At the outset, I would like to thank Dr. Revati Rani and organizers of EVECON 2024 for inviting me to give a talk on role of lasers in hysteroscopic surgery. Actually, when I was told by Dr. Revati that the Indian Medical Association of AKLUJ is organizing this conference and dedicating it to lasers and to robotics, it was a surprise as well as a pleasure for me. And I thank the organizers for making me the opening batsman for this session. Use of lasers for hysteroscopic surgery is a topic very dear to my heart, and we are one of the pioneers with the use of laser in hysteroscopic surgery in India. Greetings from Mamta Hospital, Latur. As you all know, hysteroscopic surgery has evolved over the years, especially with the advent of newer technology and energy sources which have evolved. More and more conditions are being managed hysteroscopically than resolving to major surgeries like hysterectomy. The most commonly used energy sources in hysteroscopy are the electrical energy and the laser energy. It is very essential for the surgeons to know the basic physics, the applications, the limitations, the complications and potential hazards of all the energy sources that they are going to use. So lasers is the light amplification by the stimulated emission of radiation, a concept that was first put forward by Albert Einstein in 1917. For many years, laser was not being put into any application other than science fiction movies. In 1960, Myman made the first working laser and it was put into medical application in 1962. And it was first used by Goldrath for hysteroscopic surgeries. The first laser that was used was the ND-YAG laser. So what is laser? Laser is basically a monochromatic, coherent and collimated beam of light, which when it falls on the tissues, at the laser tissue interaction, there are various effects that are brought about. But for surgery, the effect that is used is the photothermal effect. Because of the resistance by the tissues get heated up by the lasers and hence bring the coagulation and cutting effect of the tissues is brought about. The various lasers that are being used in hysteroscopic surgeries are the fiber optic lasers, which are the ND-YAG, the diode, the holmium YAG, KTP, and the thulium YAG. So these are the various publications with the use of with the various lasers. Initially, ND-YAG laser was more commonly being used, and then presently the diode laser is more popularly being used by many surgeons from Spain and Italy. We have published our data with the use of holmium YAG laser for the surgery of hysteroscopic septal transection in 2021. Recently, our video article was accepted for publication by the American Journal of Minimal Invasive Gynecology. The various tissue effects that are brought about by the lasers, they vary with each laser because of its various characteristics. So like ND-YAG has a more depth of tissue penetration as compared to holmium YAG. The various hysteroscopic laser procedures that are being done are the septal transection, the lateral metroplasty, intrauterine adhesiolysis, Asherman syndrome, polypectomy, and the others as well. So here I would like to show a video. This is Dr. Sergio's video, which shows the use of diode laser for incision of the uterine septum. Diode is a continuous wave laser with a tissue penetration of 0.5 to 1 millimeter. Since it is a continuous laser, there is a little bit of charring at the tissue interface. Holmium YAG laser is a solid state pulsed laser with a wavelength of 2100 nanometers, and it brings about various tissue effects can be brought about by holmium YAG laser, like the cutting, coagulation, vaporization, and ablation. And that is why it is known as the Swiss Army knife of lasers. It is widely being used in urology, orthopedic surgery, and dentistry. We have been using holmium YAG laser for hysteroscopic surgery at Mamta Hospital, Latur since 2004. The tissue penetration depth of holmium YAG laser as compared to all other energy sources appears to be least. It is just 0.4 millimeters of depth, and hence it is more precise. Holmium YAG laser brings about precise cutting on contact with the tissues, defocusing of the beam or bringing it a little further away from the tissues can bring about coagulation effect, and it does not have any tissue effect if the laser tip of the laser is more than 5 millimeters away. We use a 2.9 millimeter Bitochi hysteroscope with operative sheath and the 400 micron reusable quartz fiber, which is passed through this 5 French working channel. Hysteroscopic incision of uterine septum was the first surgery that we did at Mamta Hospital, Latur, using holmium YAG laser. Holmium YAG laser brings about precise cutting of the tissues and quick. So even in broad septums, the surgery is finished quite fast. The vessels in the broad septum can be coagulated by defocusing of the beam. We start at the apex and go towards the base in a horizontal manner. We can also use this laser for cutting intrauterine adhesions in Asherman syndrome. We have also used it in stage 2 and stage 3 disease. Dense adhesions can be cut with the lasers. Initially, the adhesions in the center are cut with the tip of the fiber, followed by the adhesions along the lateral uterine walls. Angulation of the long axis of the hysteroscopic assembly helps in the incision of the lateral tissues. The distending medium that we use along with lasers is normal saline. Fundal adhesions can be cut with the tip followed by these lateral adhesions. The tubal ostium was visualized after cutting the various adhesions. Since the tissue necrosis or the depth of tissue penetration or the depth of tissue destruction and the collateral damage is minimal with the use of lasers, the regeneration of the endometrium is also very fast. Vaporization of fibrotic bands can also be done with the lasers. Since Holmium-Mag laser is a pulsed laser, you can see that there is very little charring effect during the surgery. We keep an intrauterine Foley catheter after cutting these major adhesions. The second look hysteroscopy is usually done after 1 month of the primary surgery so as to rule out any recurrence of adhesions, and you can see over here that there are absolutely no adhesions. Dysmorphic and unicornate uterus is known to cause infertility and adverse reproductive outcomes. Fundal and lateral metroplasty has shown to improve the reproductive outcomes in these patients. Especially in T-shaped uterus, Y-shaped uterus, and also in unicornate uterus, it helps in widening of the uterine cavity and increasing the endometrial volume. So lateral metroplasty with the use of Holmium-Mag laser is also a very simple procedure which has shown to improve the reproductive outcomes in these patients. Endometrial polyps can be removed with lasers. Here, this is a postmenopausal woman with a stenosed external os. The os was incised on vaginoscopy, and you can see multiple uterine polyps, endometrial polyps, the pedicles of which are cut at the base with the use of this laser. Very small polyps can also be ablated or vaporized with the laser. Bleeding vessels can be coagulated by defocusing the beam. Hysteroscopic polypectomy in these patients can relieve the patients of their symptoms like postmenopausal bleeding and prevent them from undergoing major surgeries like hysterectomy. You can now see that there are no polyps inside the uterine cavity. These are the different hysteroscopic laser surgeries done at Mamta Hospital, Latur in the last 1 year. The advantages of lasers, as we have already seen, is that it is a precise and quick surgery with minimal depth of tissue destruction and lateral thermal damage. No cervical dilatation is needed as we are using the 5 millimeter operative sheath, and there is very little risk of fluid overload and hyponatremia because of the use of normal saline. It has a short learning curve due to its easy maneuverability. And since we are sharing the Holmi-Mag laser with the urology department, and since we are using the reusable quartz fiber, it proves to be very cost effective to us. So recurrent costs of scissors can be avoided if we are sharing this with the urology department. You need to know the precautions that are to be taken. That is the knowledge of the laser physics and its tissue effects. You have to always remember to put the generator on a standby when you're not using the lasers. Keep it away from the inflammables. See that the beam does not fall on any other inflammables, and use protective glassware if you are using lasers during laparoscopy. But since in hysteroscopic surgery, we are using it in closed environments, it is not really very necessary if you remember to put the generator on a standby before removing the assembly of the operative hysteroscope. So, as I always would like to say, that now we have to embrace technology, and we have to not keep any fears for the use of technology. In the older days, gynecologists, especially the lady gynecologists, used to be very shy with the use of technology. We hardly ever used even cautery for an LSCS. But I'm sure this is not the case nowadays.
We have also seen how this machine can be made cost effective in our institution. Thank you so much for giving me an opportunity to present my work with this magic wand.
So thank you, ma'am. Okay. If anyone has any questions, you can ask. Madam is coming online. So lasers have changed the way we do our surgical procedures these days. And Dr. Anuja Madam has given a beautiful insight on the basics of laser and its role in hysteroscopy.
We can have discussion. Yeah.
I actually had a question for Madam, but if she can answer, no, she has to connect for that. For inviting us as chairpersons. Thank you so much.
Thank you. We had a wonderful.
And it was really a very nice session. Since yesterday we are here, and all the lectures were superb, very well coordinated and well thought of. It is the need of the hour. So thank you so much. And even the cultural night last night was very nice, with the same theme continued. Very nice. Congratulations to the entire team. Anyone else has any experience with lasers, use of lasers in routine surgeries? They want to share their experience?
Madam, just technology phobia, but
Yeah.
that is what we are facing right now, problems with the
Yes.
technology. So can we start with the second lecture that we have,
Yes,
the
yes.
recorded lecture? And
Yeah.
later on, if both of them can join, so that we can take the questions together.
Right, right.
Yeah, thank you.
Dr. Prajakta Purandare ma'am to kindly introduce our second speaker, Dr. Vishwas Kulkarni sir.
Yes, thank you. Good morning and congratulations IMA AKLUJ for arranging this wonderful EVECON conference. As Madam has said, since yesterday we are enjoying the feast, academic feast of various innovative technologies in laser and robotics.
Dr. Revati Rane and organizers of EVECON for giving me this opportunity to be amongst you. I'm presenting this remotely because I'm in out.
Hello, I'd like to introduce Dr. Kulkarni. Good morning, sir. He is a practicing urologist since 1995 in Mamta Hospital, Latur. He has presented many papers and posters in various conferences in India as well as out of India. For example, that means he had presented papers on sperm retrieval before TESE in University of London as well as in Birmingham. He was awarded many prizes for his best papers in Bhubaneswar and Massicon conference at Latur. He has participated in various regional, national fora, and he was a faculty and delegate in many conferences. Over to you, sir.
Good morning, dear friends and colleagues. At the outset, I would like to thank Dr. Revati Rane and organizers of EVECON for giving me this opportunity to be amongst you. I'm presenting this remotely because I'm in outside India for a conference. Lasers are not new to us. We doctors have been using lasers in different forms for the last 30 years. We all know this routine. The laser acronym is a light amplification stimulator for biostimulated emission of radiation. This was proposed by Einstein in early 1917 to be precise. But laser applications were not available almost up to 1960s. Initially, laser was an invention looking for an application. We did not know how to use it. It was majorly a part of fantasy for all of us, like Star Wars and Goldfinger, where powerful lasers were used as swords, they were used to cut people through half, but this was not possible then. Slowly we started finding uses of lasers, then we started having those small laser pointers, then CD-ROM device, then we had micro machining, like the way you put your names on small instruments. This was all done with laser etching. And now we started having different form of lasers which were for dermatological use, for surgical uses, for ophthalmic uses. But still, those powerful lasers cutting through people were not possible. But now with industrial lasers and with military applications, like you all must have heard about a large laser gun being deployed in Israel, which will work with the Iron Dome, where they can destroy incoming rockets and missiles by firing a strong, powerful laser beam on them. So we are now almost seeing the fantasies occurring in the amidst us. Now we have laser fibers which can be used through a hand instrument. It can be adapted to put use as a scalpel. It can be used as a laser fiber. So why lasers and how do they help us? The lasers, because of the intense beam of a monochromatic light, cause water vaporization or a tissue vaporization, which leads to thermal effect. It can cut through the tissue, it can destroy the tissue, denaturate the proteins, and cause hemostasis. Generally, the water heats up and forms microbubbles, and these bubbles can burst and break a stone also. That's the mechanical effect. In photodynamics, whenever you fire a laser on a tissue, the light is reflected. And there will be a difference between a reflected light from a normal tissue or from a cancer tissue. So with specific lights which can be used to identify carcinoma in situ in bladder, where it is just a mucosal lesion and you may not be able to identify it with naked eye. Similarly, tissue welding is hypothesized. We have been trying to do a good tissue welding laser, but it is not possible. Still, it's a fantasy or impractical solution as of today.
One of the many medical lasers which are come and gone, like CO2 lasers or pulse dye lasers. Nd:YAG laser was very common, but it had its side effects. Presently, holmium-YAG lasers are most commonly used for soft tissues, for prostates, for stones. KTP green light laser is one laser which is absorbed by the tissue and it causes vaporization. So it has been used to vaporize large prostates where you can't cut them. Thulium laser and thulium fiber lasers are two different lasers, but which are also again very commonly used. Holmium laser is available since last 25 years. It has got a very specific wavelength which is absorbed by water and hence causes tissue damage which is predictable. It is carried through a flexible fiber and can be used through water. The many applications of laser are basically for stone fragmentation, for tissue cutting like posterior wall fulguration for strictures, or vaporizing or cutting large prostates also. The lasers are useful for urinary stones because the fibers are very small, 205 microns, 500 microns, 600 microns. Now there are fibers which are 100 microns, 150 microns. And these are very small footprint. And once that fiber, if it is passed through endoscope, can effectively work and same time will not obstruct the irrigation channel. All those who are doing endoscopy will understand importance of an open irrigation channel which will give a good water flow and a better vision. Also because these are flexible fibers, they can be maneuvered, and as you can see here, the scope can bend into the lower calyx and break the stone there. Here I am showing a video to you which shows a lower calyceal stone. Excellent vision. The fiber is very small. You can see it's not even 1% of the total screen which you are seeing. So very small fiber, very effective. You go near the stone and fire, the stone starts breaking. This is a very hard stone, calcium oxalate. So there are more. It is better to fragment these stones and take out the tissue. But whenever you come across a calcium oxalate stone which is softer, you can just vaporize the stone, or it is called a dusting, and the dust will flow off. But whenever you come across a monohydrate stone, a dark black stone, it is better to fragment and pick up the stones and remove it and give a complete clearance. Here you can see almost the calyx is completely cleared, and in the opposite image you can see the fiber which is, so the laser scope which is completely bent almost 180 degrees and looking into the lower calyx. The second most common application which is unique for lasers is postourethral valves. As you all know, these are seen in newborn children, mostly diagnosed antenatally because of bilateral hydronephrosis and a distended bladder. And these patients develop severe renal dysfunction if they are untreated, and they can die in early childhood or even in their neonatal period because of renal failure, electrolyte dysfunctions, infections. So these babies are very small. The scopes which we use are very small, 6 French or 7.5 inch ultra thin cystoscope, out through which a fiber laser can go. So holmium-YAG fiber is used, power used is very low, so any 30-watt machine also can help. Here are two videos which show the posterior valves. There are two different types. Type 1 is where there is an incomplete flip, I will say flap-like projections, and one on this side, actually I don't know if you have missed it, is a complete occluding membrane. So this membrane can be fulgurated or vaporized with laser, while on this side, though it is taking a bit longer to show you, now here you can see the walls, and these walls are obstructive. Whenever the water comes in, it acts like a dampening, what we call it as a ball valve mechanism or an obstructing flap. This flap can be beautifully cut with a laser with minimal damage to surrounding tissues, and this gives complete resolution of walls, a good outflow, Again, this is a video of a same child, a similar type of patient. Again, the walls are being cut. While in this picture, this is post-op video. Now I'm coming back from the urethra, and here you can see the walls are completely disappeared. So lasers are very precise. There is I won't go to this slide now because it just shows the post-op cystoscopy. And this is the urinary stream which we get immediately post-surgery or maybe 2-3 years down the line. Patients have a very good flow. The upper tract dilatation goes down. So lasers are really a boon for these kind of patients where the area is very small, the scope is very small, and you need a good material, a good source, energy source which can cut precisely. One of the biggest, what I will say is, problem or understanding of laser is we always consider laser as a powerful tool, but actually it is a precise tool. A precise tool which has very low depth of penetration, causes minimum coagulation, so the tissue recovery is very good. Patients do very well post-operatively and there is minimal lateral damage or minimal side effects. Prostate, as you know, is a big issue or is one of the most common diseases occurring in men. And whenever you use a laser, I don't know if you can see my pointer here, the red thing marks the neurovascular bundle which is just outside the prostatic capsule. If you cut prostate with electrocautery, the depth of penetration hampers these nerves, and these nerves then get damaged. The patient can have post-operative incontinence, impotence. To avoid this damage, we should use lasers which have a minimal depth of penetration like 0.4 mm. Even the thermal damage is minimal, so you get a very clean cut. Now on the right side is a animation, while the left side is actual case recording. The laser cuts very precisely with minimal lateral damage, and that is, I will again and again harp on it, that why we need lasers. I think I will just fast forward this because the animation is going faster than this. Once you cut the mucosa, a distinct plane between the prostate and its capsule is seen. Anatomically, there is always a plane between the adenomatous zone and the peripheral zone. So if you are between these planes, you can effectively, nicely control the cut, and you can see the tissue which is remaining behind on the patient side. Don't look at the specimen side, look here. The floor is almost normal looking. It is not charred, it is not darkened, it is all white, as if you are peeling it off. That is what is happening in enucleation, you are peeling off the tissue. So these lasers have given a real I will say help to doctors because it is done in normal saline. Once you do it in normal saline, issue of electrolyte disturbances, water intoxicity goes down. So there are no electrolyte imbalance. It can be done in normal saline. So even if some fluid is absorbed in the body, it is treated as if there is one more infusion going in. There is low charring, there is less edema, early catheter removal, you get a very clean tissue for histopathology. And on top of that, you need not stop the antiplatelets. Ecosprin now presently nobody advises you to stop. Clopidogrel is better stopped 3 days prior. But now there are many of my colleagues who are using lasers with dual antiplatelet going on.
both our speakers are
Shall I
joining us
comment?
online. So if anybody has any question, please ask it.
Shall I comment?
Yes, yes, please, ma'am.
Yeah, it was a very elaborative lecture on the use of laser in urology as well as gynecology. Dr. Kulkarni has elaborated the precise use of the laser technology in many surgeries, and as it is minimally invasive and the thermal damage is less, it must be causing very less post-op morbidity. The post-op stay will also be reduced, and it is a very good technology to for all these procedures. Thank you all the EVECON organizers for inviting us for this conference and making the chairperson. Thank you.
Thank you, ma'am. Unfortunately, there is some problem with the connection. So both the speakers are there online on the YouTube. So hopefully we can clear the doubts later. And we would like to felicitate them virtually also. Yeah, so.
I request Dr. Savita Gujar ma'am to kindly felicitate our chairperson, Dr. Navneet Desai ma'am and Dr. Purandare.
Dr. Trupti said.
Myself, Dr. Supriya.
We are moving on to our next session, that is lasers in ophthalmology by Dr. Sagar Vardhamane sir and lasers in aesthetics by Dr. Sharvari Pandit. I request Dr. S.N. Kulkarni sir to chair this session. Sir is very senior dermatologist in AKLUJ, practicing since 35 years, specialized in lasers and cosmetology. He is life member of Indian Association of Dermatologists.
I request Dr. Sanjay Purandare sir to chair this session. Sir is General and GI Surgeon at Rama Madhav Hospital, Vice President and Medical Director of Baramati Hospital. He is a past Vice President, IMA Maharashtra State, past Vice Chairman, AMS Maharashtra State, past President, IMA Baramati, and past CWC member. Sir is also past President, Medico Guild Baramati, past EC member, Pune District Badminton Association. Welcome, sir. Now I request Dr. Praveen Shinde sir to chair this session. He is a practicing neonatologist and pediatrician in AKLUJ since 15 years. Honorary Secretary, Academy of Pediatric, AKLUJ branch. He is an active IMA member and past CME Secretary of IMA AKLUJ.
I request Dr. Aditi Thite to chair this session. Dr. Aditi is practicing as dermatologist and cosmetologist in AKLUJ. She is clinical secretary at IMA AKLUJ, life member of Indian Association of Dermatology. She is secretary of Innerville Club of AKLUJ. Apart from her brilliance, she has keen interest in other fields also. She has won the title of Mrs. Beautiful at MediQueen Maharashtra 2022, pursuing Visharad in Bharatnatyam. I request Dr. Praveen Shinde sir to introduce our first speaker, Dr. Sagar Vardhamane sir.
Good morning, everyone. So let's start with lasers in ophthalmology by Dr. Saradar Vardhamani, sir. He is a practicing ophthalmologist in Vardhamani Eye Care Clinic, Pune. So let's start.
Good morning, everyone. Good morning, chairpersons. I would like to thank organizers of EVECON and IMA Women's Wing, AKLUJ, for this great opportunity. I'll start now. I'm not a good orator, so please pardon me. My topic is lasers in ophthalmology. Lasers are all about coherence of the light. So laser is acronym of light amplification by stimulated emission of radiation. History, we won't go in details of the history. Just first branch was the ophthalmology who introduced laser to the medical field. Meyer Schwickerath highlighted that photic burns may be beneficial as a therapy in the case of melanoma. That was the first laser used in ophthalmology. So physics, when electrons, metastable electrons, photon passes through these metastable electrons, then another photon is emitted. That is called as laser. Then there are three mechanisms of light emission: absorption of light, stimulated emission, spontaneous emission, and stimulated emission. Properties of laser light: monochromatism, emit only one wavelength; coherence, all in same phase, improve focusing; polarized, in one plane, easy to pass through media; collimated, in one direction and non-spreading; high energy, intensity measured by watt. What is the difference between laser and light? Stimulated emission, laser is stimulated emission and light is spontaneous emission. Laser is monochromatic, highly energized, parallelism is there, can be sharply focused. Classification of lasers. This is all physics you must have gone through since yesterday. These are various types of lasers. Laser variables are wavelength, spot size, power, and exposure time in ophthalmology. Tissue variables are transparency, pigmentation, and water content. There are three types of ocular pigments: hemoglobin, xanthophyll, and melanin. In eye, generally macular area has got xanthophyll, and retina, other retina has got melanin, retinal pigment epithelium, RP, and choroid. This is absorption spectrum in ocular tissues. We generally use argon blue, argon green, ND YAG, diode, krypton. Then there are three tissue effects: thermal effect, photochemical effect, and ionizing effect. With thermal effect, we do photocoagulation, photodisruption, and photovaporization. Photocoagulation is generally used in retina. Photodisruption in posterior capsular opacification after cataract. Photovaporization. Then photoablation, which is generally used in LASIK surgeries. Generally, in photocoagulation, denaturation of proteins happens. Photodisruption, tissue damage happens. And photovaporization is used as cauterization, incision, femtosecond laser, which is in thing now in cataract surgeries. Then there is photodynamic therapy. This is obsolete now with anti-vascular endothelial growth factor injections in the vitreous. These are delivery systems. We generally deliver laser by laser indirect ophthalmoscope or slit lamp, or in the surgery endophotocoagulation. Uses of lasers in ophthalmology are diagnostics and therapeutic. Diagnostic use are confocal scanning laser ophthalmoscope. Then this is in thing OCT. We generally nowadays use OCT, optical coherence tomography, to diagnose retinal pathologies. Then laser interferometry, laser retinal Doppler flowmetry. These are some indications. Then therapeutic uses of lasers, extraocular, removal of lid masses, orbitotomies, blepharoplasties, capillary hemangioma and Port-Weinstein trichiasis, periocular benign lesions, perioscular vascular skin lesions, conjunctival lesions. Then transcanalicular diode laser is now used as a replacement of conventional DCR for nasolacrimal duct obstruction. Lasers in anterior segment, cornea. These are all refractive surgeries. PRK, LASIK, LASIK. Nowadays, there is silk surgery and smile surgery. This all we do with excited dimer laser, excimer laser. Then femtosecond lasers, we generally cut the flap of the LASIK, and femtosecond lasers are used in cataract surgery also nowadays. With introduction of smile and silk, LASIK stays the mainstay of any corneal refractive surgery. Then iris and pupil lasers we use for pupilloplasty, photomydriasis, synecholysis, persistent fetal vasculature destruction, corticolysis, membranectomy. We don't go in the details. Now for glaucoma, for angle closure glaucoma, we generally do peripheral iridotomies, laser iridotomies. Then now cyclophotocoagulation transclerally. Then for lens, I have talked this. For posterior capsular opacification, we do ND-YAG laser capsulotomy. Then for fundus retina disorders, for mainstay of the treatment is for the diabetic retinopathy. There is hypoxia in the retina because of leakage and blockage of small arterioles. And to counter that hypoxia, we burn periphery of the retina so that macular portion gets the main blood supply. Then we use ND-YAG laser for prehyaloid hemorrhages. This is all theoretical things. In the surgery vitrectomy, we use endolasers, which delivers directly in the posterior segment. Then laser is used for retina or choroid tumors, like malignant melanoma, which was laser was first used for malignant melanoma in the history. Then retinoblastoma, retinal capillary hemangioma, pigmented lesions of retina and choroid accessible to OCT. This is pan-retinal photocoagulation, which is used for treatment of diabetic retinopathy. Neovascularization sets in after hypoxia. So to counter that, we do photocoagulation. For macular lesions, we do grid photocoagulation, focal or grid, which burns in the areas of the macula. But now this is also going obsolete because introduction of newer antivascular endothelial growth factor injections. femtosecond laser is the in thing in ophthalmology right now. We can do various incisions, corneal incisions. Phaco-fragmentations means cataract fragmentation. Then this you all know, laser hazards. So laser is boon in ophthalmology right now. What is going on in USA is going on in India. So we must use all the lasers for to benefit human population. Thank you.
Anyone would like to ask or summarize the lecture? Any questions?
Yeah, thank you, Dr. Vardhamani, for an exciting lecture. We were knowing only about use of lasers in cornea and for cataracts, but you had given a beautiful overview of what all things can be managed by laser, right from extraocular pathologies right up to retina and from benign to malignant lesions. Thank you for an excellent overview of lasers in ophthalmology. And I would like to thank the organizers for giving us the opportunity to chair the session. And it has been an exciting conference. The contents and the lectures have been very good, and giving an overview of what lies in store for the future generations. And it is exciting to know that these things are really done in not only in mega cities, but of course in tier 2 cities as well. So thank you very much for everything.
Thank you, sir. I request Dr. Purandare, sir, to felicitate our speaker, Vardhamani, sir. Other chairperson, please kindly join the felicitation.
Hello. Good morning all. Dr. Sharvari is a dermatologist and cosmetologist. She has a fellowship on dermatology, aesthetic and lasers and Arab Academy of Dermatology. She is a consultant at Pandit Skin Clinic and consultant at MMF Joshi Hospital and even consultant at Ramakrishna Mat Hospital. Her special areas of interest are acne, anti-aging treatments which are non-invasive, aesthetic lasers, advanced peels and pigmentations. And she is a consulting trainer for Luminous India and Stellar Medical Agencies. And she has areas of training with aesthetic lasers, laser hair removal, HA fillers, Botox, threads and non-invasive facelifts. So welcome Dr. Sharvari. Over to you.
So lasers in aesthetics, skin aesthetics, do they really work? What do they do and what are the possibilities? I'll just go through very quickly. The laser applications, as you can see, skin rejuvenation. The major is laser hair reduction, pigment treatments, tattoo removal, and some vascular treatments can be done. People want freedom from unwanted hair. They want very soft, supple skin. Nowadays, having even little hair growth on the skin is not accepted by many. Lasers play a very big role here. People want spotless skin. They want even pigmentations and very uniform skin tones. Not entirely lasers will fix this completely, but it definitely helps. people don't want to age. They want wrinkle-free and younger appearing skin. So people want this. They want uniform, flawless skins. They don't want acne. They don't want scarring. They want absolute even skin texture. They do not want their pores on the skin to be seen. A lot of times, they are very bothered about the superficial vascularities that can be seen. So lasers can help you with all this. Can the lasers really deliver? So I will say sometimes they do. It's not absolute necessary that they'll do wonders, but there are some times that it really helps. So the most booming industry in the US and worldwide right now is the hair reduction industry. So the target chromophore is the melanin. Here you can see a patient. He was operated for a vaser liposuction. And after he got his 6 packs done with vaser liposuction, he still complained that he was looking like this. So we realized the problem was not with the surgery. So he just had to undergo a laser hair removal session. And this is how he looks. So the body contours, the skin, the inside muscle contours, the fat retentions, everything can be seen better if your skin is hair-free. Someone who suffers from this problem is definitely a candidate who should think of lasers. And a girl like her who will need to shave every day, it's very embarrassing. She will definitely be the candidate for laser. This is one of the most expensive laser hair removal platforms on the planet. It's called SplendorX. I don't have it, but it's my dream. So IPL Intense Pulse Light is not exactly a laser, it's a light, but it does a lot of good job like the laser. This is the NDAG hair removal system, a triple wavelength diode. This is my favorite, the Luminous hair removal diode. This is one of the most popular hair removal systems on the planet. So a lot of males also seek these treatments. So it's not only females who are desiring a hair-free skin. There are a lot of males also who are really wanting not exactly hair-free, but a skin with less hair. So there are a lot of indications that males have. Like the male hair reduction requirements are very varying. One is laser beard shaping, hairline shaping. The male genitalia also they want to get treated. A lot of males have penile shaft hair and it's very irritating and troublesome, so they come for these treatments. The pilonidal sinus, the buttocks, clefts also can be treated. Earlobes, chest, back, arms, legs, almost every area of body can be treated with laser hair removal. Just a quick video. Sound nahi. काहीतरी चेंज करायला ठीक आहे मी एक्सप्लेन करेन नसेल होत नंतर झालं तर बरं आहे सॉरी द व्हिडिओ हॅज अ व्हॉइस ओव्हर आय जस्ट नीड टू प्ले इट याचं सेटिंग बदलायला लागेल का केला बघा बघा This patient likes to keep a well-groomed beard and wants it low maintenance. We are doing laser beard shaping for him with diode laser. The area to be treated is marked at exact. Once removed, a certain hair might never grow back. Beard them meticulously. Mark both sides of the face and check for the symmetry. Shave the hair to be treated.
This tip chills the epidermis on contact. It also emits pressure. This reduces chances of epidermal injury. Photons get concentrated in hair shaft and follicle, and the follicular regrowth ability is reduced. This is a high-speed handpiece of diode which is used for larger body areas. It is based on suction principle.
So here for this patient, the hairline reshaping
Here is the
was
patient
done.
3 days later
And
with his
beard shaping.
desired beard shape.
परत व्हिडिओ होईल का आपलं? आता स्लाइडच्या मध्ये होईल. Just a quick view of how the procedure happens. So full body treatment can take somewhere around 1 to 2 hours only. Some pre-post. Sorry. इथून करू का आता? फुल करा ना. इथे करू का स्लाइड शो? This is what you can really achieve, and in many cases. Great relief from facial hair. So IPL, intense pulse light. So it's not exactly a laser, but a great tool. It works similarly.
She is a patient of acne, showing acne at all stages of development. Intense pulse light handpiece of M22 has acne filter. It passes light of 600 to 800 nanometers. A large light guide is used for larger treatment areas. A smaller 6 mm tip can be used for single lesions. The IPL reduces signs of inflammation in the skin. This treatment is followed up by Acnelan treatment.
This is what you can achieve quickly.
These are the results after 3 sessions.
So a few pre-posts where I use similar treatments for these patients. So these are the possibilities, and I have seen that when the patient presents with a lot of acne, they're not like conscious about how they look. They dress up really bad. They don't care about how they are carrying themselves. Once their skin clears up, somehow it's a confidence booster, and I've seen them really dressing up well with a super confidence. It can also help with rosacea. A photofractional laser resurfacing is what we'll see now.
We combine erbium YAG laser treatment with Q-switched ND-YAG laser treatment for this patient with fine lines, wrinkles, and pigmentary problems. Resurfax is erbium YAG laser. It's a fractional non-ablative laser with minimal downtime. Shape, size, density, and energy all can be customized. Increasing energy increases the depth of penetration. It is a non-sequential scanning. The algorithm of scanner places each fractional spot in a controlled manner to protect tissue from heat accumulation and overheating. We combine the resurface treatment with Q-switched Nd:YAG laser treatment. The endpoint is faint erythema and sometimes visible villous hair bleaching. Multiple treatment sessions can be done, which are repeated every 3 to 4 weeks.
Here are some results that you can achieve with a fractional photofacial. You can see brightening of skin, and a nice skin glow is what the patients are wanting these days. The resurface, the erbium laser, can be used for treatment of scars. It's a little difficult to really see the scar on the cheek, but that patient was very bothered with even that tiny little scar on her cheek. So I treated it with erbium. It can be also used for burns. These are the kind of results that you can get with burn injuries and hypertrophic scars. It can be used for chickenpox scars as well. And it can be used in acne scarring. You must have heard about this carbon peel or carbon facial everywhere. We'll just see what it is. It is basically done for pigmentations and acne.
Here is a patient who wants quick lightening of acne mark, also wants treatment for dilated pores and wants a lighter skin tone. We are doing carbon peel for her. That was an activated carbon gel. The gel is applied as a very thin layer uniformly all over the area to be treated. The carbon particles are left on the skin for about 10 minutes. These carbon particles are hypothesized to absorb excessive sebum. Use metallic protective eye shields during the treatment. Then a Q-switched Nd:YAG laser is delivered to the area treated with carbon. The particles are heated up and are destroyed. Fume is generated. A smoke evacuator can be used. I'm using 5 mm diameter spot-sized handpiece for this treatment. The mechanism of action is related to peeling effect of the procedure. Thinning of stratum corneum, reduction of P. acne count, and decreased sebaceous gland function leads to reduced inflammation. The procedure is generally quite well tolerated. These are the results after 3 treatment sessions.
A few more results. This patient achieved this result in just 1 session. Another patient. So she was a patient of resistant acne, excoriations, and post-inflammatory hyperpigmentation. She did not respond to any topicals or orals, so finally I decided to do a carbon peel for her. She really responded well. I wasn't expecting this. We'll just see quickly about the fractional radio frequency for rejuvenation. Again, it's not a laser, it's radio frequency, but works quite similarly.
She is a patient with signs of premature aging. She's just about 50 years with severe wrinkling, severe acne scars, deep nasolabial folds, and static forehead wrinkles. Anesthesia with infraorbital nerve block and infiltration anesthesia in the surrounding area is administered. We are using fractional radiofrequency technology called Morpheus 8 for this patient. The needles are insulated all through their length and deliver RF energy only at the uncoated tip. It cooks the tissue, causes a controlled thermal damage and wound healing. These are the results after 2 sessions at monthly interval.
Last. Another application is tattoo removal. The long pulse NDI can be used for treatment of vascular lasers. I don't use it so much. Just one case I have to share. This was a case of port wine stain. She's still on treatment but responded after about 3 sessions. Thank you.
Thank you, Dr. Sharvari, for such an interesting and informative lecture. We have with us Dr. S.N. Kulkarni sir, very senior dermatologist from AKLUJ. I request Dr. S.N. Kulkarni sir to share his experience regarding this.
Nice lecture, Dr. Sharvari.
Thank you, sir.
I want to ask one question. What wavelength of erbium you use in this?
This is erbium fiber laser 1565.
1565. Okay, okay. Is there any downtime?
About 2 to 3 days, but depends on the depth you are doing it at. So if you are at the depth of, say, the upper dermis, mid dermis, so about 40 joules plus energy, then it can get extended to about 4 days, 5 days. But a superficial treatment, 2 days is good enough.
Okay, and what wavelength of Q-switch you use? 1064? 1064. Yeah. With 1064 and which spot size and
so the
which
treatment,
mode?
for tattoo, I use somewhere around 2, 2.5, 3.5, depending on the density of pigment. And for the carbon, you can use 5, 6 plus till 8.
Okay, okay.
So my machine has a spot size of 8. So the patient is not tolerating it well, I go to 8. Otherwise, I prefer to do it at 5.
Okay, okay. It's very nice, informative lecture, Dr. Sharvari.
Thank you, sir.
And
Hi. Very nice and informative lecture. Can it be used for keloid treatment also?
So there are a lot of reports now coming up, but it's tricky. So you have to tell the patient, if at all it works, it is good. If it doesn't work, you will have to maybe treat it with intralesional and add on with the laser treatment. So the resurfax I use for keloids, but I generally avoid the chest area. So something on the arms, back or face, I use it. But for chest, I don't, because I have not seen great results on the chest area. And you always have to combine it with intralesional injections. And the intralesional injections themselves give quite a good result. So I first do the injections, and if anything is remaining, then I add on the laser. Otherwise, I don't.
Thank you.
Very nice informative lecture, Dr. Sharvari. I want to ask you one question. In hair removal, we use various types of platforms like IPL, NDAG. We are not using NDAG nowadays. Diode laser is we are using. But have you tried combined technique like IPL for some sessions, and for some sessions you use diode lasers?
Yes.
And what is the end point of hair? Actually, it is not hair removal, it is hair reduction. that we have to tell to the patient. But what is the end point of diode hair removal?
Yeah, see, I'll tell you, you say sometimes that it is hair reduction, but I have seen patients responding so dramatically with the luminous diode, sometimes 2 to 3 sessions and the hair is gone. And I have patients who have been following up for 10 years, no single hair has grown up. So there are some patients who do not respond at all. There are some patients who respond really dramatically. Now there are some patients who are on like maybe the 25th or 30th treatment with me, they don't give results. So the hair has thinned down, especially on the face. So the thick hair is gone, it's very thin now, but it's not gone at all. So I have tried combining all the different modalities that I have. I have tried the YAG, diode, IPL separately. I've even tried stacking them. Like in one session, I've done IPL, then on top of that, I have done diode. Still there is no change. So if someone doesn't respond, he doesn't respond to anything. And if someone is responding, they anyways do good with any of the machines.
So no villous hairs at all. Even villous hairs are not there after the end point.
So in some cases,
Okay,
there are others who will have no response at all. So if what I have noticed is if the hair is too thick, then they respond dramatically well. Too thin hair, I'll prefer doing a Q-switch bleaching instead of doing a diode laser. But when the hair is midway, so it's not exactly very thin, like not villous, not terminal, the response is really pathetic. I tell them either you keep doing this, like how you go to your parlor, get your waxing done, you'll have to come here every 3 months and keep doing your sessions. As long as you want to keep the hair under control, or just tell them to shift to some other modality like shave, wax, or whatever they want.
Thank you.
Thank you.
What about white hairs? Sir is asking, what about white hairs?
Electrolysis. Sir, actually, we had a training about 1 week ago. There was a plastic surgeon who was telling us that when he's doing hair transplants, he had difficulty in picking up the hair when they were white. So they were trying to color the hair. So use a hair color for 3 consecutive days just before the transplant. So when they started extracting the hair roots, they saw that the hair root also changed the color. So now I am actually planning to start like a small study. I have 2 patients who have enrolled. So I'll be doing the hair color for them. So 3 consecutive days we'll be coloring their hair. And then on the 4th day, we are going to try doing the diode if it works. If that can be done, it will be great. But right now only electrolysis is what I'm doing.
Thank you, ma'am.
Thank you.
I request S.N. Kulkarni sir to felicitate our speaker, Sharvari Pandit ma'am. Other chairperson, please join the felicitation.
Felicitate our chairpersons.
Nikhil.
Hello. Hello.
Good morning, everyone.
Session 3. In this session, we have only 2 topics, and the timing will be 10 to 15 minutes. I request Dr. Bakulesh Mehta sir to chair this session. He's a past president IMA Maharashtra State. Dr. Bharat Pawar sir, he's a senior gynecologist from Mauritius and current president AKLUJ OBGYN Society. And Dr. Nitin Rane sir, he's a physician and honorary secretary of IMA AKLUJ for past 3 years. I request Dr. Mangesh Darikar sir to deliver a talk on robotics in knee replacement surgeries, recent advances. I request Dr. Nitin Rane sir to kindly introduce the speaker, Dr. Mangesh Darikar sir.
Good morning, everyone. So we'll be going ahead with the lecture of Dr. Mangesh. He's a colleague and a dear friend of mine. He is a consultant robotic joint replacement and arthroscopic surgeon. He is a director, owner, chief robotic joint replacement surgeon at Darekar Super Speciality Hospital, Sinhagad. He is a consultant orthopedic surgeon and joint replacement surgeon at various other hospitals like Deccan Multispeciality, Hardikar Hospital, Apollo Spectra Hospital, Sahyadri. He has done his fellowship in arthroplasty and arthroscopy from St. Anna's Hospital, Herne in Germany. He has also done his fellowship in arthroplasty from Dinanath Mangeshkar Hospital. He has presented at various platforms regarding robotics. He has his own robot and has wonderful set of patients which he has done. He comes to AKLUJ on a regular basis now for a visit purpose, and so we know him closely. He has seen many patients. His special interest is in joint replacement and limb reconstruction, arthroscopy, and sports medicine. He is very much interested in sports, and we know that he has treated many sports individual personalities also with very good results. Over to you, Mangesh.
Thank you, Dr. Nitin. Thank you for the introduction, and I would like to thank all the faculty members and all the members of IMA for inviting me to deliver a presentation over here today. I'll not take much of your time because I know a lot of lectures are scheduled today. According to the introduction, I have been practicing since last 12 years in the field of orthopedics, joint replacement being my forte since last 10 years now. And I have conducted a lot of conventional orthopedic and joint replacement surgeries since last many years, robotics being the most keen interest of mine since last 2 years. Over the period of last 40-50 years, we have seen a lot of improvement in the field of joint replacement surgeries, where a lot of technology has been developed and adapted over a period of time with regards to robotics and navigation, and we are seeing a lot of improvement in the technology in the last 5 years or so. Where a lot of newer generation robotic technology is being adapted and used at various levels. And going briefly, robotics was introduced in the field of medicine in the year 1985, which was primarily used for neurosurgical biopsies which improved the precision for taking tissue biopsies, and which was later inculcated into neurosurgery department with transurethral resections in the year of 1991. Over the following 2 decades, we have seen a lot of improvement there, where a lot of newer systems like the Zeus and the Da Vinci platforms were developed, and they are still under development with a lot of advancement and being used across various surgical aspects of general surgery. However, orthopedics was lagging behind in terms of technology, where we had the navigation system, but we lacked the tools to execute the surgery properly without causing the human errors which are always associated with a lot of these surgeries. A lot of the surgical robots were dependent on robotically controlled arms. These were human controlled arms, and were utilizing 3D cameras and high definition cameras to assist the surgery, which was an added extension to the laparoscopic procedures which were carried out since last many years. Now we know for ourselves that a lot of platforms are now being used across India, where they are remotely operated, and surgeons are in complete control of those devices. Robotics in arthroplasty were under development since the year of 1980, and the first use of a robot with a tool was in the decade of 1980, which was used for knee replacement surgeries, which had a semi-navigation system and a electrical burr, which was directed on the basis of the anatomical landmarks which were registered on the system. So the orthodoc system was the software for the Robodoc machine. Now, we know for sure that more than 2 lakh knees are being replaced every year in India, and it has been the most widely executed surgery across the country. The long-term survival rate of the implant and the patient functional outcome is the main, what do you say, main motive behind the surgery, because a lot of patients coming to us are suffering with a debilitating pain since last many years, and they're not able to carry out their activities. They're pretty much housebound. So most of these patients, they come to us, and what they expect in return is that they should be comfortable and pain-free. However, what we have seen is that despite of carrying a precise surgery, a well-executed surgery, which looks very good on X-rays, the patient still remains unhappy. They are still in pain. They are not able to carry out their activities many times, and that is a very daunting number of more than almost 20 to 30% patients turn out like that. Now, why was this seen? So here is an example of this. So this is a patient which came to me. I think we have operated her last week. She had an extensive varus because she had been carrying these knees for the last 15 or 20 years. She was hardly walking. She is a retired headmistress, and the thing was, we couldn't even fit her one single knee in a single frame. So we had to take 2 separate X-rays for both the legs. So extensive varus. If we had gone by the conventional method, then it would have been very difficult to balance this knee, very difficult to get the correct alignment visually. However, we did the robotic knee surgery, and we have got a very good result with respect to the alignment, the balancing. The patient was mobilized the next day, and the most important part being that she did not require any additional augment, because X-rays like these, they usually, when we do a conventional knee replacement, we take out usually more amount of bone, and soft tissue balancing is very less. And because the bone is taken out, we need added supports, augments in the form of rods, or sometimes some additional augmentation on each of the side. So we turned out to be sort of pretty much on the safer side, because we were helped by our robo, and during each and every step of the surgery, we were able to assess what alignment was being obtained, how the balance would turn out to be after the surgery, whether the knee would remain lax after the surgery or not. So that was all predetermined. Now, conventional jig-based knee replacements, so they have their own issues. So usually what we do is we take a pre-operative X-ray film, and during the surgery we mark the anatomy and the landmarks, and we, depending upon which we place our jigs in a position which suits us the most, and which is going to give you the proper alignment. Now, these are things which are surgeon controlled, and there are a lot of variables, and a lot of errors can happen if you do not have the proper orientation with respect to the anatomical landmarks, and you can always make errors in your judgment. So therein lies the problem, because a lot of issues arise if the implant is not properly positioned, or if the tissue tensioning is imbalanced. So if you have a tighter knee on the medial aspect, or a tighter knee in the flexion attitude, then obviously the patients, they turn out to be unhappy, because the knee themselves, they don't pain. The soft tissues which are there, the soft tissue envelope which has been stripped and which has been sort of realigned, it starts paining. Now, that is why the results are not reproducible each and every time, because yesterday we did almost 3 knees back to back with similar result in each of the patients. The X-rays, you can't even make out one from the other. They are almost identical, and I'll tell you that all the 3 patients had different preoperative X-rays. They had very different deformities, and one of them was an unstable knee. So at the end of the 3 surgeries, we were able to produce the similar results. All of them started walking in the evening yesterday itself, and what happens if you don't align the joint properly and if the ligament balancing is not proper? So the long-term survivorship of the implant is less than 7 years. So you'll get a patient back in your clinic in 7 years time, and if it is not that optimal also, you can get them earlier. So implant loosening or implant failures, they tend to happen when a patient lands up for a revision surgery, and obviously they'll not be functionally at their optimum, and secondly they might have instability and poor functions. So this is an image of the Velis robotic system. This is the 4th generation robo, which utilizes a mobile robotic arm which gets attached. So it is a very small machine. So it attaches itself to the operating table, which makes our life much easier, because most of the older generation systems were quite bulky, and they almost take a place of 2 assistants, which sort of makes it very cumbersome for the surgeon to work properly throughout the sort of the position himself according to his needs. So this is the graph which we see so on the screen. So this sort of graphs we can take in sort of anywhere during the surgery. We can take a single cut and we can measure the graph. We can see how the tissues are balanced and how sort of the alignment is getting corrected. Now, there are a few basic concepts with regards to orthopedic robotic systems are that there are mainly generally 2 categories, one being the imageless system and now the other being the imagery system based on CT scans. So we have an imageless system, so we are not very dependent on a CT scan and we are not just addressing the bony landmarks, because CT scan, as we know, is just going to represent the bony landmarks, and depending upon that the surgical planning is done in those older generation robotic systems. In newer generation, we take into consideration the soft tissue balancing, which can get altered during the course of surgery as and when we take the cuts. So it sort of, the initial planning and the final outcome usually changes when the surgery is going on. Now, yeah, so the advantage of the 4th generation system is that it is an imageless system, so no preoperative CT scan is required. Only conventional X-rays are sufficient enough. We don't even need a scanogram, which is a full-length hip, knee, ankle X-ray. And surgical planning is done during the surgery, and we can make alterations to our plan at any given moment of time. It's a navigation based system, so yeah, so a lot of things can be adjusted accordingly. It is minimally invasive, and in conclusion, we have seen improved patient scores. The patient is able to bend their knees actively within a few hours once the spinal wears off, and we are able to see patients who can walk in 2 hours of surgery and they're able to go to the toilet with a walker. They don't need an assistant, and they go by themselves to the toilet, which we did not see when we did conventional knees, because patients were not able to bend their knees actively. So the functional scores are pretty good, and we have predictable outcomes because most of the times the patients behave in an identical manner. We have not seen many aberrations there. The X-rays are pretty similar, as I said. And we get out with a sort of a good soft tissue envelope because we require minimal dissection and meager blood loss. So we up till now we have done more than 50 robotic knees since we have installed this system at my place in the month of January. So we haven't had a single patient we needed to transfuse, even if we did 2 knees. And the reduced pain scores reflect in the form of the medication part being very less. The patient is managed on just 650 milligrams of paracetamol given 4 times in a day, and sometimes an oral tramadol is required. So we don't even require injectables now. So patient is pretty well managed for the first 24 hours with an injectable cocktail which is given inside the knee, and the second day the patient is shifted on oral medication. So we are completely off diclofenac and all. So we don't require that. So I would like to share some images and a short video if you're interested. So the अच्छा ते So the patient which I showed the x-rays previously, the full length x-ray which we got corrected, this is her knee. So pre-operatively when we opened up, this was the instability which was there. It was grossly lax. Oops. Walking. This was the pre-operative gait. This is second day of surgery. So I've got full correction, if you can see. She's walking well now. We haven't removed her stitches yet. And this is how it looked when the entire deformity was corrected. And here is a glimpse of how the robotic system looks like. So it is a hand-based saw system. So the cuts are pretty precise, as in we can alter the cuts in millimeters. So even if you require just a 2 millimeter cut, the robo can adjust itself and it aligns itself to the plane of the cut, and I just have to press the button and it does the rest. The most important thing being it is a semi-autonomous system, because we have autonomous systems right now, but I did not go for it by purpose, because even if you make a margin of error while registering the landmarks, the robo can offshoot of the bone, and it doesn't have a haptic feedback, so it does not stop at the soft tissue. So there have been incidences where there have been vascular injuries. So this being a completely haptic controlled and a sort of a surgeon controlled device, you'll always have the feel that you're in control. So the arrays are these are the arrays which you can see on the femur and the tibia. These are the sensors which are picked up by the high-speed cameras. They are constantly in touch with the camera system, and the saw works if and only if these things are visible. So this is how the cuts are executed, and I have a video. I'm done. Video. Yeah. So we can see that the robo aligns itself, and we have to dismount it from the machine. And once it gets aligned, you just have to press the button and take the cut. So it's hardly a 7-minute job, which used to take me almost half an hour. The cuts can be executed in a single go. We don't require any additional jig or any additional instrument to check that. And all cuts can be verified with the robo, whether we are in the given limits. Okay. So with this video, I'd like to conclude my presentation.
Thank you, Mangesh. Thank you for an excellent presentation. Thank you for enlightening us about these new things. There are many myths still about the knee surgeries, and so robotics coming up and the technological improvements that have been there, it would be very useful. We need to educate the people, also the doctors, regarding these new improvements. Also, you gave us the gist about conventional jig-based approach versus the newer types, and the recent advances pertaining to the 4th generation imageless systems and the usefulness of it, and obviously the smooth post-op recovery. So obviously this is a boon to our patients who suffer from these knee problems.
These guys are coming up with the hip module also now.
Okay.
So we have got unicondylar, which will be launching in the month of probably June or July. And unicondylars, they have their own indications. And once the hip comes, this machine will be a great asset to our area.
Okay, thank you. In view of time constraints, we won't be taking any questions. If there are any questions, he will be happy to answer in the audience. Thank you.
Thank you.
I request Dr. Bharat Pawar sir to felicitate our speaker. I request Nitinani sir to join the felicitation. I request Dr. Sanjay Deshpande sir to deliver a talk on.
Hello. Good morning, everybody. Our next speaker is Dr. Sanjay Deshpande sir. He will be speaking on digisexuality. Dr. Deshpande is past chairperson of Council of Sex Education and Parenthood International. He is Assistant Secretary AOFS, Honorary Secretary Indian Andropause Society. He is past President IMA Maharashtra State, past President Indian Medical Association Nagpur. He has many awards. He has been recipient of Golden Lamp Award CSEPI, Best Honorary Secretary and President of IMA and State at national level, Sunrise Peace Mission Yogi Manohar Vaidyakiya Seva Ratna Puraskar. The mic is over to you, Dr. Deshpande.
Thank you, dear chairpersons. In fact, I must thank Dr. Santosh Khadtare for allowing me to be here, rescheduling my lecture, which was supposed to be on yesterday because of some emergency situations. So thank you, Santosh. The first disclaimer before I start my topic is that previous speakers have spoken on their personal experiences with robots. I have nothing personal experience about this digisexuality. So that is first disclaimer. Friends, our life has become complex nowadays. Previously it was only the man and the animals, but now the man, animal and machines all are together living in this world, and we have to adjust with them. And many aspects of our lives are being transformed by technology, including how we feel and express our sexuality. Because sex is not only the peno-vaginal intercourse or the vaginal intercourse. It's a union of two souls. I always remember our very senior sexologist, who is no more now, Dr. Vittal Prabhu. He used to say that sexual intercourse is not only maithun. Marathit दोन शब्द आहे, मैथुन आणि संभोग. So what maithun is sexual intercourse. When penis goes inside the vagina, it can be called as maithun. But sambhog is even more than that. It is not only physical, but it is mental as well as spiritual intercourse. Samabhog, both the partners should enjoy simultaneously in an equal fashion. So that is samabhog. दोघांनी सम असा भोगायला हवा असा तो अनुभव त्याला आपण संभोग म्हणतो. But because of nowadays many advances in technology, the worst advantage or the worst disadvantage I can say is because of machine is that we are losing contacts with each other. But nowadays it has become a necessity also. And that's why we have to think and discuss about this digisexuality. It may not be a reality right now, or maybe very exceptional human beings are using this, not only in India but in Western world also. But definitely it can come in a big way. Now we can instantly talk with our lovers, our intimate partners. Gone are the days when husband used to be away from the wife and then he used to come only once in a year or so and have the sexual relationship. Nowadays, even video chats and everything is available. So these are all modes of telesex communication. How purposefully included sex sculptures in this, because that is what ancient India has. We have our speciality. When the whole world were not discussing anything about sexuality, our temples and our caves were having the good depiction of sex and sex cultures. WhatsApp, very important and very useful tool nowadays for two lovers interacting with each other, either by texting or by video calls, sex chats, sex toys, and sex dolls. So these are all what used to be or what is being used till now or in current situations, except the sex robots. No, it started in 16th century when some sailors from France and Japan, they started preparing the masturbation puppets, because these sailors used to go for months or years together away from their families. So the sex doll was the first sex doll was prepared by these sailors with just some cloths, leathers. Then in 1968, the first doll was prepared. It was an inflatable doll and was advertised in pornographic magazines. These sex dolls were inflatable with air consisting of penetration areas, mouth, vagina, or anus. However, due to their inflatable nature, they used to get spoiled very early. So then the material means this advancement start taking place, and then latex and silicone were used, and then full-fledged, realistic, posable and life-size sex dolls were marketed in the world. Of course, mostly in the US and other Western world. And in 2009, they started using platinum-cured material instead of tin-cured silicone to further enhance the durability and lifelike nature of the doll. So the nature of the doll nowadays is like a real human being. And if added with artificial intelligence, then it becomes a robot. It is estimated that in 2050, just around 26 years after, it will be perfectly normal for women and men to experience love and sex with robots. This futurologist, Ian Pearson, he predicted that by 2050, women and men will have more sex with robots than with their spouses or partners. So what were the sex toys? Sex toys first came, then sex dolls, and then sex robots. These are nothing but the human body parts, mostly dildos, which we know that penis-shaped, and vibrators. Vaginas are also there. They are widely used and normalized. The lifetime prevalence of vibrator use, for example, is approximately 50% in the heterosexual in United States. In the digital age, sex toys are becoming increasingly technologically advanced. Vibrators having integrated cameras now available that can be remotely controlled by a partner in a long-distance sexual relationship. Because long-distance sexual relationships have become a norm now. Husband is in India, wife is at some another place in United States or in Europe, or husband is in Europe or United States and wife is in India. Or even in India, they are far away from each other. And because of that, these new inventions are taking place. Only one thing is that use of sex toys is illegal in India. There is one law that they says that use is not illegal, but sale of sex toys is illegal in India. The law is sale is illegal. This Ambrosio Vibe, a so-called bionic dildo, which provides haptic biofeedback while strapped. So person can experience some erotic feelings while using this. This haptic way is that they stimulate the muscle as well as the nerves ending through electrical stimuli. These are sex dolls, just like human beings. They look like human beings. Anatomically correct anthropometric dolls of different. Usually, the thought process started by seeing the mannequins which we used for CPR and other things. The scientists started thinking on that line and then made a human-looking sex dolls. they are called as love dolls nowadays. People don't want to say sex dolls, so they call love dolls. And they say that it is not only for the sex purpose, but being as a companion, also they are used. They come in different genders, races, ages, body types, customized. Abstract sex dolls have no resemblance with any real person. But the portrait sex dolls they are designed like a real person. A person can get it customizedly prepared, either by the face of a porn star, celebrity, or ex-partner, or a current partner, whatever it may be. So this is nothing but what my topic is, why we called it digisexuality. The sex robots are used, and the use of sex robots in sexual life is called as digisexual, and that's why I named it as a digisexuality. So males robots are called as male bots or man bots, and females are called as femme bots or chick bots. Gender neutral terms are also used. They are called as sex droid or pleasure bot. So these are various types of sex doll, hyper realistic sex dolls. There are several companies that create silicone sex dolls that both look and feel like real people. They offer customers diverse customization options, including hair color, nipple style, body shape, makeup styles. One of the most popular is Abyss Creations in the United States, which makes the real doll that is also developing a talking robot. Japanese companies also rival in this realism, as their culture has strong appreciation for dolls. Chatbots, many of us know it. Humanoid robots. This was one of my part of my presentation where I talked on future of sex in future, what sex will be. That future of sex can be remote intimacy, internet connected sex toys, teledildonics, long distance kissing devices, VR haptic body suits, and connected pillows. So person can listen to the heartbeats and everything at a distant level, so that just a partner is present there, he or she can feel the presence of the partner. Remote sex is a sex between two or more people who are not in the same place, yet are connected through the internet. People often use electronic sex toys operated by computers or devices that use data to boost the experience and share the pleasure. They transmit the sensation through touch sensors to help long distance partners arouse each other. That is what is haptic. Super connected sex toys is interactive sex shows, participatory porn. We are discussing about effects and side effects and bad effects of pornography, but participatory porn is also nowadays maybe a future, that one can participate in sexual activity, at least on the screen, and experience that through the haptic ways. Teledildonic virtual sex words, computer generated words, and massively multiplayer online sex games are beginning to support remote sex devices. So when the avatars are having sex, the people behind the computer can feel the action through the synchronized sex toys. Long distance sex, pansexual social networks, remote sex workers, even commercial sex workers also can have the clients from the long distance. Now these sex dolls or sex robots, it's not very, very easy and cheap source of sexual gratification. So people have brothels also. Means in United States they have brothel also, but then later on it was stopped because of the anti-movement by the residents and public. Holograph. We know holograms and everything. People used to do it for canvassing in Lok Sabha elections last year. But these holograms also can be used nowadays for making love with the distant partner. Virtual sex through telecommunication, seductive artificial intelligence, creating the atmosphere, immersive environment. Just as we see in Singapore and everywhere, the 3D or 5D environment, and we experience the same feelings. Same thing is with this immersive entertainment, multi-sensory experiences, blended sexual environments. This very, very long list. I'm not going into the details of it. Wearable sex performance. Now, what is the use of these sex dolls? Because if there is a market, there are users. And if there are users, mean there must be some uses. Maybe one may like or not. So it is a recreational and long-term use at home. Those who can afford can buy this. Social companionship, sexual exploration, pleasure, increased satisfaction. Disadvantage means strong negative effect in terms of objectification and violence against women. Because of this very wide use of pornography, the violence against women has increased. People see that women is just a tool of sexual gratification, and that is wrong. There are many gender scientists, they feel that if it starts very much in the society, then people will feel that this is only female body, not a soul, and that all the problems will arise out of it. Even adolescent girls, women, because of the mass media nowadays, everybody wants to look beautiful. And if these sex toys and sex robots are so beautiful and perfectly having a perfect figure, then its impact on the adolescent girls and young women will be very large. So that will also have adverse effect. So are these only selecting one gender? Are these sex toys? Previously what used to happen, sex toys were only for women, like dildos and vibrators. But now because of shift of sex dolls and sex robots, now the shift is only for the men. So there may be chances that robotic males, robo males also will be used. And I always say that in our ancient history, somebody say it mythology, but I say it ancient history. आपल्या पुराणातल्या गोष्टी जर आपण ऐकल्या, so what we know that Shankar has given a birth to Kartikeya without any help from Parvati. Or Parvati also gave birth to Lord Ganesha without any help from Shankar किंवा महादेव. कदाचित तसंच पिक्चर पुढचे काही दिवसानंतर पाहायला मिळू शकते. A man will not need a woman or a woman may not need a man. Do we want such atmosphere or life in future that we have to answer it? So commercial use, everything. There are some therapeutic uses. I just will tell one, that people say that like in sex therapy, sex counseling, we can use it because there will be a partner like situation and there will not be a huge performance pressure. So person can have a good sexual excitement as well as the treatment for erectile dysfunction or other sexual dysfunction can be very well be done because of that. Or body therapists, sex therapists also can use this. There were questions from even sex workers also that we will be extinct from the society because the role of prostitutes will be taken by sex dolls or sex robo. So will that be a future? So there are many questions, but the claim benefits are that they can be used as surrogates, body therapists, or they can be used in sex therapy for having a good result. But the question is that will that be a boon or curse? I left the answer. I wish that you answer it yourself. Thank you very much.
Thank you, sir. Thank you, sir. It was an elaborative lecture and it showed how modern science has helped in this field, right from sculptures to love robots. But what I feel, as you initially mentioned, it will be only Maithun with a robot and the Sambhog will be only with a live female only, sir. Thank you, sir.
So live partner in live situation is more important. Thank you.
I request Dr. Nitin Rane sir to felicitate our speaker, Dr. Sanjay Deshpande sir. Also Bharat Pawar sir to join the felicitation.
After this, we'll proceed for the important function of the day, inauguration.
I would like to make one important announcement. The checkout time for rooms is 12 o'clock. So I would request everyone to please...
Dr. Padmaja and Pradnya to please come forward and take the charge.
We'll be going ahead with the...
Good morning, everyone and all. I would like to welcome you all on this lovely morning on behalf of IMA AKLUJ. It's an honor to stand before you all and to welcome our esteemed IMA leaders on the occasion of 14th Indian Medical Association Maharashtra State Women Doctors Week Conference EVECON 2024, hosted by Indian Medical Association AKLUJ GENEXT 2024 on 4th and 5th May in the beauty of Panchgani. We embark on this journey of knowledge, sharing for excellence in our practice and for the better service of our patients. So, we must embrace the innovations and the new technologies like lasers and robotics to improve and evolve as professionals. Let's rededicate ourselves to the pursuit of knowledge and the advancement in this medical science for the betterment of our patients. These 2 days, we had a wonderful academic feast covering the use of lasers and robotics in all the fields of medicine, the dermat, ophthal, gynec, onco, surgery, fetal, and general medicine. We have received an overwhelmed response from all IMA doctors all over the Maharashtra. Now, friends, we will proceed to the most important and the most awaited part, the inaugural function of this conference. I welcome all the esteemed IMA leaders on behalf of IMA AKLUJ once again. Now I request Dr. Khadtare sir to kindly escort the chief guest of today's ceremony, Dr. Shivkumar Uttare sir, National Vice President, IMA Headquarters, New Delhi, and past Maharashtra Medical Council President, IMA Maharashtra, onto the stage. Now I request Dr. Sanjay Seth sir to kindly escort President Dr. Dinesh Thakre sir, President, IMA Maharashtra State. I request Dr. Nikhil sir to kindly escort guest of honor Dr. Ravi Panchgani sir, past President, IMA Headquarters, New Delhi. Now, I request Dr. Nitin Rane sir to kindly escort Dr. Jayesh Lele sir, past Vice President, IMA Headquarters, New Delhi. I request Dr. Amol Shinde sir to kindly escort Dr. Anil Pachnekar sir, National Vice President, Aao Gaon Chale Project. I request Dr. Aniket Inanda sir to kindly escort Dr. Jayant Navrange sir, past Chairman, Social Security Scheme, IMA Maharashtra State. I request Dr. Rohit Pade to kindly escort Dr. Vikrant Desai sir, Treasurer, IMA Maharashtra State. I request Dr. Puzar ma'am to kindly escort Dr. Meena Vankhedkar ma'am, past President, Women's Doctors Wing, IMA Headquarters, Delhi. It is indeed a great fortune for us to conduct this ceremony in the esteemed presence of Dr. Ram Arankar sir. I request Dr. Khadtare sir to kindly escort Dr. Ram Arankar sir, past President, IMA Maharashtra State. I request Dr. Sanjay Seth sir to kindly escort Dr. Bakulesh Mehta sir, past President, IMA Maharashtra.
request Dr. Nitin Rane sir to kindly escort Dr. Nitin Godpade sir, Vice President, IMA Maharashtra State.
I request Dr. Khattare ma'am to kindly escort Dr. Asha Jadhav ma'am, Joint Secretary, IMA Maharashtra State.
I request Dr. Digvijay Rao to kindly escort Dr. Yashwant Gade sir, Chairman Ao Gaon Chile, IMA.
I request Dr. Rohit Khade sir to kindly escort Dr. Prakash Marathe sir, Past President, IMA Pune, Honorary Secretary, Social Security Scheme, IMA Maharashtra.
I request Dr. Khattare sir to please join the dignitaries on the stage. Khattare sir is immediate past president, IMA AKLUJ, CWC member, IMA Maharashtra State and organizing chairman, EVECON 2024.
I request Dr. Savita Gujar ma'am to kindly be on the dais and join the dignitaries, Women's Wing IMA AKLUJ in charge and organizing secretary, EVECON 2024.
I request Dr. Sanjay Singh sir, President IMA AKLUJ and organizing secretary, EVECON 2024 to kindly join the dignitaries on the stage.
I request Dr. Nikhil Dani sir to kindly be on the dais with the dignitaries as the secretary of IMA AKLUJ.
I request Dr. Nikhil Misar, Treasurer IMA AKLUJ to kindly join the dignitaries on the
Now, the most awaited person, not last but the least, Dr. Reti Rani, Chairman, Women's Doctors Wing, IMA Maharashtra State, and the organizing chamber and the backbone of today's conference, EVECON 2024.
stand up for the IMA prayer. Please repeat after me. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure.
Now we'll proceed with the flag salutation. Please do not repeat. We, the members of Indian Medical Association, stand before here to salute our national flag. It's an honor and a glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, long live IMA. Dignitaries on the stage, kindly proceed for the lamp lighting ceremony.
I would request Dr. Revati Rane to kindly take us through this journey of EVECON in a few words.
Hello. Respected dignitaries on dais, all the delegates who have joined here online and offline, faculty members, my friends and colleagues. On behalf of IMA Women Doctors Wing Maharashtra State and IMA AKLUJ, I welcome you all for this official inauguration of 14th Maharashtra State WDW Conference, EVECON. I must say that on the 23rd February, I got to know that I have been appointed as a chairman of WDW. And I have to confess that it was out of the blue and I wasn't very much ready for that, because I knew it is a mammoth task of arranging EVECON and taking the responsibility of being a chairperson or chairman of the whole Women Doctors Wing. Because you have to lead the women who are already empowered and who are already strong and be the light holder for them. So in that 2 months, we did Life Beyond Medicine 2 episodes, which also got good response. And we had this task of arranging EVECON. It wouldn't have been possible in just 2 months without the active participation of IMA AKLUJ. I must say to everyone that we are a very small society, but we are united and we have so much strength within us that everyone has worked beyond and the scope as his or own post and has done work for many. So the great round of applause to the whole IMA AKLUJ. I wouldn't say just the committee, the IMA AKLUJ, and the supporters, even the supporters behind that, because even the non-IMA members here, the spouses, they have been so supporting that everyone can put in efforts and work for that. The theme we chose for this was robotics and laser, which was really little bit difficult because to find the speakers for that within that short period of time was difficult. But we could manage, and I'm very happy that everyone has given the inputs that they like the content of the conference. The scientific content was very good, and even we could, able to reflect that in the banquet and the cultural theme. Everyone was surprised, robotic dance ka asto kiva laser dance, but we could see yesterday that everyone can do robotic dance. We might learn robotic and laser later on in our practice, but robotic dance everyone can do now. So here we are celebrating this wonderful conference, and everyone has traveled here from all the places from Maharashtra. So I really thank you all for that, and thank you once again. Thank you.
Thank you, Revati. Now I ask Dr. Santosh Khadtare sir to kindly welcome all the IMA dignitaries.
सर्वांना नमस्कार. आज इंडियन मेडिकल असोसिएशन महाराष्ट्र स्टेट वुमन डॉक्टर विंग कॉन्फरन्स या ठिकाणी साजरी करत असताना या उद्घाटन सोहळ्याचे प्रमुख या ठिकाणी आपल्याला चीफ गेस्ट म्हणून लाभलेले IMA नॅशनल हेडक्वार्टरचे व्हाईस प्रेसिडेंट, महाराष्ट्र मेडिकल काउन्सिलचे माजी अध्यक्ष आदरणीय डॉक्टर शिवकुमार उत्तुरे सर, या ठिकाणी अध्यक्ष म्हणून आपल्याला लाभलेले इंडियन मेडिकल असोसिएशन महाराष्ट्र स्टेटचे कर्तबगार आणि अतिशय सिन्सिअर व्यक्तिमत्व डॉक्टर दिनेश ठाकरे सर, गेस्ट ऑफ ऑनर म्हणून या ठिकाणी आपण ज्यांना आमंत्रित केलेले आहे असे पास्ट नॅशनल प्रेसिडेंट, पास्ट ट्रेझरर वर्ल्ड मेडिकल असोसिएशन, पास्ट प्रेसिडेंट सार्क मेडिकल असोसिएशन, ज्यांच्या नावातच सूर्य आहे, रवी आहे, असे डॉक्टर रवी वानखेडकर सर. त्याचप्रमाणे पास्ट चेअरमन वुमन डॉक्टर विंग IMA हेडक्वार्टर डॉक्टर मीना वानखेडकर मॅडम, पास्ट व्हाईस प्रेसिडेंट IMA नॅशनल. आपणा सर्वांना माहीत आहे की रामदेव बाबांना ज्यांनी उघड विरोध केला, ज्यांच्या विरोधात केस टाकली आणि ती केस जिंकली, असे डॉक्टर जयेश लेले सर. कायम हसतमुख असणारे IMA महाराष्ट्राचे माजी अध्यक्ष डॉक्टर जयेश लेले सर. खरं तर पास्ट चेअरमन IMA सोशल सिक्युरिटी स्कीम डॉक्टर जयंत नवरंगे सर. IMA महाराष्ट्राचे ट्रेझरर ज्यांनी अतिशय सुंदर काल गायन केलं असे तरुण तडफदार डॉक्टर विक्रांत देसाई सर. या सर्वांची मी नावं आपणासमोर घेतली, परंतु ही घेत असतानाच ज्यांच्या नावानं मी माझ्या भाषणाची सुरुवात करायला पाहिजे होती अशा काही व्यक्ती या ठिकाणी उपस्थित आहेत, ज्यांचं बोट धरून मी इंडियन मेडिकल असोसिएशनमध्ये आलो, असे ऋषितुल्य व्यक्तिमत्व डॉक्टर राम आरणकर सर. वय वर्ष 84 असताना IMAच्या सर्व मीटिंग अटेंड करणं, या ठिकाणी सर्व ठिकाणी एका फोनवरती या ठिकाणी हजर असलेले आणि नॅशनल IMAमध्ये ज्यांच्या शब्दाला मान आहे असे आदरणीय डॉक्टर बकुलेश मेहता सर. जे आज या ठिकाणी आपल्या इथं उपस्थित नाहीत, परंतु त्यांच्या उपस्थितीत आपण हा कार्यक्रम करणार होतो असे पश्चिम महाराष्ट्राच्या IMAचे नेते डॉक्टर अशोक तांबे सर. त्यांचा मला या ठिकाणी उल्लेख करावा असा वाटतो त्यांच्या नावाचा. त्याचप्रमाणे या ठिकाणी IMAचे व्हाईस प्रेसिडेंट डॉक्टर नितीन गोरपडे सर, जॉईंट सेक्रेटरी डॉक्टर आशा जाधव मॅडम, खास IMA संभाजीनगरहून या ठिकाणी उपस्थित असलेले डॉक्टर यशवंत गाडे सर. या ठिकाणी सर्वच खूप डिग्निटरीज या ठिकाणी आहेत. इंडियन मेडिकल असोसिएशन सोशल सिक्युरिटी स्कीमचे सेक्रेटरी डॉक्टर प्रकाश मराठे सर. IMA अकलूजचे सर्व या ठिकाणी उपस्थित पदाधिकारी. कॉन्फरन्स आहे वुमन डॉक्टर विंगची, चेअरमनचं नाव घेतलंच पाहिजे डॉक्टर रेवती राणे मॅडम. खास IMA नाशिक रोडहून या ठिकाणी उपस्थित असलेल्या IMA WDWच्या को चेअरमन डॉक्टर स्वप्नांजली आव्हाड मॅडम. कन्व्हेनर डॉक्टर सुप्रिया आरवारे मॅडम. घेतलं ना डॉक्टर अनिल पाचलेकर सरांचं नाव घेतल्याशिवाय भाषणच सुरू होणार नाही, कारण सर मला गुलगुल्या या शब्दामध्ये बोलतात, त्यामुळं पाच प्रेसिडेंट म्हणून त्यांचं नाव घेतलेलं आहे. कन्व्हेनर डॉक्टर सुप्रिया आरवारे मॅडम. या ठिकाणी वुमन डॉक्टर विंगमध्ये असणाऱ्या डॉक्टर सुनीता कारण्या मॅडम, डॉक्टर उज्ज्वला शिरसाट मॅडम. IMA पंढरपूरचे अध्यक्ष डॉक्टर सुनील कारंडे सर. खासून या ठिकाणी देसाई मॅडम या ठिकाणी उपस्थित आहेत. आपले आत्ताचेच DG सेक्शुअलिटी या विषयावर टॉक दिलेले. खास IMA अकलूजवरती प्रेम आहे म्हणून फक्त आपल्या प्रत्येक इव्हेंटमध्ये सहभाग घेतात असे डॉक्टर संजय देशपांडे सर या ठिकाणी आहेत. डॉक्टर प्रेमा आरणकर मॅडम या ठिकाणी आहेत. डॉक्टर गाडे मॅडम या ठिकाणी आहेत. डॉक्टर नीलिमा ठाकरे मॅडम या ठिकाणी आहेत. याशिवाय कोणाचं नाव राहिलं असेल तर मी दिलगिरी व्यक्त करतो आणि आलेल्या या सर्व डिग्निटरीजचं इंडियन मेडिकल असोसिएशन अकलूजच्या वतीने सहर्ष स्वागत करतो. सुस्वागतम, सुस्वागतम, सुस्वागतम. सर, इंडियन मेडिकल असोसिएशन ही एकमेव शाखा आहे की जी भारतामध्येच नव्हे देशामध्ये सगळ्यात पहिल्यांदा 42 वर्षापूर्वी इंडियन मेडिकल असोसिएशनची ब्लड बँक असलेली ही एकमेव शाखा सध्या महाराष्ट्रामध्ये कार्यरत आहे. आणि आजपर्यंत गेल्या 42 वर्षामध्ये जवळजवळ 3,36,000 रुग्णांना ब्लड बँकेमार्फत आम्ही रक्त इश्यू केलेलं आहे. म्हणजेच एवढ्या लोकांचं प्राण वाचवण्यामध्ये आमच्या IMA अकलूजचा सहभाग आहे. खरं तर IMA अकलूज ही शाखा आम्ही रन करतोय, यामध्ये आमचे जे सर्व सिनियर डॉक्टर्स आहेत यांचा नक्कीच आम्हाला सिंहाचा वाटा त्यामध्ये आहे. यामध्ये काल रात्री या ठिकाणी उपस्थित होते डॉक्टर MK इनामदार सर यांच्या बॅकबोन ऑफ IMA अकलूज असं म्हणलं तर काही वावगं नाही. त्याचप्रमाणे डॉक्टर सतीश जोशी सर, डॉक्टर राजीव राणे सर, डॉक्टर SN कुलकर्णी सर ज्यांचा या कार्यक्रमामध्ये सक्रिय सहभाग आहे. आता काल सकाळपासून ते या ठिकाणी उपस्थितसुद्धा आहेत. हे रन करत असतानाच कार्यक्रम EVECON घ्यायचा म्हटलं तर आम्हाला पहिल्यांदा आमच्या अकलूजच्या IMAचे माजी अध्यक्ष डॉक्टर नितीन एकतपुरे सरांना विचारल्याशिवाय आम्ही सुरुवात करत नाही. या ठिकाणी आपण सर्वजण या ठिकाणी उपस्थित झाला आणि EVECON 2024 IMA महाराष्ट्र स्टेट वुमन डॉक्टर विंग हे सक्रिय यशस्वी पार पाडण्यासाठी या सर्वांचं मी सहर्ष स्वागत करतो. जर काल सकाळपासून आजपर्यंत काही त्रुटी राहिल्या असतील तर त्या नजरचुकीने राहिल्या असं समजून मी आपल्या सर्वांची क्षमा मागतो आणि मी माझे 2 शब्द संपवतो. जय हिंद.
Thank you, Khadtari sir. Now I request all our esteemed IMA leaders to kindly accept on our behalf a token of love and respect. I request Dr. Satish Doshi sir to kindly come on stage to felicitate the chief guest of our ceremony today, Dr. Shivkumar Uttare sir. I request Dr. Santosh Khadtari. I request Dr. SN Kulkarni sir to kindly come upon stage to felicitate guest president of today's program, Dr. Dinesh Thakre sir.
I request Dr. Vivek Gujar sir to kindly be on the stage to felicitate our guest of honor, Dr. Ravi Wankhedkar sir.
I request Dr. Nitin Ekatpure sir to kindly come on stage to felicitate Dr. Jayesh Lele sir.
I request Dr. Amol Shinde sir to be on the stage to felicitate Dr. Anil Patsnekar sir.
I request Dr. Suryavanshi sir to kindly come on.
सर लेले सरांचं इथे इथे सर इथे
I request Dr. Suresh Suryavanshi sir to kindly felicitate Dr. Jayant Navrange sir.
I request Dr. Sanjay Shit sir to kindly come upon stage to felicitate Dr. Vikrant Desai sir.
I request Dr. Savita Guzar madam to kindly felicitate Dr. Meena Wankhedkar ma'am.
I request Dr. Khattare sir to kindly felicitate Dr. Ram Arankar sir.
I request Dr. Harpan Ali sir to kindly felicitate Dr. Bakulesh Mehta sir. I request Dr. Nitin Rane to kindly felicitate Dr. Nitin Ghorpade sir. I request Dr. Supriya Khattare to kindly felicitate Dr. Asha Jadhav ma'am.
I request Dr. Aniket Inamdar sir to kindly felicitate Dr. Yashwant Gade sir.
I request Dr. Nikhil Misar to kindly felicitate Dr. Prakash Marathe sir. Now we will proceed towards Women Doctor Wings felicitation by the hands of IMA dignitaries. I request Dr. Shiv Kumar Utture sir kindly felicitate Dr. Revdi Rani, Chairman Women's Doctors Wing, IMA Maharashtra State.
I request Dr. Dinesh Thakre sir to kindly felicitate Dr. Swaplanjali Awad madam, WTW Co-Chairman, IMA Maharashtra State.
I request Dr. Ravi Vankadkar sir to kindly felicitate Dr. Supriya Arwari ma'am, convener WDW IMA Maharashtra State.
I request Dr. Jayesh Lele sir to kindly felicitate Dr. Ujwala Srisant madam, Executive Committee member WDW Maharashtra State.
I request Dr. Anil Pachnekar sir to kindly felicitate Dr. Sunita Karande ma'am, Executive Committee member WDW IMA Maharashtra State.
I request Dr. Jayant Navrange sir to kindly felicitate Dr. Saudamini Gandhi ma'am, Executive Committee member WDW Maharashtra State.
I request Dr. Ram Arankar sir to kindly felicitate Dr. Sanjay Deshpande sir. A special felicitation from IMA AKLUJ for travelling all the way from Nagpur for our conference. Thank you, sir. I request Dr. Nitin Ghorpade sir to kindly felicitate Dr. Karande sir, President IMA Pandharpur.
I request Dr. Wankhedkar madam to kindly felicitate Dr. Ghate madam from Sambhajinagar. Sorry, yes, Gade madam. I request Dr. Asha Jadhav madam to kindly felicitate Dr. Desai madam from Meera Bhayandar.
I request Guja ma'am to kindly felicitate Dr. Patil madam from Thane for her excellent dance performance which we all enjoyed yesterday evening. We are also happy to announce Patil ma'am has been the winner of yesterday's dance competition. Thank you, ma'am. I request Dr. Meena Wankhedkar madam to kindly felicitate Dr. Nilima ma'am. Nilima Thakre ma'am, please be on the stage.
I request Dr. Asha Jadhav madam to kindly felicitate Prema Arankar madam.
request Dr. Shivkumar Utture sir to kindly felicitate the backbone of IMA AKLUJ, Dr. Santosh Khatare sir. Please sir. Sir to kindly felicitate Dr. Sanjay Seth sir. I request Dr. Ravi Wankhedkar sir to kindly felicitate Dr. Savita Gujar ma'am, Organizing Secretary EVECON 2024 and in charge of Women's Wing IMA AKLUJ. Gujar ma'am. I request Dr. Nitin Ghorpade sir to kindly felicitate Dr. Nitin Rane sir. I request all the dignitaries on the dais to felicitate, last but not the least, Dr. Nikhil Misa sir, Treasurer of IMA AKLUJ. I request Dr. Ram Arankar sir to kindly say a few words.
Very good morning. कालपासून मी पाहतोय ही जी कॉन्फरन्स IMA AKLUJनी आयोजित केलेली आहे, खरोखर अतिशय हृद्य वातावरणामध्ये ती सादर करण्यात आली. या सगळ्यामध्ये अतिशय सुंदर असा वेन्यू, उत्कृष्ट फूड क्वालिटी, हॉस्पिटॅलिटी, सुंदर असा सायंटिफिक सेशन आणि अशा अनेक गोष्टी आहेत की खरोखरच त्यांचं किती कौतुक करावं तेवढं थोडंच आहे. या निमित्ताने मला एक गोष्ट अतिशय महत्त्वाची वाटते की ह्या सगळ्यांना जोडणारा जो दुवा आहे तो म्हणजे संतोष खडतरे. मी बघितलंय कुठलीही कॉन्फरन्स असो, मी त्यांना सांगितलं ना, अरे संतोष आपल्याला अमुक अमुक कॉन्फरन्स करायची आहे आणि तुझ्याकडून मला 100 रजिस्ट्रेशन अपेक्षित आहेत. आश्चर्य म्हणजे दुसऱ्या दिवशी 100 लोकांचे पैसे माझ्याकडे पाठवून देऊन मोकळा. माझं मी बघून घेईन काय करायचं ते. हे 100 रजिस्ट्रेशन. अतिशय शांत स्वभाव, त्याला आपण कूल हेडेड म्हणतो, सॉफ्ट स्पोकन, व्यवस्थित. आता बाकी संतोष खडतरेबद्दल काही बोलायचंच नाही. जसं रवी वानखेडकरच्या नावात रवी आहे तसं संतोषच्या नावात संतोष आहेच आहे. म्हणजे खरोखरच मला आश्चर्य वाटतं काय आपण आपल्याकडे ज्या वेळेला IMAमध्ये काम करणारी माणसं पाहतो त्याच्यामध्ये आपण 4 गोष्टी पाहतो. पहिली गोष्ट म्हणजे ती व्यक्ती कशी आहे, दुसरी गोष्ट म्हणजे ती IMA करता वेळ देऊ शकेल का. तिसरी गोष्ट म्हणजे तिच्याकडे नेतृत्व करण्याची धडाडी आहे का. आणि चौथी गोष्ट म्हणजे सर्वांना बरोबर घेऊन जाण्याची त्याची प्रवृत्ती आहे का. या सगळ्या गोष्टींचा जर विचार केला तर संतोष ही खरोखर हा एक हाडाचा तळागाळाचा कार्यकर्ता आहे हे आपल्याला मान्यच करायला पाहिजे. मित्रांनो, ह्याच प्रसंगाचं निमित्त करून मला आपल्या सगळ्यांना अशी विनंती करावी वाटते की आता पश्चिम महाराष्ट्रामध्ये ग्रामीण ब्रँचेस ज्या आहेत त्या ब्रँचेसची प्रेसिडेंटशिपची टर्न आहे. तर ह्या टर्नमध्ये एकदा मी इंदापूरचा प्रेसिडेंट झालो, तांबे बारामतीचे प्रेसिडेंट झाले. आता माझं मत असं आहे की सोलापूर जिल्ह्याला प्रतिनिधित्व म्हणून आपण संतोष खडतरेंना नामांकन द्यावं अशी माझी सर्वांना विनंती आहे. ह्या विषयावरती स्वतंत्रपणे बोलायला मी तुमच्याकडे पुन्हा येईनच. पुन्हा एकदा मला या ठिकाणी बोलवलं आणि एक अतिशय उत्कृष्ट अशी कॉन्फरन्स या ठिकाणी केली याबद्दल मी अकलूज ब्रँडचं अभिनंदन आणि कौतुक करतो.
Thank you so much, sir. And thank you for representing our Khattare sir from IMA AKLUJ as a candidate for president of IMA Maharashtra. We are really overwhelmed for your response and your love which we have showered on our IMA AKLUJ branch. Now I will request Dr. Anil Patsnikar, sir, to say a few words.
आज आपण इथे EVECON ऑर्गनाइज बाय द अकलूज ॲट द महाबळेश्वर सर्वजण उपस्थित आहोत. ऑफ द फंक्शन डॉक्टर शिवकुमार उत्तरे सर, व्हेरी thankful personality, and you know the think tank of the IMA headquarters. Really, we are proud about Dr. Shiwkumar Uttre sir. Our president, Doctor of the IMA Maharashtra, Dr. Dinesh Thakre, very cool, calm personality, but at the same time very knowledgeable and dedicated worker. What about Ravi Wankhedkar sir, the past national president, the 4-time treasurer of the World Medical Association, and absolutely knowledgeable, but his speeches makes speechless to everyone. Yes, everyone is very eager to hear his extempo speeches and all. So we really appreciate you, sir. Dr. Jayesh Lele, past president of the National IMA headquarters, known for the Ramdev Ama, and good knowledge about computer science and all. Our Navarange sir is a very good athletes as well as good in medical legal knowledge, and everybody treat him as a respectable personality, guru personality. My younger brother, the bestie of Navneet, is from Mira Bhainder, is now treasurer of the IMA Maharashtra. Very dynamic in AMC also. He has represented very well, knowledgeable, well versed about physical fitness and all. But yesterday I have seen his singing class and all, and I really appreciate, admire from bottom of my heart. So thank you very much, boss. Our Bishop Pitama of the IMA, Dr. Ramarankar sir, वागणं सुंदर, बोलणं सुंदर, स्पष्ट वक्तेपणा. Thank you, sir. Dr. Bakulesh Mehta, our cheerleader, die-hard smiling personality. Friends, इथे आज जो प्रोग्राम ऑर्गनाईज केला आहे आपल्या संतोष खडतरे साहेबांनी, ज्यांना मी फॅरेक्स बेबी म्हणून नाव ठेवलं आहे पूर्वीपासूनच, आणि गुलगुल्या म्हणून संबोधतो, कारण तो एवढा गोड वागतो आणि एवढा गोड असतो, आणि त्याचं हे पण फार सुंदर आहे हो, फार सुंदर गातो हा माणूस एकदम. म्हणजे आय एम रिअली सरप्राईज की स्टेज कॉन्फिडन्स आज खूप सुंदर आहे गाण्यामध्ये, आणि गाताना तो नाचतोही, हे महत्त्वाचं आहे. त्यामुळे आय रिअली लव दिस काइंड ऑफ पर्सनॅलिटीज, की काल तुमचा तो अमोल मला आवडला, त्याचं वागणं बोलणं, म्हणजे मिमिक्री करू शकतो, गाऊ शकतो, प्रोग्राम कम्पेअर करू शकतो. या अशा कला आपण जपून ठेवल्या पाहिजेत. फ्रेंड्स, मला मी एम्सकॉन अटेंड केली होती, तुमची अकलूजला होती. त्यावेळेलाही संतोष खडतरेने संपूर्ण लेडीज विंग उभी करून ठेवली होती फॉर द एम्सकॉनसाठी. म्हणजे क्रेडिटेबल, संपूर्ण सगळ्या लेडीजच होत्या टोटल, फक्त एकच संतोष जैन दिसत होता मला त्याच्यामध्ये. म्हणजे दॅट इज युअर कॅपॅसिटी, क्रेडिटेबिलिटी, की काम करण्याची पद्धत. आता इथे अकलूजला त्यांनी सेक्सकॉन पण ऑर्गनाईज केलेली आहे, फलटणला पण कॉन्फरन्स ऑर्गनाईज केलेली आहे. म्हणजे इज अ मास्टर इन ऑर्गनायझिंग कॉन्फरन्सेस अँड ऑल, डेडिकेटेड वर्कर. फ्रेंड्स, आता इलेक्शन आलेले आहेत, आपल्याला चान्स आहे प्रत्येक कॅन्डिडेटला भेटा, आपल्या सेंटरचा हेल्थ मॅनिफेस्टो त्याच्या हातात द्या. आपल्या ज्या व्यथा आहेत की अटॅक ऑन द डॉक्टर्स, बायोमेडिकल वेस्ट, महाराष्ट्र पोल्युशन कंट्रोल बोर्ड, नर्सिंग होम ॲक्ट, याविषयी थोडं सविस्तर त्यांच्याशी बोला, त्यांच्या कानावर पडून द्या थोडे चार शब्द. काही काही लोकांना तर 12वी झालेले नसतात, तरी पण त्यांच्या कानावर थोडे शब्द पडले तर त्या पुढे आपल्याला फायदा होईल, की हे शब्द ऐकले होते म्हणून इलेक्शनच्या अगोदर, आणि ते त्याबद्दल ते संसदेत आपले प्रश्न मांडायचा प्रयत्न करतील. आणि मी तुमचा जास्त वेळ घेणार नाही. आता मेडिकल फॅटर्निटी इज गोईंग थ्रू द क्रायसिस, अँड इंडियन मेडिकल असोसिएशन इज अवर बिग एक्सटेंडेड फॅमिली. आता इथे एखाद पुढे जाणार, बाकीचे थोडे मागे राहणार, बाकीचे काही कट्टू हेवी दावे असतात, पण मग तेच मनात ठेवू नका, तेच मनात घेऊन चालू नका. एकमेकाशी ओपनली बोला, हॅव अ कन्व्हर्सेशन, रेग्युलर भेटत जा. त्याने काय होतं, वाद मिटतात, मनातला कटुता कमी होते, परत आपण एकत्र येतो, वाढतो. बिकॉज आपल्यावरती होणाऱ्या आघाताचा जर सामना करायचा असेल तर वी हॅव टू बी युनायटेड, अँड वी आर इन डेमोक्रेसी. डेमोक्रेसी इज अ गेम ऑफ नंबर. इफ यू आर युनायटेड यू आर गोइंग टू विन. इफ यू आर डिवायडेड नोबडी इज गोइंग टू टेक केअर ऑफ अस अँड ऑल. सो मी जास्त काही सांगणार नाही, बट प्लीज एन्जॉय द big extended family life. Thank you very much. Thanks a lot.
Thank you, sir, for wonderful and encouraging words. I now request Dr. Jayesh Lele, sir, to kindly address the gathering.
Today, Dr. Shivkumar Utture, Vice President, President Dr. Thakre, IMA Maharashtra State, Dr. Ravi Wankhedkar, Dr. Anil, Dr. Ram Arankar sir, my very close friend, Dr. Bakulesh, Dr. Navrange, and all the team, and Ache Utsav Murti, Dr. Santosh Khadtare. And very correctly, I remember somebody just now mentioned the registration comes from him like anything, because when we had arranged EVECON, I think about 10 years back, and we had requested, and he immediately sent a registration. So definitely today's program, I really congratulate the entire IMA AKLUJ team for organizing this great event. Very reciprocal, very informative, especially the yesterday's 4 or 5 lectures which I happened to listen. I got this robots and lasers and other things, very informative. And today we are really working in Maharashtra is leading the front in all the respects of this technological, and I am very much a technology man, and I was really very happy to see that all our doctors, even the inroads inside Maharashtra also, not only Mumbai, even though I am coming from Mumbai, these facilities are available, but outside also they are available in small places, and really it's really worth it. And I am really happy that today's attendance also has been very good. Since I am coming from headquarters, my request to Dr. Santosh would be, Santosh, please listen to me. So I would request the IMA AKLUJ team that IMA headquarters is building a new building now, which is many of you must have seen there whenever you have visited. So we are constructing a new building which will go for demolition in another 2-3 months' time, and mostly it will take about 3 years. At present, the building is about 35,000 square feet, which is going to be made about 80,000 square feet, and we need some funds we are gathering from Maharashtra also. We are given individually also, we are giving. IMA branches also are giving. So whatever contribution we are getting it from the various funds, we should contribute. You can open the app, you can go to the website, directly you can pay. Even if a member pays 1,000 rupees, we'll be happy. So I would request Santosh to please give some money to the IMA headquarters, and please inform to the Maharashtra state so that we can collectively say how much Maharashtra has contributed. Today IMA Maharashtra is nearly 50,000 members, and still we are adding more and more members, largest. But our contribution is at the moment, I think, number 4, I think, Dr. Utture. It is not number 1. So we should go slightly above. Of course, Gujarat is number 1. They have crossed way ahead of us, but definitely we can make some difference. And we are fighting almost a lot of issues, whether it's a Human Rights Commission, whether it's various cases, whether it's medical terminologies or writing. Yesterday somebody mentioned in one of the talks that not writing a capital letter, he got a punishment because there was a scene in the newspaper. So we are working on that, and our IMA's headquarters is versatile in nature. Lot of acts which are against the common faculty, which we are opposing it. Another 2 very important wings we are promoting is a medical student network and junior doctor network, because ultimately they will be the future of the medical faculty today, what we are having it. Many of us have done the medical practice maybe 20-30 years, but those students who are learning, they will be there, and we have offered them for 3 to 4 years deemed membership by just paying 1,000 to junior doctor networks, and for 500 rupees for 5 years medical student network. So they can participate in all the IMA activities, and we are promoting every branch in the vicinity, wherever there is a medical college, should actively get involved in joining those students, MSN and JDN, and help them to know what is IMA, because we have to nourish them, we have to see that those students do much more in future life, and then they will preserve the medical fraternity, because a lot of difficult laws are going to be pushed on us and we have to fight it out. So IMA is doing that. Definitely, yesterday I mentioned another one very important, IMA's National Health Scheme, which is for the members. I would request Dr. Santosh to send the forms to everybody. Those who can join, it will be very helpful. And Dr. Arankar sir, you know very well, is the Karta of the Social Security Scheme. Even Dr. Nauranga sir, they are promoting it. So similarly, it is for the members. We are going to help out a needy person wherever there is an issue. Once again, I thank the entire IMA AKLUJ and IMA Maharashtra for organizing this very successful event. Congratulations and all the best.
Thank you, sir. Now I request the most dynamic personality of IMA, Dr. Ravi Vans.
ज्यांचं आयुष्य जरी लहान होतं, पण त्यांचं कर्तृत्व जगात महान होतं, आणि त्या मातीत आपण जन्मलो याचा आपल्याला सार्थ अभिमान आहे. असा पहिला मानाचा मुजरा त्या शिवछत्रपतींना. कारण आपल्या प्रत्येकाच्या मनामनात, रोमारोमात, कणाकणात छत्रपती असले पाहिजे, ते भिनले पाहिजे, त्यांचे विचार भिनले पाहिजे. दुनिया की पहचान है औरत, दुनिया की पहचान है औरत, हर घर की शान है औरत. बेटी, बहन, पत्नी, माँ बनकर घर घर की जान है औरत. या सगळ्या माता माऊलींना माझा दुसरा मानाचा मुजरा. जिथे भक्ती, शक्ती, सेवा आणि समर्पणाची भावना आहे, अशी देशातील एक अत्यंत व्हायब्रंट IMA अकलूज ब्रांच त्याला माझा तिसरा मानाचा मुजरा. आजच्या या उद्घाटन सोहळ्याचे प्रमुख अतिथी माझे सन्मित्र राष्ट्रीय IMA चे उपाध्यक्ष, ज्यांना आम्ही थिंकिंग पर्सनॅलिटी म्हणतो, असे डॉक्टर शिवकुमार उत्तुरे सर. अत्यंत बहुआयामी व्यक्तिमत्व. तुम्हाला बऱ्याच लोकांना कल्पना नसेल, पण आपले राज्याचे अध्यक्ष डॉक्टर दिनेश ठाकरे यांचा कायद्याच्या बाबतीत, पुस्तक लिहिण्याच्या बाबतीत, एथिक्सच्या बाबतीत, लेखनाचा, कविता करण्याचा दांडगा अनुभव असलेले डॉक्टर दिनेश ठाकरे अत्यंत सिन्सिअरली, डेडिकेटेडली, कोणालाही न घाबरता आपल्या मताशी आणि आपल्या फ्रॅटर्निटीशी कायम एक प्रकारचं नातं जोडून ठेवलेले आपले माजी सेक्रेटरी जनरल, माजी राष्ट्रीय उपाध्यक्ष, महाराष्ट्र IMA चे माजी अध्यक्ष, आमचे मोठे बंधू डॉक्टर जयेश लेले सर. या ठिकाणी ज्यांना मी हरदिल अजीज असं एक व्यक्तिमत्व जे आहे आणि ज्याला मी नेहमी IMA चा हिरो नंबर 1 म्हणतो, ते IMA चे माजी राष्ट्रीय उपाध्यक्ष, IMA महाराष्ट्राचे माजी अध्यक्ष डॉक्टर अनिल पासनेकर सर. तसे ते नात्याने माझे सासरे लागतात. जरी जावायला काहीच देत नाही आणि प्रत्येक वेळेला काहीही मागितलं तर म्हणतं मुलगी दिली हेच तुला खूप झालं. असे चिरतरुण व्यक्तिमत्व आणि ज्यांना मी नेहमी जेंटल जायंट म्हणतो. आणि याही वयात IMA साठी कुठेही कधीही हजर राहणारे महाराष्ट्र राज्याचे माजी अध्यक्ष डॉक्टर बकुलेश मेहता सर. अत्यंत गुरुतुल्य व्यक्तिमत्व. अत्यंत शांतपणे परंतु मोलाचा सल्ला आणि मार्गदर्शनात ज्यांच्या मार्गदर्शनाखाली आम्ही काम करतो, ते महाराष्ट्र राज्याचे माजी अध्यक्ष आपल्या सगळ्यांचे लाडके डॉक्टर अरणकर सर. या ठिकाणी डॉक्टर नवरंगे सर इथे उपस्थित आहेत. ते आमचे गुरु देखील आहेत आणि आदर्श देखील आहेत. आदर्श या अर्थाने मी म्हणतो, त्यांनी मनात आणलं असतं ते कधीही महाराष्ट्र राज्याचे अध्यक्ष झाले असते. नॅशनल IMA कुठलंही पद त्यांच्यासाठी कधीही खुलं होतं, परंतु अत्यंत दुसऱ्यांना पुढे करायचं आणि कुठल्याही पदाची अभिलाषा न बाळगता जे भारतभर ज्यांच्या शब्दाला मेडिको लिगल क्षेत्रात अतिशय मोठं वजन आहे, ते आमचे गुरुवर्य डॉक्टर जयंत नवरंगे सर. अत्यंत जिंदादिल कपलच तसं आहे. आमचा लहान भाऊ आणि महाराष्ट्र राज्याचा कोषाध्यक्ष विक्रांत आणि नवनीत. राष्ट्रीय IMA CGP चे सहसचिव खास औरंगाबादहून आलेले डॉक्टर यशवंत गाडे साहेब. IMA वुमन्स विंगच्या माजी राष्ट्रीय अध्यक्षा डॉक्टर मीना. महाराष्ट्राचे उपाध्यक्ष नितीन. सहसचिव जाधव मॅडम. या ठिकाणी आमचे सन्मित्र संजयजी देशपांडे आलेले आहेत. कन्व्हेनर अरवरी, स्वप्नांजली आणि IMA अकलूजची संपूर्ण टीम. प्रकाश मराठे सर अतिशय सिन्सिअरली, प्रामाणिकपणे महाराष्ट्र स्टेट सोशल सिक्युरिटी स्कीम सगळीकडे प्रत्येक ब्रँचमध्ये पसरवणारे असे आमचे खानदेशचेच आहेत ते मूळचे, त्याच्यामुळे त्यांच्याबद्दल आम्हाला विशेष लगाव आहे असे डॉक्टर प्रकाश मराठे सर. या ठिकाणी IMA अकलूजबद्दल त्या छोट्याशा सिमरजीतपासून तर इनामदार सरांपर्यंत एकोप्याने कसं काम करायचं याचा आदर्श घालून दाखवणारे IMA अकलूजचे अध्यक्ष संजय शीद, सचिव नितीन राणे, कोषाध्यक्ष निखिल, या सर्व वुमन्स विंगच्या राज्याच्या अध्यक्षा रेवती गुजर मॅडम, सर्वच IMA अकलूजचे पदाधिकारी, नितीन एकतपुरे असतील, मला विशेष उल्लेख करावा लागतो की ऑर्थोपेडिक्स सारख्या वृक्ष ब्रँचमध्ये काम करून देखील इतका त्यांनी त्याच्यातला कलाकार जिवंत ठेवले आणि कुठल्याही प्रोफेशनलच्या गालात मारेल अशा पद्धतीने कालचं सादरीकरण करणारा अमोल शिंदे आणि तुमच्या आमच्या सगळ्यांचं आन बान शान असलेला संतोष खडतरे आणि त्याची जान असलेली सुप्रिया आणि उपस्थित सर्वच मान्यवर, खरं या ठिकाणी मी आजकाल IMAच्या खूपशा कार्यक्रमाला जात नाही, परंतु एक तर संतोषचं, आग्रहाचं आणि प्रेमाचं आणि हक्काचं निमंत्रण आणि दुसरी गोष्ट म्हणजे इव्हकॉन हा कार्यक्रम. मला माहीत नाही इव्हकॉनच्या कमिटीला देखील माहिती आहे की नाही, 2010 साली इव्हकॉन या नावाची कॉन्फरन्स सगळ्यात पहिले IMA धुळेनी घेतली होती आणि तेव्हापासून मला महाराष्ट्र राज्य IMAचा अभिमान आहे की त्यांनी ती दरवर्षी त्या पद्धतीने ती आता होते आहे. राष्ट्रीय अध्यक्ष 2018 साली असताना पासूनही आम्ही सतत वुमन डॉक्टर्स विंगला कसं प्रमोट करता येईल, कारण एक लक्षात घ्या, आज मेडिकल फ्रॅटर्निटीचं फेमिनायझेशन झालेलं आहे, म्हणजे 50% डॉक्टर्स या महिला आहेत आणि जर तुम्ही त्यांना IMAच्या डिसिजन मेकिंग पासून वेगळं ठेवलं तर IMA कधीच मजबूत आणि स्ट्रॉंग होऊ शकत नाही. कुठलीही IMA स्ट्रॉंग असण्याचे माझे 2च क्रायटेरिया आहेत आणि जे कधीच फेल गेले नाही. ज्या IMAत वुमन डॉक्टर विंग स्ट्रॉंग आहे आणि ज्या IMAची स्वतःची बिल्डिंग आहे ती IMA इनबिल्ट स्ट्रॉंग असते आणि स्ट्रॉंग होतच राहते. म्हणून सातत्याने सर्वांचा आमचा प्रयत्न असतो की महिला डॉक्टरांनी पुढं यावं आणि बघ, अतिशय दुर्दैवाची गोष्ट आहे आणि आमच्यासारख्यांना लांछनास्पद गोष्ट आहे की गेले 96 वर्षात नॅशनल प्रेसिडेंट IMAचा फक्त एक महिला झाली. कालच सुप्रीम कोर्टाने बार असोसिएशनला निर्देश दिले की तुमच्या पदाधिकाऱ्यांमध्ये 30% महिलांसाठी रिझर्वेशन ठेवा. आणि आपण डॉक्टर स्वतःला अति उच्च शिक्षित सुसंस्कृत समजतो, परंतु आपल्या संघटनेची काय परिस्थिती आहे? हा महाराष्ट्र राज्य आपण म्हणतो संतांचा राज्य, पुरोगामी राज्य, या महाराष्ट्र राज्याची अध्यक्षा देखील अजून एकही महिला झालेली नाही. म्हणून म्हटलं ही लांछनास्पद गोष्ट आहे. आपण म्हणतो हरियाणा फार स्त्रियांच्या बाबतीत भेदभाव करतं, त्या राज्याची अध्यक्ष सचिव महिला होऊन चुकली. ओडिसा सारख्या राज्याची अध्यक्ष महिला झाली, आसाम सारख्या राज्याची अध्यक्ष महिला झाली. कधी महाराष्ट्र राज्याला महिला अध्यक्ष मिळणार आहे? केवळ कुठेतरी एखादं उपाध्यक्षपद द्यायचं, एखादं सहसचिवपद द्यायचं आणि त्यांची बोळवण करायची किंवा वुमन्स डॉक्टर विंगमध्ये टाकायचं, हे कदाचित हे चित्र आम्हाला सगळ्यांना मिळून बदलावं लागणार आहे आणि ते बदलल्याशिवाय अजून IMA महाराष्ट्र ही स्ट्रॉंग होणार नाही. आणि म्हणून इव्हकॉन सारखे कार्यक्रम अशा पद्धतीने प्रत्येक ब्रँचमध्ये वुमन्स डॉक्टर विंग्सचे कार्यक्रम हे फक्त नाच गाणे आणि कल्चरल कार्यक्रमापुरते मर्यादित राहता कामा नये. जे संतोष करू शकतो त्याच्यापेक्षा जास्ती चांगल्या रीतीने सुप्रिया करू शकते, हेही मला माहिती आहे, परंतु ती माऊली संतोषला पुढे करते. ठीक आहे, तर अतिशय सुंदर नेटकं नियोजन, आयोजन आणि प्रयोजन सगळंच अतिशय देखणं होतं. यापूर्वी देखील IMA अकलूजच्या खूपशा कार्यक्रमाला मी हजर होतो. परत एकदा आपलं सगळ्यांचं आभार मानतो आणि पुढील वाटचाली शुभेच्छा देऊन इथेच थांबतो. जय हिंद, जय महाराष्ट्र.
Thank you, sir, for a wonderful speech. I now invite Dr. Shivkumar Utture, sir, chief guest of today's program, to kindly say a few words.
Good afternoon to everybody. Today, indeed, it's my privilege to be over here, and at the outset, before starting anything, I must apologize to the organizing team. I was supposed to come yesterday for a lecture, but due to some reason, right up till the last moment, it was not sure that I would be able to make it. But then, I think almost 3 times a day, Santosh was giving me a call. And once he does that, it becomes very difficult. So luckily I could make it, but I made it yesterday late in the night. So that's why I apologize for that. And I thank you for having invited me here today. Maharashtra State President, Dr. Thackeray, sir, you have heard what type of a personality he is. जितका माणूस शांत असतो तितका माणूस आतून टफ असतो, and this is what is epitome of Dr. Thackeray. Especially as far as medico-legal things are concerned, legal things are concerned, not only that, but I think even branch constitutions are concerned, I think he agrasar aahe to ekdam pude, right? He has created everything, and I hope you all also go through whatever documents he has prepared for the state and for the national. My friend, colleague for years, Dr. Ravi, I think everybody, he has spoken about everybody, but let me tell you about this man. He was the first, I think one of the only national presidents who took on the national government in the very first week or 10 days of becoming the president, national president. And we had that huge strike, which we always used to say was, as far as medical fraternity is concerned, we could never have a strike all over India, but that during his tenure, because he roamed about all over India, I think we were successful and we could stop a lot of things that were going to come, which would have been quite harmful for the medical fraternity. Then my friend again, and who was with me in the council also, Dr. Jayesh Lele, we have fought a lot of battles together. We have won some, we have lost some, but I think he is a man who will never stop fighting, and everybody has seen that. Dr. Anil, I think majority of you all know him. I have known him right from his college days. He is a great IMA activist and a fighter, and knows when to say yes for anything, and rarely he ever says no for something. So he is that type of a personality. And then my gurus in IMA, Dr. Arankar sir, Dr. Bakulesh sir, Dr. Navrange sir, and these are the elders from whom we have learned what exactly is IMA and how to fight for IMA. So thank you very much all of you for having guided us all these years. We have the state leaders and office bearers, Dr. Gorpade, Dr. Jadhav, Dr. Gade, Dr. Marathe, who are over here, and the very fact that you have so many people from the state and the national who are sitting on the dais today. I think this is one of the biggest dais I've seen ever, around 20 people. And that credit goes to, I think, IMA AKLUJ and to Santosh for being able to collect so many leaders over here under one roof. President of AKLUJ branch, Dr. Sanjay Sheth, Secretary Nitin Rane, DWD Chiefs Dr. Revati Rane Madam, Dr. Swapnanjali, Dr. Arwari, and Dr. Gujar, who is the Chief of Women's Wing. And last but not the least, my close friend and colleague, Dr. Santosh.
I think Santosh is a man who knows how to get yes from a person like me. So, always gentle, always very respectful to whomever he talks to. And you have heard just now that whenever he has had such big programs, he has got the support of the whole women's wing of AKLUJ. आम्हाला आमच्या एका पत्नीला मॅनेज करणं डिफिकल्ट पडतं. I don't know how he manages the whole show. And what do I say about AKLUJ branch? I think a branch which is about 200 plus, of which more than 100 of you with your families are over here. And the name of AKLUJ and of course Santosh has become almost synonymous at the Maharashtra state level. And it was possible for you to do all these things purely because of the unity that you have got in your branch. You work as a family, and that is something very few branches can boast about. And I hope you continue working as one unit even in the future so that you can achieve more and more. The only thing request to Dr. Santosh would be, and what I think just now Ravi has also said, that your ladies wing is active in AKLUJ. I think it's high time you start pushing them at the state level and then the national level also. You have got the potential. The thing is, you require that push to be given to all these. And from yesterday, I've been seeing the programs that you all are holding. I've also heard all the lectures which were there online when I was coming all the way. Even in the morning, I was hearing it online. I think beautiful lectures. And the best part is the theme that you have taken, robotics. I mean, this is the future of medicine. I've been giving talks on AI everywhere and what technological changes and how it is going to disrupt the whole way of how we are going to practice in the future. And even, and let me tell you, at the national level, we are contemplating having a separate wing as far as, AI is concerned, because that is what is going to be, that you have to follow in your day-to-day practice tomorrow. And whatever we have learned of whatever, may it be clinical, may it be investigative, whatever it is, the whole thing is going to change, I think, within the next less than a decade, when AI is going to play a big role as far as your clinical practice is concerned. And so congratulations for choosing such a topic over here today. So I bring greetings from IMA headquarters, so I'll just speak a few words of whatever IMA headquarters is doing, because everybody asks us, what is IMA doing for our members? Number one is the Charter of Demands. I hope everybody of you all have heard those 10 charters, main things that we have demanded from the politicians in this election time. My request is, please go to whoever are the who are standing for the elections over there in your area, for the MP elections, please meet them and hand them over the Charter of Demands. Many a times I hear people saying that what is the use, they never listen to me. See, try and you will succeed. This is what we have learned right from our school days. We keep on trying. We have been successful in a lot of things. Like Clinical Establishment Act in Maharashtra, we have been successful in not getting the Clinical Establishment Acts, which is detrimental to our practice, for so many years in spite of the pressure from the central government on Maharashtra government. And that has been possible because we have kept on trying to avoid this clinical till they come out with an Maharashtra-specific act which is conducive to how we are going to practice. And that document is already ready, which has been given to the government. Please go through the document. I think it is there on the Maharashtra state website. The second aspect is the issues of nursing homes, which I was supposed to talk yesterday. HBI has taken it up very, very seriously. May it be the MPCB issue, may it be the renewal of registration. Even at the Maharashtra state, we have taken this up. We know how difficult it is getting day by day for small hospitals that we doctors as IMA members, single or jointly we own. Unfortunately, what I foresee is corporate hospitals are going to take over the whole thing in the future. So we have to avoid that. And to avoid that, we have to unify as one unit of small nursing homes. And the IMA headquarters and IMA state is also fighting on every issue And today the greatest issue is the MPCB issue, all of you are aware. We are not getting our renewals because of that. We are working both at the national, and let me tell you, because of our persistent demands with the national government, the central government, which we were trying for the last almost 10 years to see to it that IMA becomes part and parcel of the committee formed by the central government as far as health issues are concerned. Health sector, we are the greatest healthcare sector that is there. And we have been successful because today, let me tell you, in MPCB also, there is one IMA representative who's there in the central board. There's one representative who's there in the state government MPCB board also. So they can, partake in whatever rules and regulations are coming, which is going to be conducive to us. And that is the strength of IMA, and slowly this strength is growing day by day. Even as far as human rights is concerned, just last 15 days back, I was in Delhi for the human rights. I was nominated by the central IMA. And let me tell you, there we took up two issues as far as our future youngsters are concerned. Many of us have our children who are in medicine. And these two issues that we took up was, one was the bond issue. And we have categorically told them that no to bond as far as IMA headquarters is concerned. We are not bonded labor, so our children and our youngsters will not be bonded labor as far as the government is concerned. So either they have to change their bond policy and make it so that their youngsters are encouraged to take up bond, or absolutely we do not want the bond. And let me tell you, even the Human Rights Commission was quite, whatever demands we were doing, they were convinced that they were right demands. And the second thing is the stipend issue that is there. Especially in the private medical colleges, we are finding that they are given, sometimes they are not given stipend, and even if they are given stipend, immediately that stipend is taken back, saying that hostel facilities and mess facilities, whatnot, they take it back again. So this is also what we are fighting, and IMA headquarters is fighting for single stipend in the whole state as per what stipend is given by the state government. That is what we are fighting for our youngsters. And let me tell you, both the MSN unit we have started, the JDN unit, that is the Junior Doctors Wing, these are going to be our future activists. These are going to be the strength of IMA in the future. So it is rightful that we fight for their rights so that they are attracted towards IMA. That's what's going to come up. Assault is another big problem. Just yesterday, in two places, one in Maharashtra and one, I think, somewhere in Kapathodia or something like that, assaults go on taking place off and on. We are asking for a central act which is there, because as you know, in Maharashtra we have a state act, but all of us are aware that in the last so many years, 2010 if I'm not mistaken, that act has come into play. There has been only one conviction under that act, and there have been hundreds of assaults on our members. So we are trying to get it. There is some resistance from the national IMA saying that only doctor profession cannot be given this protection. Then the lawyers will ask, different other professionals will ask. But we are in a unique position where we are open to assaults day to day in our clinical practice. Because when a patient comes to you, remember the patient is suffering and he is coming for treatment. But what do the relatives feel? That once, in whatever condition the patient is brought to the hospital, his patient should completely get cured and walk back home, which is not possible. That is not in our hand. So this is the position that we are, and we are fighting. The National IMA is fighting to get a central act also as far as assault. It is going to take time, but it will happen someday or the other. Another thing, let me tell you that we are open to feedbacks from our general members. Many a times I have seen that some members have got some beautiful points to put forward, which can be taken up by the state IMA, which can be taken up by the national IMA. Please do not become a WhatsApp activist. It is very easy on WhatsApp to put what is IMA doing, why is IMA not doing this. Please come out with something that what should be done by all of us. Ultimately, what is IMA? IMA is every member who is sitting over here is IMA. So we are open both at national level and of course the state level also. So if you have anything to contribute towards, maybe, everyone is an expert in some branch or the other. Some people are experts in medical legal, some people are experts in nursing home issues, some people are experts in financial issues, whatever it is which helps our members, please put it down in writing and send it by email to the state IMA or the national IMA. And let me assure you that definitely it is taken cognizance of, and we will be working on that, because ultimately the strength of IMA is in the strength of the local branches. So Santosh, it is your job to make AKLUJ more and more strong, because when you make these local branches strong, we get the strength at the state level and the national level from your strength. So once again, thank you very much, all of you sitting over here who have invited me over here today and letting me talk about some issues as far as the national IMA is concerned. And congratulations to the whole AKLUJ branch. Congratulations to the whole Women's Wing branch also for doing such a fantastic program. Since I came, though it was late in the night, your hospitality was superb. The venue that you have chosen is excellent, and we have enjoyed our stay since yesterday over here. So thank you very much, the whole of AKLUJ branch. Thank you.
Utture sir. Before presidential talk, we took two more felicitations. I request Dr. Utture sir to felicitate today's MOC, Dr. Padmaja madam.
Good vision.
Both MOCs are ophthalmologists. खूप वेळ झालेला आहे, 1:30 वाजलेले आहेत. मी गोरपडे सरांची माफी मागतो सर. मी डायरेक्ट प्रेसिडेंट आणि टॉकसाठी दिनेश ठाकरे सरांना विनंती करतो. डॉक्टर दिनेश ठाकरे सर प्लीज. गोरपडे सर सॉरी बरं का, गोरपडे सरांना बोलायचं.
Good afternoon. I am very well aware that I am between you and the lunch, and also the leaders traveling via Pune need to leave at the earliest to avoid the traffic jam. So I will try to be short. Chief guest of today's program, National Vice President Dr. Shivkumar Utture sir, past National President Dr. Ravindra Wankhedkar sir, Dr. Meena Wankhedkar madam, Dr. Jayesh Lile sir, Dr. Amarga sir, Dr. Bakulesh Mehta sir, Dr. Anil Pasnekar sir, Dr. Jayant Naurange sir, State VP Dr. Nitin Gorpade, Treasurer Dr. Vikrant Desai, State Joint Secretary Dr. Ashish Jadhav madam, Agawachale Chairman Dr. Yashwant Gade, Social Security Scheme Secretary of Dr. Prakash Marathi sir, AKLUJ President Dr. Sanjay Sith sir, Secretary Dr. Nitin Rane, Treasurer Dr. Nikhil, IMMS Women's Wing Chairman Dr. Revati Rane, Convener Dr. Supriya Arwari, Co-Chairman Dr. Swapnanjali Awad, whole team of IMMS Women's Doctor Wing, Dr. Sanjay Deshpande sir, Dr. Navneet Desai madam, Dr. Anjali Gade madam, Dr. Arankar madam, and the man behind all this show since yesterday, Dr. Santosh Khatare. Along with him, whole of the EVECON organizing committee, along with Organizing Secretary Dr. Savita Guzar madam, all the leaders of IMA, all the office bearers of IMA, faculties, speakers, delegates, and friends. Organization of a very successful and grand conference is not a surprise when it is organized by IMA AKLUJ. I think this is nearly 4th conference I am attending in various capacity, which were organized under the leadership of Dr. Santosh Khatare sir. I still remember when I used to take any entry level standards workshop for the whole day, and I was at that time very much surprised that branch like AKLUJ, which we feel at that time I used to feel that a small branch organized these any entry level standards. And when I went deep into the medical fraternity of IMA AKLUJ, then I came to know that it is the hub for medical facilities. Whatever comes in Solapur, usually Solapur is a district branch, but AKLUJ was, as far as medical fraternity facilities are concerned, they were at part the Solapur and surrounding districts. Again, when I became president-elect, only 2-3 months after, Dr. Santosh Khatare sir called that we are willing to take EVECON 2024. So there was no question of saying no, and he was the first. I even didn't ask him who will be the WWE chairman, because when Santosh is there and we look after him, leader from this area, and the person responsible for the state. So he suggested the names, Dr. Revati Rane madam, and I was not knowing her, but more than my expectation, she conducted 2 webinars, Life Beyond Medicine, very excellent webinars, both of them, and just thoughts out of box, thinking out of box, speakers out of box. All the presentation in both the conferences was very good. And again, I saw the combination of OBGY, ISA, and IMA. All three various specialties sitting together and talking about non-medical things. That was again a great surprise for me. And as rightly said by our treasurer, our leaders, we note as leaders when we travel that wherever women's wing is strong, that branch automatically becomes strong. And as suggested by our leaders, and that the women should now come forward at state level and national level. I wish IMA AKLUJ, WWI Maharashtra, rather I congratulate for organizing such an excellent conference, such an excellent hospitality, such an excellent venue. And yesterday, while opening the ceremony, opening the conference, I said that let's have fun in Fern. And Samarjit has proved it. He was the person who had fun in Fern. And that I just said that during the speech, but he really, I can say, enjoyed the things. And I will never forget him enjoying all the things. When you go home, you take some messages, you take some pictures, so visualizations, you can say. So I can't forget him, Samarjit, enjoying all the show. And of course, Dr. Amol Shinde, who really yesterday did a very great job. I was not knowing him in this capacity. I remembered Meera Bhayandar Hospicon, and I remember Dr. Navneet Desai in the same role there in Hospicon. So we have such personalities in our IMA. In capacity of IMA Maharashtra State President, I am supposed to talk about the issues of medical fraternity. I have talked about them yesterday, and most of you were there in that speech, heard me. So I will not repeat it. I will only say that whatever things, whatever problems, whatever issues are going, IMA leaders are working on it. If you have any issue, you should contact IMA Maharashtra through proper channel. And rest assured that each and every issue that comes into your mind is being addressed at state level and is being thought at state level. Times are difficult. We are being targeted on all the sides. Every strata of society is targeting us. Therefore, I will only repeat the one thing that I said yesterday. That is, it is time to save some time, to dedicate some time to save our practice. It is not that we are going to practice, we want to practice, very good, but it is now time to give some time for the practice, to save the practice so that we can earn, we can enjoy our work through this practice. So, I congratulate IMA AKLUJ WW team, and I am thankful to the WW team through Dr. Santosh Khadtare sir, who has nicely organized this conference, and the memories are there to cherish. I am thankful to all the leaders because this is the conference of state level, and all the state leaders, national leaders, they managed to come to this bit odd place for this conference, but I am very much sure that with all this organization, they enjoyed the things, and I am very much thankful to all of you, IMA AKLUJ and WW, for your contributions, inputs, and all the support you have extended to IMA Maharashtra State. I am thankful to you. Thank you.
Thank you, sir. After receiving lot of appreciation and praise from all the IMA dignitaries, I will request Dr. Nitin Rane, Secretary IMA AKLUJ, to conclude this inauguration ceremony with his votes of thanks.
First and foremost, sir, I would like to thank all the dignitaries present on the dais, and WW Wing especially, for being present for this EVECON 2024 conference and blessing us with your presence and making this conference a huge success for us. It's been your blessings and your guidance that we are able to do such conferences. You have been helping us, guiding us for last 4 years. We have been in contact with you for conducting these conferences, and you have showed us the proper channels due to which we are excelling every year. And we hope to continue doing these conferences at such high levels. Thank you, sir. Thank you very much. Thank you, everyone.
I request all the dignitaries please be on the stage for the group photo.
Hall and continue with the sessions. So all are requested to come in and have the lunch in the hall so we can continue.
Yeah. Good afternoon, everyone. Good afternoon, everyone. At the outset, I thank AKLUJ IMA office bearers for giving me this opportunity to chair this session. I take this privilege to introduce Dr. Rohan Krishna Kumar sir. He is the gold medalist in MS Obstetrics and Gynecology, DNB, FCPS and DFP. He has done his fellowship in Gynec Oncology from Ahmedabad. He has done his fellowship in Minimal SS Surgery, ICOG and EVA Women's Hospital. Also the fellowship in Advanced MIS and Endometriosis and Cancer Surgery. He International School of Surgical Anatomy from Italy. Then he has done his training in Gynec Oncology.
I'll introduce myself, it's very long.
Yes.
So I'm a laparoscopic and robotic surgeon from Mumbai. So I'll begin the topic. It's robotic transformation and how we should all accept it. Thanks everybody for having a working lunch. Slowly we know that this is reality. We see this in our homes. We see even bodies are being replaced by robots. So why not surgery be done by robots, which is much better for everybody. This is what happens typically in medical colleges when we see in the dissection table, we are all standing at the back, we can't see anything. And when we all enter surgery and PG training, this is what happens. You're standing, your boss is operating, you can't see the minute structures, and again you end up missing so much. So that's where minimal invasive surgery takes the lead, because it has magnification, precision, documentation, and everybody can see, and you can review your recorded lectures again and again, recorded videos again and again. So from open we move to lap, and from lap slowly to robotic assisted surgeries. For many people would say, Arey, it's just another way of doing laparoscopic surgery, but it brings the power of AI. We saw digisexuality and even our normal human functions are being replaced by AI. So surgery is must, and we should all accept it. There are more than 400 robotic installations in the USA, and almost 75% surgeries are performed robotically. These are a list of all the other robots. This is how some of them look. There are ortho robots, which we all must be knowing. Even India has produced its own SSI Mantra robot. They already have 4 or 5 installations throughout the country. So slowly it is getting assimilated into our system. It has allowed open surgeons to offer patients their minimally invasive approach, and those already doing lab to do more technically superior stuff. But what are the obstacles? Though the assimilation has occurred, it has not entered mainstream. We don't see counseling our patients for robotics because of the lack of access to technology, deficit in learning opportunities, and undoubtedly cost, but also our acceptance that robotic is better in many ways to other forms of surgery. So the challenges are to educate ourselves about the next generation technology and apply it selectively where it's actually required. So this is how a patient consoles look in a typical Da Vinci system with all its arms. This is how we see it in the OT. You see, India, the utilization of robotic assisted surgery is just about 1%. And that too, if you see, urology takes the majority piece of cake, followed closely by gynecology. We are not far behind. Slowly it is increasing, and then gastroenterology. You see a markedly increased robotic installation in 2022 and beyond, where it's going on increasing. And the companies which are there, these are the 4 main systems for GI surgeries and gynec surgeries and urology: the Ugora, CMR, the Mantra, and the Intuitive, which is the age-old brand. Coming to the Indian statistics, slowly more and more surgeons are getting trained for this. More than 15,000 surgeries were performed robotically in 2021. So what is conventional lab? It's inserting trocars, performing the surgery, closing the stitches, and you're out. That's what makes it faster. Why is robotics different? Because everybody says, "Arey, docking mein bahut time lagta hai, it makes our surgery slow." But slowly your team learns to do it faster. And the best part is that the surgeon controls every movement, including the camera. So you don't have to shout at your assistant every time, "Hey, pass ja, dikha barabar," and don't need to get distracted from surgery. So this is how a typical gynec robotic setup looks. The big one with 4 arms is the patient console, which is on the patient attached, docked. The center one is the instrument control with the screen and the cautery and the camera system. And the last one is the surgeon's control, where you can actually sit and operate. These are the variety of instruments. Now it is 8 ports which are used, and all forms, even clip applicators are available. So this is how typically an OT works. You see, I'm the one who's operating the robot here. This is how docking is done. This is how the arms move. It rotates. You can rotate it according to surgery, where you're going to perform. If it's upper abdomen, there are options for it. If it's lower abdomen, there are options for it. And then you actually go ahead and push the entire system towards the patient. Oops, I think it's not forwarding. Yeah, is it? Forward नहीं होता क्या इसमें? ठीक है, it's not forwarding, so I'll move on. So that's how it's placed and got close to the patient, and then the camera port is inserted. Now you see that green target-like thing, this is targeting. You target the organ and the arms will align itself according to the surgery. If it's liver, the arms will align accordingly. If it's uterus, pelvis, the arms will align accordingly. Then comes attaching the trocars to the robotic arms. Just like lap, you insert the trocar, and then there is a typical groove in which you fit the trocars, and that's how the arms are attached and the instruments are fed into those trocars and attached to the robotic arms, and it moves. So this is what a surgeon actually sees inside. It's a totally 3D view. Now that's how it looks inside. You have to see through those binocular-like structures. And then this is how surgery looks in a robotic system. You have to sit. It's like how we are having a working lunch here. You can have lunch and also operate on a robot. So that's how simple it is. But you have to use all your 4 limbs, hands and both feet, as well as your mind. And as soon as you remove your head from the console, the arms will freeze. So there are no chances of injury. Whichever position you have left, the arms will lock itself. Going further, this is how the surgery is done. You can see the arms are moving, and similarly the movement of the hands and the feet, and the same movements being replicated exactly the same way inside. They are intuitive movements. You can rotate an instrument 360 degrees. As much as your wrist can rotate, that much the instrument will rotate. So this is how a case is being performed. I think I can't fast forward. So I'm just going to keep it on for some time and then move ahead because the video is not fast forwarding. So you can see how easily the instruments are moving. There is no restrictions. The tip rotates as much as your wrist can. And it's all precision micromillimeter cuts without any damage. And you see the camera can be moved according to the way you want it to move. You can zoom where you want to zoom. You can unzoom. You don't have to instruct anybody in the OT what they have to do. You are the boss. Even you can see even structures lower down in the pelvis, you can easily approach. Now I've purposefully kept a simpler case here for everybody to understand how it actually works. Now coming to this side, you can use the arms to retract as well and then go ahead and cut. One of it is a bipolar and the other is a monopolar scissors, but even harmonic, suction catheters, and even ligatures now available for attaching in the robotic arms. You can see how easily the vault is being opened without telling the camera person to move an inch. You're moving, you're operating, you're doing. Further going, this is the most easiest thing. People struggle for endosuturing in lap. They give up lap because they can't suture endoscopically. See how easy robotic makes it. You don't have to move a muscle. You just have to stand, and like you would suture in an open case, just operate on the console and the robot will the robotic arms will replicate those movements and the procedure will go on. So this requires less training and less practice, and you can learn it faster. So we all know the benefits: shorter hospital stay, fewer surgical complications, and shorter recovery times. But for the surgeon, it almost increases your surgical life by 10 years. Because in open and lap, you usually tend to damage your shoulders, your wrist, they're painful. In robotics, you sit and operate, and that's how your surgical lifespan increases much more. Going further, I won't say only robotics, because I'm primarily a lap surgeon, so I also want to show some good advances that have occurred in laparoscopic surgery. Now this video, unfortunately, if I'm unable to fast forward, I'll have to skip. This is wherein you can actually put... Nahi ho raha na, fast forward. Let's see if they can. This is just stenting the ureters with a infrared stent so that you can see them while operating and not damage them. Hot nahi? So I think I can't fast forward it. So let's skip this video. Going further ahead, this is in the Olympus system. You can see everything yellow. That's because the fat enhancement mode is turned on. This will highlight the fat. Now you can see I'm doing retroperitoneal dissection here, and it's highlighting the fat and showing me the exact planes where to go. While dissecting, you'll just see in a moment, while dissecting over the ureter also, the fat around the ureter is appearing more yellow. So that will help us in preventing from, unnecessarily, unduly stripping it. You can see that yellow layer is on the ureter. So I can just keep away from it so that I don't devascularize it completely while doing these surgeries. So these are the advances that have come in imaging systems using infrared. Going further ahead, this is a grade 4 endometriosis. I think I'll just let this video play for a bit because we all struggle in endometriosis because of anatomy. The anatomy is totally distorted and we have to find it. But with a simple ICG system, it becomes so easy. You just inject IV ICG, diluted, and then once you turn on the ICG, so you are confused where to cut. But as soon as you turn on the ICG, you can start seeing the structures. Now there the ureter has directly come in front, which couldn't be seen due to a frozen pelvis. So you can very clearly avoid it. You can see the lymph nodes on the vessels plus the ureter running laterally. Yeah, this is one slide which is comparing all the new systems that has ICG in it. Plus, this is used, I use it a lot in sentinel lymph node mapping in CA endometrium. Robotics also has it, is known as Firefly technology. You can see those green areas, that is the sentinel lymph nodes. So you just need to biopsy them, and then you can avoid a lymphadenectomy and unnecessary surgery in many of the cases. So what are the indications? Any case that is fit for a laparoscopic surgery is indicated for robotics. Gynecological malignancies, especially endometrial CAs, difficult endometriosis cases. And my aim today was to just introduce everybody to robotic surgery so that at least we know what it is and how it will benefit us, and highlight the newer innovations to make endoscopic surgery better for women, since this is EVECON. The biggest obstacles is easy access to laparoscopy. I won't call it an obstacle, it's a boon as well. Slightly longer operating time, high cost because instruments are still disposable, lasts only 10 cases. And unawareness, lack of many trained people to do it. And most importantly, ourselves, because we have to believe if change has to come. Today, this is a reality in many places. Like you said, you will have love dolls. But for that, you'll have to wait till 2050. This is already there. So better we start using it now. Even in India, we see waiters, robotic waiters delivering food to all of us. So something is already knocking on our doorsteps. We just have to open it and let it in. So the biggest thing is we must believe first that we can change and we have to change. And it takes a lot of curiosity to learn, but it takes courage to unlearn. And learning is how you evolve, and unlearning is how you keep up as the world is evolving. So we have to accept change and we have to move ahead. Thank you very much.
Hello. Wonderful presentation, really wonderful. Rohan, as I fondly call him as the Crown Prince of Dombivli, is doing great work. And Rohan, just one question, whether you've explored the possibility of single port surgeries in such cases?
Single port robotics is not yet come, it's just getting introduced. Only one place in India has it, I haven't tried it. Okay. We use minimal ports, 2 ports is sufficient, 3 ports, 1 for camera and 2 for instruments. Because the lesser ports you use, lesser is the cost of surgery for patient. Right. So as lesser ports we use is better.
Great. Any questions from the floor? So Rohan... I
think he has a question.
Yeah.
Yeah, everything is same as lab. Yes, CO2. Yes.
Okay, so I will wind up your talk.
Thank you.
With a poem dedicated to you and to your robo. I told my robo to sweep my shack. He said, "You want me to sprain my back?" I told my robo to answer the phone. He said, "Sorry, I'm making calls of my own." I told my robo to boil an egg. He said, first, let me see you beg. I told my robo, there's a song you can play me. He said, first tell me how much you'll pay me. So now I'm confused because I never knew who is whose servant and who belongs to who. So I hope that face doesn't come.
No, it will not come because the moment you leave the console, the robo freezes.
I know. And it is not the robo, but the hands behind the robo. We all agree. Thank you so much.
Thank you very much.
You were a wonderful speaker. Thank you.
Thank you very much.
Now I request Dr. Supriya Arwari ma'am to felicitate Dr. Rohan Krishna. All the chairpersons, please be on the stage. Lights लावा समोर.
Hello. Now the time for the next talk. I request Dr. Shweta Gugre Surana to be on the dais. Thank you, ma'am. I request Dr. Ujwala Shirsat ma'am to introduce our next speaker, Dr. Shweta. Presentation on, please. CV slide, please.
CVच्या slides.
Good afternoon to all. I take this privilege to introduce our today's speaker, Dr. Shweta Gugre Surana. She had done MBBS, MS Obs Gynae, DNB Obs. She is postdoctoral fellowship in fetal medicine, 2 years. Director at Pune Fetal Care Center, consultant fetal medicine at KM Hospital, Pune. And her interest in fetal imaging drew her to Mediscan system in Chennai, where she gained a fellowship in fetal medicine. She currently pursues her passion in fetal medicine and fetal therapy at KM Hospital. So over to you.
Thank you so much, respected chairmen. Okay, let me start this presentation with a question to all. How many people can you see in this slide? Anyone? Absolutely, fantastic. So only in past decades, the fetus has been considered as a patient and has become a subject of extensive scientific study and attempts at treatment. So hi, I'm myself Dr. Shweta. In next 20 minutes, I'm going to take you through laser in fetal medicine. So we all are aware of mythological heroes, and this one is Ashtavakra. His father had wronged a sage, and so he was cursed that his child would be deformed in 8 places. To remedy the situation, the couple began narrating Vedas, and upon the birth, the child was physically deformed, but his mind was enlightened. So this story challenges us wisdom over physical deformities. It is important that the pregnant woman should understand what the condition of the baby is, under what circumstances the baby is in, and to stay positive to shape the destiny of the unborn child. So there are 3 types of lasers which are used in fetal medicine. First is the fetoscopic laser ablation. Here we have a fetoscope which is 2 mm, straight or curved, which is connected to the light source and the camera. And with the help of ultrasound, we put the fetoscope into the abdomen. This is done under local anesthesia. We prefer local anesthesia because we want the mother to participate in the surgery. Next type of laser. So this is fetoscopic laser ablation. Here, the fetoscopes allows us to intervene in conditions apart from twins, also in congenital diaphragmatic hernia, obstructive urinary abnormalities, and even more complex, the spinal column closure. Next, we can use is radiofrequency ablation. Here we have a radiofrequency needle, and there are tines which open up in the fetus to ablate the fetus. This works at very high frequency, causing tissue coagulation and necrosis. So this can be used in twin pregnancy with severe anomaly, growth restriction, or twin arterial perfusion. Then we have this interstitial laser ablation, where we have an introduce a needle and the laser fiber with a special adapter, and with this we ablate the umbilical cord stump of the fetus. So there are several indications of laser in fetal surgeries, of which today we are going to concentrate on twins, especially the monochorionic twins. So the first condition is twin-to-twin transfusion syndrome. Now here, in monochorionic pregnancies, there's a single placenta, so hence there are vascular anastomosis, due to which what happens is one fetus donates blood to the other fetus, and the one which donates the blood becomes oliguric, and hence there is oligohydramnios. And the other which receives more blood, the heart has to overwork and goes into failure, and the sac becomes polyuric. Once we diagnose twin-to-twin transfusion syndrome, the next step is to stage it. So the fetoscopic laser ablation is usually done in stage 2 TTTS. Now without the treatment, the twins would die, and even if they survive, they will have neurological sequelae. So with treatment, there is 90% survival rate of one twin and 70% survival of both the twins. So this surgery aims at underlying pathology, that is the vascular anastomosis. Now I'll take you through the case. This was done in 2020. This was the first fetoscopic laser ablation which was done in Pune. So this patient was referred to us at 19 weeks as a monochorionic pregnancy. So one fetus had oligohydramnios and the other had polyhydramnios. The rest of the structures were normal. We called her up after 1 week because there was a oligopoly sequence. But the patient came at 21 weeks. After 2 weeks, the polyhydramnios had increased. In the oligohydramnios sac, the bladder was not seen because the bladder had collapsed due to oligouria, and the other side there was a prominent bladder. So here you can see in this picture, one side there is lot of liquor, and other side there is very less liquor. Bladder is collapsed in the donor twin and prominent in the recipient twin. So this becomes twin-to-twin transfusion stage 2. We counsel the couple for fetoscopic laser ablation. Here we are putting the vascular sheath and the guide wire, and then we'll put the fetoscope inside, and we map the placental vessels for the anastomosis. So here you can see these are the vascular anastomosis on the placenta. This is intrauterine. 12 vascular anastomosis were identified and then they were ablated. We also drained the liquor from the polyhydramnios sac. We followed this case. Next day, you can see this membrane is freely floating. On either side, there is liquor. The bladder, which was collapsed, now the donor twin has a bladder, and the cardiac status is turning towards normalcy. So this case, we followed up 2 weekly. At 36 weeks, she underwent cesarean section. Both the twins, 2.2 and 2 kg, they are now 3 years doing well. So all cases are not a treat. Second case which was referred to us recently, as a second opinion, kidney is not seen and oliguria. So it was 17 weeks pregnancy, monochorionic pregnancy. So here we can see that in one sac there is very less liquor and other sac there is more liquor. So we labeled it as TTTS, twin-to-twin transfusion stage 2. Now here you can see this is a membrane which is very snugly fitting one twin. This is the membrane which is engulfing the twin, and the other sac has a polyhydramnios. Now the challenge in this case was the placenta was anterior and the donor twin was completely stuck to one side. Hence they had referred to as kidney is not seen because of oligohydramnios, but the kidneys were well seen in this fetus. So at 19 weeks, she came back to us at 19 weeks. You can see here, one sac there is polyhydramnios, the cardiac failure in the recipient twins. You can see the cardiomegaly, pericardial effusion. And now she went in TTTS stage 3. We counseled the couple for fetoscopic laser ablation. Here we've introduced the fetoscope inside. And 10 anastomosis were identified and ablated. So after you ablate the placenta, that is the single placenta, the anastomosis ablation looks like that. And single placenta becomes dichorionic placenta. That's the way to treat this pathology. So post laser, after a week, we could see liquor on both the sides, bladder appearing in both the twins. So we followed this pregnancy. However, there are complications of the surgery. So this twin had developed anemia in one side and polycythemia on the other twin. So this polycythemia and anemia are due to small vascular anastomosis, which we are not able to reach during fetoscopy. So on scanning, you can see that one side of placenta is hyperechoic and other is hypoechoic. The liver in the recipient twin, which is polycythemic, has a starry sky appearance. So this was the onset of another complication in already complicated twins. This was twin anemia polycythemia sequence. So we followed. Sometimes this resolves on its own. Sometimes it will need an intervention. So what happens in twin-to-twin transfusion? There are large anastomosis which we can see through fetoscopy and we ablate them. Small anastomosis which we might miss on fetoscopy still causes imbalance in both the twins and we are not able to ablate them, and then this complication arises. So at 25 weeks, you can see that the polycythemic twin, the MCA mom was 0.6 and the anemic twin had become severely anemic. There was cardiomegaly in both the twins. Now the two options were to repeat the fetoscopy or to do intrauterine transfusion for the twins. So fetoscopy repetition was not possible because the case was already very challenging. Placenta was anterior and anastomosis were not very well visible. So we opted for intrauterine transfusion to buy more time for the twins. Now in anemic twin, what we do is, this is the portal vein, we put the needle and we push O negative blood into the fetus. So we take the sample before doing the intervention. So this hemoglobin of this twin was 7.7, which was severely anemic. We transfused 54 ml of blood and post transfusion, the hemoglobin was around 15. In the polycythemic twin, we did partial exchange. In the partial exchange, what we do is, we remove the blood and we perfuse the twin with normal saline. So opening hemoglobin in this polycythemic twin was 16.7, and closing hemoglobin, after the partial exchange, the hemoglobin came down to 14.4. So both the polycythemia and anemia were corrected. At 28 weeks, we did the neurosonogram for the babies. This lady unfortunately had PPROM, that is premature rupture of membrane at 31 weeks. We did an emergency LSCS. Both the twins are doing well now, 1.2 and 1.3 kg. Neurodevelopment and echocardiography are normal for the twins. So second case where we are using laser in fetal medicine is selective growth restriction in monochorionic twins. Here what happens is, one placenta, the twin sharing of placenta is unequal, where one twin has more amount of placental sharing and the other twin has less. Hence, it becomes growth restricted. So there is classification for growth restriction, and we use laser for type 2 and type 3 selective SIUGR. So let me just speed up with the case. So this is a case of selective growth restriction, type 2, where one fetus had Blake's pouch cyst in the brain and the other fetus was normal. So we used RFA in this fetus. So this is the RFA needle. We are introducing into the fetus which is severely growth restricted. We position the needle near the umbilical cord stump and we ablate the stump. So this lady continued as a single pregnancy and delivered at 32 weeks. Baby weight was 3.2 kg, doing well. Next case is twin reverse arterial perfusion, where there is a pump twin and an acardiac twin. Now this acardiac twin acts as a parasite, putting the pump twin at the risk of high cardiac output failure, and there is 50% demise if we don't intervene. Recently, we had this case of monochorionic triplet where there was one placenta and 3 babies. So all the 3 babies were sharing the placenta, but one baby was abnormal. You can see here there is a dilated ventricles and the spinal cord is open in the lumbar region. So this fetus had long segment myeloschisis. So we opted for interstitial laser ablation. So this is the laser fiber which is introduced into the introducer, and then we target the fetus. Here you can see this laser fiber, we are positioning it towards the stump of the abnormal fetus, umbilical cord stump, and we will ablate the stump. So now this pregnancy will continue as monochorionic twins. So this is the ongoing pregnancy. We are waiting, she's now 16 weeks. So what we have seen in fetal medicine is it has an opportunity to see and understand the life before birth. But it needs multidisciplinary discussion about the pros and the cons. Every form of fetal therapy is available in our country, but appropriate treatment is not always intervention. Fetal surgery has its limit, as our primary concern is do no harm. The surgery should clearly outweigh the benefits. In the end, I would end my presentation by thanking my mentors who are pioneers in fetal medicine in India. Thank you, IMA, for inviting me for this lecture. Thank you so much.
Actually, it's a wonderful talk, Dr. Shweta.
Yeah.
It's really eye-opener for all of us. I'm a pediatrician, so we are managing such cases, congenital anomalies, like diaphragmatic hernia, twin-to-twin transfusion syndrome.
Yes.
But it's really enlightening session for me too. Fetoscopic laser ablations for diaphragmatic hernia, like radiofrequency ablations.
Yeah.
And management of twin-to-twin transfusion by laser. And it's really great to hear that. More than 90% survival rate.
Correct.
You are doing good job. And intrauterine partial exchange, where we are doing it
postnatally.
Yes. So I think it's a wonderful talk from your side.
Thank you so much, ma'am.
Good job.
I have just one question. How much does a laser ablation cost? Sorry to ask, because patients will first come out with that question.
Ma'am, the cost of laser ablation is 70,000. But since this is a research thing also. So we have fetal research unit where we have clubs who will fund the surgeries for the patients.
Great, great. Thank you, thank you.
Thank you, Shweta ma'am, for briefing us on what all therapies we can offer to a fetus. I request Dr. Ujjwala Sirsat ma'am to felicitate Dr. Shweta Surana ma'am, and I request all the chairpersons to join. I request Dr. Rajiv Rane sir to felicitate one of our chairpersons.
I request Dr. Monica Misal and Dr. Priyanka Mahadik to come forward to chair manage the next sessions. The next session will be Women's Health WDW session, and the Master of Ceremonies will be Dr. Monica Misal and Dr. Priyanka Mahadik.
Hello and good afternoon all the faculty members and delegates. I am Dr. Monica from IMA AKLUJ. As we know, after the delicious lunch and satiating food, that our brains has been captivating by that food, but now it's time for dedicate this session to the all women who have captured our heart in the form of kind and compassionate mothers, adorable daughters, and so is loving, caring wives. To begin the next lecture by our ravishing clinical secretary, Dr. Revati Rane ma'am. To chair this session, I would like to call upon the stage
Dr. Savita Guzar ma'am. Dr. Savita Guzar ma'am, dynamic and ever smiling gynecologist from AKLUJ and director of Guzar Hospital and Nursing Home. Dr. Vivek Guzar sir, the most experienced physician and director of Guzar Hospital and Nursing Home. Dr. Manisha Kadam madam, amiable and energetic gynecologist and director of Vatsalya Taste Tube Baby Center. And Dr. Mansi Inamdar ma'am, composed and charming radiologist from AKLUJ.
I would like to ask Dr. Savita Guzar ma'am to introduce. I would like to ask Dr. Mansi Namda ma'am to introduce our speaker, Revati Rane ma'am.
Hello. Yeah, today I have an opportunity to introduce my dear friend Dr. Revati Rane. Actually, she needs no introduction because she is the young dynamic gynecologist from the AKLUJ, and she is the backbone of this conference EVECON 2024. She is the organizing chairperson of this conference. She is a high-risk obstetrician and gynecologist at Apex Hospital since 11 years. She is a IVF consultant at AKLUJ Fertility Center since 5 years. She is a newly appointed as Maharashtra IMA Women Doctors Wing Chairman. And she is All Maharashtra Obstetric and Gynecology Society Public Awareness Committee Chairperson also. Recently, she has also received Signature Award at Delhi in 2023 for her commendable work for womanhood in rural area.
So she is a multi-talented lady. She has many more talents, but I don't have such time to introduce her in detail.
Thank you for that kind introduction, and it's my privilege to have my very good friend introduce me. Till the time he starts with that, first of all, I'm going to be very short and precise with my talk. This is the Women Dr. Wing session, and as we know, this is the Women Dr. Wing conference. So this session is the core and the most important session. Unfortunately, it is at the end, but I urge you all, because all the lectures are really wonderful. So I urge you all to please be present, mentally, physically here. So till the time we begin, I would like to start this session with small poem. This is dedicated to all the females who are here and who are listening online. So it is about umang. उमंग है कुछ करने की, उमंग है कुछ बनने की, जो सपने देखे हैं उन्हें पूरा करने की, समाज में नया बदलाव लाने की, अपना अस्तित्व बनाने की, उमंग है कुछ नया करने की, अपना इतिहास बनाने की, उमंग है कुछ करने की, उमंग है कुछ बनने की. So with this, we start this a very powerful session of Women Doctors Wing. And today I'm going to talk on a different topic, which is we all know we are facing it, but we are not addressing it. So this is about the biological clock which is ticking. So we know that as women, we try to, achieve everything and try to get it all. We juggle with time. We try to, have our family time, our exercise time, the everything, the profession, the finances. But with that, we cannot beat the time, because time is not our friend here, as it has been the term that I used was coined in, it is not something which is new. It was coined in 1978 by Richard Cohen, that the clock is ticking for the career women, which is outlined that the struggle for women who want it all and want to have it all. And, at some point of time, we cannot beat the biology, we cannot beat the physiology, and we cannot fight with the biological clock. And that is why they said that you cannot have it all. But no, the time has changed and the advances have come, where of course women can have all what they want. So what is this biological clock? What are we talking about? So basically women are born with certain finite number of eggs. So if you see here, Mala cursor mail, Siddhant cursor. So if we see here at birth, suppose we have 100% eggs, which are 1.3 million. So at puberty, that goes down to 27%, and at the age of 30, as we see, it goes down to 12%, and at the age of 40, it is just 3%. So maximum females which are getting married now are thinking of getting married after like 27, 28, and then they plan, they want to enjoy their married life, and they are planning pregnancy at the age of 30, where you see the ovarian reserve is just 12% from 100%. So already we are getting married at the age where the fertility potential is falling. So fertility and fecundity, ability to get pregnant, it decreases. And the social fabric of India is also changing. See, Indian female are not same as European or American female. Our egg number is less, our egg quality is less. Unfortunately, that is the fact. So if we see, so here, at the age of 30 to 34, initially we thought that after 35 the quality of eggs goes down and the number goes down. But no, the fabric has changed. At the age of 30 only, there is sudden fall, if you can see, fall in the rate of fertility and increase in the rate of miscarriages. So yes, age is the most important prognostic factor when it comes to any infertility treatment. That is something we cannot change. We can change treatment protocols, we can change media, we can change injections, but we cannot change the age of the patient. So if you see here, at the age of 20 to 24, there is chance of 86% of pregnancy. Je purvi hota, there were early marriages, there were no problems or any issues, very less problems of getting pregnant. But now we are facing a lot of infertility patients because the age as marriage has gone up. So this is something that, do we need to stop our girls dreaming to be someone who wants to be an athlete or go be a ballet or an engineer or do something with her life because she cannot have children? because she is not going to have that, pleasure of being a mother. Because can we force every girl to get married at between the age of 20 to 24? The answer is no. So what we can do about it? So here another important factor about age is, it is not just because about the egg number or the egg quality, it is about the aneuploidy of the embryos. So there are a lot of chemical pregnancy losses, lot of embryos which are not implanted, and that is why the chances of natural pregnancies or the chances of infertility treatment goes down. If you see here, at the age of 43, there are chances of abnormal embryos is almost 80%. So how can we test it? Suppose like what I told you now, that in India there are a lot of females who are having premature ovarian menopause. There are many gynacs here, and we know that at the age of 28, 27, after 25 also many girls are coming with low IMH levels and poor ovarian reserve. So how can we test it? All of us, we have had our kids. All of us, we have, but this is not only for us. This is for our patients, this is for our daughters, this is for our daughter-in-laws who are going to come here, who are going to be very strong, career-minded females. So we check our hemoglobin, we do our routine tests, but do we check our fertility potential of our kids or of our daughters or daughter-in-law when they plan something for their future married life? So how can we test it? So basically, I don't want to go into detail, but the age is the most important prognostic factor, but we cannot rely on age. There can be a female of 35 years age who will have good eggs, but there can be a female of 28 years age who will not have good eggs. So we have to do AMH, that is anti-Mullerian hormone, and we have to do a simple sonography, transvaginal, to do her antral follicular count. So those are the two most important things which should be done before she plans her. For our kids, we plan so many things, for her admission, for going to 11th, 12th career. But this is also something, family life is also something which is very important. And as a gynecologist, now we are recommending, little bit early marriages, little planning pregnancies, first pregnancy early, or at least do something with your eggs so that you will have if you want it later. Yeah, so these are the tests that we should do. As ESHRE is the European society, which is the most standard society, which puts up guidelines for this, all the infertility workup. So they recommend these two tests. So as I told you, ART is something that we deal with, we try to fight with nature in that, and sometimes it is such a negative branch because here the age is not our friend. And when a patient comes to us and she is not ready for donor egg, if you see the green chart, after 30 to 32, the result starts falling. If she opts for donor oocyte and she has a poor reserve, then she has a similar, the blue chart says the similar success. But we cannot force anyone, or rather everyone has a right to go, have their own biological child. So for this, we have to consider doing egg freezing for such a specific class of females. So it is basically a patient is given injection, the oocytes are taken out transvaginally after anesthesia, and the oocytes are frozen. Freezing is something that we routinely do for semen embryos. It is just taking those cells to -190 degrees, and in that temperature they remain alive and remain potent for infinite period of time. Yeah, so this is something which is not experimental. I am not coming up something which is, which requires a lot of further studies, but it has been, this is the American College of Obstetrics and Gynecology. It says that it is not an experimental thing. So we have to consider it seriously and think of doing it for our patients, our relatives. Yeah, so initially if you say that still there is no much awareness. People come to us now, we are 35, married since 8 years, आम्ही लांब राहत होतो किंवा करिअरचा प्रॉब्लेम होता आणि आता आम्हाला मूल हवंय आणि आता मग oocyte कमी झालेत. Still young, educated people are coming like that. So only 2% of IVF cycles are done for oocyte freezing. If you see, the number of cycles using eggs, whatever eggs are frozen, they are not utilized later on that much. And but because now the technology of oocyte freezing has changed slowly to the fast freezing technique, now we are getting better oocyte outcomes and better results. Yeah, so there are many options, there are different scenarios. I'm talking about social freezing, but sometimes we have a young girl who has a ovarian tumor. Most of the times what happens is whenever patient comes to us or a surgeon or a pediatrician who is 12 or 13-year-old and she's diagnosed with a ovarian malignancy. At that point of time, we are so worried, the relatives are so afraid of her malignancy or losing her life that we do not think of her future marriage, her future potential to have kids. Most of the times, the oophorectomy is done of the same ovary and she is directly put up for chemotherapy and her ovaries are fired. Her life is gone. She cannot get married. And I know marriage is not everything, but from the place from we come from, for a family, it is very difficult to have a child who cannot have pregnancy, cannot get married, cannot have kids. So for this reason, there have been different, we can do directly, ovary can be taken out and can be preserved. Ovary can be transpositioned that we saw in the robotic surgery yesterday. So there are many ways. So here I would like to urge every surgeon, every pediatrician or every gynecologist sitting here, whenever we have a pubertal lady, a girl who has an ovarian mass, we have to consider her fertility options later on. Yeah, so these are some conditions. Another important condition is endometriosis. We know many actresses, I don't want to take the name, that they have endometriosis and they have already frozen their eggs. Now they can wait till 38, 40 because they have their eggs frozen and they can have the pregnancy later on. But here we have to do counseling of the patient. It's very important because sometimes the frozen oocytes, when they are thawed, may or may not give good results. So accordingly, the counseling has to be done. Here, if that patient who is coming to you is already married, so it is better to take out the eggs, form the embryos, because embryos, they sustain the freezing better as compared to eggs. So it is always better to freeze the embryo than the egg. If she has a partner, they should go for embryo freezing and let them plan pregnancy whenever they want to. Yeah, so cancer we have already talked about. Some important points here that very low risk, if we go for targeted agents, that we have to communicate with our oncophysician where we are sending our patient, that if we are giving her targeted therapy, then her chances of her ovaries and endometrium getting fired is very less. Yeah, so here is one more point to be taken from this slide is that we do not want to risk her life. Her life is more important than her fertility, but that is why there are so many protocols. We need not have to wait for her menses also. We can directly start her from random protocols where within 10 to 12 days, we just need 14 days of her life to save her oocytes. That is what, as an infertility consultant, we are asking for. After that, we can give whatever chemotherapy we want, but those 14 days are going to give her better life later on. Yeah, so that is what I told you about slow versus fast freezing. Now the technique of fast freezing has come up, which causes less ice formation, more oocyte retrieval, and the pregnancy rate is always equivalent to the fresh oocytes. So how many oocytes we want here? The only point important is if a patient is coming to us at the age of less than 35 years, usually if we see that, we get 16 oocytes, but if she comes to us at more than 40 years, so maximum number of oocytes that we get is 9. So chances of getting euploid embryos from that is very less. So take home message from this slide is, if you want to go for freezing, better to do it at younger age. Now at 38, अजून मला 1-2 वर्ष थांबायचं आणि मग मी करते, then already your chances have gone down. Yeah, so better freeze at early age and then your plan your life accordingly. So everything is age dependent, and again the chances of, if you see the number of euploid embryos at less than 35 years, if we see, the chances is 2.5% that we get those embryos, but at the age of 42, it's 0.1%. So again, it's not about the number of egg, it is about the quality and the embryos we are going to take. So overall, what we see, there are a lot of studies that 51%, whatever patients who have undergone oocyte freezing, they anticipated their future. 95% would say, I would do it again if given chance to. 76% of them said, no, I would have done it at younger age. Yeah, and 10% they had regret for whatever reason, and 45% said that I would have done it if it was cheaper. So we need to work on protocols which will minimize the cost of this, and so that many patients, such kind of patients can be benefited. आपल्याला असं वाटतं we are doing something abnormal, we are dealing or messing with the nature, so would it affect my oocyte, would it affect the baby that we'll have? So no, the safety of egg freezing has been already established and studied, and it does not increase any chances of abnormality in your child. Yes, of course, with any procedure there are some small risk of oocyte stimulation and whatever, which is already there for any IVF procedure you go for. And yeah, as it is coming up, there are no long-term studies. I mean, we do not know that what happens to that embryo at when that baby is 35 years of age. But yeah, the studies are ongoing. So in short, age-related infertility is one of the biggest challenge that we are facing in modern medicine. Oocyte pool is fixed and declining with age. So ovarian reserve testing shows size of recruitable follicle, that is very important, and they can be cryopreserved with IVF success rate similar to fresh IVF oocyte. So as we said, the biological clock is ticking and we cannot fight with the time, but we can hold the time. We can set the timer and we can hold the time, and women can take charge of her life and can have it all. Thank you.
Thank you, Revati ma'am, for elaborating new point of view in oocyte freezing in view of preserving fertility for women in new era. I would like to ask Gujar ma'am to felicitate our speaker.
No, it's very wonderful. Even as a radiologist, we loved it.
Now for the next lecture, he is the dynamic personality from Satara, not only in medical field but also in literature and expertise in co-curriculum activities, Dr. Shantanu Abhyankar sir, and his topic is Menopause Revisited. I would like to ask Dr. Vivek Gujar sir to introduce our speaker.
Dr. Shantanu Abhyankar needs no introduction. He has passed his UG and PG from BGMC Pune. He was the president of Satara and Obstetric and Gynecological Society in 2015 and 17. Chairperson of Sexual Medicine Committee, FOXY, in 2011 to 2013. He was the organizing chairperson of UA FOXY 2010 and AMOX 2019, a well-known writer, orator, blogger, innovator, and TED speaker. He has 8 million views on his YouTube. He delivered several orations. Over to you, sir.
Thank you, Revati, for having invited me here. And thank you also for putting up all those videos on social media which educate the patients from time to time. I believe that is a very, very important task that you've taken up for AMOX. Now, I am here to talk about menopause revisited. So I'll only be talking about the changes that have come up. There is no presentation. It's me who is going to present. So you have to look at me. Lights chalu kara. There is a pendulum swing. We have the Women's Health Initiative data now. And maybe in our college days, we learned that all women should receive hormone replacement therapy, which is no longer the case. So we actually look for an indication, rule out all, see to it that there are no contraindications, and only then put the woman on this. I'll try to be as brief as possible and give you just the bullet points. So we assess the benefits and risks. There are also changes in the age and the time since menopause that we are giving this. It has to be started, if at all it has to be given, it has to be given at an age earlier than 60 years of age and is best started within 10 years from the last menstrual period. It is no longer called hormone replacement therapy, it is called menopausal hormonal therapy, because we are not replacing anything, we are only assisting the body in whatever problems it has landed up because of some hormonal changes. It is most effective in vasomotor symptoms, which are the most commonest problems with menopause, and women suffer from these vasomotor symptoms which are very, very real. It is also effective in genitourinary syndrome, wherein it leads to dryness of vagina, some urinary incontinence, and itching, and such other things, and in osteoporosis. So these are the things in which it is really, really very, very helpful. There are other benefits, though we don't actually treat these conditions with hormone replacement therapy, either keep the lights on or switch them off altogether. So there are other benefits, though we don't use these as indications, but these are the sort of beneficial side effects of this particular management strategy. So the sleep will improve, the joint and muscle pain will go away, mood swings will be less. There is an improvement in sex life, especially due to certain agents, and decreased chances of colonic cancer, decreased diabetes and metabolic syndrome, and possible benefits on coronary vascular disease and even cognition. Coming from the indications, we move to the absolute contraindications, which we must know. History of estrogen-sensitive breast cancer is an absolute contraindication. History of endometrial malignancy is an absolute contraindication. Active liver disease, thromboembolism, and undiagnosed vaginal bleeding. The textbooks also list pregnancy as one of the contraindications, but then I really don't know why it is there. It's quite obvious since we define menopause as 1 year of cessation of menses. Pregnancy, I believe, is practically ruled out. Anyway, so I told you that it is now menopausal hormonal therapy. There was a condition defined as premature ovarian failure. Now we have another. And then there is premature menopause, which is now called premature ovarian insufficiency, meaning thereby that in premature ovarian failure, there is a chance that the woman will regain her menses and maybe even have babies later on, whereas in premature menopause, this does not happen. It is defined as menopause earlier than the age of 40. We are using as low dose as possible, and I'll come to the doses in a little while. And we are using less androgenic progesterone. So no medroxyprogesterone acetate or norethistérone is used in hormone replacement therapy. If at all, you have to add the progesterone. And surprisingly, it is found that it is the progesterone that is related to the increased chances of breast cancer and not the estrogen component of it. So the estrogen remains and the progesterone is the one that we have switched from medroxyprogesterone and other androgenic progestrogens. There is a drug called ospemifene, and it is especially useful for vaginal atrophy, and women who have sexual problems would be helped with this. And then there is the TSEC, tissue selective estrogen complex. We'll come to it in a little while. So the conventional hormone therapy that was offered to symptomatic menopausal women, not as a prophylactic to anything, symptomatic menopausal women, is only estrogen if the woman does not have a uterus, and estrogen plus progesterone if the woman has a uterus. You can give them in a sequential fashion if she is perimenopausal, or continuous estrogen and progesterone if she is well into her menopause. Then there are selective tissue enzyme activator regulators such as tibolone, and of course I mentioned the TSEC. It is recently now is available in India. It's a combination of bezodoxifene and equine estrogen. So this is the most effective. And how long do we continue? As long as the women requires. It is not that you stop at 60 years of age or stop at the natural age of menopause, as long as she requires. Only in girls with premature ovarian failure, who have lost their ovarian reserve very early, we continue it till the natural age of menopause and then stop it. We may add it back again, start it back again if they need it because of menopausal syndrome. This leads to greater acceptance by the women. Now, this particular change from the Women's Health Initiative to the newer guidelines, it came because of two trials. One is called the HOPE trial and other is called the Replenish trial. And one of the important things that these trials underlined was that regardless of the BMI, the low doses are effective, which is such good news. So irrespective of age or BMI, we can start with the low dose. How low? Usually it is the conjugated equine estrogen that is started, not the 0.625 that is the standard dose available, but 0.3 milligrams. And the estradiol, 1 milligram and not the 2 milligram. The starting doses are at least this. Patches and skin gels are also available. And even vaginal estriol and conjugated equine estrogen gel is available. The treatment isn't effective immediately, so the effects is not seen within a days or week. Some effect will be seen after a month and a good effect will be seen after 3 months. So you have to explain this to the patient beforehand. The type of progesterones that are used for patients with intact uterus or those with history of endometriosis, whom we fear giving just plain simple estrogen, is 200 milligrams once a day or 300, 12 days if you're giving it in sequential fashion, or dydrogesterone, that is the new progesterone that we're using, 5 milligrams daily dose. There is a intrauterine device called levonorgestrel intrauterine system, which is very, very helpful. It releases levonorgestrel in low doses, and then you don't have to worry about compliance since it's a IUCD-like device which rests in the uterus. Tibolone, it has got estrogenic action on bone and vagina and androgenic action on mood and libido. So that is possibly the best drug that one could have. But then all the actions are not as much as we want them to be. So, but then still we can use it in a dose of 2.5 milligrams once a day. So there are specific indications, especially libido issues or mastalgia or unpleasant side effects with the routine therapy. These are the women in whom tibolone will be used. Testosterone is the drug of choice. It is said for lack of libido, but to tell you frankly, sorry, testosterone preparations are just not available. They are available for men, they are not available for women. The tissue selective complex, I mentioned the bazadoxifene and the CE, that is estrogen 0.545 milligrams. That is the new tissue selective complex that is available for us. So it is good for menopausal syndrome, for osteoporosis, and it has got no effect on endometrium, and it has got more, it maintains the amenorrhea longer with less mastalgia. Ospemifene I mentioned some time ago. It is a third generation SERM drug. It is an estrogen agonist on the vagina and it is approved for dyspareunia. So this is another drug that is useful for dyspareunia. It increases the bone mass density. So when to start? Like I said in the beginning, with proper indications, ruling out the contraindications. Earlier than 60 years of age and within 10 years of the last menstrual period. The investigations, you do all the routine investigations to check if she's obese, if she's dyslipidemic, and if she's perimenopausal, you choose the sequential. And mammography studies, it is better to do them if they are available, because the lesions in the breast, the already present lesions in the breast are likely to respond to these hormones. So one better be careful. And the follow-up is 1 month, 3 months, and then an annual follow-up. And you have to stop it when symptoms subside. Preferably taper it down. I think this was a brief overview of what all is available for the menopausal women now and what are the latest guidelines in this area of our specialty. Thank you so much.
Thank you, sir, for this wonderful lecture. Any questions from the mob?
Excuse me, sir. When we give estrogen for a longer time, you said we have to keep follow-up, 1 month, 3 month, and annual. What are things we have to look for? Like any things that are contraindicated and we can stop the drug immediately?
What you should be looking for at the end of 1 month is if the patient has got any side effects. You don't expect any drastic side effects because of the drug, but because of the intolerance, sometimes breast pain, nausea, vomiting, these are the things that you must look into. If you find that she doesn't have enough relief, then you can increase the dose. Since we have started at a very low dose, sometimes it is imperative that you adjust the dose at the end of 1 month. At the end of 3 months, you call her back again to again check whether she's got adequate response. It is for these reasons. What you're probably hinting at is systemic side effects and such other things that will come only perhaps 1 year later. When only vaginal estrogen is used, then practically there are no systemic effects.
Thank you, sir. It was a nice lecture. Thank you very much.
Now I would like to ask Dr. Vivek Gujar, sir, to felicitate our speaker.
Cancer screening in females will be delivered by a dynamic and gorgeous gynecologist and infertility specialist from Nashik, Dr. Swapnanjali Award ma'am. And I would like to ask Savita Gujar ma'am to introduce our speaker.
To introduce Dr. Swapnanjali Award ma'am. She is a practicing obstetric and fertility expert in Nashik. She is a co-chairman Women Doctors Wing IMA Maharashtra. She is a member of Socio-Culture Committee IMA headquarters for 22-24. She is a immediate past president IMA Nashik Road Maharashtra. She is a convener Women Doctors Wing IMA for 22-23 tenure. She is a director of Award Maternity Home Nashik. She is a director of Sparsh Garbhini Sanskar Center at Nashik and National Faculty Yuva Foxy. She is a national awardee winner. She is a best adjunct presidential local branch for 22-23. She has received Dr. Ketan Desai National Yuva Leader Award in 2021. She has received Maharashtra State Awards as a President Appreciation Award and Wonder Emoxion Award in 2023. Over to you, ma'am.
Hello, thank you for that kind introduction. I greet you all from the city of wine, Nashik, and it's so lovely to see you all till the end of the session. Now today, the success, I believe the success of my talk would depend on how depressed every one of you will feel. You'll get my point by the end of the lecture that, it's like we aspire of so many things in our life, but then we forget one thing, that there is an inevitable enemy waiting for all men and women, especially women, because they are hardly taking care of themselves. With all the modern technologies, with all the advances, we are going nowhere if we lack in screening. That's the best thing scientists and doctors have given us. आणि म्हणून जर स्क्रीनिंग पण जर आम्ही करू शकलो नाही तर एव्हरीथिंग गोज डाऊन द ड्रेन. सो प्लीज काय आपल्याला आयुष्यात करायचं आहे हे आज मी तुम्हाला सांगणार आहे. आणि आय विल बी युझिंग मराठी, हिंदी, इंग्लिश बिकॉज आय वॉन्ट टू गेट मोर कनेक्टेड. द मोर द कनेक्टिव्हिटी इज अगेन इनव्हर्सली प्रपोर्शनल to the complexity of my talk. So I don't want to make it sound very complex. सिंपल भाषेमध्ये आपण बोलूयात. आणि इथून जाताना मात्र मी जेव्हा इथून उतरेल खाली तेव्हा प्रत्येकाला वाटायला हवं. सो दॅट वुड बी द सक्सेस आय फील. सो लेट अस गेट बॅक टू स्क्रीनिंग. I'm so fortunate enough to come here and talk in front of you all. Thank you, Revati ma'am, for calling me at the 14th Maharashtra State Women Doctors Wing Conference, EVECON 2024. Ata important ka screening. Now screening is something that nobody wants to talk. Everyone wants to talk about treatment options. What all investigation, test kai naveen ahet. Because that makes money. And screening is something we waste money on. So nobody wants to talk about screening. But let me tell you, when we invest more money on screening, we actually save our money on treating. So I think screening is the most important thing a doctor has to look upon. Now, early detection helps in each and every cancer. Mind you, every cancer has that time period when you can screen and start treating. You can make the life better of that cancer patient. So screening is again important for each and every cancer out there. Prognosis, it would be better in early stage. जेवढं लवकर कळेल आपल्याला prognosis तेवढं चांगलं असणार आहे. Ease of treatment and tolerability of patient. And obviously, we are all earning, we are all working so hard to increase our quality of life, and that will increase only with early screening. Definition, the most boring part of any talk is the definition. Let me go through it. Secondary prevention method in which early therapeutic intervention is possible through screening and asymptomatic population. Please, I would like to stress again and again on this. Don't let you get all the symptoms and then go for screening. Screening is only for asymptomatic patients, म्हणजे ज्याला काहीही त्रास नाही आहे त्याने स्क्रीनिंग करायची आहे, त्रास सुरू झाल्यानंतर नाही. So asymptomatic population to identify cancer at an early stage than it would have been diagnosed in absence of screening. Why to do the screening? What is the goal of this thing? To reduce mortality and or severity of the disease through early detection and treatment. Principles काय आहेत? स्क्रीनिंग का करायची, कधी करायची आणि ते करून आपल्याला काय साध्य होणार आहे. So disease should be important health problem. You can't screen for common flu. It is not a very difficult health issue, not a problematic thing. So ज्याचा सगळ्यात मोठा प्रॉब्लेम आहे त्याच्यासाठी स्क्रीनिंग करायला लागेल ना आपल्याला. Then natural history of the disease presents a window of opportunity. If a disease does not have a big window, then what is the use of screening? If after screening with the symptoms, the patient is going to present to you within a month or two, effective treatment should be available that favorably alters natural history of the disease. Treatment option असेल तर screening करायचं. Treatment option nahi hai, then there is no use of screening at all. Treatment again should be not just available, but it should be effective. Fakta treatment द्यायची नाही आपल्याला, effective treatment, and it should be initiated earlier than the symptomatic stage. Once the symptoms have come, then it is no more a screening thing. It should be available, of course. You can't screen if the test is not available. And the strategy. That is again very important. Now, being a gynecologist, आपण cervical cancer screening, breast cancer screening, ovarian cancer screening वर एवढं सगळं बोलतोय. But do we actually think about it की कोणत्या population साठी आपण हे सगळं करतोय आणि तिथपर्यंत हे पोहोचतंय का? So target population, if you can't reach, you can't make them aware, then it is of no use. म्हणून सगळं अवेलेबल आहे, पण ते कोणासाठी अवेलेबल आहे आणि कोणाला त्याचा उपभोग घेता येईल हे जर आपण नाही सांगू शकलो, then it is totally a waste of money. So you should arrange these screening programs as per the target population. If जर एक सिंपल राहणीमान किंवा दारिद्र्य रेषेच्या खाली जे असतात त्यांच्या राहणीमानामध्ये जर काही आजार असतील तर you have to go and reach to the slums. You have to go reach to the low socioeconomic status, and then talking here in affluent society is of no use when we are talking about a cancer that is there in the affluent society. Ideal screening test, we all know this, it should be cheap. स्वस्त हवी आहे, सेन्सिटिव्ह, स्पेसिफिक, ॲक्सेसिबल, सेफ, ॲक्सेप्टेबल बायस असतात काही स्क्रीनिंगमध्ये. नाव दीज बायस, आय वुड लाईक टू स्ट्रेस अ लॉट ऑन दीज बायस, कारण या बायसमुळेच आणि इफेक्टिव्ह स्क्रीनिंग न केल्यामुळे फॉल्स रिझल्ट्समुळे काय प्रॉब्लेम होऊ शकतो आपण त्यावर पण बोलणार आहोत. देर कॅन बी अ लीड टाईम बायस, देर कॅन बी अ लेंथ बायस, सॅम्पलिंग अँड सिलेक्शन बायस. पिटफॉल्स काय आहेत? स्क्रीनिंगबद्दल जर बोलतोय तर काय त्यामध्ये चुकीचं होऊ शकतं ते पण आपल्याला माहीत हवं आहे. सो there can be a false positive test result, unnecessarily anxiety. We literally get at least 10 patients every month with a breast lump that is absolutely normal. They just want to remove it. So that is when I feel that I failed as a doctor. If I could not reach and I couldn't educate them regarding the lump that they are presenting with, it's totally of no use. So फॉल्स पॉझिटिव्ह रिझल्टसुद्धा तुम्हाला नीट समजून सांगता आला पाहिजे. ओव्हर डायग्नोसिस, नेवर डायग्नोज एक्स्ट्रीम कंडिशनमध्ये की हे होऊ शकतं ते होऊ शकतं. इतकं हायपर जेव्हा आपण करून सांगतो, ओव्हर डायग्नोज करतो, डेफिनेटली दे आर गोइंग टू गेट ओव्हर ट्रीटमेंट. सो दॅट शुड नॉट बी डन. फॉल्स नेगेटिव्ह टेस्ट रिझल्ट जे आहे falsely reassure an individual with subsequent clinical signs and symptoms of cancer and thereby actually delay diagnosis and effective treatment. स्क्रीनिंगमध्येच एवढे महिने घालवले तर ट्रीटमेंट कधी देणार आपण? सो इट हॅज टू बी व्हेरी फास्ट, एफिशियंटली डन अँड डन इन प्रॉपर कंडिशन्स. अगेन चॅलेंजेस आपल्याला आहेत. कॉस्ट. To cut down the cost, government has come up with very nice programs. People like us, now I would always talk more on gynec कारण मी त्या फील्डमध्ये आहे. आम्ही आमचा वेळ, आमचं नॉलेज, आमचं इनफॅक्ट even we are sacrificing our practice to reach out to people to make them aware of the screening programs. We actually go and test them. So cost is not a problem these days. Actually समजावून सांगणे आणि त्या लोकांपर्यंत पोहोचणे is a bigger challenge, I would say. ट्रेनिंग ऑफ मॅनपॉवर. नाव दॅट्स द रिझन की आपल्याला इतक्या सोप्या स्क्रीनिंग टेस्ट आणायला हव्या आहेत की ज्या नॉन एज्युकेटेड लोकांना देखील त्या स्क्रीनिंग टेस्ट पुढे प्रोव्हाइड करता येऊ शकतात. सो आय विल टॉक अबाउट दॅट अगेन. फॉलोअप मॅनेजमेंट डेफिनेटली हे व्यवस्थित होत नाही आहे आणि ॲडिक्वेट लिंकेज फॉर फ्युचर ट्रीटमेंट, फर्दर ट्रीटमेंट. सो आता आपण जेव्हा हे पाय डायग्राम बघत आहोत आपण, यू कॅन सी दॅट ब्रेस्ट, सर्विक्स आणि युट्रस म्हणजे गर्भाशयाचा मुखाचा कर्करोग, पिशवीचा कर्करोग आणि स्तनाचा कर्करोग. जर आपण तिन्ही कॅन्सर बघितले, इट कंप्राइजेस ऑलमोस्ट 50% ऑफ द कॅन्सर्स दॅट females they are facing right now. Now these days we are seeing more of lung cancer and colon cancer as well because of passive smoking or like inappropriate food habits. So that also should not be ignored these days. Now the guidelines, मी काय फार डिटेलमध्ये गाईडलाईन्सबद्दल बोलणार नाही आहे. I don't want to educate you about this. I just want to make you know what you should be able to do. सेल्फ ब्रेस्ट एक्झॅमिनेशन सगळ्यात सोपं आहे. आपल्या हाताने ब्रेस्ट एक्झॅमिन करायचं आहे. दिस इज द सिम्पलेस्ट वे अ हजबंड कॅन डू फॉर हिज वाईफ, वाईफ कॅन डू फॉर हर सेल्फ, शी कॅन डू ऑल्सो फॉर हर मदर. नाव दॅट इज अगेन व्हेरी इम्पॉर्टंट, अँड हर मदर इन लॉ. Now you have old women at home. If they can't do it themselves, you have to do that. That is your responsibility as a woman. Axilla, breast, collarbone, every month. Cycle येऊन गेली की 3rd to 5th day after period you need to check. Maintain a record. Now that is again important. कालनिर्णय सर्वांकडे आहे. So make use of that, please. So that is not just to be hanged on the wall. It has to be used for this and also for the periods of the doctor's visit as well. Now this, if there's a doubt, they can go to a clinician and get it done again. And high risk population madhe, along with general population, it has to be done. There is no high risk these days. Everyone, every person is at a high risk is what I believe now. These are the typical signs that we see. Mammography वर फार again मी डिटेलमध्ये जाणार नाही आहे. This is not for you to understand. Let the doctor, treating doctor, explain it to you. काळजी करायची गरज आहे की नाही. And again, please, you are not the expert. then don't try to diagnose yourself. You just have to go to a doctor and ask whether I need to worry or not. High risk population, more than 20 to 25 time lifetime risk of developing CA breast. Sorry, I'm so sorry. More than 20 years. When you are more than 20 years, you have a 25% lifetime risk of developing CA breast. Now, I believe everyone with a breast can have a breast cancer. That includes males as well. Okay? So, everyone, even if a male has some lump or some kind of a growth in the breast, in the chest, they also should go and get it checked. BRCA gene mutation, it has a lifetime risk of 55 to 85%. P53, Leaf Raumani, P10, Cowden, Pitts, Jaggers, ATM and other mutations, again hi-fi things. Don't pay attention to all these things. Strong family history is a very important thing. I have seen, literally we have seen everyone की आपल्या फॅमिलीमध्ये एक तरी जर अशी केस झाली CA breast, CA ovaries. We as a doctor, we try to explain it to them that everyone needs to get screened. None of them, they get screened because they feel that if we get screened, in case we come positive for that, that would be a very difficult, time consuming, and they'll require money, a lot kind of money. So they won't go for a screening. कारण screening केलं की आपल्याला होणार कॅन्सर ही एक भावना आहे आणि त्यामुळे आपल्याला त्याच्या पलीकडे जाऊन आपल्याला समजून सांगायचं आहे. Prior history of lobular carcinoma in situ. Very important. आजकाल सर्वांना सेल्फ ट्रीटमेंट हवी आहे. हेल्दीफाय and what not apps are available over there. See, first thing, please don't kill the joy, whatever left you have in your life. So, I always feel this, that by replacing your morning coffee with green tea, ऐकायला खूप सुंदर वाटतं green tea. But then you can lose up to 87% of whatever little joy you still have left in your life. So please don't go for anything hi-fi. Please be simple and as easy as possible. काय अवॉइड करायचं आहे आय थिंक सर्वांना माहिती आहे. मेडिकोज, नॉन मेडिकोज, नॉन IMA, IMA, एव्हरीवन नोज. अल्कोहोल, टोबॅको, प्रोसेस्ड फूड, ओबेसिटी. Obesity again, easier done than said. Easier said than done, I would say. So there are ways to tackle once you accept few things. Accept that you are obese and then you will be able to solve the problem. आजकाल acceptance-लाच problem येतोय. People say no body shaming, that I'm against that. Body shaming is a good thing, but provided there are some results. Otherwise, you just can't say that, okay, I'm quite good, I'm looking good, and I shouldn't be body shamed only because I'm fat or I'm obese. It's okay, just accept it and know that this is a wrong thing, you need to change it. Breastfeed kara, the best thing, easiest thing. I think all mothers over here, they must have understood simplest way to feed your child is breastfeeding. Exercise, an active lifestyle, balanced fiber-rich diet, vitamin D adequacy. Tropical country मध्ये मला हे कळत नाही की 80%, 70% are vitamin D deficient. That is absolutely like unbelievable. Countries, other countries which don't get enough sunlight, they are surprised to know that Indians are deficient in vitamin D. That is because we don't expose our skin properly to the appropriate kind of light. Yeah, I'm almost ending it. So sunlight is very important again. पण कपडे घालून नाही. I think sunbath should be encouraged. So this is something, the barrier has to be broken. आणि सनलाईटमध्ये थोडा वेळ घालवा. जसं जुने लोक जे अंगणात बसून जेवण वगैरे करायचे, न्याहारी वगैरे करायचे, नाश्ता करायचे. I think that has to come into the picture. Cervical cancer, don't pay attention to this. Not very important. Again, high risk म्हटलं तर आपल्याला नेहमी वाटतं चला आपण हाय रिस्कमध्ये नाही आहेत. But let me go through it. Multiple sexual partners, okay. आता a catch there is multiple sexual partners. पण त्यामध्ये if a sexual partner, even if you have a single sexual partner who has another sexual partner who has CA cervix, then you are at a greater risk. So even if there's a single partner, but he has a infected partner, that is also high risk. Early age of sexual intercourse. Now this thing, I think increasing the marriage age doesn't change that. So it's something that concerns me a lot but can't be avoided. Only thing is that the awareness has to be increased. Barrier contraceptives and all, they should be freely available for this youth. History of HPV infection or condyloma or both. History of herpes simplex virus infections, vulval cancer, immunodeficiency, you just name it and all, everything is there as a high risk. Now I think just eating food also will be in high risk after a few years. Because everything has so many carcinogens in it that this is like with westernization you will get the western country illnesses in India as well. So in western countries every family has a person who has died of cancer. So now I think in the coming years we will also have one person who has died with cancer. So it is not a long time dream, it is something that is there waiting at our door and knocking. So I think this is the time when we should start screening. Low socio-economic status, again, काही फरक पडत नाही, high socio-economic मध्ये पण होतं. We have seen very high-fi women who don't know how to have a good private part hygiene. So that has to be inculcated in families these days. Smokers and abusers of other substances, including alcohol. Now smoking as well as passive smoking. Passive is more dangerous since a smoker at least has a filter. But a passive smoker doesn't even have a filter. So that is more dangerous for that person. Screening test कोणकोणतं available आहे? Everyone knows this. Pap smear आहे, liquid based cytology आहे, colposcopy, co-testing, which is like in vogue these days. आता आजकाल सगळे पेशंट येऊन म्हणतात co-testing करा म्हणून. Another thing is that, you know, जसं मी सांगितलं की स्क्रीनिंग टेस्ट सिम्पल हवी आहे. म्हणजे एक नॉन मेडिको, एक आया असेल, सिस्टर असेल, मावशी असेल, टीचर असेल, तिलाही करता आली पाहिजे. सो आय थिंक इट्स फॅड वगैरे सगळे बाकीचे जाऊ द्या, पण आज आपल्याला ज्याची गरज आहे ते करायचं आणि दॅट इज सिम्पल व्हिज्युअल इन्स्पेक्शन. यू कॅन यूज ॲसिटिक ॲसिड, दॅट्स द सिम्पलेस्ट वे. सगळ्यात सोपं, स्वस्त अँड कॅन बी डन बाय एनी वन. रिझन्स काय काय आहेत? वी हॅव ऑलरेडी डिस्कस दॅट. लॅक ऑफ नॉलेज, अ फॅटॅलिस्टिक ॲटिट्यूड टुवर्ड्स कॅन्सर. कॅन्सर व्हायला नको म्हणून चेकच नाही करायचा, शुगर व्हायला नको म्हणून चेक नाही करायची. नाव आय डोंट थिंक एनीवन कॅन अंडरस्टँड दिस, पण हे होतं आहे आणि वी आर ऑल्सो द कल्प्रिट समवेअर. एकदा एकाला CA समजला की आपण त्याला इतकं घाबरवून टाकतो ना की स्क्रीनिंगमध्येच की असं होऊ शकतं, ते होऊ शकतं, जस्ट थिंकिंग की अरे आपण नॉलेज दिलं पाहिजे. अरे पण तुम्ही नॉलेज जे देताय ते जर अप्रोप्रिएटली नाही देताय, इफ यू आर गोइंग टू टेल दॅट पर्सन की स्क्रीन करताना यू मे गेट कॅन्सर, वाय इज दॅट पर्सन गोइंग टू कीप द युट्रस ओव्हर देअर? सो इफेक्टिव्ह awareness is, again, you can't stress more on that. Lack of knowledge by the medical and paramedical, including us. And हे जे सगळ्यात इम्पॉर्टंट आहे, डिसऑर्गनाइज्ड स्क्रीनिंग प्रोग्राम. स्क्रीनिंग प्रोग्राम कॅम्प एका ठिकाणी होते, तिथे स्क्रीन होत आहे, ती व्यक्ती परत दुसऱ्या कॅम्पमध्ये जाते, तिथे स्क्रीन पॉझिटिव्ह होते, तिसरीकडे जाते, स्क्रीन पॉझिटिव्ह होते. दे आर जस्ट फाइंडिंग, सर्चिंग अ कॅम्प वेअर दे विल स्क्रीन नेगेटिव्ह फॉर दॅट. सो they are not followed properly. Disorganized असल्यामुळे हे सगळे प्रॉब्लेम आहेत. Please have something organized and which I think only government can do. Private मध्ये it's very difficult to keep a follow-up. A simple LBC, a liquid based cytology, will take somewhere around 1,000-1,200. Again 400-500 डॉक्टर्सची फी 1,500 द्यायचे हे समजून घ्यायला की मला काहीच नाही आहे, त्यापेक्षा आम्ही काही न केलेलं बरं, सिम्पटम येतील तेव्हा बघू, हा ॲटिट्यूड झालेला आहे. अँड लॅक ऑफ equipment, healthcare facilities. Now if you don't have a colposcope, definitely you can't do anything. I have seen hospitals who don't have acetic acid. And then I told, like, I won't name someone, but then I just gave an idea. See, you must be having vinegar in your kitchen, right? So that is acetic acid. And then it was like, oh, this is something that we have everywhere. But still, why is it not in the hospital yet? So every gynec hospital should have acetic acid, a speculum, sim speculum, and every woman who comes there should get, according to me, this is what I offer. Every 35 plus ला VIA करा acetic acid ने, free of cost करा, ती आयुष्यभर तुमचं नाव घेईल. ठीक आहे? So that is the best thing a doctor can offer. Genital hygiene, screen and diagnose early, and HPV vaccine. Now vaccine is something that we have got. Just imagine, कोणत्याच कॅन्सरवर वॅक्सिन नाही आहे, सर्विक्सवर मिळत आहे, जे की सगळ्यात मोठं कॉज ऑफ डेथ आहे. वी हॅव सीन दॅट पाय चार्ट. 30 to 35% कॅन्सर जो आहे त्याच्यासाठी जर वॅक्सिन मिळते, एक लस मिळते, सो हू वॉन्ट टेक दॅट? अ फूल ओनली वॉन्ट टेक दॅट. आणि इट्स व्हेरी डिसहार्टनिंग टू से दॅट वी ऑल आर फूल्स ओव्हर हियर. ठीक आहे, किती जणांनी वॅक्सिन घेतलेलं आहे? कॅन यू प्लीज रेज युअर हँड?
No one.
See, we just have 2 people, including me, 3 people. I've taken 4. So I've taken that vaccine 10 years back. कोणती वॅक्सिन बाजारात आली तर पहिले हेच होणार की ती खराब आहे, त्याचे काहीतरी प्रॉब्लेम्स असतील, ओव्हेरियन इन्सफिशियन्सी, प्रीमॅच्युअर ओव्हेरियन फेलियर. Mind me, let me tell you, I have a very good obstetric history. I have 2 lovely kids. I had taken that vaccine. I don't have PCOS, anything, no ovarian failure, nothing. So, you know, it's better to die with PCOD or with ovarian failure rather than dying with cancer. You know, it's that easy to understand. So vaccine,
Sorry to interrupt, but we are running very
yeah, this is the
short.
last slide. Yeah,
Please.
This is the last slide. सर्व वॅक्सिन उपलब्ध आहेत. 3,500 मध्ये क्वाड्रावॅलंट मिळते आणि नॅनोवॅलंट अराउंड 10,000. आय डोंट थिंक दॅट इज व्हेरी डिफिकल्ट टू लाईक इट्स नॉट काइंड ऑफ लाईक नॉन अफोर्डिंग. सो एव्हरी वन हॅज टू टेक दॅट. आजकाल गव्हर्नमेंट प्लॅन्समध्ये पण अवेलेबल आहे. ओके, द रेकमेंडेड एज, एव्हरीथिंग इज अवेलेबल. एव्हरी वन कॅन टेक इट. 26च्या पुढे किती बेनिफिट होतो सांगता येत नाही, पण बेनिफिट थोडा जरी झाला, आय थिंक 10% जरी झाला, सो इज इट लेस? नो, इट इज नॉट लेस. And love yourself. Thank you.
Thank you so much, ma'am, for this wonderful lecture. I would like to ask Dr. Mansi Inamdar, ma'am, to felicitate our speaker.
The next lecture will be on mental health in females. It will be delivered by the Iron Lady in a Mediqueen beauty pageant, a vivacious gynecologist from Mumbai. And a little gossip we had yesterday night, that she told me that in the last lecture there will be only me, Revati ma'am and Emosis will be there only. But see ma'am, still there are few people for your lecture. So please.
And she is a very good shire, so I'm hoping to, you know, get one good shayari to begin with, yeah. And I assure that every waited for this lecture. She is such a good orator.
Chairpersons, they'll also be present, no, obviously.
I would like to ask Manisha Shinde ma'am to introduce our speaker.
It's my privilege to introduce a charming lady, Dr. Supriya Alvari ma'am, consultant obstetric and gynecologist and infertility specialist. She has done her UG and PG from KEM Hospital, Vadia Maternity Hospital, ZGS Medical College. Practicing at Supreme Hospital, Bhiwandi for last for 20 years.
It's okay, fine. I will introduce her. Brain with beauty, one line, finish.
Oh, so sweet. Thank you. And organizers of EVECON, I am the closing batsman. You know, normally the last speaker says, I am standing between you and lunch. Now the lunch is also gone. So
You are Dhoni, ma'am. You are Dhoni.
And your departure home.
You are Dhoni. You are the finisher.
So I'll keep it, you know, short and sweet. Thank you, Revati, for having me here. Thank you, Swapnanjali, all you beautiful women and men who are waiting back. अधूरी कहानी पर खामोश होठों का पहरा है, चोट रूह की है इसलिए दर्द गहरा है. अकेले मत रो, दिल का बोझ उतार दो, आंसुओं को समंदर को किसी कंधे का आधार दो. मत रोको अंदर के सूनेपन को, कभी समझो कभी समझाओ अपने अंतर मन को. Thank you. And if you are wondering why I am talking about mental health, so let me tell you, I am a psychiatric, not patient, but psychiatric doctor's mother. My daughter is a psychiatrist. Well, that doesn't qualify me to give a mental health lecture, but yes, I am going to try my best because this topic is very close to my heart. We all know mens sana in corpore sano, you know, always a sound body only with a sound mind. So if your mind is not sound, your body is not going to be sound. And therefore, I am running a project Mananti with AMOGS, that is the Association of Maharashtra OBGYN Society. And we plan to, already we are underway, and we plan to take up more mental health issues, mental health sessions for doctors, for the public at large. So now let us discuss why we are even talking about mental health, and that too at the end of the talk. कि आपने खा पी लिया, पेट भर लिया, अब मन भर के आप वापस जा सकते हैं, right? WHO constitutes the definition of health as a state of complete physical, mental, social well-being and not merely absence of disease or infirmity. इसका एको कम कर सकते हैं? नहीं तो मैं गाने लग जाऊंगी एको. In underserved population, activities have tended to focus on issues related to reproduction such as family planning, childbearing, everything in women's health, but women's mental health has relatively been neglected. 45% of women with mental disorder and activity limitation. Now this is a huge number. We are talking about 50% of the population which can contribute positively to our country, to the growth of the nation. And of these 45%, so nearly half women are going to be in some point of time or the other incapacitated due to their mental health disorder, especially between 18 to 44. That is the most reproductive time, not only reproductive function wise, but otherwise also a productive time of your life. Sorry. Okay, why women are more prone to psychiatric illnesses? Mental health of women must be considered in the context of their lives, because they are multitasking, they are, waging wars on various fronts. Okay? For example, a man comes home and he'll say, I'll help you with the chores. Why does he need to say help you? Is it not his chore too? He should be saying, I'll do my share of the chores. He will say, I'll help you with the chores. जो अच्छा है, करता भी है तो भी at the back of the mind उसके दिल में रहता है, ये इसका काम है, मैं मदद कर रहा हूँ. नितिन वहाँ से देख रहा है सब गुस्से में एकदम. Okay, overall equal number of women and men get diagnosed of mental disorders. However, depression, panic disorders, general anxiety disorders, GAD, OCDs, PTSDs, are eating disorders, somatization disorders are significantly greater in women. The gender disparities, basically genetically women are more predisposed. Hormones are playing havoc in their life right from a young age. You know, the changes, number of changes that, hormonal changes that we undertake. Trust me, if the men had to do even 1/10 of that, they will all be admitted to the psychiatric hospital. Neurodevelopmental differences, neuropsychological or physiological changes, difference in the stress receptivity. See, nature has made women more emotional, more receptive. If you all have read the book, Men Are From Mars and Women Are From Venus, the crux of the matter is why women are like this and why men are like that. Because women have been prepared for motherhood. Imagine एक आई जी नुसती अशी है तो छोटू धावतोय ना, with all those male hormones raging, अशी बाई असती तर how well can she look after the child? She will, म्हणजे नुसतं त्या बाळाला पकडताना सुद्धा, you see the touch of a mother, see the touch of a father. I remember when my daughter was born, my mother used to say, अगं तुझ्या नवऱ्याला सांग तो एक दिवशी हाड मोडेल तिचं, आणि त्यांनी खरंच मोडलं एकदा. He just picked the खेळ, मस्तीचे खेळ करता करता, he had dislocated. See, that is the difference, that a woman has been made gentle, soft, so that she can look after her children well. She doesn't harm them while she is bringing them up, you know. And that is why they are more receptive to these emotional changes, to emotional disorders. What are the psychiatric aspects of the reproductive cycle? All phases of the reproductive cycle can predispose women to various kind of psychiatric illnesses. Here I have enumerated them. I will just go quickly to the important ones. Please let me know when my time is up, because mental health I can just go on and you all can keep listening, but we have to wind up and lights band करायचे असतील hall वाल्यांना. Let us start with PMS. What does PMS stand for? Problems men start. Correct? The men don't agree. Permanent male stupidity. All women agree. Punish my spouse. Now the men agree. Okay, so when woman is in the PMS phase, she, You know, she punished. In fact, I know women are in PMS phase all around a month. Okay, they're always punishing their spouse for everything. Why you should marry, you know? Why woman should marry? Because you cannot blame Modi or God for everything. You need third person to blame few things on. So you marry. Okay, now obviously if the woman of the house is having PMS, who is the worst sufferer? The husband, the children, right? PMS is characterized by a pattern of emotional, behavioral and physical symptoms, minor to major mood changes, breast tenderness, bloating, headache, other premenstrual, you know, we know that it's a spectrum of disorders from the physical to the emotional to the mental, crying spells, lack of concentration many women complain of. 75% of women with regular menstrual cycles experience PMS. Now this is important. PMS is caused by the progesterone that is secreted in the later half of the menstrual cycle. Now this is something you can't change and you can't halt it for a long time. You can give it some temporary relief, but the progesterone will keep coming, especially in the childbearing age. So can you imagine the distress of that woman? Month after month she has to face this without any respite till she attains menopause, after which the menopausal psychiatric symptoms will start. So there is no respite, right? Majority of women do not require medical treatment, luckily, or even psychiatric intervention, just conservative treatment like lifestyle changes, like diet, exercise, some supportive therapy will usually do the trick. Symptoms already I have mentioned. There will be the physical symptoms, abdominal cramps, bloating, breast tenderness. Some of them get lower limb swelling. Some of them get constipation premenstrually, then they followed by diarrhea because the prostaglandins come in. So these can be the physical changes. Now there is a terminology which is premenstrual dysphoric disorder. This is something which can it is detrimental to her routine life. It will seriously interfere with her day-to-day activities. And this is something that needs to be taken care of, but of course by the right kind of doctors. Extremely distressing emotional and behavioral symptoms. It is a small age group of women, but then these women are going to really have a bad time. In fact, there are the hormonal changes in this progesterogenic phase can also exacerbate underlying other psychiatric illnesses. Suppose she is already having some kind of psychiatric illness in the premenstrual phase, all those psychiatric symptoms will worsen. Generally do not respond to conservative treatment and they do need medications, maybe psychiatric help, maybe the gynecologist can help by giving some oral contraceptives and suppressing the endogenous hormones. Premenstrual exacerbation, I already mentioned, usually the psychiatric illnesses will increase in the premenstrual phase. Let's move to the pregnancy phase, okay? Pregnancy is actually supposed to be such a happy time. You know, you're welcoming a new member in the family and everybody is excited, right? From your parents, your in-laws and your spouse, everybody is so very happy. And can you imagine the sad state when some kind of psychiatric illness haunts the poor lady during pregnancy? Psychiatric illnesses typically emerge during the childbearing age. So as such, she may be more prone. There have been cases where she has maybe a family history. She is not suffering from that psychiatric illness, but the first time symptom may appear when she gets pregnant. Recent data states that relapse during pregnancy with recurrent mood disorders in women who discontinue treatment. Now, discontinuing pharmacological therapy, especially in psychiatric age, illnesses is very common because usually they need treatment for life, and eventually, being human nature, they start getting bored of the treatment, often because of the side effects. You know, they cause a lot of sedation, often because of fear of social ostracization. She gets married, she doesn't want to tell her mother-in-law that she's suffering from some schizophrenia or something, so she cannot take the medicine, she will stop the medicine. And then they come to us with exacerbated symptoms, and on top of that, if she is pregnant, treatment becomes really hampered because we cannot give all the drugs. All psychotropic medicines diffuse readily across the placenta, and no psychotropic drug has been approved by the US FDA for use during pregnancy. So you can imagine the plight of the gynecologist and the psychiatrist if such a patient comes to you. Major depression, bipolar disorders, panic disorders and obsessive compulsive disorder. These are the 4 leading disorders that can come during pregnancy. In the postpartum period, now this is again a continuation of the hormonal changes, and postpartum blues is one of the commonest psychiatric problem that women face during the postpartum phase. Most common, it's the least severe of problems, affects around 50%. Now just see the number, 50 to 80%. That means if we are like 50 women here, at least 25 to 30 of us have been through some point of time, we've been through postpartum blues. Depression. Now, postpartum blues usually with time, with some psychotherapy, it will go. Usually it is because of the anxiety of how will I cope up with the child. Child is keeping her awake in the night. She doesn't have enough rest. She's tired or she's having pain because of her surgery, either LSCS scar or episiotomy scar. Trust me, episiotomy is equally painful. When patients say, दुखेगा क्या operation में, बोली भैया normal delivery का भी दुखता है टाका. Right? So these factors can worsen the postpartum blues. Postpartum depression, again, now this is something very serious, and like in my long years of practice, 20-25 years, I have seen 2 cases which was so severe, like a book picture. She cannot tolerate the child in front of her eyes. Can you imagine newborn baby, 10 days old, 8 days old baby, and mother saying, isko hatao mere aankhon ke samne. She is trying to kill that baby. She feels he is a threat, or that baby is a threat to her existence. She thinks that the baby has been sent by Satan. Tela rakshas hai. Ashe kai severe mental thoughts. They cannot keep the baby. Now imagine the flight of the family. They have to look after a woman who is gone totally bonkers, and a small baby who actually at that time needs breastfeeding, needs to bond with the mother. In fact, I have written a paper on this, an article which I have seen some references that children whose mothers have suffered from severe postpartum depression are themselves more prone to psychiatric illnesses in adulthood. And one of the main reasons for that is said to be lack of bonding in the initial phases because mother was suffering. Psychosis, again, this can be very severe. I have seen one girl, she ran away from home. The relatives had to actually go on a manhunt to search for her, and they had to bring her. She couldn't get controlled even in my nursing home. I had to transfer under psychiatric facility. Poor girl had to receive ECT because she was that bad. So these can be really scary situations for both the gynecologist, the family, and for the attending psychiatrist. Menopause, again, with its set of disorders. Here now the hormones are waning, so estrogens are gone. Already Shantanu has spoken at length about the physical disability, but also the mental disability. Not only because the hormones are waning, but also this feeling of emptiness. This is the time when most women think about retiring, or there is now a daughter-in-law, or the daughters are grown up, they are working, they are looking after the house, and then that woman feels that there is no place for me in this home, nobody needs me anymore, मला तर काहीच नाही, कोणी विचारतच नाही. She is in control for so many years, she is संसाराचं सगळं बागडोर सांभाळलेली, अचानक तिला तर वाटतं मला कोण कुत्र पण विचारत नाही. This is the time when she is also going through physical menopause, and they can be very prone to certain psychiatric problems in this phase of life. Sexual dysfunction in menopause, not only in menopause, in fact, throughout the reproductive years, and we have an aesthetic gynecologist sitting right here with us who is dealing probably day in and out with such things, and this is something in the women we really neglect. I remember yesterday sir said that equal number of men and women suffer from sexual dysfunction, but typically only the male come. The reason being, for a woman to be sexually excited and to get sexual gratification is not a must in the process of the sexual intercourse. In men it is different. If man cannot have erection, there is no sexual intercourse. But in women's case, it is not the case. So therefore, they will never come up with it. Women are never taught that they have a right to have sexual gratification, that they have every right to feel sexually aroused and reach a climax. So these things are never discussed by women. And this is again one more most important, in fact, I would say, part of mental health. Many marital discords will start from here. आमचं बोलणं होत नाही, त्याला काही पडलेलीच नसते, त्याचं झालं का तो उठून जातो. Men typically they'll finish and they'll just scoot, or they'll just turn on their side and go to bed. the women have some different set of requirements. I guess communication is what will help. Depression, again, women are at a greater risk, and especially in the reproductive age group, we've already spoken about the hormonal factors that can be a cause. Depression is something which not many people also, realize that they are depressed. So I guess any patient who comes to you, even from their body language, if you feel that she is depressed, you can ask few leading questions. Sorry? Oh, you're talking to him. Okay. Yeah. He was bursting balloons there. And by now, I am sure all of you also want to go do that. So I'll just take 2 minutes more. So, hormonal imbalance. So ask leading questions. Like, do you get bad dreams? Do you sleep well? Do you wake up in the night with panic attacks, or do you keep this feeling of impending doom? कधी कधी त्यांना सांगता येत नाही काय होतंय. मग you ask 2-3 questions की असं वाटतं का की आता जगूया नको, किंवा असं वाटतं का उद्या नक्की काहीतरी वाईट होणार आहे. So all these things are part of the depression symptoms. So this is something which maybe we can ask for some leading questions. Schizophrenia, bipolar disorders, these are usually very severe. They come directly with the symptoms and they go directly, I guess, to the doctors. Luckily now the stigma of going to a psychiatrist is much less. In fact, my daughter is now doing child psychiatry, and even autism spectrum is on the rise. Not only numbers are on the rise, but the orientation of parents is on the rise. What was once thought as हे मुलाचं लक्षच नसतं किंवा जरा जास्तच मस्तीखोर आहे किंवा मेंटली थोडासा कमी आहे. Now people realize these are learning disabilities. So more and more children are getting diagnosed. Anxiety, again, more amongst women. I've already put some symptoms. Anxiety and depression usually go hand in hand. The symptoms that I have spoken about. Ask them about their food habits also. Are they eating too much, or are they eating too less? Are they eating between meals, or eating, sometimes they don't know this is a psychiatric disorder. In the middle of the night they get up and they feel that urge to eat. That is just त्यांच्या माइंडमधलं जे एम्प्टीनेस आहे ते कसं तरी भरून काढायचं असतं त्यांना. And then usually at night there's nothing much to do if your husband is asleep. So then you start binge eating. OCD is again common in women, but I guess out of the scope of this lecture. What can we do for PMS or any other psychiatric illness? We as primary doctors, can we suggest some things? Yes, there are some do's, there are some don'ts. Ask them to take calcium supplements, vitamin D, take B complex, take lots of proteins. What should not they be doing? No alcohol, no caffeine, especially at bedtime. Sometimes, we do the American way. After dinner, we have some black coffee. And that is going to send your sleep for a toss. So tell them to avoid coffee at bedtime. Nicotine, smoking, and, should be avoided. Promotion of mental health. Let me go directly to the conclusion slide. That mood and anxiety disorders disproportionately affect women of the reproductive age. Times of hormonal change are particularly they are vulnerable at such times, like adolescence, like during premenstrual phase, like during pregnancy, like during menopause. Treatment of psychiatric illness is complicated by potential pregnancy. Risk and benefit of both treatment and non-treatment needs to be carefully considered and discussed with the patient and her relatives. It is essential to recognize how the socio-cultural, economic, legal and infrastructural factors affect women's health and pay due attention to it. Early and appropriate psychopharmacological intervention along with above determinants that, all these, studying her family background, studying her economic status, studying what she does in life. All this must be, taken in the right context, and overall objective is to give an effective prevention and promotion of women's mental health. Treat them on time, diagnose on time. As practitioners, it's our duty to do so. I began with a shairi. This poem is definitely not mine, but this is given to be by my daughter. So, it's a lovely poem. तो मैं पढ़ के आपसे विदा लूँगी कि मौन हूँ, निशब्द नहीं, आवाज़ है, बस बोलती नहीं, जज्बात है, मुँह खोलती नहीं, चाहत है, किसी से उम्मीद नहीं, पहल न करूँ, किसी से डरती नहीं, जीत की चाह नहीं पर हार मानती नहीं, आईना हूँ बिखरती नहीं, दर्द से भरी हूँ मगर जीना छोड़ती नहीं. Thank you so much. You've been a lovely audience. Thank you for waiting till the end. And if you want some mood swings, you can definitely have them. They are available at home with your wives, daughters, mothers. Thank you women, thank you gentlemen for bearing with us, and thank you chairpersons.
Thank you, Supriya ma'am. Thank you, Supriya ma'am, for putting some light on most neglected part in women's health. And I would like to ask Manisha Kadam ma'am to felicitate our guest speaker. And very thank you to all chairpersons who were so much into the all. Thank you all chairpersons for giving every enthusiastic ear to all lectures. And I would like to ask our WDW head, Dr. Revati ma'am, to felicitate all chairpersons. Dr. Vivek Gujar sir. Dr. Savita Gujar ma'am. Dr. Mansi Namda ma'am. And Dr. Manisha Shinde ma'am. Now I would like to hand over my mic to Dr. Nitin Rane sir for valedictory function.
Conclusion of this wonderful event. I would like to thank many members, but to mention some of them, I hope so I don't miss anyone. First, we would like to thank the central and the state IMA dignitaries who are present today for the function, making it an elite one. Second would be, first, the venue itself, the Hotel Grand Victoria Fern, which has provided this wonderful venue. And we enjoyed the venue a lot. We know the stay was comfortable, the food was good, all the arrangements, the hall. Obviously, there were some glitches, but we overcome those, and the function went on very good. We would like to thank the online YouTube support person for giving us wonderful support and providing us the link and giving the glimpse of the conference to the online attendees as well. Also, the sound system guy who helped us with presenting all the different technical support as well as system sound support in it. IMA helpers Abhijit and Siddhant who have provided with multiple supports over here. And we would also thank the MOCs who were present, Suraj Mahadik, Sunil Narute, Tejaswita Raut, Dr. Trupti Sid, Nikhil Ekatpure, Gayatri Ekatpure, Mansi Devdikar, Srikant Devdikar. Also, we know that this whole conference wouldn't have been such a success without all the faculties that were present over here. And they have delivered such wonderful talks on a topic which is not routine. And we know that these things are going to be there, the crux of the future, and we know all these things are going to go in a big way. So presenting these topics is not as such a simple thing, and we have been educated in a very wonderful way about this our conference of robotics and the aptly said GENEXT conference. The next, I would like to thank all the office bearers who participated in this event and have helped in much better way as compared to what we were expecting. But obviously, Dr. Santosh Khartare sir, immediate past president, he was there for each and every step. Dr. Sanjay Sith, president. Dr. Nikhil Misar, treasurer. Dr. Aniket Inamdar, joint secretary, who has given us a lot of joints. And Dr. Amol Shinde, cultural secretary. Rohit Fade, sports secretary. Digvijay Raut, young doctors wing. Pradnya Gandhi, AMS chapter chairman. Dr. Supriya Khartare, vice chairman, AMS chapter. Padmaja Fade, secretary, IMS chapter. Also Dr. Mansi Inamdar, Monica Misar, Priyanka Mahadik, who are executive members of our body. Dr. Smita Dhotre, Gaochale in charge. Dr. Prashant Gandhi, Dr. Dattatreya Sarje, VPs, Vice President. Aditi Thite, the Clinical Secretary. Chaitanya Teke, Sports Secretary. Dr. Sujit Gandhi, Organ Donation in charge. Kiran Phade, Executive Member. Obviously, this conference was held under the Women's Wing, and Dr. Savita Gujar Madam has also helped in this. And obviously, last but least, Dr. Revati Rane, she is the organizing chairman of this EVECON 2024, chairman WDW-IMAMS, under whose idea and whose theme of this robotics and whatever we have seen, the lasers have come to light, and we have seen everything about the conference over here. So thank you all for all the IMA members, all the delegates who have attended the conference, online as well as offline, and thank you very much. We conclude the session. I would request all the IMA members of body to be on the stage and have a group photo. I would request Khadtere sir to please be on stage to felicitate a few of our members. Please felicitate our YouTube support person. Yaki. Yere. Sport. Sound system, please. सिद्धांत करायचं तुम्हीच करायचं सर. थोरात all the office bearers who are present over here.
Most of the MOCs are being felicitated already, but I would like to point that Nikhil and Gayatri had taken, not being in the IMA body also, they had taken a lot of efforts and they have been here for 2 days. Atal almost. So they have been here for 2 days and they have shown initiative to learn, and this is really that is what we need, youngsters coming up and trying to learn. So I would like to request, So please, Secretary, Honorary Secretary Nitin Nair to please felicitate the chairperson. Pude Nikhil Gayatri Thumi. And also Monica and Priyanka for chairing the tumcha doginche rahilla hai. So for chairing the session, they waited till I feel that that was a very important session that you conducted. So.
And we expect such active participation in ongoing IMA programs. अरे हाँ Monica and Priyanka, they did really wonderful job for cultural program. And I all your guidance. Yeah. Sorry if I shouted in between. And but I feel our conference was you are the backbone for W. But our conference was success. That the cultural program was a big event.
I request Dr. Rajiv Rani sir, please come on the stage. Sir, please. Madam, sir, Nitin sir, Madam, so felicitation.